Hi, good afternoon, ladies and gentlemen. A very warm welcome to you for Remarkable Rapid Revision 2.0 in Ophthalmology. A very warm welcome to you from Hyderabad. It's a very warm evening here. And so again, good evening. Vanakkam, Namaskar, Sat Sri Akal, Adab, Privyat, and Ni Hao to all of you across the world. So you might ask, what is this remarkable rapid revision about? And remarkable is about the fact that a normally 40-hour ophthalmology lecture we can compress in 7 to 8 hours. Okay, so we are going to have 7 to 8 hours of high density MCQs, high quality MCQs, which you can get up from here, and only from Dr. Bhanu Prakash's YouTube channel. So I hope you're all keyed up. So without wasting further time, we're going to start this, and your questions are welcome. Remember, it's live, so if you write questions to me, I will get back to you as soon as I can. So very well, this happens to be my photo, the first slide. Some of you are not able to recognize this is because I keep getting handsomer, younger and handsomer every day. So that maybe some of you cannot recognize from this photograph, isn't it? Very well. So this is, ladies and gentlemen, Ophthalmology live on Dr. Bhanu Prakash YouTube channel. Remember, normally we expect about, in ophthalmology, we expect about 15 to 30 MCQs. It's not anything. 15 is the bare minimum. So this is what we expect. But last time there were almost 23 questions of ophthalmology. Now you cannot predict this. Okay? I must tell you at the beginning that any time the examiners want to make a more difficult paper, question paper, they will include more questions of ophthalmology. As you all know, it's the single most difficult subject out of all 19 subjects. So if you want to make life easier for you, I suggest that we start studying ophthalmology. Right? So here it is. You can see these hypnotic eyes, these mesmerizing eyes, the most famous eyes of the 20th century. And here we go. I'm going to start with embryology, because embryology, even though it's a part of anatomy, remember embryology, the first thing to remember in ophthalmology is that out of the three primordial germ layers, ectoderm, endoderm, and mesoderm, we do not have any derivatives. We do not have any derivatives from endoderm. So that makes life easier. We have from ectoderm, mesoderm, and neural crest, okay, of which the ectoderm is further divided into surface ectoderm and neuroectoderm. Okay? And remember that always, for some reason which I'm not able to understand, the question is always from surface ectoderm. Okay? We don't have questions from mesoderm so much or neural crest at all. We're going to focus on the most important. Remember, it's a short, concise, it is a rapid revision, so it will be done very fast. So of the ectoderm derivatives, we divide into surface and neuroectoderm. Let's look at the derivatives of surface ectoderm, which are usually the most commonly asked questions. And here we memorize it by this simple mnemonic called level. Level, because you're working on a surface. Remember, surface means level surface. You're walking on level surface. And that stands for LEVL, which is L for lens, E for epithelium of all the structures of the eye except the ciliary body and the iris, V for vitreous, and L for lacrimal apparatus. Okay, so LEVL. Remember, most of the time we keep getting questions from the lens. It's derived from which? And you will say surface ectoderm. And the next one is the neuroectoderm. Okay, I told you the most questions are asked from the ectoderm. So we divide into surface and neuro. And neuroectoderm, you remind is yourself by rows. Neuroectoderm, rows. And R for the retina, because remember it's neuro, so retina and optic nerve, RO. S for the sphincter and the dilator pupillary muscles of the iris. Okay, remember the pupils constrict and dilate. So the muscles which dilate the pupil are dilator pupillae, muscles constrict the pupil is sphincter pupillae. And E is the epithelium of the iris and ciliary. But remember, the epithelium which was missing from this previous, except iris and ciliary, this epithelium makes its appearance on the neuroectoderm. Okay, so rows. So this is about all the ectodermal questions you get. And we are not going to talk about then the mesoderm structures and the neural crest, because those are not really asked. So this is enough about a bit of the embryology that you need to know. Then we start with anatomy of the orbit. We're going to do orbit and oculoplasty. In the orbit, what are the most important MCQs of the orbit? Remember the famous rule of 7. Okay, 7 bones, 7 muscles, 7 nerves, and 7 contains 7 suspensions of the eyeball. Okay, suspend by 7 attachments. The first question is, what is the volume of the orbit? Remember, the volume, you have to memorize this. Certain figures you have to memorize. I always mention that. And we have a slide where we will give you the most basic measurements. 30 ml is the volume of the orbit, but the volume of the eyeball is only a measly 6 ml. Remember, a teaspoonful is only 5 ml, and the eyeball is only slightly bigger than a teaspoonful, which is 6 ml. And it's suspended by the 7 attachments of the 6 muscles and 1 optic nerve. Now, of the 4 walls of the orbit, you have a superior, inferior, medial, and lateral. And if you look at the diagram here, these are walls, and they're just walls, nothing else, as bare as a prison cell or a monk's monastery. And of these 4 walls, superior, inferior, medial, and lateral, remember the thinnest wall is the medial wall. Okay? The thinnest wall is the medial wall. Okay? Always the medial wall is thinnest. And those who study anatomy, you know that that is because of the lamina papyracea. Okay? The lamina papyracea, which is the wall of the sphenoid sinus, I beg your pardon, the ethmoid sinus. This is the thinnest wall of the orbit, the weakest point of the entire orbit. Yeah? So this is the medial wall, the thinnest. But however, kindly remember, the most commonly fractured wall of the orbit is the inferior wall. Okay? It's not the medial wall, it's the inferior wall, which is the floor. You see it in the diagram. Why is that? The reason is simple. As I've talked to you in many of my lectures, is the inferior wall is thicker, but yet it is the most commonly fractured wall, because just under the inferior wall lies the maxillary sinus. The maxillary sinus. And the maxillary sinus is completely hollow and cavernous. It cannot support the inferior wall or the floor. So that's why it fractures. But the medial wall, despite being thinnest, still is supported by the air holes, the holes or the air sinuses of the ethmoid sinus. You know, the ethmoid sinus is full of air. It's the honeycomb structure. And this honeycomb structure, which looks like this, any structure which is full of air cells, as the ethmoid sinuses, is bound to support the overlying wall, which happens to be the medial wall. So medial wall, despite being thinner, does not fracture so often as the inferior wall, which despite being thicker, fractures more, because there's nothing to support the inferior wall or the floor. Okay, so remember, anatomy is important. Anatomy is destiny, as Sigmund Freud said. Okay, very well. Then what about the salient points of the eyeball, which you need to know? Let's look at the 3 concentric layers. You know that the eyeball is composed of 3 concentric layers, one below the other, like a matrushka doll in Russian and Ukraine. No, we have this matrushka doll-like structures, the outermost layer, the middle layer, and the inner layer. And the outermost layer is the cornea sclera, which is the tough fibrous layer which protects the eyeball. The middle layer is a vascular layer, where the blood vessels are, which is the iris, ciliary body, and the choroid, which is called the uvea, which means grapes. And the innermost layer is the retina. Innermost layer of is the retina, which is the nervous layer. So we have the outer fibrous, the middle vascular, and the inner sensory layer or the neural layer. Okay, and then this is the 3 layers to begin with. Then remember, the MCQs often ask that all the structures of the eye have their own blood supply except 2. And you have to remember the 2 avascular structures, which is the cornea and the lens. Please remember that. They don't have their own blood supply at all. And the total refractive power of the eye is a massive plus 60 diopters. Okay? Plus 60 diopters. Remember, we write it plus. Why? Because in ophthalmology, anything that converges rays of light like this, any lens converges, we call it plus. Anything that diverges like this, we call it minus. Since the rays converge onto the fovea, we call it plus. Okay? And 60 diopters, of which 43 diopters contributed by the cornea, which is 70% of the power, and lens contributes 19 diopters, which is 30% of the power. Okay? You might argue 43 plus 19 should actually be 62, but they are not in contact with each other. You see, the cornea and the lens are separate from each other. So since they are not in contact, so they will not be exact summation. Okay? It's not really 62, it is closer to 60. And then this is the slide I was telling you, is that it is the slide which gives you all the important measurements which you have to memorize here. Look at that. Here we meet the original volume. I said 30 ml, but the eyeball volume is 6 ml. You have to memorize these numbers, kindly remember. Okay, these are important numbers in ophthalmology. Axial length of the eyeball, which is the from center of the cornea to the center of the retina, gives you the anteroposterior diameter. This is 24 millimeter. Antechamber depth, which is from the center of the cornea to the center of the iris. This is average is 3 mm. And the critical angle, now this is a new question. Remember, of late in the last 2 years, this question has been asked, what is the critical angle for total internal reflection from tear? See, what does this means is that why we can't see the angle, is not. When we want to see the angle of the eye, this cannot be seen because you see this is the iris, this is the angle. The rays of the eye, the light that travel from the angle, they get reflected from the cornea like this and goes back into the anterior chamber. So that's why you cannot see the angle. So this critical angle has to be more than 46 degrees. You have to remember this, 46 is critical angle. So when we put a gonioscope on the eye, it increases the angle by more than 46, and then we can see, as you can see, these rays are no longer coming inward, then they go out like that, and you can see the angle. So kindly remember, critical angle is 46. This is a memory-based question. We cannot help it. You have to memorize this. Average corneal thickness is about 540 microns. Most of us have around 540. Some of you have thinner. Some of us have thicker corneas. Ascorbate is the highest amount, remember, in the anti-aqueous humor. The one component that is higher compared to the blood is vitamin C or ascorbic acid or ascorbate, which is almost 30 times higher compared to this is in the aqueous. Remember, this is not a vitreous, it is a misprint here, it is an aqueous. The 30 times higher in the aqueous. So this is one component that is very high in the aqueous compared to that of blood. Aqueous formation again is important to memorize, 2.5 microliters every minute. This is you have to memorize this particular figure. Remember, this is the formation of aqueous every minute, and it remains all the time the same thing, except at night when you're sleeping, when it comes down by 50%. Okay? Otherwise, the volume of the aqueous production is the same. Then, the fovea diameter, the optic diameter, you have to remember this, is 1.5 millimeter. We often call this optic disc diameter as ODD. So kindly remember, this is 1.5 millimeter. So sometimes we can ask you, how much is 2 disc diameters? You'll have to calculate 1.5 into 2 is 3 millimeters, right? So if you write 2DD, you must write 3 millimeters. If they say 3DD, it becomes 4.5. So that is then. And how much is the visual field? Remember, monocular means for one eye visual field. Remember these limits, superior, inferior, nasal temperature. Remember, superior field is the shortest, 60 degree. Then is the nasal, which is 60 degree. Then is inferior, 70 degree. And then is widest is temporal, which is 100 degrees. Okay. So remember, the shortest is the superior and the nasal. Why? Because of the forehead and the nose blocking the field. Okay. So these are two shortest. But however, if asked which of them is the shortest, it becomes superior. And temporal is the widest because there is no obstruction of the temporal rim. So temporal, there is no obstruction here. So temporal field is the widest. But also remember, temporal rim is also the most unprotected because there is nothing blocking here. Often injuries come from the temporal side of the socket and damage the eyeball. Okay, so everything has a flip side. You may have a wider field of vision temporal, but it's more susceptible to outside danger, isn't it? So fields are done. And how much is high myopia? Remember myopia. Anybody more than -6. So those of you, my friends, who are wearing more than -6, which is -7, 8, 9, 10, 20, whatever, you are high myopes. Remember, this is called as high myopia. More than -6 is high myopia, which puts you at slightly risk of developing retinal detachments. Okay, anything more than -6 is high myopia. Intraocular pressure is between 10 to 21 millimeters of mercury. So 10 to 21 millimeters of mercury, remember, is the variation of intraocular pressure. But the average pressure is 16 millimeters. Most of us, intraocular pressure will be around 16 millimeters. So if you check my pressure or yours right now, it will be around 15 to 16. This keeps varying all the time. But if it goes beyond 21, it's diagnosed as glaucoma. Then how do I inject intravitreally? Remember, intravitreally, you want to inject an injection inside the vitreous cavity. Where will you go through? Not through the nose or the forehead, but through one particular structure of the eye, which is called the pars plana, is not. So this is called pars plana. Intravitreal injection is through the pars plana because this is the only structure that is safe enough for us to inject. And the site of pars plana, remember, there are two different questions. The site of pars plana, as you've seen this picture, is approximately between 3.5 to 4 millimeters from the limbus. Okay, so remember, not through the limbus. You enter through the limbus into the anterior chamber. Okay, you enter through limbus into the anterior chamber. But you enter into the vitreous cavity via the pars plana, which we measure by using calipers around 3.5 millimeters from the limbus. Okay, so kindly remember, through the pars plana is vitreous, through the limbus is anterior chamber aqueous. So after having taught those, gone over the basic ophthalmic measurements, now we go to the next thing, which is the orbit and the adnexa. Orbit and adnexa. And orbit and adnexa, what about this? So let's talk about the Graves' disease. which is thyroid disease and thyroid eye disease. So let's look at the most common question of thyroid. Remember, the most common cause of proptosis, you can see the proptosis, also called as exophthalmos, is thyroid eye disease, also called as Graves' disease. Okay, remember this is the most common cause of thyroid, which is much more common in ladies, almost 5 times higher than women compared to that of males. But please also remember, the most common presentation of thyroid, is not exophthalmos, it is actually lid retraction. Okay, so be careful. So it is when they ask you what is the commonest presentation of thyroid, you don't say proptosis or exophthalmos, you say lid retraction. Retraction means going back. Like you look at my lids, looking at you like this, the lids go back like that. Okay, so this gives you a very angry looking patient. The patient looks staring at you like that, as he's very angry with you because the lid goes back. Okay, remember this is the most common manifestation of thyroid eye disease. Okay, most common thyroid disease. But if the question is what is the commonest cause of proptosis or exophthalmos, that's become thyroid. So be careful not to be confused with the two questions. Then the next thing is the most common muscle get restricted in thyroid disease is the inferior rectus muscle. Okay, why does the muscle get restricted in thyroid? Because you see in thyroid you have these mucopolysaccharides, MPS, which you have done biochemistry, and these mucopolysaccharides, they deposit on the muscle tissue, they damage the muscle tissue, and these muscle fibers, they cannot contract. So when they can't contract, so they cannot move the eye. The eyeball will not move simply because there's no contraction of the muscles. So when they can't move, so it causes restriction, and the restriction follows a certain order. Okay, certain order. This order is called IAMSL. It's easy to memorize. It stands for I am so lucky. Why am I so lucky? Because I have such wonderful students sitting here watching me, making fun of me. I am so lucky. But what it really means is I for inferior rectus, M for medial rectus, S for superior rectus, and L for lateral rectus. Remember, the first muscle to be restricted always is the inferior rectus, and then the medial rectus, and then the superior, and then the lateral. This stands for I am so lucky. It's a mnemonic to measure. Right. Then the next question is going to be a very famous sign which is called a fusiform dilated muscle belly. See what happens, normal the muscles, they look like this. This is the muscle belly, and this is the tendon which attaches to the bone. So in thyroid, the mucopolysaccharides, they deposit on the muscle belly. Remember, when they deposit on the muscle belly, so the muscle belly becomes enlarged like this. Okay, this is called a fusiform. Fusiform means like a turnip. Okay, a spindle-shaped thing, spindle with the tapering ends, superior and inferior, and the centers there. So because it enlarges the size of the eyeball, so it pushes the eyeball out. There's no space in the orbit for the eyeball. That is why proptosis occurs in thyroid, because there's no space inside. The enlargement of the muscle belly. But also remember, the tendon is spared. Okay, the sparing of tendon is a very important sign. It'll only cause bulging or enlargement of the belly, muscle belly, not the tendon. Okay, and this because it is the sign. So you can pick it up in a CT scan. In a CT scan, you'll be able to see the enlarged muscle belly bulging like this with the thyroid, with the tendon completely spared. And this is called the Coke bottle sign because, as you can see, this is a Coca-Cola bottle and does not look the enlarged muscle belly, and this is the tendon. Okay, so this is the Coke bottle sign, or also called the Coca-Cola bottle sign. And you can see this is a very powerful sign, many times asked in NEET PG also and your MCQs also. Very well. The next question is on the orbit after having diabetic proptosis. Next question is about the blowout fracture. We call it the blowout fracture. It happens to be a very powerful MCQ. Every time, each year, there is at least one MCQ on that. And it's called a blowout because there seems to explosion. It seems to blow out like that. And remember, the definition of blowout is that it is fracture of any of the walls of the orbit, superior, inferior, medial, lateral, but without including the rim. The rim, remember the border of the wall, the rim is very powerful and cannot fracture. So in a blowout fracture, there's no fracture of the rims, but an isolated fracture of any of the walls. And we just talked about this. Remember, the inferior wall is the most commonly fractured, okay, or the floor of it. Why? We just talked about it because there is no support for the floor or the inferior wall. And the famous triad that you know, which you have to remember, ophthalmology is full of triads. Triads means three things. It's easy for us to remember these triads and apply them in the MCQ. So this is the famous dye. Okay, Die, it stands for die, not that death, not death. We all have to die, of course, but not today, inshallah, not today. And for diplopia stands for DIE, which stands for diplopia, which is double vision. Infraorbitable anesthesia here on the inferior half, you will be completely anesthetic. Why is that? Because the nerve gets damaged. There's infraorbital nerve here which gets damaged in fracture. So you cannot feel it. After the fracture, if you touch it, even with a pin or a lighted matchstick, you will not be able to feel it. It is completely anesthetic. Okay? So this is called infraorbitable anesthesia. And enophthalmos. Remember, enophthalmos, it goes in. Diabol goes in, which is called enophthalmos. It sinks inwards. It's exactly opposite to exophthalmos of thyroid. The famous triad, diplopia, infraorbitable anesthesia, and the teardrops. And can you see the teardrops? It calls teardrop because this is the orbit, and as it fractures, the contents of the orbit, the herniate downwards like this into the maxillary sinus, which is the inferior. This is the famous inferior fracture, and this you can see in the diagram here, the CT scan, the teardrop sign, and this is the famous teardrop sign, which you love to ask in ENT also, which my friend Dr. Rajiv will be soon taking, and it is also seen we asked in radiology, we asked in ENT, anatomy, and ophthalmology. Remember the powerful teardrop sign. Okay, very well. What next? Then we come to tumors. Tumors are going to be a very important source of MCQs. And so remember, but here, before we go to tumors, I want to tell you something. Remember, when we do ophthalmic tumors, you have to remember whether they're asking it's orbit or is it eyeball. Remember, orbit is the bony cavity and the contents. The eyeball is different from the orbit, so be careful. Are they asking orbits? Are they asking the eyeball? Okay. Eyeball, if they ask, then the answer changes because we're talking about the soft tissue. If the orbit, we're going to talk about the contents of the orbit. Is it the orbit of the eyeball? Is it primary or secondary? Primary means a tumor of that particular structure. Secondary means it comes a metastasis from some other tissue. And third, is it a adult question or is it pediatrics? Remember, tumors differ from adults to children, so we have to be very careful. So here we are talking about orbits, so we are going to talk only about the orbit here. So let's look at the questions here. Now look at this. This comes to be the most common primary tumor of the orbit in children is a dermoid cyst. Remember, dermoid cyst is a benign tumor. This is the most common tumor of the orbit, primary tumor in children. But if they ask, remember, if they ask a most common primary malignant tumor of the orbit, remember, it's not dermoid cyst because dermoid is not malignant. The malignant would be rhabdomyosarcoma. So be careful what they're asking. Most common overall malignant tumor of the orbit in children is rhabdomyosarcoma. What about secondary tumors metastasizing? Remember, secondary tumors, they come from neuroblastomas, and neuroblastomas are tumors of the renal gland, and when they metastasize, is the most common tumor to metastasize to the orbit of the child. And you can see the famous raccoon sign. Can you see that? This dark raccoon sign, this leads to a very famous raccoon sign because the child looks, eyes are dark like a raccoon. Okay, you've seen the raccoon's eyes, they are dark, filled with blood. So this darkening, this raccoon sign is the bleeding around the lids that are ecchymotic patches that are visible around the lid that you will see. And so remember that this could be a very dangerous cause of a neuroblastoma metastasizing to the pediatric orbit. Okay. Then the most common primary tumors of the adults are cavernous hemangiomas. Remember, these are cavernous hemangioma means that in adults, it is a tumor of the blood vessels of the orbit. Okay. So remember, these are orbital questions. So this is a blood vessel and it's a tumor of the blood vessel of the orbit. Cavernous hemangiomas are benign tumors found mostly in females between 20 to 45 years of age, and they cause proptosis. They cause proptosis, pushing the eyeball. It's a benign tumor. What about malignant tumors? In malignant tumors, remember, this is the most common question asked to us these days. This is the most common malignant tumor, I beg your pardon, secondary tumors to the adult orbit is going to be metastasis from breast cancer. Remember, number one is breast cancer, followed by lungs and prostate. So overall, most common is breast cancer. Remember, this is the most common tumor of the females. Okay? And if they ask males, then you ask a lung cancer. So kindly remember, CA breast is the most common metastatic to the adult orbit. And a very powerful question is, remember, this breast cancer, particularly serous. Serous means hard. The serous breast cancers, kindly remember, cause enophthalmos. What is that? They push the eyeball in. Now that's surprising because you would expect the metastasis to push the eyeball out and cause proptosis. You would expect that. But no, it doesn't. It causes exactly the opposite. it causes fibrosis of the extraocular muscles and it pulls the eyeball in, which is causing enophthalmos. So be careful, we can ask this question, what is the most common tumor of the orbit in females? Okay? What is the most common secondary tumor of the orbit in females? Remember, it is clear breast metastasis, okay, which causes enophthalmos. Then we come to the next orbital structure, which is going to the ptosis. Ptosis, remember, is drooping of the upper lid. The ptosis, the P is silent, remember it's ptosis, and ptosis is drooping of the upper lid. Normal lid droops around, remember it covers 2 millimeters of the eyelid. It covers 2 millimeters of the eyelid, and so if it's more than 2 millimeters, this is known as ptosis. It can be either congenital from birth onwards, or it may come after 1 year of age, which is called acquired ptosis. So from birth till 1 year of age is called congenital, which happens because of maldevelopment of the LPS. That means that from birth onwards, the levator palpebris superioris is not well developed, it's maldeveloped, and is not able to pull the lid up, which is causing the ptosis, okay? This is congenital ptosis. And if it comes after 1 year of age, called acquired ptosis. But remember, here's one more thing which I want to talk to you about. This is a question which has been asked recently. In the congenital variety, there's one more ptosis which I like to ask you. This is the famous Marcus gun ptosis. Okay, look at this. It's called the Marcus. This is a very recent question which I'm going to include it here. Marcus gun ptosis. What is that? It is the name of an ophthalmologist, Robert Marcus Gunn. Remember, those of you might remember Marcus Gunn pupil also. The same Marcus Gunn. The Marcus Gunn ptosis, it is what? It is also a type of congenital ptosis. That means it occurs before age of 1 year. But here there is, remember, the abnormal connection between the lid nerves, the LPS, which is the nerve, which is the third nerve which supplies the LPS, and the fifth cranial nerve which supplies the muscle of the jaw. So this is also called as jaw winking, syncytial, jaw winking. So when you open the jaw, the lid flutters open. So normally there is a ptosis, so you will have a child who is born with ptosis, okay? But surprisingly, when the child opens the mouth or chews, chewing movement, like chews like this, or even sucks, the sucking movement or chewing movement, you will find the drooping lid rising up and down, okay? This is amazing phenomena where the lid moves up and down in connection with the chewing movement of the jaws, okay? This is called as Marcus Gunn ptosis, also called as jaw winking syncytial. Remember, the MCQ is that it is an abnormal connection from birth onwards between the fifth cranial nerve, which supplies the jaw muscles, and the third cranial nerve, which supplies the LPS, okay? This was asked last year when the question was asked, FMGE, that the mother reports that when the child feeds, remember when the child feeds, so it's a sucking movement, on the child, when the child feeds, the lid seems to go up or increasing of the lid palpebral aperture. So what is the reason? Remember, the sucking movement caused the lid to go up. So this is an example of a Marcus Gunn ptosis, also called a jaw winking ptosis. So this is congenital also. What about acquired? Acquired ptosis development is after 1 year of age. There are 4 different types. Aponeurotic or involutional is the most common, okay? And this is seen in senile ptosis. Senile means old people who are 75 years of age. You've seen your grandparents. Their lid is drooping. Why? Because they have involutional. What does involutional mean? The word involutional means shrinkage of the tissue. Because of old age, the tissue has shrunken and is not able to pull the lid up, okay? So this is called involutional. And this is the most common of all the 4 different types of ptosis seen in older people. Also, post-contact lens. Remember, my friends, those of you wearing prolonged contact lenses, 10 years, 15 years, 20 years, well, you can't be wearing 20 years, most of you are about 25 anyway, but those who have prolonged contact lens wear, 15, 20 years, they also develop a damage to the aponeurosis, and this can cause an example of aponeurotic or involution ptosis. This is the most common one. What else? Myogenic ptosis. You can see the involution ptosis here. You can see this picture here. This is an old lady whose lid is drooping down. Okay? Myogenic, where the ptosis occurs due to weakness of the muscle, like myasthenia gravis and myotonic dystrophy. So myasthenia, remember, young ladies, my students remember, you people have myasthenia. Okay, remember, myasthenia is very common in young ladies. And those of you looking very tired, unfortunately, I can't see you. You can see me, but I can't see you, unfortunately. Those whose lids are already drooping, young ladies, remember, myasthenia is the most common disorder of the neuromuscular junction, is it not? So you may have myasthenia. Then ptosis can be seen neurogenic ptosis, which means the nerves is damaged and the nerve is weak, so it's not able to contract the muscles. So example being third nerve paralysis, this is called LPS2 droop, and Horner syndrome is due to sympathetic plexus damage, which will cause the muscle, which is what? Remember, the Mueller's muscle is supplied by the sympathetic plexus. So it's the sympathetic plexus which you see in damage in Horner syndrome. So these are examples of neurogenic ptosis. Mechanical ptosis, something is pushing the lid down mechanically, okay, by its weight, like lid tumors or chalazion. Okay, so these are examples of four ptosis. So these are the four major types of ptosis that you have seen here. The main kinds: aponeurotic, you have myogenic, you have neurogenic, and mechanical. Okay, so these are the four different types of ptosis. But please remember, acquired ptosis, the aponeurotic is the most common. Now, what is the treatment of ptosis? Treatment of ptosis, remember, is always surgical. There's no medical management here. And you have to first determine the LPS function. If there's a good function, then we do a certain surgery. If it's poor function, then we do different surgery. The LPS function, if it's a good function, then we do something called LPS dissection. What is that? LPS dissection means that we cut the LPS. And this resection is to cut, you know that, no? So we cut the LPS and stitch it back again. So this shortens the muscle arm and makes it more powerful. It lifts the lid up, and this is you can see the example of a good LPS. This is the frontal. You can see the example here. This is ptosis, and following surgery, you can see that this looks pretty good compared to this surgery. This is very good. This LPS. This is the single most important surgery for ptosis. And kindly remember that almost 85% of ptosis are corrected by the LPS. This surgery you have to remember. However, if the LPS function is not very good, if it does not function very good, then you have to do something called frontalis suspension. What we do here, we engage the frontalis from here and we stitch it to the LPS like this. Okay, so because there's not enough power in the LPS to pull the lid up by itself, so we attach the frontalis muscle to the upper lid, and when the patient wrinkles the frontalis like this, so it lifts the lid up. It's called frontalis suspension, which we really don't ask you many times. However, to give you completion, poor LPS, we do frontalis. Good LPS, we do LPS dissection. Okay. Then the next topic is lacrimal drainage apparatus. Okay. Remember drainage. Lacrimal, the word lacrimal, kindly remember, always refers to tears. And when you have lacrimal, means the drainage of the tears. Okay. So how do the tears drain? And let's look at this. This is very important for you primarily because the excessive tears that often come during the exam, they have to have a way to drain out, is it not? So where do they drain? From here. So remember, it consists of, drainage apparatus consists of a system of tubes and valves. There are almost 7 different tubes and valves which control the drainage of tears from the eye and finally into the inferior meatus of the nose. Okay, inferior meatus of the nose. That's the final drainage which you can see here. It starts from lacrimal gland here. Okay, remember the lacrimal glands are these two very large glands. These are the largest glands in the eyeball complex, and they're present supratemporally. Okay, so somewhere here in the supratemporal area on the upper lid here, 2 glands here, and they produce the tears. And these tears, you can see in the diagram, it goes down to the inferior on the lateral half of the conjunctiva, and from there, as you blink, remember you have to blink like this. This blinking rate, this blink is very important, and this blink, it conveys the tears to the nasal half. From the temporal, it conveys to the nasal half of the eyelid, where there are 2 small tubes waiting for the tears, 2 small holes. So this is called the upper punctum. The word punctum means holes, and this is the lower punctum, so on the lower lid. So 2 small holes, they convey the tears from the upper punctum into the small upper canaliculus. Canaliculus is a very small canal, and then it's from the lower canaliculus like that. Then they combine together to meet for a very short time, which is not mentioned here. It's called the common canaliculus. Okay, from common canaliculus, the common canaliculus goes into this lacrimal sac. Okay, you can see here, lacrimal sac is a small pouch here. You can feel it. You touch it here. There's a small pouch. It's called a sac. Remember, sac. Be careful. Do not confuse the sac with the gland. The gland produces the tears. The sac drains the tears. Okay, this is a lacrimal sac where they rest a bit. And finally, the tears are pushed down the nose like this. You can feel this huge tube, this long tube called the NLD, nasolacrimal duct. So the tears drain down the nasolacrimal duct like this, and finally they go into the inferior meatus of the nose, where they drain into the nose. Finally, that is the drain of tears, and inferior meatus of the nose is where the tears drain finally whereas what our rivalry begins with the ENT surgeons. Remember, the ENT and the ophthalmic surgeons, we often clash on territorial rights. The ENT surgeons say, what are you doing in the nose, which is my territory? I say, but my friend, the tears are mine. Is it not? So we have this territorial fight in the inferior meatus. So this is important pathway to remember, kindly remember. So from the lacrimal glands, it comes as it did you, as you blink like this, the tears are swept into the nasal side. From the nasal side, upper punctum and lower punctum, upper canaliculi, lower canaliculi, common canaliculi, lacrimal sac, nasolacrimal duct, okay, and into the inferior meatus. So this is a pathway. So this you have to remember, and also remember that it is the lower canaliculi is more important. This system is more important because it drains 75% of the tears here. Okay, so can you remember, because of gravitation, 75% of the tears are drained by the inferior meatus, not the superior meatus. Okay, so drain down that, and from here it goes in the nose like that. Now the problem is that sometimes these things can get blocked, because there are so many tubes here. They can get blocked here. If you have blockage here, suppose the most common site of blockage is this one, the nasolacrimal duct. Write this down, MCQ. This is the most common site of blockage, NLD, nasolacrimal duct here. What will happen if it gets blocked here? Then the tears will go back, they'll reflux, and they will pour down the inferior lid margin like this, which is quartering, inferior lid margin like this. So this is where you have epiphora. So remember, this is a new term for you. We call this epiphora, which is drainage of the tears down the lower lid. Drainage of tears down the lower lid is called as epiphora, okay, because of obstruction of some part of the drainage apparatus, okay. So this is the most common site, and the most important clinical question that we'd like to ask you is that a valve, there is a valve here. I told you there is a system of valves here. The valve, this valve, it guards, there's a very important valve here which you have to memorize, which guards the inferior part of the NLD into the nose, so that this valve opens like this. So it allows the tears to drain down into the nose, but it does not allow the valve, the tears to come back again. Why? Because you don't want the tears that are stained by the mucus of the nose, okay, to get back into the eye and damage it. So as soon as the tears start to reflux, the valve closes like this. Okay? This valve is important, and this valve, you have to remember, is called the valve of Hasner. We just talk about this. Now, in certain children, when they are born, the valve opens immediately, of course, with birth. But in certain cases, say 5 to 6% of these children, this valve remains blocked. It does not open at birth like this. So if it remains blocked, as you can see, it's a persistent valve of Hasner, which means it is persistent, means it is not opened up, it's not canalized. So what will happen is, in almost 6% of children, the nasolacrimal duct obstruction takes place. Obstruction, NLDO. So the tears cannot come out into the nose, and because it cannot come into the nose, so they reflux back into the eye, and they pour down the lower lids like this. So this child always looks as if it's crying. This is called as epiphora, and this is the classic triad of NLDO, nasolacrimal congenital nasolacrimal duct obstruction. Epiphora, drainage of tears, discharge because it gets infected, and crusting as it dries up. You see, because these tears now they're stagnant. These tears collect in the sac here, and as they collect in the sac, so it becomes stagnant, and anything that's stagnant becomes infected. So this infection, when it dries up, is called discharge, and is called crusting when it totally dries up like that. So this epiphora, discharge, and crusting is the sign of congenital nasolacrimal duct obstruction. You can see the kid here. Many of you have seen kids like this. It's pretty common. So the most important question here, because of the watering, remember, there's a very important differential diagnosis. The differential diagnosis is that of congenital glaucoma. Many children's eyes are also watering because they have congenital glaucoma, which is called ophthalmos. Now, this is a far more serious condition than nasolacrimal duct obstruction. So whenever a child's eye is watering, we have to take care to understand whether it is glaucoma, ophthalmos, or is it NLDO. Okay, how do you distinguish? Remember that ophthalmic kids, they have also photophobia, as well as they cannot tolerate bright light, so immediately eyes close, as well as blepharospasm, they're tightly shut lids. And they're extremely uncomfortable, So ophthalmic kids, their eyes be watering, and they'll always be crying. The cranky child is always very crying, very irritable child, because it's very unhappy with blepharospasm, tightly shut lids, and avoiding light like that, okay, like this. But in this case, in congenital NLDO, as you can see, the child is wide open eyes, and he is fairly comfortable. He's not very happy because of the watering, but he's not unhappy and he's not very irritable. Okay, so this is differentiating. That easy to differentiate this. 90% of this, remember, they improve spontaneously. 90% they improve spontaneously. They become fine. Okay, but 10% don't. And for them, we have to treat. We have to do this called digital sac massage. Okay, so you have to treat the mother how to do it. What is that? In the first 6 months of age, you ask the mother to put her finger here. If both eyes, then you have to put both here and gently stroke it down like this. Okay, look at that. You stroke it down 1, 2, 3, 4, like this. Slight pressure, and stroke it down like this. This is called digital massage. What does that do? It increases the pressure inside the valve, and the valve pops open. It valves open like that. Okay, so this is a very nice technique. But remember, this works only for about 6 months of age. After 6 months, it is too stiff to open up like that, so we cannot do this. So after 6 months of the child presents to us, you have to do an NLD probing. So we have a very fine probe, very slender, very delicate probe. It's made of metal and goes right into the nose. Okay, so you take it from the inferior or the superior punctum, goes into the common canalicus, inferior canalicus, lacrimal sac, and right into the nose, and we go pop like that. We push it gently. It has to be done under anesthesia, and we push it gently and breaks the valve. Okay, so this is called probing, but this can be done only up till 2-3 years of age. That's all. Okay, because as the child becomes older, even the valve becomes stiff, and you cannot break it also. And if that also doesn't work, the probing, then we have to do a dacryocysterhinostomy, DCR, after 3 years of age. We have to wait for 3 years of age because of the growth of the nasal bones. Okay, no, DCR cannot be done before 3 years of age. What is that? DCR stands for dacryocysterhinostomy. Okay, like this. Look at that. So what from the dacryocyst means is the lacrimal sac. From the lacrimal sac, we connect it directly to the middle meatus of the nose. So remember, so we bypass this. We bypass the inferior meatus where, be careful, the tears drain into the inferior meatus, but the DCR opens up into the middle meatus. Okay, so we bypass the entire NLD because we think it's closed, and we enter into the middle meatus like that. This is called DCR, dacryocysterhinostomy. Okay, this is the third step we've done. So kindly remember, this is an important algorithm. You have to memorize this. First 6 months, sac massage, then doesn't work, go to probing, and if probing doesn't work, then you do DCR, but you have to wait for 3 years at least. Remember, 3 years, not months. 3 years before you do a DCR. So with that, ladies and gentlemen, we have now finished our orbit and oculoplasty. These are the 5 most important topics: orbit and oculoplasty. And if you've done this and you can answer these questions, you've done well up in the ophthalmic MCQs. Then we come to cataracts. Cataracts, remember, is the single most common cause of blindness in the world. Remember, blindness, the first quiz, cataract defined as, you can remember, opacification of the lens or cataract. Okay, opacification of the lens or capsule, I beg pardon. It can be the lens or capsule. This is called a cataract. So this is the lens and capsule opacification. It's called cataract. You can have either or both. Cataract is also, remember, the world's most common cause of blindness. Almost 50% of the world's blind are because of almost 50%. That's a huge figure. India is almost 70% of these blindness because of cataract. Okay, and what exactly is blindness? You have to remember the definition of blindness according to NPCB, which is National Program for the Control of Blindness, which is the governing body in our country, and also WHO, which governs the entire world. Anybody less than 3/60. Okay. That is, if you cannot read the first line of the Snellen's chart from a distance of 3 meters, it means you're less than 3/60, then you're considered blind. But also remember, this vision is taken with glasses. It is not taken without glasses. So if you're wearing glasses and still not able to read 3/60, it means you're blind. Okay? And it is taken with the better eye. So suppose you have one eye 6/6, the other eye is 1/60. This is not blindness, because the better eye is 6/6. You have to check the vision of the better eye, and that should be less than 3/60. Okay? So if you have one eye 1/60 and the other eye 2/60, this is blindness because this is the better eye and this is less than 3. Is it? That's important. So kindly remember the caveats that you are blind if the better eye wearing glasses is less than 3/60. That is the blindness. Okay? So this is the typical Definitely. And as I told you, the world's most common cause of blindness is cataracts. Okay. So, which is the most common type of cataract? The most common type of cataract is age-related cataract. Age-related cataract is people above 60 years of age almost, we call them, those who develop cataract after 60 years of age. This is almost 80% of cataracts are because of that, okay? 80% of cataracts. So, kindly remember there are many types of cataract causes like age-related, okay, like metabolic, like complicated, like steroid-induced cataracts, but the most common type, single type, is the age-related one. And what is the reason why older people develop cataracts? Because the most common reason causing cataracts is the exposure of ultraviolet light. As we all grow old, so we have more exposure to ultraviolet light, and the ultraviolet light, it damages the lens capsule and the lens proteins and causes a cataract. Okay, this is the world's most common. Then what about the other morphological differentiation? Remember, morphologically, it depends. We divide into three types of nuclear, cortical, and posterior subcapsular cataract. If the nucleus is opaque, then we call it as a nuclear cataract. If the cortex is opaque, the periphery of the lens is opaque, we call it cortical cataract. And if the cataract is close to the posterior capsule, then we call it a posterior subcapsular cataract. Okay? So you can have all three, of course, in the same cataract. All three can be possible. It can be one, it can be two, or all three. Let's talk about nuclear cataracts, which means the center of the lens is opaque like this. Center of the lens opaque. This is the nucleus to become cataractus. And here we have three MCQs. Look at that. Look at the color. This yellowish color that you see, it's called amber. Actually, if you want to know the correct name, it's called amber color. And the yellowish layer, it becomes amber. That is the sign of a nuclear cataract. Remember, normal cataracts, normal lenses are transparent. A lens does not have any color. But when it becomes yellowish amber, it means you've got a nuclear cataract. And this is a nuclear cataract which you see here. That tells you what are the three MCQs. First of all, it causes index myopia. Okay, what is that? Because these rays of light, they focus in front of retina. When you have a nuclear cataract like this, look at this. Because of the increase of refractive index, they bend more light, and the light comes in front of retina, so they become myopic. Okay, so they become myopic. And that is why they will complain the same as a myopic patient, which is, doctor, I can't see distances. So nuclear cataract says, doctor, I can't drive, I can't watch TV, however, I can read. So you don't have a problem in reading. Nuclear cataracts are well known for the fact that near vision is preserved, but not the distance vision. The second is called Amblyopia, which means that they have day blindness. These patients are not able to see very well in daytime. Why? Because in the daytime, the pupil constricts, there's too much light, pupil constricts. So when the pupil constricts, the rays of light go only through the center. They only through the center, the nuclear cataract is in the center, it will block the rays of light, so they can't see in the daytime. But in the night time, the pupils dilate. No, they will dilate like that. So when they dilate, the rays will go to the periphery. The periphery is the cortex, and the cortex is clear, so they will be able to see. So paradoxically, kindly remember, these patients cannot see very well in the daytime, but they see very well in the night time. Okay? This is called day blindness, Amblyopia. And second sight is a condition where their near vision improves. Okay? Because why? Because of the myopia. So remember, those of you who've done refractive errors, you know that after 40, all of us, we become presbyopic. It's not loss of cognition with age. So after 40, we all need glasses to read. But this patient, because he becomes myopic, so initial presbyopia, which are rays of light we're focusing here, the myopia forces the rays of light on the retina, and paradoxically, his near vision improves. This is called as second sight. Be careful about nuclear cataracts. When you have a nuclear cataract, the distance vision becomes worse and the near vision becomes better. This near vision improvement in nuclear cataracts is called second sight. It's called second sight because this patient would become presbyopic at 45 and vision dropped at 45, now recovers vision, near vision, due to the index myopia created by the nuclear cataract. This is called second sight because he gets it back again. Okay? So this is the three important MCQs of nuclear cataract, and be very careful that you do not miss these questions. What about cortical cataracts? Cortical cataracts are cataracts in the cortex, in the periphery, and we call them cuneiform cataract. Why cuneiform? Because look at that, they look like this. The wedge-shaped cataract, wedges, or fork-like cataracts. They have this wedges cataract here. Cortical cataracts are cuneiform-shaped cataracts. And the third one is our favorite cataract. Remember, the posterior subcapsular cataract, which means close to the posterior capsule. These are our favorite questions for asking MCQs because remember, they cause the maximum visual handicap. That means of all patients, these cataracts have the poorest vision. Of all cataracts, these patients have the worst vision or the poorest vision. Why? Because remember, they have the maximum glare. That is unwanted light. Glare means when light is radiating out from point source of light and they are washing out all the details, they do not focus on the fovea. Okay, you get a glare. No? Those of you who've seen at night, if you're driving, particularly with your spectacles on, you get a lot of glare. No? So maximum visual handicap because they have the maximum glare. But why should they have maximum glare? Because they have maximum glare because they're located closest to the nodal point of the eye. The nodal point of the eye, remember MCQ, is also located on the posterior capsule. The posterior subcapsular cataract is also on the posterior capsule. So this coincidence of the posterior subcapsular cataract right next to the nodal point of the eye causes the maximum scattering of rays of light in posterior subcapsulars and causes maximum glare. Okay, the glare of PSC is well known. You can see the glare here that you can see. Okay? Look at the glare here of the oncoming lights, headlights. So please remember again to summarize, posterior subcapsular have the maximum loss of vision because they have the maximum glare. Why? Because it's situated closest to the nodal point of the eye. Why? Because the nodal point is also on the posterior capsule, so is the posterior subcapsular cataract. And one more question, remember, posterior subcapsulars, they have loss of near vision. PSCs, they can't read very well. Why is that? Because of the pupil constriction. Remember, when you see for near vision, you have three things. You have accommodation, you have convergence, and you have constriction. Okay, so when you see a read for near vision, your pupil constricts. But when the pupil constricts, the posterior subcapsular cataract blocks the entire pupil because of the constriction. So none of the rays can pass through. Remember, a well-known characteristic of posterior subcapsular cataract is they have problems of reading. So be careful. Nuclear cataracts have very good near vision, but poor distance vision. Posterior subcapsulars have poor near vision. Okay, so that distinguishes between the two cataracts by the symptoms alone. Very well. So then we have done the types of cataracts. Let's look at some of the other types of cataracts also. So what we have is the most common type of congenital cataract. That means children born with cataracts. Congenital cataracts. This is a very famous cataract called zonular cataract, also lamella. You can see it here. Can you all say zonular cataract? It's called a zonular cataract because of the specific zone. See the entire lens. You can see the entire lens is clear, but a small zone of the lens is opaque. That's why it's called a zonular cataract. It's called zonular cataract because it's a very small zone of the lens opaque. Okay, and this is the most common type of cataract causing blurring of vision in children. Can you remember again what did I say? Remember, it's not the most common type of congenital cataract. No, that most type of congenital cataract is a more common type of than this. It is called a blue dot cataract. Blue dot cataract is small dots are there. Also called as punctate cataract. Punctate means dots. Okay, that is more common, but this is less commonly asked. Okay, because they don't cause loss of vision, so we are not interested in cataracts which don't cause loss of vision. The most common congenital cataract which causes loss of vision is this one, called zonular lamella, as you can see here. Then the key critical period of fixation, that is the time at which the fovea develops. Remember, the fovea is the single most powerful area of the lens of the retina, and this fovea normally collects 80 to 90% of light and gives the best possible vision. But this fovea is not mature. It's not developed at birth, and it develops maturity anything between 2 to 4 months of age or approximately 3 months of age. So you have to remember this, because at 3 months of age, when the fovea develops fixation or the fovea becomes mature, the vision rises very much so. The child's vision improves dramatically after 3 to 4 months because the fovea is now ready. Then another powerful question is the rosette. Rosette, remember, the word rosette means like the petals of a rose, okay? Like the petals of a rose, you can see here, rosette cataract. It's like the petals of a rose, and it's very famous because of a shape. But also remember, rosette cataracts are a sign of trauma. So when you get hit in the eye, you can develop a rosette cataract. But also remember, rosette cataracts are not overnight. Rosette cataracts take time to develop, okay? It takes often some 5, 10, 15 years. So they cannot get overnight. So you cannot have a rosette cataract, let's say, immediately the next morning after trauma. So suppose you get a question which states that the cataract occurs immediately after following trauma, then that is not a rosette. That is some other type of cataract, okay? And they're trying to fool you with the question with the history of trauma. Remember, so rosettes are a sign of trauma. Then what are complicated cataracts? Remember, complicated are important because these are our favorite cataracts. The word complicated cataract means cataract due to some disease of the eye, second disease of the eye, okay? So there has to be some disease of the eye. So if you have diabetic cataracts, that's not complicated cataract, because diabetes is not a disease of the eye. So any other disease of the body causing cataracts is not an example of complicated. It has to be specifically disease of the eye. And so the most common cause of complications are uveitis, because that's disease of the eye. Uveitis, you can have glaucoma, you can have myopia, you can have retinitis pigmentosa. All these diseases of the eye causing cataracts, we call them as complicated cataracts. Okay? And complications have three important characteristics, which is posterior subcapsular. Usually these are close to the posterior capsule. We call them posterior subcapsular. Second, these are polychromatic. Polychroma means multiple colors. So you will see a rainbow-like hue. These are very beautiful cataracts, let me tell you. Okay, they look like, shine like a rainbow. So often you ask that, which cataracts have a multiple color shine or polychromatic shine or luster? You will say a complicated cataract. And third is the breadcrumb appearance. Breadcrumb appearance means they look like crumbs of bread, the grayish white breadcrumbs. And remember, this is not the breadcrumbing, which a lot of you Gen Z doing this to your friends. It's not that breadcrumbing that I'm talking about. And those of you who don't know what breadcrumbing is, too bad. I'm not going to explain it here. Okay, this is called the breadcrumb appearance. Remember, they look like breadcrumbs. You have to call it breadcrumbs. Many of my Tamil and Chennai students, they want to call it idli crumbs. You can't call it idli crumbs. No. What else? Then you have the snowflake cataracts. They look like flakes of snow, and snowflake cataracts is a very important cataract. It's a diabetic, it's a true diabetic cataract. Remember, they look like flakes of snow. And the powerful oil drop cataracts. The oil drop cataract is like a drop of oil, and this is very well seen in galactosemia. So look at the question, remember, this combination of questions is important. A newborn child presents to you with mental retardation and cataracts. Okay? What kind of cataract do you expect? Remember, mental retardation cataract is typically seen in galactosemia. These kids are born mentally retarded. So if you have a common mental retardation with cataracts, you know that's going to be galactosemia. So the answer will be an oil droplet cataract. Okay, so be careful. Oil drop cataracts look just like a drop of oil. Then the Wilson's disease has a sunflower cataract. Looks like a sunflower. The Wilson's disease will cause a. So remember, two ophthalmic Wilson's disease. You know already more. The more common one is the. You all know that. What is that? It's called the, well, what is called? You can answer me. The ring, which is called the Kaiser-Fleischer ring. Remember the KF ring? The Kaiser-Fleischer ring, KF ring, is the more common ocular finding. The less common is sunflower cataracts of Wilson disease. Okay? It looks like a sunflower. And the famous Christmas tree cataract is myotonic. Christmas is round the corner, but the myotonic dystrophy is even more around the corner. They are present everywhere. They shine like a Christmas tree, shining and coruscating a Christmas tree. Then what about a glass blower's cataract? People who work in glass blowing industries, melting sand and silica at 2000 degrees centigrade, they get exposed to intense amount of heat. They develop a heat cataract, which is called a true exfoliation cataract. And so glass blowers cataracts are glass blowers cataracts are seen in heat cataracts. So they're not very commonly seen, okay, but they can be seen. People who work in a steel industry, they get also exposed to a lot of heat. So these people, we also call them iron workers cataracts, because they are working in steel industries, making steel from iron. And a lot of your parents work in steel industries like Tata, Tisco, SAIL, the plant in Salem, the plant in Jamshedpur, They often work as developing these steel plants. They often develop cataracts. Remember, they're examples of heat cataracts. The two examples of heat cataracts, glass blowers and the iron workers cataract. Then certain drugs also cause cataract. You have to watch out for them. Look at the ABCD drugs of cataracts. Okay? A for amiodarone, antiarrhythmic. B for busulfan, anti-cancer. C for chlorpromazine, okay? That is antipsychotic. So chlorpromazine is a very powerful antipsychotic, and this may cause cataracts over many years. C also for chloroquine. Chloroquine is for malaria, of course, but malaria is only 3 to 4 years of treatment, so that doesn't cause cataract. However, we do use chloroquine, derivatives of chloroquine like hydroxychloroquine for things like rheumatoid arthritis. That is a prolonged treatment, and that may cause cataracts, okay? The ABCD, D is dexamethasone, the steroid, and this is the systemic. So remember, of all these drugs, the ABCD drugs, A, B, C, D drugs, Dexa, which is steroid, is the most common drug causing cataracts. Please remember, systemic steroids by mouth cause the most common cataracts. These drugs also, of course. Remember, steroids can cause, any steroid can cause cataract. Injectable steroid, topical steroid, steroid creams, steroid ointments, steroid aerosols, steroid sprays, inhalers. Every little kind can cause cataract, but the most common is by mouth. Oral steroids cause the maximum cataract, drug-induced cataract. So these, remember, steroids were the most. So some of you who are on steroids for whatever reason, bronchial asthma, or those who go to the gym to pump iron, remember, be careful, you'll land up with cataracts. Then another question which you'll have to ask you, particularly in NEET PG, which can be seen in diabetic cataracts, is the famous fluctuation of vision. The vision fluctuates, okay? In the morning it's 6.6, in the evening it's 6.6, 6.9, in the night it is 6.12, or vice versa. So if you have fluctuating vision, watch out for diabetics. So in fact, many times you'll be able to diagnose diabetes just by looking at the history of fluctuating vision, okay? So you have diabetic cataracts. So these are cataracts questions. Then the next things we want to talk about, that every cataract undergoes 4 stages. Every cataract undergoes 4 stages. So let me know if the speed is okay, most of you, because I'm going a little fast because I don't want to take too long for this. I said the whole thing should be over in 7 to 8 hours, but if possible faster, because but if I'm going too fast, please tell me to slow down, because as most of you are aware, I am very, very fast in every way, isn't it? Very well. So let's look at the 4 stages of cataract. What is it? Incipient, immature, mature, and hypermature. These are 4 stages. All cataracts pass through 4 stages. We have to know them. The word incipient means early. Okay, like you people are incipient doctors. Okay, early doctors. Okay, immature. So incipient is the earliest phase of cataract where there are hardly any symptoms. There are hardly any symptoms. Patient does not complain to us. They don't come to us most of the time. Okay, then a few months later becomes immature, which is defined as a partially opaque cataract. Okay, so some areas are clear, some areas are opaque. It's a partially opaque cataract. You recognize this because the vision, loss of vision is more. It's called moderate loss of vision. So it will be 6.18, 6.24, 6.36, etc. Unlike incipient, which have 6.6 or 6.9. Okay, so there are more loss of vision. You recognize this by the grayish yellow color of the lens. Remember that I told you lens is transparent. Normally, a clear lens will be transparent. This is yellowish gray in color, and you will get an iris shadow here. This is a finding called iris shadow, which will tell you that it's a mature cataract. About 50% of these patients come to us because they realize they have blurring of vision, and we take care of them. Another few months, and it becomes a mature cataract. Okay, mature cataract, remember, means completely opaque, and it's totally opaque, right? This, so nothing can pass through. The vision becomes hand movement of finger counting. Because remember, you can diagnose the stage of cataract by the vision. So if he says hand movement of finger counting, it means it's a mature cataract. If it's 6.18, 6.12, it's immature. If it's 6.9, if 6.6, it's incipient. Okay, so this is a totally mature cataract, and the mature cataracts often cause glaucoma. Remember, they swell up, and this swollen lens is called intumescent cataract. Okay, so remember, intumescent means swollen up, and intumescent stage is seen in mature cataracts, and they cause glaucoma. So remember, MCQ can be asked is possible, is that which stage causes the highest amount of glaucoma? Which stage of cataract causes highest glaucoma is a intumescent cataract, or if intumescent not given, you can answer the highest is seen in mature cataracts. And finally, if 10% of patients, by mature cataract, 90% of patients have come to us because they can't see anything. But 10% of patients don't come to us, they are in hypermature state. They still don't come to us because they still can't see anything, but they don't come to us because these are completely apathetic patients. They don't care if they live or die, they don't care if they see or not. But they do come to us in last stage hypermature, where the lens shrinks. With the loss of water, the lens becomes very small, so very small white lens is called a hypermature cataract and keeps moving around all the time. Why? Because it's a very small lens, so the zonules cannot hold this. Originally, the zonules were holding this like this, but now they can't hold it because the lens is too small, and this lens starts moving and shaking and rocking. Okay, like Shakira, it keeps rocking all the time, and this is the hypermature cataract. Okay, remember, all cataracts pass through these 4 stages. Then, after many symptoms of cataract, you have to remember 3. The classic 3. What is that? Blurring of vision. Patient says, doctor, I can't see. And there's no pain. Remember, it's a slow, painless blurring of vision. Remember, many times you have loss of vision with pain. Cataracts is not one of them. It's a painless, gradual blurring of vision. Second, you will have double vision, or sometimes you have polyopia, multiple vision. Remember, doubling of vision in that particular eye. If you have cataract one eye, then with that eye you will have doubling either doubling or multiple vision sometimes. You have both eyes, one eye is normal, other is cataract, you will have not doubling. You will only have doubling with that particular eye. Okay? Doubling or multiple vision polyopia, and the famous colored rings which are seen in colored halos, which is so frightening to the patient. He sees these colored rings all around, bulbs of light. So you have the classic symptom, remember, blurring, polyopia, diplopia, and colored halos. This is the thing that you have for cataracts. Then what about the treatment? So when you have diagnosed cataract, remember, there are only two treatments. Either you give them glasses or you give them surgery. Okay, that's all. Glasses you give in the earlier phases, incipient and immature. Okay, but if they are mature, you have to operate them. Okay, so late for surgery. And also remember that for younger patients like you people, okay, we would try to avoid surgery. Why? Because you see, if we remove the surgery, if your lens is removed, then we take out 19 diopters of lens, which carries loss of distance vision, and you would lose accommodation. Remember, accommodation depends upon the lens, which is for near vision. So if I take out your cataracts, then your near vision would be lost. You still have distance vision, but you won't have the near vision. So for younger people, near vision is important because you have to write to exams and do many other things, exams apart from that. So near vision will be a major loss of vision for cataract surgery. So we can operate on older patients about 40, 45 because they've already lost their near vision because of presbyopia. But for younger patients less than 40, we would not like to operate because we will sacrifice their accommodation needlessly. So let's look at the surgical indications. So remember, there are two important indications. First, they are advanced cataracts, they are mature, half mature. Second, if they're visually handicapped. Visually handicapped means you have to ask them that, look, are you visually handicapped? Which means, can you do your day-to-day activities? A person who cannot do his day-to-day activity is called visually handicapped because he cannot earn his living. So a driver who can't drive is visually handicapped. Operate him. A plumber who cannot fix the pipes is visually handicapped because economically handicapped. Operate him. A teacher who cannot see his own students and the exercise books is visually handicapped. Operate him. So people with visual handicap and people with mature cataracts need surgery. Okay, and so you see this is typical blurring of vision, which you see. The blurring of vision, you see the outlines are visible, but the details are hazy. Okay, so that is typical loss of vision in cataracts. This little vision. Then let's look at some of the few surgeries. Remember, cataract happens to be one topic in ophthalmology where the surgeries are asked. Otherwise, most of the surgeries we don't ask you in ophthalmology, but cataracts, yes. So the first one is ICC. Remember, it stands for intracapsular cataract extraction. Intracapsular cataract extraction. What is that? You take out the entire lens and the capsule. You take out both together. Okay? And so this creates a condition which is called aphakia, which is the absence of the lens. Remember, phacos means lens. So aphakia means absence of the lens. You've taken everything out. So you give them these thick glasses which will correct for the distance vision, but they cannot give a near vision. So this is aphakia, and aphakia, remember, has a lot of problems. Why? Because you see, because you wear these glasses which are thick lenses. Remember, you have replaced a lens which is 19 diopters of power, is not? You want to give them glasses. The glasses will have very high power also, 15 diopters. Such thick lenses, they will cause magnification because these are convex lenses. And remember, each convex lens diopter magnifies by 2%. If you wear these thick lenses, you have a 30% magnification, which means that you will not have fusion. Remember, I told you, or you should know, that fusion occurs when the maximum difference in image size should be 5%, not more than 5%. If it's more than 5%, you're not going to fuse, you will have diplopia. So these patients land up with diplopia. A jack-in-the-box scotoma, where your jack-in-the-box is a toy. When you open the toy, and it comes out like a spring like this, jack-in-the-box. So this is a jack-in-the-box where you wear this patient wears thick aphakic glasses, and at a certain point, he finds objects disappearing suddenly. You can see somebody coming like this. At a certain point, which is about 50 degrees away from the lens, this object suddenly disappears. Why? Because at this particular thing, the rays of light, they strike the edge of the lens, and the rays go out like that, reflecting out. So suddenly, this person here, he disappears, and as he walks out of that area, he again reappears like a jack-in-the-box. Okay, this is a very powerful and very famous optical illusion of aphakia. We call it a jack-in-the-box. Then we have a pincushion distortion. Pincushion distortion means everything appears to be distorted like this. Okay? All the buildings, all the people, all the cars, all the trees, they appear like a pin cushion, bent outwards like this because of the high magnification power of the convex lenses. So this is a world without any straight lines. It's very disorienting, let me tell you. Okay? So these are the three important MCQs that you have, and they have loss of orientation also. They cannot judge depths. So on trying to pour water into a cup, they will pour it over themselves. Trying to drink water, they may spill it on themselves. Okay, they fall down the stairs, they fall in the streets, they can't walk properly. So multiple side effects of aphakia. We hate aphakia. We don't do aphakia anymore. So we don't do this surgery called intracapsular surgery anymore, except for one particular indication, which is what? Which is a subluxed cataract or dislocated cataract. So the next surgery that was discovered, invented, was the ECC. What is that? Extracapsular cataract extraction. Here what we do? Here we take out the lens, but we leave the capsule. Okay, see, this was the capsule like this. So we take out, make a small opening here, and we take out the cataract, place the intraocular lens here, and we leave the capsule behind. So the whole point is that we make a small opening in the capsule, and we do not remove the entire capsule. From this, we remove the cataract and we place the IOL. So the intraocular lens, this is called IOL, which is one of the great inventions of ophthalmic world. And the next one, when you open the bandage, the rays of light are focused by the intraocular lens perfectly on the retina. Patient get a very good vision around 6:18 the next day. This whole surgery, we call it, this IOL is called a posterior chamber intraocular lens, PCIOL, a posterior chamber intraocular lens, because it's on the behind the iris. And this whole surgery is called ECC with PCIOL, extracapsular cataract extraction PCIOL. And this condition, when you have an artificial lens, it's called as pseudophakia. Remember, pseudo means artificial, aphakia means no lens. So when you do intracapsular, the eye becomes aphakic. When you do ECC, it becomes pseudophakic. Anytime you place an intraocular lens, it becomes pseudophakic. Okay. So the next thing, surgery, the most advanced surgery nowadays, is the phacoemulsion. This is what we do. Phacoemulsion means stitchless surgery. Okay. So what we do, we make a very small incision. Okay. So either through the sclera or through the corneum. It's called a tunnel. It looks like a tunnel because it has walls and it has a roof and a base. It looks like a tunnel. We can make a very small opening through this, which is less than 2.8. It's less than 3 mm, around 2.8. And through this, we induce a probe which breaks down the cataract and takes it out. It has to emulsify. That's what emulsification. Okay, it breaks it down by hammering it away with mechanical hammering away at the rate of 40,000 times per second. It breaks down the cataract, takes it out from there, and we squeeze in an IOL, a foldable IOL. Remember, this IOL is very flexible and can be folded like this. You fold the IOL, you put it inside, and unfolds inside beautifully like a flower. And this, because the opening is so small, less than 3 mm, and because it's made in 3 different planes, okay, it goes 1, 2, and 3 in planes 1, 2, and 3. And remember, single plane will not self-seal, okay, but this is in 3 planes. You have 1, 2, and 3. It's a multi-planar. It creates a valve, and this valve seals the incision. So this creates, we do not have to stitch this incision. We don't have to put a stitch or a suture. It automatically seals. It's a self-filling incision. And this, we put a foldable IOL. So the next vision is 6 by 6 because there is no stitches, no distortion of the cornea, no astigmatism introduced. The patient develops very good vision. Okay, so this is the principle of the phaco, which you do nowadays, the most popular surgery. And then because phaco is expensive surgeries, because we need a phaco machine, and we need the foldable IOLs, which are expensive, and we need all these instruments, which are expensive. So everybody cannot afford a phaco in our country. So what we have, particularly for India and most South Asia, we use this very important surgery called SIC. It stands for Small Incision Cataract Surgery, or Manual Small Incision Cataract Surgery, where again we make an opening, but it is not that small as phaco. Phaco is less than 3. There it is 6 mm. You can see it here in this picture. See, this is approximately a 6 mm incision like this, and through this again we make in 3 planes 1, 2, 3. So it is again self-sealing. Okay, so we take this thing and manually extract that. So we break the lens with the force of our own hands. Okay, in a phaco we use a phaco machine which breaks down, hammers the lens down by relentless action of a ultrasonic probe. Here we break it down manually with the force of our own hands, and we take it out through a 6 mm opening. And so what happens is, here we don't need a foldable IOL. because the opening is 6 mm and we don't use a foldable IL because we don't have to fold. So this reduces the cost. Okay, we use a PMMA, and here also no stitches are required. Why? Because 6 mm is enough to maintain the incision. Also remember, we make in 3 different planes. So anything more than 6 mm cannot stay without stitches. So if you keep it under 6 mm and you make it in 3 different planes, so again no stitches are required. So again the vision is 6/6 after cataract surgery. So this is economically very viable. We don't need a phaco machine. We don't need a foldable IL. We don't need powerful instruments. So we get the very good vision of phacoemulsification because again there are no stitches here without the phaco machine and cost. So this is a very important surgery which we do in South Asia and India, where economically weaker countries. So SI says, remember, your question can be asked that this is the most commonly performed cataract surgery. This is the most commonly performed cataract surgery in India and South Asia. Okay. And then remember, so what are other questions possible? Remember, it's a slightly bigger opening because 6 mm, no, because after all, you're breaking down the lens with your own hands. This can never be as minute as the small fragments with the phaco machine. So it is a bigger incision, and remember, we don't need a foldable IL. Very well. Now, the latest surgeries that have been introduced about a few years back only is called FLACS. It stands for Femto Laser Assisted Cataract Surgery. Okay, there's a new laser which does do cataract surgery. And this laser, what it does, this laser surgery, it has 2 advantages. So it creates a perfect, see, when we have to take out the capsule, we have to cut the capsule, no? We have to cut that capsule with our own hands, no? That's called capsule rhexis, and that's manually. So here, the laser beam performs a rhexis, which is a perfect circle. See, when I draw a circle like that, this is my rhexis. You can see how it's ragged, it's irregular, isn't it? So with a laser, it creates a perfect rhexis, and that is why this FLACS is this advantage of a perfect capsule rhexis, and it's a very tight incision because we don't use a blade here. We make the incision with the femto laser itself, so there's no leakage here. So these 2 advantages give, it's a lot of advantages. It's called FLACS, but unfortunately it's very, very expensive. In our country it's very expensive, so most of us, we don't do FLACS, but many of us do. And this is the last surgery. So remember the advantage of femto laser, FLACS, femto laser assisted cataract surgery. The laser is used as femto. The 2 advantages, it creates a very tight opening and creates a perfect rhexis, but it's too expensive. It's a bit like phaco. Again, it's stitchless. Remember, there are 3 stitchless of these: phacoemulsification, SICS, and FLACS. All these 3 are stitchless. We don't apply stitches here. And the stitches that we use here are in ICC and ECC. So of the 5 surgeries I have described, only 2 of them have stitches. ICC, which is the oldest one, and ECC, which also is pretty old. The rest of these 3, phaco, SICS, and FLACS, don't require stitches because they're all small incision. All of them are multiplanar. Okay. Then an MCQ about a refractive question. Okay. Refractive questions of IOLs. What about the IOL power? What are the IOLs? And then let's look at intraocular lens. Remember, we have to remember that we have to calculate this power for everybody. Remember, just as you all wear glass of different power, you know, somebody's wearing -1, somebody's wearing -2, somebody's wearing -3, +1. Similarly, for every patient who do cataract surgery, we have to calculate the IOL power. Okay, this IOL power is calculated by a technique called as biometry. You see why? Because when you place intraocular lens, remember, the rays of light have to focus perfectly on the retina. No, only then will you get good vision 6/6. No, the IOL has to be absolutely correctly powered. No, so for instance, most of the IOL powers that we put, the most common IOL power is around 21 diopters. Okay, this also you can remember as MCQ. What is the most common power of the IOL implanted? The most common power of IOL implanted is about 21 diopters, because remember, our lens carries 19 diopters. No, all of us remember the normal power of the crystalline lens is 19 diopters. The IOL is also close to that 21 diopters. But suppose, but all of us not 21. I could be 21, yours could be 22, his could be 23, somebody could be 19. But suppose so this power, what exact power has to be calculated for the IOL implantation is checked with a biometer. Remember, biometer is the instrument which checks the IOL power. Don't confuse biometrics. Biometrics is your fingerprints or for iris scans for identification of a person. Isn't that biometrics? This is biometry. Okay? And this biometry requires 2 important investigations which you need to know. One requires the axial length, the eyeball size, okay, which is mostly 24, most of us, and keratometry with corneal curvature. So remember, MCQ can be asked, which 2 variables are required to calculate the IOL power? We require 2 variables. the corneal curvature, and the axial length. Okay? For every patient that I want to do cataract surgery, suppose I want to do cataract surgery for any of you, then I would calculate your keratometry, your axial length, and then this will give me the correct IOL power. Then remember foldable IOLs, you have to remember the two materials, acrylic and silicone. We have the two of them, acrylic and silicone, two different types of IOL. You have to remember both the names. But non-foldables are not acrylic or silicone, they are less expensive and they're made up of PMMA, a type of plastic, polymethyl methacrylate, PMMA, polymethyl methacrylate. And the lowest incidence of PCOs, remember PCOs are what? Secondary cataract. You know that most of the secondary cataract, the most common complication of cataract surgery is sometimes called secondary cataract or called as PCO, posterior capsular passivation. So there's another MCQ. The lowest incidence of PCOs is with hydrophobic cataract. Now this is a more advanced MCQ and this is mostly asked in NEET PG, but you might as well know it because a lot of questions are borrowed from NEET PG. Okay? So please remember, and in fact I must tell you something, ladies and gentlemen, you have to listen to me. In the last 2-3 years I have found, and many of my faculties, our faculties think so too, that the FMGE exam is becoming more difficult than the NEET PG itself. This is not only my impression but other faculties, so you have to watch out. Okay? Kindly remember, the secondary cataracts depend on the material of the intraocular lens that you place. And the IOL with the least amount of secondary cataracts or the PCO, which is desirable because we don't want to have secondary cataracts, is this particular acrylic IOL, which is called hydrophobic. Hydro means water, phobic means hating, so it repels water, hydrophobic. So this is a kind of acrylic IOL which repels the water, and this has the lowest incidence of secondary cataracts. Many of you ask me, many of my students ask me, sir, my parents are getting operated and the doctor has given us the choice of intraocular lens to be implanted. Which IOL should I ask them to implant? Remember, ask for a hydrophobic acrylic IOL. This has the least amount of secondary cataracts. Okay? Then what happens, remember, when you place the IOL, you will always have to wear glasses, because there's no accommodation. So you have to wear glasses. But supposing there is a patient who doesn't want to wear glasses after cataract surgery, there are many patients like that, they hate to wear glasses after cataract surgery. In that case, we have a special IOL, we call this a multifocal IOL. Yeah, multifocal IOLs have two different foci, one for distance, one for near. If you implant a multifocal IOL, then you will not require to wear glasses. But they are expensive and they have their own problems. The world's most common intraocular lens implanted is a monofocal. Okay, is a monofocal. That means it carries only the distance power. You have to wear glasses. Okay, but multifocal IOLs where we don't have to wear glasses because they will also have a focus for difference. But they are expensive and their own problems. And then the complications, which I was telling you, remember complications. You have the first one, as I told you, this one, PCO, also called the after cataract, also called a secondary cataract. This is the most common complication of cataracts. Okay, remember, almost 50% of patients have the secondary cataracts. You have to remember the two names. The Elschnick's pearl is the most common, and Sommering rings is less common. Okay, there are two, pearls and rings. Okay, remember, pearls and rings sounds like a jewelry shop, but it's not a jewelry shop. It is very much an ophthalmic shop. Okay, Elschnick's pearls are more common, Sommering rings are less common. How do I treat them? Secondary cataract, I open the capsulotomy by a laser which is called the Nd:YAG laser. Can you remember? This is the second laser of ophthalmology, but this is the most important. We've already discussed one laser, which is femto. The second laser is the Nd:YAG laser, which has, you have to memorize the wavelength is 1064 nanometer. What is the full form of Nd:YAG? You have to remember neodymium, yttrium, aluminum and garnet laser with 1064 nanometer. So this is the second laser we've talked today, and this is the most important laser of entire ophthalmology. There are 6 lasers, we'll discuss all of them. Then another complication is Irvin gas syndrome. What is that? This is post-surgery cataract cystoid macular edema. Whenever you have cystoid macular edema, that's this edema over the macula, taking small cysts, we call cystoid macular edema. The cystoid macular edema occurs after a lot of ophthalmic surgeries, but occurs particularly commonly after cataract surgery, and this is called as Irvin gas syndrome. Please remember this famous name, IGS. Irvin gas syndrome is the phenomena of cystoid macular edema occurring after cataract surgery. It is also very common. It also causes slow, painless blurring of vision. So overall, most common cataract complication, of course, secondary cataract. So Irvin gas syndrome is another complication. Remember how we diagnose it? We diagnose this by not only by the loss of vision, but also by this phenomenon, symptom called as metamorphopsia. Metamorphopsia, which is distortion of shape, okay? You know, morphology means shape. So all the straight lines like this, they will appear wavy and distorted like this. This is called metamorphopsia, okay? So whenever you have this wavy lines like this, it means you are suffering from some macular pathology. It could be CME, it could be CSR, it could be ARMD. Any macular pathology, the non-specific about it, the vision appears to be distorted. It's called metamorphopsia. Okay, so this is a sign that you have CME. Then the most common dangerous complication of this is called as complication of cataracts is called endophthalmitis. Look at that. The word endophthalmitis means infection of the vitreous cavity. The end of thal means vitreous. So it is an infection of the vitreous cavity, and there are two different types of endophthalmitis. One is called early onset if it occurs in less than 6 weeks after cataract surgery. If it occurs within 1.5 months of cataract surgery, this is called early onset endophthalmitis. If it comes after 6 weeks or 1.5 months after cataract surgery, we call late onset. Okay, the early onset endophthalmitis is caused most commonly by the staph epidermidis. MCQ, remember this? The most common organism is the staph epidermidis, and late onset is Propionibacterium acnes. P. acnes, remember this is the same bacteria which causes the pimples. Staph, why is the most common? Remember MCQ, another MCQ, because staph epidermidis happens to be the most common commensal. Commensal means this is the most common microbial organism present in a normal eye. You all have commensals, no? An organism which is present normally, which does not harm the body in that particular. Okay, so the most common commensal in the eye is staph epidermidis, and this is the most common cause of infection in endophthalmitis. Okay, the acute onset or early onset, late onset endophthalmitis is Propionibacterium acnes. And remember, endophthalmitis, what is the drug of choice? You have to give intravitreal, you have to give, because infection of the vitreous cavity, so we will have intravitreal antibiotics you'll have to give. For most of the, we give vancomycin. Okay, vancomycin is the drug of choice because these are mostly gram-positive infections. So vancomycin is drug of choice, and if it's gram-negative, that's rare, but can happen, then you give amikacin or ceftazidime. And for late onset endophthalmitis is this is not very common, but can seen after 6 weeks. It is called as Propionibacterium acnes. Now, a few questions which I am getting. First, about the PDF, the annotated PDF. The annotated PDF will be available to you after the class on Dr. Bhanu Prakash's Telegram channel, the annotated one. Okay, that will be uploaded tomorrow. Okay, that's the first question if you're worried about it. And this PDF, you are already getting it. And then another question which I'm getting repeatedly is, yes, I will do how to solve numerical questions in refraction. We're going to do it tomorrow, so don't worry about that. Third question is one repeat question I'm getting it is that what is the treatment of choice in a very old patients with NLD blockage? So that's not a bad question. So sometimes if for 60-year-old, 60 or 70-year-old patients, we have difficulty doing DCR. So we do something called a DCT, dacrocystectomy. Okay, what we do, we don't connect the dacrocystor to the nose. Okay, rhinostomy we don't do. We do dacrocystectomy because they're very old, 60, 65, 70, and we just get rid of the dacrocystor, which is a lacrimal sac. We just take it out. It causes a lot of watering, but that's okay because DCT is easier for the patient to handle. So remember, in a very old patient who has fibrotic, mostly the lacrimal sac is usually fibrotic or sometimes even tumorous, we just call DCT, dacrocystectomy. That is a better choice than DCR, which may have complications later on. Okay, so that deals with the question which I've been umpteen times again and again. And then another question is that, and it will be first NLD blockage, numerical questions regarding the refraction is correct. And so we've got most questions here done. So in oil drop cataract, there's a question I've just got, which is oil drop cataract, so you needed or not? Well, that depends on the vision. Sometimes the oil drop cataract needs to be removed. Sometimes we can let it be because the child is too small. So it depends on the vision. So you will get that question, that vision is poor, you will take it out. Okay. And then what about anti-capsulotomy? There's a question anti-capsulotomy, which I told you that what happens, when you want to remove the cataract, see, this is the cornea, this is the capsule, and you have a cataract here inside like this. Now how do I take the cataract out? You have to take it out. The cataract is enclosed in a capsule. So what we do capsulectomy. Okay, so capsulectomy means you remove a small piece of the capsule like this. Okay, so you can see we removed a small part of the capsule like this, and through this we take out this cataract. The cataract was initially like this, wasn't it? So we don't remove the entire capsule. That's called capsulectomy. Now, if you remove the entire capsule, then you cannot place an IOL because there's no place for the IOL to stay, is it not? So for the intraocular lens implantation, what we do is we just take out the capsule, a small opening. This is called capsulotomy. You know that otomy means make a small hole. So this is a capsulotomy. What we've done here is like this: removed a small part of the capsule and done a capsulotomy. So this is capsule. If you want to take the entire capsule out, as we do it in intracapsule, the whole capsule is removed like this. So then you cannot implant the IOL. You cannot implant the IOL because there's no space. There's no place to put an IOL. I can't put the IOL on top of the vitreous, is it not? So that's what it is. So this is called capsulotomy. And what about the Nd:YAG capsule? No, that's different. Nd:YAG capsulotomy is different because what we do in that is you have got a secondary cataract. See, this is the capsule, this is the intraocular lens here, and what you have, a secondary cataract, is you've got a thickening here, okay. So this is blocking the rays of light. This is the secondary cataract, which is Elschnick's pearls, the Sommering rings. You can see the rays of light are getting blocked by this, So this is a patient who's very irritated. He comes back to you after cataract surgery within 6 months or 8 months or 1 year and says, "Doctor, what have you done? I can't see again. Initially I could see, but because development of secondary cataract, the rays are blocked again." So this is called blurring of vision after cataract surgery. Is called a secondary cataract. So what we do, we take a laser beam, and this laser beam is Nd:YAG laser. This laser focuses the rays of light right on that thickened capsule here, and it cuts that area of the capsule. It's called a secondary capsulotomy. Okay, remember, the property of a laser is that when you focus it on certain thing, it will damage only that particular tissue. It will not damage the tissue that it passes through. So as you can see, the laser passes through the cornea. It does not damage the cornea. It passes through the IOL. It does not damage the IOL. It only damages the area on which it focuses. This is the capsule. So what it does, it removes this part of the capsule like this. Okay, see, it removes. This is called capsulotomy. So now you can see we remove this little area of the capsule like this. And along with this, the secondary cataract also got rid of. So now the rays of light can focus on the retina perfectly. Okay. This is the principle of Nd:YAG capsulotomy. It's a very simple solution, a 2-minute solution for a very complex problem, which is a secondary cataract or after cataract. Okay. These are the multiple questions. And Sommering rings, and I haven't explained, I told you Sommering rings, we have basically 2 types of secondary cataracts. Okay. One is the Elschnick's pearls, which you saw here, or I do have a picture here. See, this is what you saw here, is a multifocal. See the rings, how to recognize the multifocal IOLs. On a picture, you can see by these rings that you will see. On a monofocal IOL, which is much more common, we don't see any rings. You'll identify these rings on the IOL, and this is a multifocal IOL. And secondary cataracts, we have 2 types: Elschnick's pearls, which is more common, and Sommering rings, which is less common. Okay, right. Then next topic, we're back to work again, and this is the amblyopia. Let's look at amblyopia. In the last 2 years, remember, have been asked very commonly. The amblyopia, the other name is called as lazy eye syndrome. Okay, LES, kindly remember, and it is a very common condition amongst young people. So many of you are watching this video who are, I'm sure, will be amblyopic. Okay, what is that? Let's look at that. It's a loss of vision in children due to prolonged visual deprivation. Okay, so how much loss of vision? Usually more than 2 lines. That means in a patient we're expecting to be 6'6", the patient will be at least 6'12", or less than that. So 6'18", 6'24", 6'36". It cannot be 6'9". 6'9" is only 1 loss of vision, so that does not come in the definition of myopia. So it's a loss of vision in a child less than 2 lines, okay, more than 2 lines of loss, which is not attributable to any structural defect. That means there is no cataract, there is no glaucoma, there is no squint, there is no refractive, there is nothing, and yet there is loss of vision. That is called amblyopia. So the causes, of course, there is a cause. You can't find that cause. That's a different thing. We remember these causes of amblyopia as strabismus, which is squint, is the most common cause. So these are children who have squints at birth and they're not able to see clearly. Okay, and they develop amblyopia. So this is the number 1 cause of amblyopia. Remember, a lazy eye is a patient who had squint in childhood and is not able to see clearly. Okay. Second is refractive error. Refractive is uncorrected refractive error. So suppose you needed glasses when in childhood there, but you did not wear glasses. The rays of light are not focusing on the retina, so you would lose vision again. This uncorrected refractive error. Remember, these are mostly hypermetropes. These are plus powered wearer glasses, okay? Remember, so there are many of you who do not wear glasses, and when you should have worn them right from childhood onwards, okay? And these are plus powered glasses. And now when we give you glasses, you will not improve, okay? This is called hypermetropia. And the third one is some organic errors like cataracts and ptosis and all. Because the cataract is blocking rays of light, so rays of light are not focusing on the fovea. The rays of light not focusing on the fovea, child develops amblyopia or lazy eye because the fovea somehow forgets to see it. It becomes lazy. Because rays of light not focusing on the fovea, fovea forgets how to see it. This is the lazy eye development that you have. So these are the three multiple causes of loss of vision amblyopia. So the critical development number is 8. So though some of you remember how to diagnose amblyopia in your case. Suppose there is a patient amongst you, suppose there is some student amongst you whose vision is 6/6 in one eye, but the other eye is 6/18, okay? Now, when I check his eye, I find there is nothing. There's no cataract, there's no glaucoma, there's no squint, there's no refractive, there's nothing. The eye is absolutely normal. And yet the vision is poor. This is called amblyopia. Remember, not attributable to any structural defect. Do you understand? So this is amongst you, there will be at least one of you who has poor vision for which there is no cause. No cataracts, no glaucoma, no refractive error, no squint, no detachment, nothing. So then what is the cause of loss? That is amblyopia. So then we have to find out, we have to go into your childhood of the child, of the patient, okay? So, and then we find out, well, maybe the child had cataract at birth, maybe he had squint at birth, maybe he had refractive error for which he did not wear glasses, and that is the cause of amblyopia. Remember, the most important thing to remember is amblyopia occurs up till 8 years of age. 8 years of age, after that doesn't come. So this student, this hypothetical student who's sitting amongst you, who has 6/18 vision amblyopic, it means he became amblyopic in the first 8 years of life. You cannot develop amblyopia now, okay? So at this age, after 8 years of age, you cannot develop amblyopia. But unfortunately, after 8 years of age, you have no treatment also. So this is called the critical phase because amblyopia occurs before 8 and the treatment is also before 8, okay? So amblyopia lazy eye syndrome is that. So the problem is that after 8 years of age, we have no improvement of visual acuity after correcting visual disorder. A very famous phenomenon is called the crowding phenomenon. Crowding phenomenon means what? Crowding phenomenon means that when you present stimuli to this child or this patient in a crowd, he will not be able to see it. But when you present this as a single stimulus, he'll be able to see. So supposing you have these, you present these letters, the fourth line, VOXT, okay? There are letters, 4 letters in the fourth line of the Snellen's chart. When you ask him to read it, he won't be able to read it. But suppose you block out these 3, you close the other letters and present only the letter V to him, the patient will be able to read it, okay? This is called as crowding phenomena. That means in a crowd or a clutter, patient is not able to see, but present as a single stimulus, the letter V or the letter O or the letter X or T as a single stimulus, they will be able to see. This is called crowding phenomena. This is a very important property of amblyopia. And what is the treatment? Remember, treatment is only up till 8 years of age, I told you. So I'm sorry to say that if any of you are amblyopia right now watching me, we have no treatment for you. We cannot treat amblyopia after the age of 8 or maximum 10 years. Maximum 10 years, after that we can't treat. So I'm so sorry, if anybody is amblyopic here, we can't do anything for you. Okay? But before 8 years of age, what we would do, we would close the eye. Occlusion means close, look at that. In this child, we can see we close the eye for 6 to 8 hours in a single day, okay? 6 to 8 in a single day, every day for 6 to 8 hours, you close the good eye, remember. This is the amblyopic eye, this is the normal eye, we close this like this, and we force the bad eye, the poor eye, the amblyopic eye, we force the bad eye to develop fixation in those 6 to 8 hours. You see, because if I did not close the good eye, the child would never recover vision in the bad eye. He would only see with the good eye. Forcing the good eye close forces the bad eye to develop fixation. And this takes about 6 months, 8 months of occlusion and maybe 1 year, but they get very good vision. But only till 8 years of age. Sometimes the child resists occlusion. You see, we have to close the eye with a patch or a bandage like that. The child resists that because he doesn't see with the other eye, he's amblyopic in the other eye, and he cries and pulls it off. In that case, we do penalization. Penalization means punish. We put a drop atropine. Weekend means only Saturday, Sundays. We put atropine only Saturday, Sunday in that eye. That causes blurring of vision in the good eye. Again, the good eye. Amblyopia occlusion, remember, is always done in the good eye. We close the good eye so that we force the barrier to develop fixation. So we can put it, remember the drug of choice is atropine, which causes blurring of vision. So the treatment is actually occlusion is better, but suppose children don't want occlusion or they resist occlusion by crying excessively, pulling the bandage off, then we can penalize them. Penalize means we punish the good eye. Punish the good eye for being too good. So don't be too good, okay? Too good, we often punish you. Remember, of late, so amblyopia has been asked quite a bit, so you have to be careful about amblyopia because in the last 2-3 years we have been asked amblyopia. So again, to summarize, okay? So suppose you have any of my students, you have one eye 6, 6, 6, 18 at which you are sitting right now. If I find that 6, 18 is there, but the eye is absolutely normal, no cataract, no glaucoma, no detachment, no squint, no refractive error, that means amblyopic. So then I look into your history. I delve with history when you were a kid. Before you do, did you have refractive error, not wear glasses? Yes, that is the cause of your amblyopia. Did you have squint for which you did not get corrected? Yes, that is the cause of amblyopia. Did you have a ptosis which was uncorrected? Yes, okay, that caused loss of vision. You understand? So anything that causes loss of vision in a child during the first 8 to 10 years of age. Why this particular 8? Because that is called the plastic age. The brain is highly plastic and is able to form new influences. Plasticity of the brain means that a brain can adapt to new influences, new change. So in that particular critical period, if images are not forming on the brain, so it becomes amblyopic. Okay, so that is why after 10 years of age, we cannot, the brain is no longer plastic, is not able to adapt itself to new images, new memories, new stimuli. So that is why there is no treatment after 8 to 10 years of age. Okay, so be very careful about this. The most common cause is uncorrected squint, uncorrected refractive error. So one more question I would like to ask you, which they love to ask you, is suppose the question is a 5-year-old child has 6 by 60 vision. Okay, when we give what is the cause of loss of vision? It is refractive error of +3. When you give him +3 diopter sphere, the vision should become 6 by 6, but does not become 6. It becomes 6. It still remains 6 by 6. Okay, so again, see, 2 children. Suppose both of them are 5-year-old kids. Both of them have poor vision, 6 by 60. Both of them have 3 diopters difference. Okay, they need glasses. Remember, the patient A is a hypermetrop, he needs +3. Patient B is a myop, he needs -3. So when they come, they have both of them, remember, 6 by 60 vision. When they come to me, I give them both glasses. But when I give it to -3, vision improves to 6 by 6. But when I give it to +3, vision remains 6 by 60. This vision, which goes to 6 by 6, is the refractive error. So if the vision improves with glasses, it is a refractive error. If it does not improve, it is amblyopia. Okay, remember, it is only amblyopia when, despite correcting the refractive error, the vision does not improve. So you give glasses, it doesn't improve, amblyopia. You correct squint, vision does not improve, amblyopia. You do cataract surgery, vision does not improve, amblyopia. Okay, if it improves, then the diagnosis is the cataract or the squint or refractive error. If it doesn't improve, it's amblyopia. Why doesn't it improve? Because the brain has forgotten how to see. Okay, so kind of remember, amblyopia is a very important topic. We get a lot of questions on amblyopia, and children become amblyopic primarily because they don't come to us. Okay, very well. So we go to now, we finish cataracts now. We go to another important topic called uveitis, inflammation of the uvea. So this is the inflammation of the uveitis. Remember the uvea, if you remember the uvea, what is iris, ciliary body and choroid. Okay, remember there are 3 things: iris, ciliary body and choroid and uvea. So inflammation of any of this or all of them is uveitis. So if the iris gets inflamed, we call it iritis. The choroid gets inflamed, is choroiditis, and ciliary body gets inflamed, we call it cyclitis. Remember, the word cyclo refers to ciliary body. And if all of the 3 gets inflamed, we call it as pan-uveitis. So there are 4 types of uveitis. Okay, pan means the whole thing is there. The anti-uveitis is if the iris or the ciliary body gets inflamed. Okay, iris or the part of the ciliary body which is the pars plicator. Intermediate is when the pars plana and the vitreous gets inflamed. This is called intermediate uveitis. And posterior uveitis, as you can see the diagram here. See, the diagram tells you, see, this is the iris. When this gets inflamed along with the part of the ciliary body, this is the pars plicator. This is called as anti-uveitis. So it can be a plain iritis or it can be iridocyclitis. Second is intermediate, if this is the pars plana and this is the vitreous here. Okay, so if the pars plana and the vitreous both get inflamed because they are in continuation with each other, this is called as intermediate uveitis. This is intermediate uveitis. And the third is posterior uveitis, if the choroid gets inflamed. If the choroid gets inflamed, this is called as choroiditis, also called as posterioritis. So it depends on the anatomy, which part of the eye gets inflamed. Okay, this is the inflamed, and this is anterior, intermediate, and posterior uveitis. And if the whole thing gets inflamed, remember, whole means pan, called panuveitis. So let's discuss this. And in uveitis, apart from this classification based on anatomy, we have another class which is called acute uveitis and chronic uveitis. Acute uveitis means uveitis which lasts less than 3 months, and chronic uveitis which lasts more than 3 months. Any uveitis lasting more than 3 months is called as chronic uveitis. Anything less than 3 months is acute uveitis. And then one more classification we have to know. What is that? It's called granulomatous and non-granular uveitis. Granulomatous uveitis means uveitis caused by any disease which form granulomas, like TB, syphilis, sarcoid, Lyme disease, etc. So that is called granulomatous uveitis. So these are not very common. They're dangerous, but luckily they're not very common. Okay, much more common are called non-granulomatous uveitis. So they do not form granulomas. So kindly remember, when we write diagnosis of uveitis, we have to write the full form, whether it's acute or chronic, whether it's anterior, intermediate, posterior, or pan, whether it's granulomatous or non-granulomatous. Okay? So the full description of uveitis would be something like this. You can write as acute, anterior, non-granulomatous uveitis. Okay? So this is the full, this is an example of a kind of uveitis we did. Now, so what is of this lot, remember, the most common is this one called as anti-uveitis. This is the most important. Why it's most important? Because it's the most common. Almost 70% of all uveitis is anti-uveitis. So anterior part of the iris gets the most anterior part of the iris and the pars plicatum is anti-uveitis. And then anti-uveitis is the most common, 70% as I told you. And the most common cause is idiopathic. Remember, what is idiopathic? Idiopathic means that there is no known cause. So there's no known cause. We don't know why. Almost 50% of all anti-uveitis, we don't know any cause. So this is the single most common cause. But we don't ask you questions of idiopathy. Idiopathy is nothing to ask. So what is the second commonest cause of anti-uveitis? Are certain diseases which are linked to this particular group of antigens called the HLA-B27. Okay, this is called the HLA-B27. Remember, the HLA full form is human leukocytic antigen. Okay? So this is an antigen which is present in the blood, and people who have HLA-B27 positive, you have to do a test for that, they have these 4 types of spondyloarthropathies. Look at that. Spondyloarthropathies means disease of the spine and the joints. So there are people who have their disease of the spine and the joints, and there are 4 of them: ankylosing spondylitis, IBD, ulcerative colitis, and psoriatic arthritis. Okay, so remember that these are 4 diseases which occur to people which are HLA-B27 positive. Okay, so HLA-B27 positive will have a higher chance of developing these 4 diseases, and these diseases, they can cause anti-uveitis. So the number 2 cause of anti-uveitis, remember, is this one called ankylosing spondylitis. Can you remember this? This is a disease very commonly in our country and has 3 characters. It is found in young males which are tall and thin. Okay, so remember, tall, thin, young males. Okay, many of which are my students. So tall, thin, young males who have chronic low backaches. Remember, any of you who are tall, thin, and young males and have chronic low backaches, you have to see a doctor. You could be ankylosing spondylitis. The ankylosing spondylitis occurs, and this causes the second most common cause of anti-uveitis. Okay, so remember, this MCQ often asked a young male with low backache, especially red painful eyes. Remember these ankylosing spondylitis and the red painful eyes telling you they are causing anti-uveitis. Okay, so this is the second most common after idiopathy. Then IBD, inflammatory bowel disorder, remember, consists of 2 diseases, either Crohn's disease, or ulcerative colitis. There are 2 of them, and they are seen in young ladies, usually middle-aged young ladies, 30s, 40s, and IBD also cause anti-uveitis. So typically with this MCQ often asked that a 40-year-old lady comes to you with bloody stools and red painful eyes. Look at that. Bloody stools in combination with red painful eyes is a combination of anti-uveitis with inflammatory bowel disorder. So please remember, bloody stools and red painful eyes means it is IBD causing anti-uveitis. Third type of disorder, HLA-B27 positive, have the psoriatic arthritis. So these have psoriasis and they have arthritis, and they also cause recurrent anti-uveitis. Fourth is reactive arthritis. Reactive arthritis, remember, is a classic triad of CUR. Remember, conjunctivitis, urethritis, and arthritis. So these are also found in young males. Remember, so a typically MCQ asked, a young male comes to you with urethritis and arthritis, okay, and has red painful eyes. You will say it is reactive arthritis. How to diagnose it, remember, is that reactive arthritis occurs only in young males. But young males have urethritis. You all know that males usually do not have urethritis. Urethritis is normally seen mostly in females because of the shorter length of the urethra. So whenever you see a young male with urethritis and arthritis, your mind should jump to that it might be reactive arthritis. Okay, simply because it is very rare to have urethritis in males. So we have these 4 different causes of HLA-B27. This is the typical 4 types of uveitis. They can cause this thing. Then another important cause is the famous JRA. Okay, this is called juvenile rheumatoid arthritis, also called as juvenile idiopathic arthritis. Okay, so now the older term was JRA, juvenile rheumatoid arthritis. Now it's called JRA. Remember, it is the very common cause of uveitis in children. It is in fact the most common cause of uveitis in children. In adults, it is idiopathy. In children, it is JRA. And these are children with joint pains. Remember, it's not the same as rheumatoid arthritis. Remember, these are small children with joint pains, and they develop uveitis again and again throughout life. Okay? So this is the most common cause of uveitis in children. So these are multiple causes of questions, and once we have done the cause of uveitis, let's look at how we diagnose it. See, the first and very important thing is the famous circumciliary congestion. These patients have anti-uveitis presents to us with 3 things: pain, redness, and loss of vision. Okay? Pain, redness, and loss of vision. These are the 3 causes, the 3 presentations. So typically, the patient wakes up with pain, redness, and loss of vision. And remember, it's called circumciliary congestion. What is that? Congestion is redness, and it is called circumciliary. You can see that the word circumciliary means around the ciliary body. To see this redness all around the cornea or also the ciliary body, this we also called as circumciliary or circumcorneal. Okay, so typically it is a pinkish red. It's a bluish red color, which is very obvious on examination, and it will surround the entire cornea like this. This is called circumcorneal or circumciliary congestion. Okay, then this is one of the major important findings. But the hallmark of anti-uveitis is the presence of cells. What are cells? Cells are white blood cells or neutrophils in the anterior chamber. Okay, these are white blood cells or neutrophils in the anterior chamber, and they keep moving up and down. Okay, normally there are no white blood cells in the anterior chamber. So when you have a lot of white blood cells, then you have a lot of, that means that you have cells here. Cells is a very important marker of activity. Activity means that the uveitis is active and needs to be treated. Then flare. The earliest sign, remember, MCQ is early sign of uveitis is flare. Flare is seen as a beam of light passing through the aqueous humor. Okay, you will see when you put it on the slit lamp, you will see a beam of light passing through the aqueous humor. This is called flare. Okay, so this is the early sign of anti-uveitis. Then certain signs called KPs. KPs are keratic precipitation. Remember the word KPs, keratic means cornea. So whenever the word keratic is used, it means cornea. So what happens? Remember these cells. These cells are neutrophils moving up and down in the anterior chamber. And when they get stuck to the cornea, because they're very sticky, they get stuck to the cornea, they're called KPs. And because they settle down at the bottom of the cornea, remember, because of gravitation currents, they settle down at the bottom of the cornea, and that's why KPs are seen in the inferior half of the cornea in the shape of a triangle. Very important MCQ, please remember, it's called as Arl's triangle. This is called as Arl's triangle. This is the famous triangle. So you will see it's something like this. So you will see the cornea like this. On the Arl's triangle, the inferior triangle, inferior area in the cornea, this is the KPs get stuck here. This is called the Arl's triangle. It's a very peculiar triangle which you can see in the inferior half of the cornea, called Arl's triangle. Okay, then a special type of a KP which you must remember is called a mutton fat KP. A mutton fat KP, what is that? A mutton fat KP is a KP only, but it is like mutton. It's large and oily and greasy. Okay, it looks like mutton fat, and that is why it is a sign of granulomatous uveitis. You must remember, I told you granulomatous uveitis means uveitis caused by either TB or leprosy or syphilis or sarcoidosis. Is it not? So this is a typical sign. They are large and oily and greasy. It's called mutton fat KPs. Remember MCQ, the most common type of a granulomatous disease causing anti-uveitis is sarcoidosis. Always remember, never forget that. Okay, the most common granulomatous disease causing anti-uveitis is sarcoidosis. And then you have Kopis and Bisacca's nodule. Remember, Kopis has double P. So these are nodules on the pupillary margin. Okay, on the pupillary margin, there are small nodules like this. Just remember P to remember Copi's nodules. And Busaka has an S, so they are on the surface of the iris. S for surface of iris. So these are nodules both on the iris. If they are on the surface of the iris, remember the S for Busaka, it's called Busaka's surface. If they are on the pupillary margin, we call P Copi's nodules. Both of them are signs of granulomatous uveitis. Remember, in granulomatous uveitis, you can have mutton fat capes, you can have Copi's nodules, you can have Busaka's nodules. You can have any one of them, you can have all of them, but the most common are the mutton fat capes. Remember, mutton fat cape is always seen, mostly seen in granulomatous uveitis. Another powerful sign of uveitis is the famous festooned pupil. What's that? A festooned pupil, remember, is an irregular pupil like this. You see, the normal pupil is regular, but a festooned pupil becomes irregular. Why? Because the sign of posterior synecdoche. You see, look at that. Why? See, this is the iris, and the iris is very sticky because of inflammation. So it can either get stuck to the cornea like this, called anterior synecdoche, or it can get stuck to the posterior structure, which is the lens. If it gets stuck to the cornea, we call it anterior synecdoche. Okay, anterior synecdoche. Synecdoche means adhesions. Okay, the holding together. And it can block the angle, so anterior synecdoche may lead to glaucoma because the angle is blocked, the aqueous cannot get out. Okay, but also it can attack the lens. Also, it can touch the lens, and this is called posterior synecdoche. And as soon as you get a posterior synecdoche, you develop cataract. Because remember, the lens is absolutely transparent, and the minute the iris touches it, it becomes opaque. It becomes cataract. This is the complicated cataract forming. And see, normally this pupil is circular, but when the iris touches the lens, it becomes irregular like this. And this irregular pupil is called festooned pupil. Can you remember, festooned pupil is a very important sign of posterior synecdoche seen in anterior uveitis. Then what about intermediate uveitis? Intermediate uveitis, remember, by definition, is inflammation of the pars plana along with the vitreous. So it's pars planitis with vitritis. And the most common cause is again idiopathic. We do not know the cause. Again, cause idiopathic. And second commonest cause is sarcoidosis. Remember, sarcoidosis, can you remember, I just told you, is the most common granulomatous disease causing uveitis. Remember, sarcoidosis can cause all kinds of uveitis, anterior, intermediate, posterior, and pan. But if asked which is the most common type of uveitis, you will say sarcoidosis causes most commonly anti-uveitis. It's caused most commonly anti-uveitis. So, but it can also, intermediate is the most common cause here after idiopathy. Remember, idiopathy we don't usually ask you. Then sometimes you have loss of vision. Normally, remember, posterior intermediate uveitis has only these things called floaters. They are mostly floaters, which are black objects floating in front of the eye. They are called floaters. But sometimes you have loss of vision. In intermediate uveitis, sometimes you have loss of vision. This is called loss of vision. This is due to cystoid macular edema. It's called CMA. Remember, CMA again makes its appearance. I told you cystoid macular edema occurs cataract, and here CMA occurs after anti-uveitis. In intermediate uveitis also, this is called CMA. But the most important MCQ of intermediate uveitis is the famous snowballs and snowbanks. Okay, and remember that because there's inflammation, so these neutrophils, they collect on the pars plana like this. Okay, and because they're white in color and round in shape, so they look like snowballs. They look like snowballs, and the entire collection is called a snowbank. Okay, the entire round in shape, and it is it's completely full of this thing. The whole thing is called a snowbank. So very important MCQ. Where would you see snowballs and snowbanks? Remember, in intermediate uveitis. And then what about posterior uveitis? Posterior uveitis, which is also choroiditis, the most common cause, these are infections. Remember, they are not idiopathic. Unlike anterior and intermediate uveitis, which are idiopathic, the most common posterior uveitis are infections. And the most common infection, kindly remember, is toxoplasma. MCQ, very important. Remember, toxoplasmosis is the single most common cause of posterior uveitis, and it is got from cats. Okay, so remember, those of you who are fond of cats, you might get toxoplasmosis. The number 2 cause of posterior uveitis is tuberculosis. Okay, so there are 2 infections which cause posterior uveitis. Mostly they are infections only. Okay, non-infectious are also there, but they are rare causes like sarcoidosis. So tuberculosis, can you remember, is the second commonest cause of posterior uveitis, and this has a very important MCQ. What is that? Remember, the tuberculosis attacks the eye in multiple ways. It can attack the eye in 10 different ways, but the most common cause is posterior uveitis. So this question is often asked, what is the most common ocular manifestation of tuberculosis? Ocular manifestation of tuberculosis, remember, is posterior uveitis. So TB can attack the eye in multiple ways, but the most common way it attacks is posterior uveitis. Then what about when you have toxoplasma? Remember, there's a very famous appearance. See, the entire vitreous becomes hazy. You can see the picture here. Can you see that? The picture is very hazy. And because it's hazy, so it's typically called headlight in fog appearance. The fog is the haziness which you see, which is caused by the vitritis, and the headlight is this thing which you see is the toxoplasmosis lesion. Okay, very famous appearance. Can you remember? Headlight in fog appearance is the description of posterior uveitis caused by toxoplasmosis and only toxoplasmosis. And sometimes, you get another question which is more of an advanced question. You get this word called punched out retinal scars. Punched out retinal scars is what you see. Can you see this black thing here? This thing here, this is like a punch, like a punching. You have seen a punching machine. So when you have posterior uveitis which is healed or an older toxoplasmosis, so you often on the retina you will get these absolutely punched out lesions which looks as if created by a absolutely circular, like a clean cut. This is called a punched out scar, and this is a sign of old toxoplasmosis. Remember, though toxoplasmosis, we can ask two questions, and we do ask this. Sometimes we give you punched out retinal scars, that's also toxoplasmosis. Older ones and the fresh ones are called as headlight and fog appearance. So this is about posterior uveitis. So we've done posterior uveitis, the three different kinds: anterior, intermediate, posterior. Remember, anterior uveitis and intermediate are mostly idiopathic. Posterior uveitis, toxoplasmosis, followed by tuberculosis. And then, what about sympathetic ophthalmitis? Sympathetic ophthalmitis, okay? Sympathetic ophthalmitis is a type of panuveitis. Okay, this is pan. Remember, we've talked about panuveitis, which means the entire uvea is inflamed. Okay, the entire uvea is inflamed. Okay, the entire iris, ciliary body, and choroid, the whole thing is inflamed. So this is called panuveitis. This is, of course, the most dreadful, the most dangerous, and the rarest kind of. It's also, luckily for us, rare. Okay. So let's look. This sympathetic ophthalmitis is an example of panuveitis. It is very dangerous. Look at that. What is it? It's a bilateral granulomatous uveitis. That means both eyes are inflamed. It's granulomatous and it follows trauma to one eye. So see how sympathetic ophthalmitis is different from the other kinds of uveitis. How it's different from other kinds of uveitis? First, it is bilateral. Okay, remember, all other uveitis is unilateral. This is both eyes. Second, it is granulomatous uveitis. That means it behaves the same way. It has granulomas like TB, leprosis, syphilis, and sarcoid. And third, it is due to follow trauma to one eye. What happens? You get trauma to one eye, but both eyes get inflamed. Then be careful. Trauma is to one eye, but both get inflamed. That is why the injured eye is called the exciting eye. Remember, the injured eye is called the exciting eye, and the other eye, which is perfectly normal, which is sitting quietly, not doing anything at all, and yet gets inflamed, is called the sympathizing eye. Okay? It's called the sympathizing eye because it is sympathizing with the damaged eye. Okay? So we have two things. One is called the exciting eye, which is the injured eye, and the other eye, which is not doing anything but gets inflamed and damaged both, is called sympathizing eye. That's why it's called sympathetic ophthalmitis, because it's sympathizing with the other eye. And then this, what about this trauma? This trauma has to be very specific. Okay? It cannot be a blunt trauma. Okay? It has to be either penetrating or perforating trauma. Okay? What is that? Penetrating means an injury which enters but does not exit. Okay? There's not enough force to carry it out. The enters but stays there, does not get out. And perforating is through and through. So remember the difference? Perforating is through and through. This is perforating through and through injuries. And also remember that injuries, this the most commonly seen to the ciliary body. Very important to remember, ciliary body has the highest incidence of causing sympathetic ophthalmitis. So ciliary body injuries have the highest incidence of causing sympathetic ophthalmitis. So it is also called the dangerous area of the eye. Why? Because ciliary body injury has the highest chance of getting providing injury causes the sympathetic ophthalmitis. Also called the dangerous area. Ciliary body is called the dangerous area of the eye. And then most commonly remember, sympathetic ophthalmitis is seen within 2 weeks to 3 months after injury. That means suppose my left eye injured, the right eye will develop sympathetic ophthalmitis within 2 weeks to 3 months of injury. This is the most common time period. 50% of sympathetic ophthalmitis occur within 2 weeks to 3 months of injury. You can count it after that also, but it's not very common. So you can remember this critical period, 14 days to or 2 weeks to 3 months of injury. And you have to remember one particular famous finding here called the DFN, Dalen-Fuchs nodules. Okay, remember DFN This is an important trick. See, I am giving you an important hint. Sometimes when you have to memorize something, you find it easy to memorize if you just remember the initials. Instead of remember Dalen-Fuchs nodule, suppose you just remember DFN. So it makes life easier sometimes. So Dalen-Fuchs nodules are nodules on the choroid, and they can be seen in the sympathetic ophthalmitis. And because the granulomatous uveitis, so you will see mutton fat capies also in sympathetic ophthalmitis. And the most important question is the famous retrolental flare. What is that? Behind the lens, you develop, because retrolental means behind the lens. So behind the lens, you develop this flare, which is called retinal flare. And remember, this is the earliest sign of sympathetic ophthalmitis. Very dangerous, and always asked what is the earliest sign of sympathetic ophthalmitis. The other eye is getting dangerously inflamed is called retrolental flare. And the best question, the most important is that supposing you have one eye injured, okay, so that is PL negative. That means there is no useful vision in this eye, PL negative, okay, and the second eye is 6/6, okay. So he comes to, why does he come to you? Because the second eye is now developing signs of inflammation. So he develops photophobia, he develops accommodation failure, and you can see the retrolental flare and the granulomatous uveitis, which is mutton fat. So you know that this patient has had injury to this eye, this is the exciting eye, and this is sympathizing. So what do you do? The best treatment here is to take out this eye, enucleate, remove this eye. Why? Because first, it has no vision, so there's no loss, and second, if you remove this eye, then you take out the antigens also. These antigens are responsible for producing the antibodies which attack the other eye. If you take out the eye, which is no vision, you take out the antigens, so there's no further antibodies. The antibodies cannot attack the other eye, so there is no sympathetic. But remember, it has to be taken out within 2 weeks. That's an MCQ. What is the critical period for taking out the eye, which can prevent sympathetic ophthalmitis of the other eye, is 2 weeks. Okay, if you take it after 2 weeks, then it will not help. Okay, so this is the dangerous sympathetic which we are very scared of, because one eye is injured, but both eyes are lost. Remember, it is the single most dangerous condition in entire ophthalmology, because in this case you can become bilaterally blind. Okay? You can become bilaterally blind. So this is the example of panuveitis we can do. And then the next thing we need to do is ocular manifestations of HIV. Is what are the ocular manifestations? If HIV, suppose develop AIDS, then what will happen? If you develop AIDS here, then what will happen here is that, what are the conditions? Now here, that's a very important question, because AIDS or HIV is a very important combination of questions for us. Remember, here, the most common ocular manifestation of HIV is called cotton wool spots, also called as soft exudates. You have to remember this. You can see this picture here. This is the soft exudates that you see here. Okay, soft exudates here. And the soft exudates, they are also called cotton wool, because that's what they look like, balls of cotton wool hair. The balls of cotton wool hair. Remember, this is also called as microangiopathy. Why? Micro is small, angio is blood vessels, pathy is damage. So what happens? The earliest manifestation of HIV-2 occurs in the retina, where the small blood vessels of the retina get inflamed. Microangiopathy. So when the small blood vessels of the retina get inflamed, they produce these soft exudates, which are also called as cotton wool spots. Remember, they are the earliest and the most common manifestation of HIV. But the vice versa is not true. What does that mean? It means that vice versa is not true. It means that they may be the most common presenter of HIV, but HIV is not the most common cause of soft exudates. So whenever you see soft exudates on the retina, your first diagnosis is not HIV, because they are seen more commonly in diabetic retinopathy and hypertensive retinopathy. Okay, so remember, if you see soft exudates in a patient, don't jump to the conclusion that he has HIV. No. First, rule out the diabetes and the blood pressure, because they are more common, and then you think of HIV. Okay? Then a very important question is the most common ocular infection. The most common ocular infection of HIV is called as CMV retinitis. Please remember, this is not a very rare infection. It's not a very common, it's not a very common infection, but when you see it, it means that there is underlying HIV. Okay? So please remember that CMV retinitis is the most common ocular infection of HIV, and it appears this very colorful picture. Can you see this red and yellowish picture? This typically, it's called a pizza pie appearance. Very famous pizza pie, because this red and white appearance. Red is the hemorrhages that you can see, and yellow or white is the necrotic patches of retina. It's often called a pizza pie appearance. This is a very dramatic picture, and whenever you see it, you should identify this as CMV retinitis, because red and white is the famous. We call it the tomato ketchup appearance. Sometimes we call it the scrambled eggs and tomato ketchup appearance, where it looks like scrambled eggs and tomato ketchup. Sometimes we call it the pizza pie. Okay? Ophthalmology is full of lovely terms for horrible conditions. Then you have the most common systemic infection of HIV. Remember, the most common ocular infection of HIV associated is CMV retinitis, but the most common systemic infection is tuberculosis, which also kills and is the most common cause of death in HIV patients. However, the most famous question asked is, what is the most common tumor, ocular tumor associated in HIV, is the famous Kaposi sarcoma. Okay? Kaposi sarcoma is normally a very rare infection, but this is very commonly seen in HIV, okay, because of the lack of immunity. HIV suppressed the immune response, so a lot of rare and infections and tumors which are not commonly seen, they are spring up. Okay? So kindly remember, Kaposi sarcoma is the most common tumor of the eye in HIV. Okay? So multiple questions of HIV, and one more we like to ask. See, nowadays the commonest treatment for HIV, as you know, is heart therapy. You all know that. Highly active antiretroviral therapy. No? This is a combination of 3 drugs. It's a cocktail of 3 drugs. Highly active antiretroviral therapy is a combination of 3 drugs which we use in HIV. Remember, we have an important side effect. When we use this drug, the patient starts improving, but also paradoxically, his eye appears to be more worse. You know, it appears more inflamed, it becomes red, it has more cells, it has more hypopyon, and you may have CME. So this is called as immune recovery uveitis, IRU, immune recovery uveitis. You understand? This is the most common ocular side of heart therapy. Paradoxically, the eye seems to worsen. It's improving, but seems to. Why? Because as the drugs take place, the recovery starts, because the immune recovery starts, and this immune system now attacks the HIV, causing more inflammation. Previously, there was not enough immunity to attack the infection. Now there's enough immunity to attack the infection and cause this immune recovery uveitis. This attack, increased inflammation of the eye, paradoxically is called IRU. Be careful about this question, because it seems the patient is worsening, but actually is improving. Okay? Then, so that's about uveitis treatment. We have enough of uveitis, and now we are going to talk about glaucoma. The next condition, glaucoma, is, remember, the second commonest cause of blindness in the world. Okay? About 12% of patients suffer from glaucoma. Remember, the most common cause of blindness is cataract, it comes glaucoma. So how do we diagnose glaucoma? We have 3 conditions. Remember, there are 3 things again. Raised intraocular pressure. How much? That is more than 21 millimeters mercury. Remember, I told you when we're doing the various numericals that the intraocular pressure varies anything from 10 to 21. Anybody more than 21 millimeters of mercury is glaucoma, has glaucoma, and this is more than 21 millimeters of glaucoma. So this is first. Second is optic disc. This raised intraocular pressure damages the optic disc. Okay, and third is visual field defects. Okay, so remember, the visual field is this area. Look at me when I look at you straight like this. So I'm looking at the camera, but while looking at the camera, I can see the other things also. No, I can see there are walls here. There is a ceiling and there's a floor. All of this which I can see while looking straight ahead. So this is my visual field. Okay, all this area that I can see around the central target is called my visual field. This visual field is an important function of the optic nerve. If you have normal optic nerve, the visual field will be normal. If you have a damaged optic nerve, the visual field will be lost. This is often asked as an MCQ, which is the most important investigation for checking the optic nerve function. Okay? The most important most important examination for checking the optic nerve function is a visual field testing, which is called perimetry. Remember, perimetry is the term for visual field examination. Just like tonometry is a term for intraocular pressure measurement. When we measure intraocular pressure, we call it tonometry. When we measure perimetry, we mean visual field. So kindly remember that if your visual field is poor, it is only because the optic nerve is damaged. So look at the classic triad, you will have raised intraocular pressure. Why? We don't know. Most of the causes are not known to us. This leads to damage to the optic disc. Why? Because the optic nerve can only take a maximum pressure of 21. And after that, it will start damaging due to compression of the optic nerve. And third, as the optic nerve gets damaged, you will have visual field damage. Slowly, the visual field collapses over many years. Okay. So out of these three, remember, you need only two. Just two are enough. You don't have no need to have all three. You can just need to any two. No, any two. So that's why be careful. So suppose you have a condition where you have the pressure is normal, say 15 millimeters. Okay. But the optic disc is damaged and the visual field is damaged. See what's happening? This means this is glaucoma. Why? Because any two out of the three, we need disc and field are damaged. Even with normal pressures, this is called normal tension glaucoma. Even normal pressures can damage the optic nerve. So it's called normal tension glaucoma, which is particularly dangerous because the pressure is normal and still there is glaucoma. But if the pressure is high, say 55, but the disc is normal, optic disc is normal, and the field is normal, remember, this is not glaucoma. The pressure is high, but the disc is normal and the field is normal. This is not glaucoma because you have only one which is abnormal, the rest two are normal. You need two out of three. So this condition is not glaucoma. This is called as ocular hypertension. If only the pressure is high, but the other two are normal, this is called as ocular hypertension. It may be cause glaucoma later on, or it may not, but right now, this is not glaucoma. Okay. This is the raised intraocular pressure causing glaucoma. And the destruction, so remember what happens as this pressure comes, it destroys this one particular cell which you must remember. This is called the ganglion cells of the retina. We call them the RGCs. The targets, kindly remember MCQ, the target of glaucoma is to destroy the ganglion cells of the retina. These ganglion cells, if you might remember, are the third order neurons. Remember I told you, or you should remember from basic ophtha, the first order neurons are the Roentgen cones, the second order are the bipolar cells, and the third order are the ganglion cells. So the target of damage is the retinal ganglion cells, and they get damaged in glaucoma. And we cause glaucoma. There are two types of glaucoma. One is called congenital from birth onwards, and adult glaucoma, which is after 40 years of age. So congenital glaucoma, the child develops glaucoma from birth till 3 years of age. Okay, usually within 3 years of age. So when we have developed till 3 years of age, remember, we call this as primary congenital glaucoma, PCG. Primary congenital glaucoma. Okay, this is also called buphthalmos because it stretches a lot and it looks as big as a bullseye or a cow's eye. Okay, so that's why you see why this definition is within 3 years of age. Why not 4 or 5 or 6 or 7? Because up till the age of 3, remember, the eyeball is highly elastic and it can cause enlargement of the size of the eyeball. Up till the age of 3, highly elastic and enlarge the size of the eyeball. That's why these eyes are very large, like a bullseye or a cow's eye. We call this as buphthalmos. Okay? So this is the and the classic triad. Can you remember that you can diagnose them? I mentioned this before. Remember, we're talking about nasolacrimal duct obstruction, photophobia. That means he cannot tolerate bright lights. He turns the head away like this. Photophobia and blepharospasm, tightly shut lids, eyes tightly shut, and third, lacrimation, excessive watering. Remember, that was the whole point. If the eyes are watering, it could be nasolacrimal duct obstruction also, but it could also be primary congenital glaucoma buphthalmos. Okay, remember how to differentiate. These are highly intolerant patients. They keep their eyes closed, cranky, irritable kids. They're always crying. Okay, and why does this occur? This occurs because look at the cause. The cause is there is a membrane present right from birth onwards. The angle. This membrane is called the Barkhan's membrane. Remember the name of this membrane? See, the angle is like this. This is the cornea. This is the iris. So you have an angle like this. No? This is the angle it gets. So this Barkhan's membrane is present right from birth onwards here. Right from birth onwards here, and it causes obstruction of the aqueous. The aqueous cannot get out. The pressure rises, causes glaucoma. This is how the basic process. Remember, this child, the main problem is born with the Barkhan's membrane. The Barkhan's membrane does not allow the aqueous to get out, raises intraocular pressure, damages the optic nerve. This is how we have buphthalmos. And so how do we diagnose? We diagnose by the large size of the eyeball, a lot of hazy cornea. The cornea becomes hazy. So this is because the corneal edema, and the famous Habs. Because of the enlargement of the size of the eyeball, the cornea is stretched. As the cornea stretches, see what happens? It causes these Habs striae. Striae means folds. You can see these tracks, these parallel railway tracks like this. You can see this very clearly. They appear on the cornea. This is called as Habs striae. And whenever you see Habs striae, this is the diagnostic finding of buphthalmos or congenital glaucoma. Okay? So this is the typical diagnosis. Remember how to diagnose? It's pretty easy actually. First of all, the patient is a child up to 3 years of age who has an enlarged eye, whose cornea is hazy because of corneal edema, who has HABs dry, these parallel tracks, the intraocular pressure is very high, compared to should be about less than 20, it is mid-30s, 31, 32, 35. Okay, so everything was easy to diagnose this. And what is the treatment? Treatment is basically we do goniotomy. So remember this angle, no? So this is the angle here, and this is the angle. So what if I took a needle here and perforated the amber like this, then allow the aqueous to get out, no? So this is called goniotomy. So remember the treatment of choice of ophthalmos is goniotomy, making a hole in the angle. You take a needle and you make a hole in the angle, and this will allow the aqueous to get out, the pressure will fall down. So this treatment of choice is goniotomy in ophthalmos, but as I said before also, goniotomy is difficult to do because the cornea has become hazy. By the time he comes to you, the cornea has become totally hazy. So ophthalmos doesn't have a very good prognosis. Therefore, next thing is open angle glaucoma. Open angle glaucoma, let's talk about open angle glaucoma. Open angle glaucoma, what is, now we divide adult glaucoma. So see, this was children glaucoma up till age of years. Adult glaucoma is defined as anybody more than 40 years of age having glaucoma. If one glaucoma is 40 years of age, is adult glaucoma. Adult glaucoma, so we divide them into open angle glaucoma and angle closure glaucoma. Okay, we divide into open and angle closure glaucoma. The worldwide difference, remember, a ratio, you have to remember that. Worldwide, open angle is 3 times more common than angle closure glaucoma. Okay, so this has been asked once. What is the frequency of open angle glaucoma? It's 3 times more common than angle closure glaucoma. Okay, let's look at open angle glaucoma. What are the risk factors? Why should you have open angle glaucoma? The pressure rises. So, but why? First of all, risk factor is family history. So, if you have a family history, your parents, your grandparents have glaucoma, then the chance of developing glaucoma higher. If you have a thin CCT, what is that? CCT stands for central corneal thickness. If we have a central corneal thin, remember there are 2 problems here. A thin central cornea, remember cornea is, I told you, it depends on patient to patient. Remember one of the few slides I told you, average thickness is 540 microns, I told you. But there are many patients who have thinner corneas. And when you have a thinner cornea, then the pressure, because the thin cornea damages the optic nerve more. Okay, that is one. And second, the thinner the cornea, the intraocular pressure is lowered falsely. You understand? So supposing your pressure is 25, okay, but you have a thin cornea, it will register not as 25, but say as 15. This is because of a trick of measuring the pressure. Thinner corneas measure falsely low, thicker corneas measure falsely high. Okay, false. So that gives a problem. Okay, suppose you have a thinner cornea, say 500 microns. So even if the pressure is 25, because it will measure falsely low pressure, so you will see it as 15. If you see it as 15, you will think that you have normal pressure, but it is not normal. It's not normal. No? So it is. This is how we do it. So it is not normal, and it is actually high pressure, which is registering falsely low. So you under a false sense of security. So remember, those of you who have thinner corneas, like me, I also have thin corneas. Remember, the pressure is always measured falsely low, and you have to be careful that you don't be under this false assumption the pressure is normal. Actually, it is higher. Okay. So thin CCT, color racism. What is that? Color racism means the black population of the world. That is the people who are from Africa, from Caribbeans, the West Indians. They have the highest open angle glaucoma. So glaucoma is ethnic and racial. So if you belong to the black population, which we call as colored races, no, so people from Africa, from West Indies, from West Africa, they have the highest chance of open angle. So you have to watch out for that. Okay? Being a part of the pigmented races of the world automatically puts you at risk of developing open angle glaucoma more than the other races. And myopia. People who are myopics, they have more open angle glaucoma. So myopics amongst you, kindly watch out. There are four main risk factors. And what happens here, the trabecular meshwork gets blocked. For reasons of unknown to us, the trabecular meshwork, which is full of small tumor holes, they get blocked with age. So as these, myopic people turn 50, 45, 50, and they are blacks, colored races, family history, and ethnicity, for reasons unknown to us, the trabecular meshwork develops fibrosis and the aqueous cannot get out. The aqueous cannot get out, the pressure rises, they develop open angle glaucoma. Okay? And what are the signs of open angle glaucoma? You can see the increased cup disc. Look at that. This is pale disc, increased cup disc ratio, splinter hemorrhages, focal notching, and disc asymmetry. So when you look at the optic disc, these are some of the optic disc signs where increased discs. Now this is the most important sign, increased cup disc ratio. The normal cup disc ratio is between 0.3 to 0.6. Okay, this is normal cup disc ratio. and anybody more than 0.7, more than 0.6 is 0.7, 0.8, 0.9 is suspect of developing glaucoma. Disc pallor, you can see the pale disc here that you can see in this picture here. This is a sign of glaucoma. The normal optic disc has a healthy reddish orange color. Reddish orange color, this is a pale disc, and that's the sign of glaucoma. Splint hemorrhage means on the rim of the disc you will have a hemorrhage like this. These are small lines of hemorrhage. They're called splinter hemorrhage, and this is a sign of glaucoma. And focal notching, you get a notch in the cup, the sign of glaucoma. And disc asymmetry. Asymmetry means the two discs don't look alike; they look separate. Okay, so these are some of the important optic signs of glaucoma. Here, I would be happy with increased cup disc ratio, disc pallor, splinter hemorrhage. Okay, these are the three most important signs of glaucoma. And what about the visual field changes? Remember, the visual field changes that are occurring, the visual field slowly decreases, are occurring because of the optic nerve damage. And why is the optic nerve damage? Because of the raised intraocular pressure. So what are the visual fields? The visual fields are very famously asked because that is called a paracentral scotoma. The scotoma is a localized loss of vision surrounded by normal vision. Remember, scotoma is not blindness. Okay? Like for instance, look at this visual. This is my visual field. No? So in this visual area, there is an area somewhere here where I cannot see. This is called a blind spot. So the blind spot is an example of a scotoma. Remember, scotoma is defined as a localized loss of vision surrounded by normal vision. Remember that it is not blindness. It is a very small area of loss of vision of the patient. It's a localized loss of vision. These are called scotomas, and close to the center means paracentral scotoma. Okay, so this is the earliest field defect of glaucoma. Remember, close to the center there is a localized loss of vision called a paracentral scotoma. This is the earliest sign. You can have a Bieram scotoma. What is that? Look at that. It's called a Bieram. J becomes silent. It becomes Bieram. And see, this is an extension of the blind spot in the shape of an arc like that. Okay, it's an extension of the blind spot in the shape of an arc. This is called a Bieram scotoma. This is a very powerful sign of glaucoma, and anybody of you who has Bierams would have glaucoma. Okay, a nasal step. Okay, a nasal step means on the temporal side is the blind spot. On the nasal side, there is a step-like field defect. The field begins like this. No, it looks like a step. I have put a foot on it like this. This is a step-like field defect, and this is a nasal step. Again, nasal step, remember, is very characteristic of glaucoma. So if you either get a Bierams or a nasal step, it means you are heading towards glaucoma. And you have an arcuate scotoma. What is that? It's an arc-shaped scotoma like this. An arc-shaped scotoma like this. So remember, these are the four important field defects of glaucoma that we like to ask you about glaucoma. And for this, we have to do visual field testing, which means a perimetry. So on the perimetry, if I detect any of these four, either paracentral scotoma or a Bieram scotoma or an arcuate scotoma or a nasal step, I would think you're developing glaucoma. Okay? And but the most characteristic, what is the Bierams and the nasal step. Okay? And can you have visual field defects in any other condition of ophthalmology? Yes, of course. Remember, visual field damage is a optic nerve, is a sign of optic nerve damage. So any time your optic nerve gets damaged, be it glaucoma, be it neuroophthalmic conditions like optic neuritis or papilledema or retrobulbar neuritis or traumatic optic neuropathy, any time the optic nerve gets damaged, you will have visual field defects. Okay, but glaucoma is one of those visual field defects causes, and there are very specific field defects of glaucoma which we just talked about: the paracentral, the Bierams, the nasal step, and the arcuate scotoma. Okay, various other conditions have various other field defects. Okay, they are not typical of glaucoma. And the only symptom of glaucoma, remember, open-angle glaucoma at least, because it is completely silent, there is no pain, no redness, no loss of vision, no corneal edema, no colored halos, nothing. The only symptom is a frequent change of reading glasses. Remember these are older people, 45 and 50. So we all know that older people, 45, 50, they need reading glasses. Here, if you look at your parents' reading glasses, normally they change every 3 to 4 years. But in glaucoma, they will change it every 6 months or 1 year. Typically, the patient will complain to you of glaucoma and complain to you, look doctor, I'm not able to read with my glasses. I'll say, I have just changed it last month or last year. He says, but I can't see. Remember, this frequent change of reading glasses is the only sign of open-angle glaucoma. Why is it changing? Because the raised intraocular pressure is destroying the ciliary muscle. The ciliary muscle is a very sensitive muscle, is destroyed. It cannot cause accommodation, it cannot accommodate. Patient keeps fussing about with his glasses and can't read. So please remember, if you have older relatives like your parents, your grandparents, okay, and others, parents, grandparents and others, they are older parents because these, remember, the old patients. They complain to you, look, my reading glasses are changing very fast. Remember, they could be heading into open angle glaucoma. Okay? This is the only symptom. The problem about open angle is that it's completely silent. There's no pain, no redness, no watering, no irritation, no headaches, no colored halos, no nothing. Slowly, you have tubular vision. The end stage lands up with tubular vision or tunnel vision. Okay? So this is the problem of open. What about angle closure glaucoma? In angle closure glaucoma, let's look the angle. It's a different thing. Here the angle gets closed. Okay, look at that. This was the original angle. In open angle, if you saw, this was the trabecular meshwork here, which was getting blocked, no, because they were fibrosed and not allowing the aqueous to get out, so the pressure rose. But in angle closure glaucoma, the angle is not open; it is closed. Okay, so it closes like this. If you look at this, this is the angle. And why should it close? Let's talk about why should the angle close. And before we talk about why should it close, we need to talk about the risk factors of angle closure. What's risk factor? Again, remember these are middle-aged, just like open angle, they're also middle. So it means usually above 50. And these are mostly females. Why females? Remember, open angle glaucoma anybody can have, males or females. But angle closure glaucoma only occurs in females because, not only, but more, say about 60%. That is because the female eyes are smaller. You all know female eyes are slightly smaller than males. So the angle is also shallower and the antechamber is also shallower. So it's easier for the female eyeball angle to close because it's already shallow to begin with. And they are hypermetropes, that means they have small eyes. Hypermetropics occur to people with small eyes. So again, they have a small eye and the angle is shallower, it closes easier. Hypermetropes. Shallow antechamber we've talked about, and Asians. Why Asians? Remember all of us, Asians, Indians, Pakistanis, Sri Lankans, Nepalese, everybody, all Asians, Chinese, Japanese, Mongols, we have slightly shallower eyes compared to European eyes. So because we have small eyes, they see shallow and the angles close easily. So these are some risk factors, and the most important risk factor, but this is the mechanism, it causes pupillary block. See what happens. The pupillary block occurs, one particular thing caused by the pupil blocks when there is mid dilation of the pupil. Remember that when the pupil dilates halfway. Okay? The normal pupil is about 3 to 4 millimeters, and this pupil would go to halfway. It is 5 to 6 millimeters. That's called mid dilatation. So look at this. This is the normal antechamber. This is the angle, and you know the aqueous humor. It comes like this from here. See, it flows here into the posterior chamber, through the pupil, into the antechamber, goes to the angle and goes out like this. Okay, this is a normal pathway. But now see angle closure, what happens? What happens is the pupil dilates midway. I just told you mid dilation, so it dilates like this. See what happens. When look at my finger, in order for the pupil to dilate, the pupil originally is like this. In order for it to dilate, the iris has to relax, is not? The iris has to relax. Iris is normally a tight and a very, very tight and a contracted structure. But in order to dilate the pupil, it has to relax like this, not? It has to relax, and this relaxed iris becomes loose and lax and flabby. Loose and lax and flabby. Look at what happens to the iris. Look at what happens to the iris. And this relaxed iris is like this. See what happens? It falls back like this onto the lens because it's loose and lax. So it doesn't have any rigidity in it, and this loose and lax iris, see, it tends to fall back on the iris like this. And now see what has happened. All the aqueous humor which was here, the pupil is blocked here, no? The lens is blocking the pupil. You can see the pupils get blocked. So all the aqueous humor gets trapped in the posterior chamber. It pushes the iris forward and the iris angle closes, okay, because of the trapped aqueous. So that is the reason. So main thing is the pupillary block. Okay. Why does the pupil block? Because of mid dilate. Why does the pupil mid dilate? Well, it could be anything. It could be drugs like atropine, homotropine, cyclopentyl, tropicamide, which are all dilators, or it could be night when the pupil dilates at night time. Okay. So various conditions cause mid dilatation, and if this mid dilation occurs in elderly, female, hypermetropic Asian females, then it's already shallow and it may cause pupillary block. Okay. So there are 4-5 stages of angle closure glaucoma. The latent, which is mostly hidden, you can't detect it. Subacute sometimes occurs. Patient has these colored rings coming at the end of the day when he's tired. Sometimes these colored rings, which becomes normal. But the most dangerous and the most sudden and the most dramatic is the acute angle closure glaucoma, where the patient comes to us with full severe attack, raised intraocular pressure, pain, redness, loss of vision, colored halos. It's a full panic, and this may lose vision. This acute angle closure glaucoma, remember the hallmark of it is a severe pain and it does not go back itself. Subacute, they go back itself. The spontaneously resolve. Acute angle closure glaucoma, the spontaneous do not resolve. We have to admit them and lower the intraocular pressure, otherwise the patient will become blind within 5 days. Okay? Then chronic and absolute. So these are the 5 stage angle closure. We only talk about acute angle closure glaucoma because this is the most dramatic and causes the maximum problems for us. So the patient presented with, you can say, a sudden severe pain, redness, blurring of vision, and colored halos. Okay. So again, angle closure glaucoma, remember, has colored halos just like cataracts, but the reasons are different. So in cataracts, there's also colored halos. Angle closure glaucoma is colored halos. The difference in this mechanism is different because in angle closure glaucoma, the colored halos occurs because of corneal edema. Okay, you understand? Because the pressure is so high, see what happens. The pressure of the glaucoma is so high, what it does, it forces the aqueous into the cornea. And this aqueous enters the cornea and causes corneal edema. Corneal edema is droplets of fluid, and look at these fluid droplets, they behave as optical prisms. They behave as optical prisms, which means they split the light in the colors of the rainbow like this, and they split the colors of the light. Like this is what the optical prism behaves like, no? It splits the light like the colors of a rainbow, and that is why these patients also have colored halos. So remember, the difference is in cataracts, the colored halos occurs because of different refractive indices of the cataract, but in angle closure glaucoma occurs because of the prismatic effect of the corneal edema. Okay, so there are different mechanisms, but the color halos are the same. And so sudden severe pain, raised intraocular pressure, eyes for red and vomiting, and patient is severe pain, crying and shrieking and shouting. And on examination, the patient is very famously vertically oval, mid-dilated, and non-reactive. See, normal pupil is circular like this, is not. But in angle closure glaucoma, acute angle closure, look at that, it becomes vertically oval, which you can see the diagram here, mid-dilated, it's half dilated because that's when the attack takes place, and it's red and not reacting light. Remember, the most basic reaction of the pupil is that when you flash a light, it constricts. You take it away, it dilates. This most basic reaction, it does not take place anymore, and it stops reacting. So this is a very powerful pupil, which we describe as vertically oval, mid-dilated, and non-reacting to light. Okay, so this is the classic feature of angle closure glaucoma. And remember that sometimes we'll ask that again a neat PG MCQ, how to differentiate chronic angle closure glaucoma from open angle. Remember, acute is very symptomatic, but chronic, the pressure is already high, there's no pain, no redness, no watering, no loss of vision. So chronic angle closure looks very much like open angle in its lack of symptoms. Okay, and the only way to differentiate between them is to do gonioscopy. Remember, look at the angle. We have to differentiate because you look at the angle by doing this thing called gonioscopy. Remember, gonio means angle. So just do gonioscopy. In angle closure glaucoma, you'll have a closed angle, open angle, the angle will be open. It's visible. So gonioscopy differentiates between open angle and angle closure glaucoma because they look similar. And one more powerful test is the Fincham's test. Fincham's test is to differentiate between the colored halos of cataract and glaucoma. Remember, I just told you they have different causes. So where we do, remember, you give them a stenopic. So look at that. What is this? Stenopic slit is this one. It's a plastic disc, completely opaque, with a central slit down the center. Okay, you can see the slit here. You give this to the patient and ask the patient to move the slit in front of the eye like that. Okay. Remember, you can't see the colored halo. Only the patient can see it. This test is to be done while the patient is seeing the colored halo. So if you see the colored halo like this, you give the slit to her and ask this to move in front of the eye like this, and ask her, because mostly it's a female patient, what is happening to the colored halo. If the colored halo breaks up, like this, see, this is the colored halo like this, no? It breaks up like this and unites, breaks and unites, it means it's a cataract, and if it does not break up, it is glaucoma. So very powerful test. Remember, in angle closure glaucoma, the colored halo will not split up in Fincham's test, but in cataract, it will split up. So that's a very powerful test to differentiate between colors of cataract and glaucoma, right? And so now we have diagnosed open angle, angle closure. Remember, they are different, totally different angles. Open angle, there is no pain, redness, loss of vision, colored halos, etc. acute angle closure glaucoma at least has severe pain, redness, vomiting, loss of vision, colored halos, corneal edema, etc. Okay, totally different. So once you've diagnosed glaucoma, what is treatment of glaucoma? The treatment of diagnosed glaucoma is to lower intraocular pressure. Remember, that's the only thing, because the visual fields cannot be changed, they cannot reverse, the visual field damage and the optic disc damage cannot be reversed. They will remain the same. But at least you can lower the pressure, so further optic nerve damage is avoided. Okay, so further optic nerve damage is avoided. So this is the treatment of glaucoma, just lower the IOP. And they are irreversible. So how do you reverse lower the pressure? The best ways are to use drugs. Remember, open angle glaucoma, it will lower the pressure. How do you lower the pressure? There are two ways. Either you increase the outflow of aqueous, so the pressure falls down, or you decrease the production of aqueous, so the pressure falls down. Is it not? So remember, when we increase the outflow of pressure, there are two groups of drugs. What are these? They are called cholinergic agonists. Cholinergic agonists would increase the outflow of aqueous, and they are drugs like pilocarpine and carbachol. They increase the outflow of aqueous through the trabecular meshwork. That is one group. The second group of drugs which increase the outflow are called the prostaglandin analogs, PGAs. The prostaglandin analogs, they use this pathway, which is called the uveoscleral pathway. Remember, normally this uveoscleral pathway only contributes to 20% of the aqueous drainage. Okay, the trabecular meshwork is the one that contributes to 80% of the outflow. So this uses a different pathway called uveoscleral, and the prostaglandin analogs like latanoprost and pemetrexed increase the outflow through the uveoscleral pathway. So remember, both these drugs increase the outflow, lower the pressure, but the pathways are different. Okay, pathways are different. The pilocarpine carbachol increase the trabecular meshwork pathway. The prostaglandin uses in the uveoscleral pathway. Be careful about that. The rest of all the drugs decrease the suppressed production. They suppress aqueous production, so the pressure comes down. So there are different mechanisms. Okay. And remember, so a few MCQs about the open angle glaucoma drugs. Remember, drugs of glaucoma are important. Drugs of glaucoma, we have the drug of choice of POG. Remember, POG stands for primary open angle glaucoma. We call it primary because, as I said, we don't know the causes. Okay. So this is the same thing as open angle glaucoma only. We could just call it primary open angle glaucoma, POG. This is worldwide. Remember, the most common type of glaucoma are open angle glaucoma. Drug of choice is prostaglandin analogs. So kindly remember, FDA has mandated that the drugs of choice are the prostaglandin analogs. So latanoprost, pemetrexed, tavoprost. Why these are drugs of choice? Because they're very, very safe. Okay, remember, there are hardly any systemic side effects. There are some topical side effects, but systemic sides are very rare. So this is the drug of choice, open angle. Okay, so please remember, they are the safest drugs of glaucoma. They are also, prostaglandins also, remember, are also the drug of choice of normal tension glaucoma. Remember, normal tension glaucoma is difficult. No, why? Because the pressure is all normal. Suppose you have pressure is 15. Now it is easy for a drug to lower elevated pressure 25, 35, 45. But it's not easy for a drug to reduce 15, 16 because they're already physiologically normal. It's not. Already the pressure is normal. You want to reduce them further. From 15, you want to get down to 10 or 11 or 12. How do you do that? So the drug has to work harder. Remember, prostaglandin drugs are also drugs of choice with normal tension glaucoma. So be careful about that. So there are two important drugs. And angle closure glaucoma, remember, mostly are not drugs. We use surgery. Why? Because angle closure glaucoma is already closed. The angle is already closed. Angle is already closed. So how will the aqueous get out? They won't be able to get out. So that's why mostly we use surgery. And the surgery is called LI, laser iridotomy. Okay, what is that? You make a small hole. You make a small hole in the periphery of the iris like that. Okay, so this behaves like another pupil because remember this pupil block, angle closure glaucoma is called pupillary block. This pupil is already blocked, so we create another small pupil through which the aqueous can drain out like that. Okay, so LI called laser iridotomy, which is used by our old friend. Which laser is it? Our old friend, the Nd:YAG laser. The Nd:YAG laser is the laser of choice. Okay, so Nd:YAG laser, we make a small hole, blast a small hole in it, and it allows the aqueous to get out. So this is the treatment of choice of angle closure glaucoma. Okay. Now the latest drugs. So remember, we have this questions from pharma and ophtha where we often ask latest drugs. Remember, the latest drugs of choice, latest drugs in glaucoma introduced are fairly recent. We call them the ROCK inhibitors. Okay, ROCK. It stands for Rho kinase inhibitors. So often we call them ROCK inhibitors just to make it sounding like a rock star. Okay. So Rho kinase or ROCK inhibitors we call them. Remember these drugs we have to remember these are netazodyl and ripasodil. Just remember, you'll probably do in pharma also. But just to tell you, the latest drugs introduced in glaucoma are nitasodil and ripasodil, which are Rho kinase inhibitors, and they also increase the outflow. They also decrease production by increasing the outflow of the aqueous humor. Right, then anti-glaucoma drugs, some other drugs question anti-glaucoma drugs are, what about drugs of choice in children? Remember, these anti-glaucoma drugs are extremely toxic, so we try to avoid them in children. So the drugs of choice in children are the safest anti-glaucoma drugs are topical carbonic anhydrase inhibitors. CAIs are topical carbonic anhydrase. These are the drugs of choice in children because they're the safest anti-glaucoma drugs. Okay, so dorzolamide and brinzolamide can be used in children. Okay, even the prostaglandin analogs are not very safe in children, so we have to restrict ourselves to dorzolamide and brinzolamide. Remember, a very important MCQ is what anti-glaucoma drug is contraindicated in children. Okay, what anti-glaucoma drug is contraindicated in children? Remember, it is brimonidine. This is alpha-2 agonist, which is contraindicated in children because it may cause respiratory apnea and death. Okay, kindly remember, it can cause respiratory apnea. It may cause death also. Very important MCQ. Which anti-glaucoma drug is contraindicated in children? Okay, that is brimonidine. Then another powerful question is, which anti-glaucoma drug is contraindicated in pregnancy? Remember, these are the prostaglandin analogs. Why? Because remember, these are prostaglandin analogs. So if you give it in pregnancy, it may cause cervical dilatation and may cause premature delivery. Very important to remember. And prostaglandin analogs, though the drugs of choice in glaucoma, are not to be prescribed in pregnancy because they might cause premature delivery. Okay. So what are the drugs of choice in pregnancy? Remember, actually in pregnancy, none of the drugs are very safe, but in the first trimester at least, remember, in the first trimester at least, brimonidine is a drug of choice. So be careful. It is a drug of choice in pregnancy, but also it is contraindicated in children. Be careful. So while the child is in utero, you can give the drug to the mother, but when he comes out, then you can't give it to him. Be careful about that, please. Okay, they are different people. So drugs of choice in pregnancy is brimonidine in the first trimester, but is contraindicated in children because of respiratory apnea. Then remember, bronchial asthma, beta blockers are contraindicated. Beta blockers like timolol, levobinolol, they will cause bronchoconstriction and cause bronchial asthma. Absolutely contraindicated. And diabetic patients, we will not give glycerol, because glycerol raises the blood sugar and worsens diabetes. And acetazolamide will cause ketoacidosis. Okay, it may cause ketoacidosis because it causes metabolic acidosis. By excretion of potassium, it leads to metabolic acidosis. So we have to use it in caution. You can give it, but you have to give some potassium supplements. Okay, and very important, remember, brimonidine has very important side effect, depression. Please be careful. Remember, depression, according to WHO, is the world's most common prevalent disorder. And many of you sitting here are subclinically depressed. You know, looking at me with baleful eyes like that, I can make out that you're deeply depressed. Okay, but not me, not me. So remember, watch out for depression. Brimonidine is to be contraindicated in depression. Okay, another drug which can cause depression is timolol, but it is not so much. It's not so much. It's brimonidine which is mostly. Brimonidine actually a lot of MCQs. It's contraindicated in children, contraindicated in depression. It is a drug of choice in pregnancy. So multiple choices. MCQs you can have in brimonidine. Okay. Then the next thing of the anti-glaucoma drugs is apraclonidine, which is another alpha-2 agonist, along with brimonidine, has the highest amount of allergic reactions. Okay, so people who have allergic reactions, we avoid them. In any case, remember, apraclonidine is not a drug which is very commonly used nowadays because of multiple reasons. But remember, brimonidine is also in the same group. So brimonidine is also highly allergic. Okay, because any two alpha agonists are highly allergic drugs. So apraclonidine and brimonidine are to be avoided in people who are allergic patients. Okay, that's the next brimonidine, as I said, because these are also belong to the alpha-2 agonists. And topical CIs, carbonic anhydrase like brimonidine, they can, and sorry, not Proxy, not brown, sorry, it's dorzolamide and brinzolamide. They are topical CIs. They can also cause allergies, and prostaglandin is the third. So this is the highest of allergies. First, the alpha-2 agonists, then the topical CIs, then the prostaglandin analogs. And another question, which brimonidine and pilocarpine, which we'll discuss again when we do conjunctiva, are drugs well known to cause follicles. What are follicles? Follicles are rounded conjunctival elevations, or rounded collections of lymphocytes in the conjunctiva, which are seen in conjunctival infections, particularly viral and chlamydial. Viral and chlamydia, they are collections of lymphocytes which are seen in certain infective disorders, particularly viral and chlamydia, but can also be seen in certain drugs like brimonidine and pilocarpine. They are well known. See, these are all PYQs. Okay? Pretty young, not pretty young things, but pretty frequently asked questions. Okay? So, PYQs, previously asked questions. And then what about the fastest angle closure glaucoma? Remember anti-glaucoma drug? We have to remember this. This is mannitol followed by acetazolamide. Why? Because mannitol and acetazolamide are the only two drugs which can be given as IV, intravenous. So they act fastest. In India, we only have IV mannitol available. Acetazolamide is not yet available. So given a choice, the fastest anti-glaucoma drug is mannitol. Is mannitol, which will lower the pressure in 30 minutes. Remember, it's intravenous. So this is also the drug of choice of acute angle closure glaucoma. Drug of choice of acute angle closure glaucoma. We're going to talk about some secondary glaucomas. Remember, so far we've done primary glaucomas. Primary glaucoma is glaucoma. The cause is not known. That is, the pressure is high, but we don't know why. Okay, that's the primary. But secondary glaucoma is we know the cause. So remember, the basic difference between primary and secondary is this: that in secondary we do not know. Beg your pardon. The secondary we know the cause of raised intraocular pressure. So what's the difference? Why should I know the difference between primary and secondary? Remember, because primary we do not know the cause. So we have to give anti-glaucoma drugs to lower the pressure, right? Since we don't know the cause. But secondary glaucomas, we know the cause. Like what? Like trauma, like uveitis, like lens-induced glaucoma. You know? So what we do, cataract-induced glaucoma. So what we do, since we know the cause, we don't have to treat the glaucoma, we treat the cause. We treat the uveitis and the pressure comes down. We treat the trauma and the pressure comes down. You understand? So basic difference with primary and secondary is that secondary we know the cause, so we treat the cause. Primary we don't know the cause, we treat the glaucoma. So that is why we need to know the difference. And secondary glaucomas, we are going to talk about two of the most important things. Actually, there are a lot of secondary glaucomas, but I'm glad to tell you that we don't ask you too many questions. Secondary glaucomas mostly are restricted to two main ones that I'm talking to about. This is called lens-induced glaucoma. Remember, lens can induce glaucomas in two different ways. Actually, there are many other ways, but we need to discuss these two. Lens-induced glaucoma, let's look at the first and the more commonly asked MCQ is phacomorphic. The other one is also there, but it's not that commonly asked. It's called phacolytic. So phacomorphic, look at the word phaco means lens, morphic means morphology. What happens to lens? Lens swells up. Why? Because it's a mature cataract. A mature cataract becomes swollen, it becomes intumescent. Remember, the word intumescent means swollen up, and it causes the glaucoma. See why? Look at the diagram. So this is the iris, this is the lens, and mature cataracts, as you know, mature cataracts is defined as completely opaque cataract, okay, totally opaque cataract. So mature cataract has this habit of withdrawing water from the aqueous humor like this. Okay? The aqueous humor, the water from the aqueous humor, it drains into the lens, it goes into the lens and swells up the lens like this. Look at that, this swelling of the lens. As the lens swells up, this is called intumescent. The word intumescent means swollen up. As it swells up, look at what happens. It pushes the iris forward and the angle closes. This is the angle, and because of the mechanical pushing of the iris by the lens, it closes the angle. The angle closes and develop a secondary angle closure glaucoma, which is called a lens-induced glaucoma. Okay, it's called lens-induced glaucoma, and this is called phacomorphic glaucoma because remember morphology. The morphology swells up. The treatment for this is, remember, to treat the primary cause. What is that? The primary cause is the cataract, so we do cataract surgery. So this is the example. Remember the difference between an acute angle closure glaucoma and phacomorphic glaucoma is just this, because they look just the same. They both have raised intraocular pressure, they have a sudden acute pain, sharp pain, antechamber is shallow, pressure is very high, and patient deep pain. The only difference is an acute angle closure glaucoma occurs due to pupillary block, so you'll have a pupil block, you will see that with vertically oval pupil. Here, the cause of the block is the cataract, so you will see the cataract. So when you see the cataract, it means it is a phacomorphic glaucoma. What you do, you take out the cataract, do cataract surgery, the patient will be fine. Another way the lens can use glaucoma is to become hypermature. It's called phacolytic. Yes, what is that? Remember, in this case, the difference is the cataract is hypermature stage. It's one stage beyond. And remember the hypermature stage, what happens in this case is because it's a very small lens and it's a very old lens with a wrinkled capsule like this. So this wrinkled capsule, because it is very old and fragile, so it allows the leakage of these things called as high molecular weight lens proteins. Okay, HMW stands for high molecular weight. These lens proteins, they leak out. They leak out from the lens. Why could they leak out? Because remember, it's a very small, very thin, very old, fragile capsule. It develops these micro leaks, and through which these microscopic leaks, they allow the lens protein to leak out. And see, what do? These lens proteins leak out, and they close the holes of the trabecular meshwork. Remember, the trabecular meshwork is full of holes? So they physically block and obstruct the holes of the trabecular meshwork, so the aqueous cannot get out. Again, the pressure rises, causes the glaucoma, but this time, remember, it's an open angle glaucoma, okay? And the treatment in this case, again, because the pressure rises, because the trabecular meshwork does not allow the aqueous to get out, the pressure rises. So again, the pressure is high. So remember, in both cases, the pressure is high, but there's a difference. Let's look at the difference, and the treatment of both is similar. Remember, hypermature cataract in phacolytic also has to be operated, because that is the main cause of the glaucoma, is the cataract. So both cases, the treatment is the same. We have to operate, but there are different mechanisms. So let's look at the difference in phacomorphic and phacolytic. Yes, remember, phacomorphic is PM and phacolytic is like this. Phacomorphic, first of all, is an angle closure glaucoma. Okay, it's a secondary angle closure glaucoma because the iris is pushed forward by the lens, by the solar lens. But phacolytic is a type of open angle glaucoma. Why? Because there is no blockage of the angle, there is just trabecular meshwork blockage, physically blocked by the high molecular weight proteins. Second, in phacomorphic glaucoma, remember, it's caused mostly by mature cataract. In phacolytic, it is a hypermature cataract. Okay? Because hypermature cataracts only, they can allow the lens protein to leak out, okay? Because they are microscopic leaks, because they're very thin capsule. This is, we already discussed that, we just want to say shallow. I want to make this, AC is shallow. In phacolytic, you can see the AC is shallow, but in phacolytic, the AC is deep. Okay? So that is why you can differentiate between the two by looking at these two things. But how I must tell you, the treatment remains the same, which is the cataract surgery. Very well. So therefore, these are the kinds of glaucoma. Now, this is one kind of a lens-induced glaucoma, which I said is type of secondary glaucoma. The second type of secondary glaucoma, which you'll have to ask you more MCQs, is the most dangerous glaucoma, called as neovascular glaucoma. Okay? Neovascular glaucoma, remember, is why called neovascular? Because of new blood vessels. And why do new blood vessels appear? Remember, new blood vessels appear for a very simple circuit. You must really memorize this right now. Remember, of all the tissues in the eye, the retina is the most oxygen consumed. Okay? That is a very important. Remember, out of all the tissues in the eye, the highest demand for oxygen, the highest consumer of oxygen is the retina. Okay? And because the retina consumes so much oxygen, so it can become easily very hypoxic, is it not? Hypoxia means lack of oxygen. When something requires a lot of oxygen and doesn't get it, it becomes hypoxic. Since retina demand of oxygen is so high, it easily becomes hypoxic. And as the retina develops hypoxia, it produces a very dangerous factor called as VEGF. Okay? This stands for vascular endothelial growth factor. We call it VEGF. And this VEGF causes neovascularization, which means new blood vessel formation. Okay? Now, this little circuit of 4 words you must remember. This will be asked again and again. Retina develops hypoxia. Any condition that causes retinal hypoxia will cause retinal hypoxia, will cause VEGF, and VEGF will cause neovascularization. Now, this must be very clear. Any hypoxic condition of retina causes new blood vessels formation on the eye. And where will they form? Look at that. First of all, the new blood vessels will form on the retina, naturally, because that is the site of the new blood vessels, of the site of the VEGF formation. Look at that. You see, after 3 to 6 months of hypoxia, new blood vessels develop on the retina like this. And then they come forward, after a few months, they come forward to the vitreous. So you can have a vitreous also full of new blood vessels. And then they go to the iris. Remember, they cannot go to the lens because the lens is avascular and does not support vasculogenesis. So they jump across the lens and go to the iris like that. And as the iris becomes neovascular, you know that the new blood vessels have fibrous tissues in it, so they can contract. All the blood vessels are contractile, and as they contract, see what happens? They contract the iris is pulled close to the cornea like this, and the angle closes. And the angle closes. As the angle closes, the intraocular pressure rises because the aqueous cannot get out, and you develop neovascular glaucoma. So kindly remember, neovascular glaucoma is a kind of secondary angle closure glaucoma. It's a type of secondary angle closure glaucoma which occurs because of the zipping up of the angle by new blood vessels. Remember, we call it a zipper-like closure. It closes like a zipper, okay? So it's zipping up the angle with new blood vessels and can never be opened again, okay? So this is the basic pathology in vascular glaucoma, and extremely deadly, these two. Remember, number one cause, I want you to remember two causes of neovascular glaucoma, but there are many causes. And you know the basic pathology is the retinal hypoxia. So the first one is diabetes. Always remember, neovascular glaucoma, 30% of cases of neovascular glaucoma, the cause is diabetes. So 1/3 of neovascular glaucoma is caused by diabetes, number one. And second is called as CRVO, central retinal venous occlusion. We'll discuss these two causes, don't worry. So these are the one and two most important causes of neovascular glaucoma. But in any condition, remember, where the retina is deprived of oxygen, you can develop neovascular glaucoma. Okay? So this is what I showed. Retina causes hypoxia, plus VEGF causes neovascularization. This pathway you really have to remember. And so as the pressure, remember, it takes time. It takes 3-4 years, sometimes 5 years before the blood vessels have contracted enough to close the angle. It takes time, but it is relentless. And when it occurs, the pressure is very high, goes up to 50s and 60s. It's very high pressure. Because red, painful eye, and the corneal edema, because there's so much high pressure, so it forces the aqueous into the cornea. So corneal edema, and this neovascular of that, this is an important term you must remember. It's called rubeosis iridis. This is also called as NVI, neovascularization of the iris, NVI, which you can see in this photograph here. In this picture, you can see this. Okay? The new blood vessels are there. So the hallmark of neovascular glaucoma is that you have to see the blood vessels in the iris, which is also called by this beautiful name called rubeosis iridis, also called as neovascularization of the iris. Okay? So you see these findings and you know that and the pressure is high and you know you have neovascular glaucoma. So how do you treat it? There are two ways of doing this. First, if it's early glaucoma. Second, it's late glaucoma. The early glaucoma we can still treat. It's not that difficult because the pressure, what we'll have to do first, in this case, we'll have to first block the VEGF. See, there are only 4 steps in this pathway. So, and 4 steps after which the retina and the neovascular are the first and the last. So there's nothing we can do there. So what we have to block is the second step and the third step. So how do I block the VEGF? We give anti-VEGF drugs. Anti-VEGF drugs, you know, there are so many of them, but at least you have to remember the first two was bevacizumab or ranibizumab, the second one, and latest is called aflibercept. Okay? So these 3 if you remember, but I'll be okay if you remember at least 2, which is bevacizumab and ranibizumab. You can give any one of the 2 or aflibercept. You block the VEGF. How do we give this? This anti-VEGF drugs, this injection, we give into the vitreous cavity because remember it has to reach the retina where the blood vessels are. So to reach the retina, we inject is in the vitreous cavity. How? Through the pars plana. You know, anytime you want to enter the vitreous cavity, there's only one way to enter the vitreous cavity, that is to go via the pars plana. It's not. So we give pars plana injection. So that is what it treats blocks the VEGF. The second thing is to treat this, remember, the hypoxia. Okay? Because the basic cause of VEGF is what? Hypoxia. That is the main cause that has to be treated. So how do you do retinal hypoxia? Treat retinal hypoxia. Remember, retinal hypoxia is treated by this procedure called as PRP, pan-retinal photocoagulation. What we do, this is the best procedure, what we do, we take a laser beam and coagulate the entire retina. Pan means whole, no? We coagulate the entire retina except the macula. So suppose this is the macular area, we fill up the entire retinal with laser marks like this. You take a retinal laser and focus on the peripheral retina, but not the macula. Okay? So this is a very extensive laser. That's why we call it pan-retinal photocoagulation. It takes about 3 weeks to perform. Okay? And this is the best of hypoxia. So now there is no hypoxia, so there is no VEGF, so there is no further neovascularization. So we have stopped the neovascularization. This is the first step. Second thing is to lower the intraocular pressure. This is not first. The step is to stop the neovascularization, and second is to treat the glaucoma. So we raise the lower intraocular pressure first with anti-glaucoma drugs. Which drugs? Remember, we can use any drugs except 2 are contraindicated. That's your MCQ. Remember, which 2 drugs are contraindicated in neovascular glaucoma? Remember, we do not use prostaglandin analogs like latanoprost, bimatoprost, etc. And we do not use cholinergic agonists like pilocarpine. Why not these 2? Because both of them, remember, they have a side effect of uveitis. They cause a lot of uveitis, and which means inflammation, which we don't want because neovascular glaucoma already is an inflamed eye. Okay? A very inflamed eye, you don't want to add further inflammation by giving these drugs. You can remember the MCQs. Which 2 groups of anti-glaucoma drugs are contraindicated in neovascular glaucoma? Kindly remember the cholinergic agonists like pilocarpine and the prostaglandin analogs like latanoprost, bimatoprost. Okay? Other drugs we can use, but you know, most of the time, because the pressure is very high, so anti-glaucoma drugs are not able to bring down the pressure. Okay? Because the pressure is really high, 60, 70, 80. So we have this do surgery. Remember, we talked about this trabeculectomy, where we take out a piece of the trabecular meshes. So mostly this treatment is surgical. So we take out a piece of trabecular mesh, and nowadays we have a latest surgery called aqueous drainage implants. Okay, ADI, or aqueous drainage implants. What we do, we put in an implant here on the eye, which diverts the aqueous from the anterior chamber out on the subclavicular space. Okay, this you have to do a surgery and put an implant there. But this is not generally asked to your exams. We don't go discuss in detail, but you should know that either surgery, or which could be trabeculectomy or aqueous drainage implants, we use primarily for treatment of neovascular glaucoma. The drugs are useful, but they most of the times they're not able to bring down the pressure. This is about neovascular glaucoma. What about late neovascular glaucoma? Early we can still treat, as I said. So first you give anti-VEGF drugs, stop the neovascularization, anti-glaucoma, followed by lowering intraocular pressure with trabeculectomy or aqueous drainage implants. But what about late glaucoma? Late glaucoma is just too late and the patient has developed blindness. You know why blindness? Because you see, they have come to us too late, and by the time they have come to us, the angle is completely neovascularized. See, it's completely zipped up short by the time they come to us, totally closed. Not a single bit of the aqueous can get out, and the intraocular pressure rises to a massive 70 millimeters of mercury. 70 millimeters of mercury, the pressure can rise up to. This destroys the optic disc, which is called glaucomatous optic atrophy, and the patient develops blindness. The patient develops blindness. So that is why most of the times this late glaucoma we treat, because the patient is already blind by the time he comes to us. So why does he come to us if he's already blind? Well, he comes to us for the pain, because the pressure is so high and the eyeball is literally being torn apart by the raised intraocular pressure. The patient comes to us howling with the pain, and the only way to reduce the pain is to reduce the intraocular pressure, which we do by this procedure called cyclodestruction. Look at that. Cyclodestruction means ciliary body is to be destroyed. Why? Because the ciliary body is the main producer of aqueous. Remember, the angle is completely closed. You cannot reduce the pressure by forcing aqueous out of the angle. Angle is zipped up shut. The only way to reduce the pressure is to stop the aqueous production, which is why we destroy the ciliary body. Remember, he is already blind. He doesn't really need the ciliary body. Destroy the ciliary body by two different techniques. One is called DLCP. It stands for DLCP, stands for diode laser cyclophotometer. And here we come across, remember, the third laser of ophthalmology. This is the third laser. We already yesterday talked about femto, and we talked yesterday about an NDAG, and the third laser is diode laser. So you take this laser, focus on the ciliary body, it destroys the ciliary body. The pressure comes down in a month. But these are expensive lasers, so what we prefer is to try another one, which is called as cyclocryoprex. Look at the word. Cyclo means ciliary body, cryo means cold, and pexi means destruction. Okay? So you take a very cold probe at minus 80 degrees centigrade. Look at that. It's very cold. You have to remember this temperature. Minus 80 degrees centigrade. You take this cold probe and touch it to the ciliary body like that. It freezes the ciliary body, destroys it, and this is how this destruction of ciliary body takes place. Slowly, the pressure comes down in about a month's time, because there's no further production of aqueous, but remember, the vision does not come back. Okay? So this is the sad story of late neovascular glaucoma and deadly glaucomitis. So watch out for people with diabetes, which is the #1 cause of neovascular glaucoma, and watch out for CRVO. So neovascular glaucomas are one of the, in my opinion, it is one of the most difficult things to treat, because by the time they come to us, usually it's very late. Okay? So that's the end of glaucoma, ladies and gentlemen. We've done glaucoma. Just take a quick look at your questions if you have any so far. I hope the audio is clear and the visuals are clear, and I hope you're learning a lot of new things. Okay? Now we come to something very important, refraction in optics, where a lot of MCQs have been asked of late, sometimes 3, sometimes 4, sometimes 5. Okay? And this you should know, because this is the cornerstone of ophthalmology, remember, which is about prescribing glasses, contact lenses, intraocular lenses. Okay? So this is something very important, because this is the cornerstone of ophthalmology. Because when you wear glasses, let's look at that. The first condition you have to know is called emetropia. This is defined as a condition where the rays of light focus on the retina. So you see what happens? This is called emetropia, when the rays of light focus on the retina like this. This is emetropia. So these are rays have, since they focus on the retina, so they have good vision. So emetropes don't need to wear glasses. I'm emetropic, some of you are emetropic. So we don't need to wear glasses, because the rays of light are focusing right on the retina. Alas, everybody is not so lucky. So there is a condition where the rays do not focus on the retina. They do not focus on the retina. This is called ametropia. Ametropia, when they don't focus on the retina. If they do not focus on the retina, where would they focus? Where would they focus? Well, there are three possibilities. What is the possibility? First of all, that these rays can, if they do not focus on the retina, then they can focus in front of the retina, is not? You can focus in front of the retina. If that is there, then this condition is called as myopia. Okay? Remember the definition, any condition where the rays of light focus on in front of retina is called myopia. Okay? Or they may focus behind the retina. Okay? Because that they may focus behind the retina like this. If they focus behind the retina, this is called hypermetropia or hyperopia. Same thing. Hypermetropia, also called hyperopia. This is the second possibility. Or they may have two different foci. Two, not one, but two. And one may be in front of retina, one may be behind retina. It doesn't matter where they are. They could be both in front of retina, could be both behind the retina, one in front, one behind. Okay? But the basic definition is that they should have two different foci. This condition is called as astigmatism. Okay? So remember, we have three different types of ametropia. If there is in focus in front of retina, it's called myopia. Focus behind retina, hypermetropia, hyperopia, and two different foci, astigmatism. Okay? And what exactly decides? Okay, what exactly decides the fact that some of us will be myopic, some hypermetropic, some emetropic? Well, there are four factors. Four factors. What is that? Depends on four things. Remember, on corneal curvature. Yeah, how curved is your cornea? Anterior chamber depth, axial length, the length of the eyeball. Remember, most of us are around 24 millimeter standard, and the lens thickness. You can remember the four different factors. Together, the entire refractive status depends on the combination of these four factors. Okay? That is the corneal curvature, axial length, anterior chamber depth, and lens thickness. Together, this combination will give you your final refractive status. But remember, the MCQ is out of this, the most important factor is corneal curvature. Okay? Remember, your corneal curvature is the single most important factor which decides your final refractive status. Why? Because the maximum bending of light takes place at the cornea. Okay? You are all aware that the light bends when it enters the eye. Remember, light bends at four places. From air to cornea is the first entry, that's the first bending. From cornea to aqueous humor, second entry, second bending. Third, from aqueous to lens, third bending. And fourth, from lens to vitreous. Okay? Because remember, the rays only bend when you have change your media, isn't it? Look at that. Let me draw it for you. So supposing, see, this is the rays of light entering. Remember, the light only bends when it changes media. So as you can see here, light would pass through air like this, straight lines. It would not bend. But if it changes media, suppose it enters from my hand like this, then it will bend. It only bends when it changes media. So look at that. This is the first bending, air to cornea. This is first bending. Second is from cornea to aqueous humor, second bending, change of media. Third, aqueous to lens, the third bending. And fourth, lens to vitreous, okay, fourth bending. So there are four bending. The light bends at four different interfaces of the eye. And I just told you the maximum bending, remember MCQ, the maximum bending is when the light first strikes the cornea, the first passage, that is air to cornea, is the most important bending of light. That is the maximum bending. You might be asked a question, which surface of the eye is most responsible for final refractive status? You would say corneal curvature or the anterior surface of the cornea. Remember, the interface is between the air and the anterior surface of the cornea, where it causes bending of light. Yeah, so we have these three things. Let's talk about myopia, which is often very commonly seen, and a lot of you are myopics. Let's talk about myopia, where the definition is clear-cut, light rays focus in front of the retina. Okay, so remember, any condition, it doesn't matter what the cause is, if the rays of light focus in front of the retina like this, it's called myopia, right? And the word myopia, remember, comes from the typical habit. Those who are myopic and not wearing glasses, remember, these are for people who are called uncorrected myopics. Uncorrected myopics means that they're not wearing glasses. People who are wearing glasses, they're fine. This myopia word comes from the habit of uncorrected myopics keeping their eyes half closed like this. Okay, look at me. When I look at you like this, I keep my eyes half closed. If I'm a myopic and I'm not wearing glasses, then I would keep my eyes half closed. This is a typical myopic look, and from where the word myopic comes, okay? Myopia comes from the word for a half closed look like this. And why do I do that? Because of the pinhole effect. By closing the lids together, we call the pinhole effect, okay? And this pinhole effect improves the vision. So many of you, my friends, you don't like to wear glasses, but you know your vision is not very good. What you do, try to squeeze your eyes together like this and create a pinhole effect which improves your vision, okay? That is how we make out that you're myopic. So look at the MCQ. Parents of a child complain that the child watches TV with the eyes half closed. Why? Because he's a myopic or she is a myopic, because they can't see and they know instinctively that by closing the lids together, squeezing the lids together, and they cause a half closed look, it creates a pinhole effect which improves the vision. Okay? That's how we detect myopics. Then let's come to the cause of myopia. What is the cause of myopia? Why should the rays of light focus in front of retina? And the first and the most common cause, remember, look at that, is called axial myopia. That means the axial length is longer than normal. Okay? So remember that the normal axial length is 24 millimeters, right? You know, the normal axial length is 24 millimeters. So it should focus like this. The rays of light focus on them. Like mine is exactly 24. That's why I'm not a myope. I'm 23.9. Okay? My axial length. So my rays focus. But supposing you had a longer eyeball. Why longer? Well, it is because of genetics. Your parents had it, so you also have it. Suppose the eyeball keeps on growing and does not stop at 24. It goes and stops at 25. You see the ray, this is your 25 millimeter retina here. Now the rays would still focus there. Okay? The rays would still focus there. Why? Because, why would the rays still focus there? Because you see the cornea still, the power still, cornea of the cornea is still 43 diopters, okay? It's still 43 diopters. And the power of the lens is still 19 diopters, is it not? So the focal length will be the same. The rays will still focus, but remember the retina is here. The retina is no longer to gather the rays because the retina has pushed back because of the greater axial length. So that is why you see this, by definition, remember, rays of light are focused in front of retina, so you have become axial myopic. So that's why this is the single most common cause of myopia. Most of you are myopics because the eyes are larger than normal. Okay? And remember, there's a very important equation here. Each 1 millimeter of axial length, can you remember, each 1 millimeter of axial length causes 3 diopters of myopia. Very important, can you remember, each 1 meter extra length, okay, causes 3 diopters. So that means that those of you who are wearing -3, we call it minus because they're concave lenses, and because they diverge, we call them minus. Remember, those of you who are wearing -3, it is because your axial length is 25 millimeter. Okay? Remember, every 1 meter extra jumps your power by 3 diopters. So suppose you have a 25 millimeter axial length, your power will be 3 diopters. Suppose 26 millimeter, it will be 6 diopters. 27 millimeters, it will be 9 diopters. 28 millimeter, 12 diopters. 29 millimeter, 15 diopters. You understand? So every 1 millimeter extra causes 3 diopters. You please do not get confused with this. This is a very important equation. Right. So this is the first, but this is also the most common. Almost 80 to 90% myopes are because of axial myopia. Okay? And then let's look at the second one, curvature myopia. Look at that. There is another cause of myopia, but this does not depend upon the axial length. It depends on the corneal curvature. Okay? So it depends on the corneal curvature. This is called as curvature myopia. This is not as common as axial myopia, but it's there and you should know it. It's called as curvature myopia. Okay? Curvature myopia means that here the axial length is normal, but the cornea is simply too curved. Sometimes too curved. Axial length is 24 millimeters only, but the cornea is too curved. And remember, when the cornea is too curved, anything that is more curved, it will cause, what will cause? It causes more bending. Remember, more the curvature, more the bending of light. So because the light rays, the cornea is too curved, it will bend more. If it bend more, it focuses in front of retina, not on the retina, because it's simply too much bending. So again, by definition, it is called myopia. It's called curvature myopia. Example being keratoconus, where the cornea is conical like this. And remember, keratoconus is a very important condition for us because it's pretty common in India and it occurs in your population, your age group, my friends, between 25 to 30. Okay, so between 20 to 30 actually. Remember, it's a corneal condition which is very common in India. And in the younger population, between age to 20 to 30, slightly in favor of females. So more females have keratoconus. And I wouldn't be surprised at all if amongst some of you watching here right now, one of you were a keratoconus. Okay? This is keratoconus. And remember, keratoconus, because the corneal curvature is very important for bending light. I told you it's the single most important surface that bends light. Remember here, the calculation is even higher. Each 1 millimeter of extra curvature causes 6 diopters of myopia. Look at that, you know. In axial myopia, I told you each 1 millimeter extra causes 3 diopters, but in curvature myopia, each 1 millimeter extra curvature causes 6 diopters of myopia. You see how it jumps. That is why keratoconus patients are very high myopia. They are not -1, -2, -3. They were -10, -12, -15, -18 because extra 1 millimeter curvature jumps your power by 6 diopters. But luckily, it's not as common as axial myopia. Then the third kind of myopia is index myopia. What is that? Index myopia is myopia where the axial length and the corneal curvature are same. So they are normal. There's no any change here. But the refractive index increases. Okay, what is that? So refractive index, remember, is a number which tells us about how much light is bent by a particular surface. Okay? So refractive index normally of the lens is about 1.4. This is the normal refractive index. But in certain conditions, nuclear cataracts we talked about yesterday, because the nuclear cataract, there's a lot of compression of the nuclear fibers in the center. All the fibers get compressed in the center. That's why the yellowish amber color. So it increases the refractive index from 1.4 to 1.42. Okay? And more the refractive index, more the bending. Okay? So remember the facts of bending of light. 3 things bend light more the curvature, more the bending, more the refractive index, more the bending, and more the thickness, more the bending. Okay? Because the refractive index of the lens increases, so see, originally the rays of light which were focusing on the retina, now they focus in front of retina. Why? Because of the increased refractive index, because they bend more light. And why have they refractive index? Because of cataract. So that is why this is nuclear cataracts all become myopic. Remember yesterday I told you that in nuclear cataracts patients become myopic. They have problems of distance vision, is it not? So this is how to explain the myopia, because nuclear cataract causes compression of fibers, raises refractive index, which bends more light, focuses in front of retina, right? There are 3 different kinds of myopia, but the most common is axial, followed by curvature, followed by index. But regardless, the reason is the same, the rays of light are focusing in front of retina. Okay? So what is the main problem? The main problem is that because rays of light are focusing in front of retina, so distant vision blurred. So these are typical new myopia come to doctor. I cannot see distances. I cannot see distances because the rays of light are focusing on retina. But remember, near vision is manageable. You can see near vision. Many of you myopes know that if you take off your glasses, you can still see the books. Is it not? Your near vision is reasonably okay. Why? Look at that. Why is near vision okay? Because remember, near vision is always, by definition, remember, whenever you see any objects near, there's a difference. The rays of light are parallel. They're not parallel, they travel divergent. Okay? Remember, distance vision, when you look at something like this, the rays of light become parallel. Okay? This is physics. When you look at a near object like this, and the nearer the object, the rays are more divergent. Okay? The rays are more divergent. Look at that. I've drawn it here. The rays are more divergent. So the cornea and the lens have to make it more parallel, and then they become parallel. Then they start converging. And by the time they start converging, see, it's too late, so they focus on the retina. You understand? They don't focus here. Why? Because those are parallel rays. The divergent rays, they need more time. They first have to become parallel like this, and because that takes more time, they also focus later. So don't focus here, they focus right on the retina. So that's why near objects are visible to a myopic. Myopic can read near objects, but not distant objects. Yeah? This is a typical problem of myopia. And myopia, so remember, what is myopia? We have to, how do we correct myopia? Therefore, we correct myopia by, we need to basically, rays of light are focused in front of retina, no? So we need to place the rays on the retina. So we need to push the rays back on the retina. How do you do that? By giving divergent lens. Because if you put them converging, remember, anytime converging means the rays of light are coming closer. So that would push the rays more in front. No? We don't want that. We want them to go back on the retina. So we have to give some lenses which diverge the rays, which are concave lenses. This is concave lenses. So what it does, by putting this, these rays are divergent like this, and because they diverge, so they'll become parallel later, and they'll focus on the retina. So these rays, which are originally focusing on the retina, now they don't focus on the retina, because by giving them diverging lenses, the lenses have made them more divergent, which causes parallelism later, and they focus later right on the retina. So all of you who are myopics, you have to wear concave lenses, okay? And you know that it appears like this. And remember, there by physics principle, concave lenses are one close to the eyes. Okay, remember, all of you, those who are myopics know that very well. That by a physics principle, it states that when you wear concave lenses, you wear it close to the eyes. Okay, that gives you best vision. And many of you know that is not, because as soon as the glasses slide down the nose, your vision drops. What do? You push it back again, because you enhance the effectivity of the lens by wearing it close to the eyes. Okay? So this is an important thing to remember. Anybody who's wearing the lens close to the eyes and is constantly pushing back these glasses like that typically is a myopic. This is a myopic, a very myopic gesture. Even kids are pushing back the lenses like this. And also remember, concave lenses have this important property that they minify the image size. Okay, how much? One diopter minifies by 2%. Every one diopter is 2%. So suppose you are wearing -5, your image size will be reduced by 10%. Okay? Every one diopter of glasses, you reduce the vision size of the image by about 2%. Please remember that. So those of you who wear high-powered glasses, suppose -10, you actually have quite a lot of minification, almost 20% minification you have. Okay? That's quite a bit, so remember that. And also very, very important, remember, so myopics are preferably undercorrected. What is undercorrection? Undercorrection means that you give them lesser power. That makes them more comfortable. You can give them the full power also, but that doesn't cause comfort. They are slightly uncomfortable because slight eye strain or headaches. That means, undercorrection means that supposing your power is -3, okay, suppose you are wearing -3. Now I could give you -3, but if I gave you -2.75, this would be better. Okay? Or even if I give you -2.5, your vision would not be affected and you would be very comfortable. So myopes prefer to be undercorrected. That is an important rule for us. We know that. And how do we know that? We are always, even if you give them full correction, so if you give the -3, it's not a wrong thing to have. Not wrong, but undercorrection is better. But what you must never do in a myopic is to overcorrect them, which you must not do. Overcorrection means you prescribe more power than the patient requires. So if he has -3, then you should not prescribe -4 or -3.5, okay? That causes a lot of headaches. So how do I prevent overcorrection? By do this very powerful test called the duochrome test. Remember, it's called duochrome because there are two colors here, duo. So at the end of your refraction, when you finished your refraction, ask the patient, it's right on the Snellen's chart, okay? This duochrome is present on the Snellen's chart. Ask the patient, look, there are 2 letters on red and 2 letters in written green. Compare the 2 letters and tell me which is clearer, And so let me tell you what is the interpretations. Remember, interpretation is that there are 3 possibilities. The 3 possibilities are that the patient will either say that red is equal to green, is not. So look at that, I'm going to write this down to you. So patient will either say that red is equal to green. If that both the letters, remember we have to look at the letters, not the color. If the letters are equally clear in both, then it means it is fully corrected. Fully corrected means that you've given -3, which is quite okay. But if the patient says red is better than green, that the red letters are clearer than green, it means you have undercorrected them, which means you give a slightly lesser power than required, and this is ideal. This is ideal. Okay, this is ideal. But if the patient says that the green is better than red, this means you have overcorrected. That means you've given more power. So it's -3, maybe you've given -4 or even 3.75. Now this is completely unacceptable. Remember, myopics should not be overcorrected because they'll cause headaches and eye strain. Okay, so we always do these tests to prevent overcorrection because a lot of you prescribe powers which is slightly higher. We must not do that. So always we should aim for red better than green. Remember, this is not based on color vision. It's not based on color vision. Even colorblind people can take this test. Okay, so it is on chromatic dispersion. It's a different principle. So red better than green is what you have to remember. So how to memorize it? Remember, I always tell you, memorize this by remembering that it is opposite to the traffic lights. Remember, when you're driving something, a vehicle, you look at the traffic lights, not. If it's green, you go ahead, is not. Well, remember, it's opposite to the traffic lights. If it's green better than red, then you stop. Then you commit an error, go back. Remember, it's opposite to the traffic lights. It should be red better than green. Very well. So this is about myopia, and myopia, we have finished now. There's a lot of MCQs in myopia. Please remember, again to summarize, raise focus in front of retina. Whatever be the cause, the main important problem is distance vision is problem, near vision is okay. And you give them concave lenses, they become very happy. Remember, myopics are very simple people. They just need to see clearly. That's all. A myopic is very simple to satisfy. You just give them concave lenses, it's very happy. Let's talk about hypermetropia. What about hypermetropia? Remember the definition. Hypermetropia is, first you remember the definition, is the rays of light focus behind retina. Doesn't matter what the cause. Doesn't matter what the cause. Hypermetropia is hyperopia. And So here, hyperopia, remember, is a much more complicated problem than myopia. Please remember, myopias are simple, hyperopias are much more complicated. How? Let's look at that. In this case, rays of light are focusing, but the single most common cause why should rays focus behind retina is the eyeball is smaller, is it not? It's smaller, that is why it focuses. Remember, the original ocular length is 24 millimeter. So what happens, but supposing you have a 22 millimeter eyeball like this, supposing you have a smaller eyeball, what will happen is the rays, they will still focus there, is it not? The rays will still focus there. Why? Because remember, the cornea is still 43, the lens still 19, so the focal length is there, but your retina has moved forward because you have a smaller eye, the retina has come forward and the rays have gone behind. So by definition, since the rays are behind, so we call it a hypermetropia. So remember, the first and the most important cause of hypermetropia is the size of the eyeball is smaller, okay? Remember, myopes have a large eyeball, hypermetropes have a smaller eyeball. And the same thing is that each 1 millimeter of shortening causes 3 diopters of hypermetropia. Please remember that. Again, the same equation in reverse. Each 1 millimeter of shortening, that was elongation in myopia. This 1 millimeter shortening causes 3 diopters of hypermetropia. So suppose you have a 22 millimeter eyeball, you are a hypermetrop. How much? Normal is 24, you are 22, which means you are 2 millimeter short. If you are 2 millimeter short, so 2 into 3, this is 6 diopter hypermetropy. Okay? So if you are 23 millimeter, you will be 3 millimeter, 3 diopter hypermetropic. If you are 22 millimeter, you will be 6 diopter hypermetropic, and so on. Okay? So every 1 millimeter of shortening causes 3 diopters, exactly reverses that of myopia. The 1 millimeter of elongation causes 3 diopters myopia. Very good. So those of you who have short eyes, you are hypermetropic. Those who have long eyes, you are myopic. And those who have normal eyes like me, you are emmetropic. So remember, therefore, also that children are always born hypermetropic. Kindly remember, because children at birth, they have small eyes at birth, isn't it? So they have smaller eyes. So at birth, they are all hypermetropic. So remember MCQ, all children at birth are born hypermetropic. All of us were hypermetropic at birth. And also remember the fact that what is the approximate hypermetropia at birth? Remember MCQ, it is between 2 to 3 diopters of hypermetropia. MCQ. At birth, hypermetropia is approximately 2 to 3. That is why children at birth have very poor vision. That's why children at birth have very poor vision because of hypermetropia. Remember, at birth, children only have around finger counting or hand movement vision. They are barely there. You can hardly see. Very well. So therefore, we have this hypermetropia. Now, so what we'll do, remember that they will be corrected by convex lenses because we need to get them in front. Because rays are focusing behind the retina. Let me clarify this a little bit by erasing all the stuff. This is interfering with the field. So if you remember what we just did, what we've just done is to define hypermetropia. Rays are focusing behind the retina. Okay. Why? Because the eyeball is shorter. This is hypermetropia. Correct? So I need to get this on the retina. So we need to come forward. So how do I do it? By converging lenses. You give them convex lenses like this. Look at that. This is corrected by convex lenses here, and these rays would focus. When you give them convex lenses, the rays of light focus right on the retina, and this is how it corrects the hypermetropia by doing convex lenses. Okay, so all happens by convex lenses, and remember that each diopter of convex lens causes 2% magnification. Now remember, this is opposite to concave lens. Concave lens causes minification, the image becomes smaller. Convex lens causes magnification, exactly opposite, and every 1 diopter causes 2% of magnification. So remember, each 1 diopter of convex lenses causes 2% of magnification, convex lenses, and so therefore, suppose you are wearing +5, you will have a 10% enlarged image size. Okay, remember all convex lenses are magnifying glasses, all convex lenses. Okay, so those who are wearing convex lenses, we call them plus powers, and they magnify the image size slightly. Every 1 diopter does it by 2%. Okay, so see what happens when we have this condition. So when the patient in hypermetropia, what happens? He needs convex lenses. But remember that hypermetropes, all of us, we already have a convex lens inside our eye, no? See? We already have a convex lens, our human lens convex. So what hypermetropes do? Involuntary. Remember, they don't do it deliberately. It's done involuntary. What they do, the lens increases curvature like this. The normal human lens is also convex, okay? And because the rays are focusing behind the retina in hypermetropia, as you can see here, it will focus behind the retina. So the eye automatically increases its curvature like this. So this convex lens, which was supposed to be worn in front of the eye, involuntarily the eye borrows from its own lens, because remember, the human lens is also convex, is it not? The human is also convex, and we can accommodate. Accommodate means increasing the power by a certain amount. So that is what hypermetropes subconsciously do. They don't want to wear glasses because they wear convex lenses. So this convex lens is borrowed from their own convex lens. So the rays focus right on the retina because they increase the curvature of their own lens, they accommodate. Okay. Now the myopics cannot do that. Why? Because the human lens is convex and myopes need wear a concave lens. You cannot make a convex lens into concave and turn it inside out, is it not? So that's why myopes have to wear glasses, but hypermetropes don't have to, because they can accommodate and get the power supply. That is what the hypermetropes do. They accommodate excessively for distance and near. Okay, both. So why is that wrong? Because remember, accommodation has been provided to us for vision only. You're quite wrong. Remember, accommodation has been provided to us only for near vision. But what the hypermetropes do, because they can't see distances, because they can't see near, they are both behind the retina. The hypermetropes are always accommodating for correcting the distance vision also, and see even the near vision. Remember, the near vision rays are divergent, so the focus become parallel later and focus behind. So what the poor hypermetrope is neither able to see the distance nor able to see the near, okay, because by definition both of rays are focusing behind. So what he does, he accommodates both for distance and near. Now this is not a very good idea, because accommodation is provided to us only for near vision. But hypermetropes also account for distance, so he is using excessive accommodation, which is where he develops asthenopia. He is always accommodating, trying to get the vision clear. So ciliary muscle is always contracting. And that is why, remember, hypermetropic complaints are about asthenopia or eye strain, headaches. Hypermetropes, remember, never complains of poor vision. Please remember, very important. Hypermetropes do not complain of poor vision, because by accommodating, they get their rays on the retina. They have very good vision, 6/6 for distance and N6 for near. But in the effort of using excessive accommodation, they have a lot of headaches and eye aches, which we call as asthenopia. So kindly remember, all of you, very clearly, must again emphasize this. Myopics will have poor vision. When you ask them to read the Snellen's chart, they will have 6/18. But hypermetropes will have very good vision, 6/6. They will have perfectly normal vision. Why? Because they were accommodated to get the vision clear. But the complaint, because of excessive accommodation, because of for near also they're accommodating, distance also they're accommodating. So hypermetropes develop a lot of headaches and eye aches. They do not have problems of vision, remember. So those of you remember, those of you have headaches and eye aches after 2-3 hours on a laptop or a book or anything nearby, I'm sorry to say that your hypermetropes who have never been examined properly. Okay? Remember, those of you who have headaches after 2-3 hours of studying, reading laptop or phones, or accommodating excessively, you're actually hypermetropes who have never been examined properly. Kindly remember, hypermetropes visual quality is 6/6. They're perfectly fine with vision, but they only have asthenopia. Okay? And because, remember, every time you accommodate, you do convergence also. Remember the three things, the triple response. Every time you accommodate, the eyes go into convergence also. So because hypermetropes are always accommodating, always converging, so this accommodates to excessive convergence, and after 5 years of uncorrected refractive error, uncorrected means not wearing glasses, 5 years of uncorrected hypermetropia, where you're excessively accommodating and excessively converging, you may develop a convergence squint. Look at that. Okay? And this is what we like to ask you whenever the patient comes us of eyes are squinting inwards like this. It means a convergence squint. The first thing you find out is he a hypermetrope or not. So that is the main cause of convergence squint. Those who are accommodating excessively and converging excessively. So after 5 years leads into convergence squint. So this, remember, this is a very important point of hypermetropia. And remember, hypermetropes do not have visual problems. They do not have visual complaints. They have asthenopia, headaches, and eye aches. But the good news for you, because many of your hypermetropes I have seen in many of my classes across the country and the world, of course, many of your hypermetropes not wearing glasses. For accommodative squint, you don't, if you have really minimal, so 1 or 2 diopters of hypermetrope, it's okay, you won't develop a squint. You need at least 4 diopters of uncorrected hypermetropia to develop a squint. So if you have, say, +4 and not wearing glasses, then only get a squint. If you're +1, not wearing glasses, no squint. Okay? And so therefore, remember, to diagnose, because these patients are always accommodating. So to get the correct, and they have always 6/6. So how do you know that he's hypermetrop? Remember, emetrop is also 6/6. Hypermetrop is also 6/6. How will you know the difference? Remember, the difference is that hypermetrop is accommodating. Okay, it's accommodating, but you can't see the accommodation because the accommodation inside the eye. The lens is curving inside the eye. What you do to detect hypermetropia is only one way. You do something called as cycloplegic refraction. Cycloplegic refraction, which is what you add while checking his power. You add the cycloplegics. There are 4 of us. Hometropine, atropine, the most powerful. Hometropine, second most. Third, cyclopentadate, and fourth, tropicamide. So there are 4 cycloplegics. So you paralyze the accommodation. So suppose you're confused whether the patient is hypermetropic or emetropic, because both of them have 6/6. You just drop a drop of cycloplegic in both eyes, hypermetropic also, emetropic also. Remember, even after cycloplegia, by paralyzing the accommodation, emetrop will still remain 6/6, because remember, he's not accommodating for distance. But the hypermetrop, the vision will drop immediately to 6/60, because he is accommodating for distance, is it not? This is how we diagnose hypermetropia, because vision is equal in both. We have to do cycloplegic refraction. Okay? Paralyze the accommodation and find out whose vision is dropping. Vision who's dropping is the guy who's hypermetrop. Okay? Remember, cycloplegic refraction is often done in hypermetrop. So any condition where the ciliary muscles are too powerful and they're accommodating excessively, we do cycloplegic refraction. So we do it in 3 important conditions. One is for detecting of hypermetropic patients. Second, because they're always accommodating. Second, in children. Remember, children have very powerful ciliary muscles. So every time you want to do this refraction for children, you have to use cycloplegic refraction, otherwise you'll get fooled. Okay. So what drug will you use? Remember, the drug depends upon the age of the patient. More young the patient, more powerful the drug, because the younger the patient, more the ciliary powerful muscle is powerful. So for the youngest children, up till 7 years of age, or say a rule of thumb is about 5 years of age, we use atropine. From 5 to 10 years of age, the older kids now, okay, so we can use hometropine. 5 is just rule of thumb. And then from 10 to 15, we use around cyclopentadate. So older the kid, the less the power of the ciliary muscle, so we use weaker cycloplegics also. Okay. And hypermetropes, remember, they wear convex lenses, so they often wear the tip of the nose. Many of you have seen your parents, they don't wear the glasses close to the eyes. Again, this is a principle of lens effectivity, physics principle. It states that convex lenses are most effective when the lenses are worn away from the eyes on the tip of the nose. Remember, concave lens wearers like myopics wear it close to the eyes, convex wearers like hypermetropes wear it on the tip of the nose. Okay? So you can make them out just by the position, by looking at the position of the glasses. Okay? The hypermetropes wear it on the tip of the nose, and myopics wear it close to the eyes. That's what hypermetropia. And hypermetropes, remember, because they are always, so kindly remember a couple of things in hypermetropia. Hypermetropes are very commonly asked as questions because they're more complicated conditions. Hypermetropics will have headaches and eye aches. They will not have visual problem. They will end up with convergent squint. And hypermetropics also have more amblyopia. Okay, remember, amblyopia, when we talked yesterday, is children. I told you very clearly that uncorrected hypermetropic amblyopia. You see why? Why hypermetropics are more amblyopia? Because they can neither see near nor distance. Because of the rays of light are, by definition, they are focusing here for distance, and near is even further. So both near and distance the patient can't see in hypermetropia. So because he has less vision, so these are chances of becoming amblyopic as kids. So it is the uncorrected hypermetropic child who becomes a amblyopic. An uncorrected myopic child may not become amblyopic because at least he can see near objects. Hypermetropes can neither see near nor distance. This uncorrected hypermetropics develop more amblyopia. Also remember that because hypermetropes accommodate more, so they lose their accommodation earlier. So a normal will lose accommodation around 40 to 45, which is presbyopia. We'll discuss this soon. But uncorrected hypermetropes become earlier presbyops at 35, not at 40, but 35 or 37 or 38, because by excessive accommodation, they have used up their whole accommodation. So by 35, they have no more accommodation left and they can't read. So remember, presbyopia, we will discuss this when I come to that, comes at 40, but if you are not able to read the newspaper at 35, it means you are a hypermetrope. The hypermetropes have other associations also. Remember, So what are the two summarize hypermetropia? They can neither see near or distance, but they don't have visual complaints because they accommodate and see clearly. The most important symptom is asthenopia, headaches, nights. Second, they develop convergent squint if they don't wear glasses. Third, they cause amblyopia as children if they don't wear glasses. Uncorrected hypermetropes cause amblyopia. Fourth, hypermetropic if they don't wear glasses will have earlier presbyopia. So look at the multiple conditions hypermetropia has. You have convergent squint, you have amblyopia, you have presbyopia. So you have multiple things of uncorrected hypermetropes. So hypermetropes should wear glasses. Very well. Now we come to the third and the most difficult, which is called astigmatism. And look at the word astigma. Okay? The word stigma means a point and astigma means no single point. So remember, that's a very important definition. In this case, it is defined as a condition where there are two different foci. Okay? Remember, there are two different foci like this, not one. Unlike myopia, which is one focus, hypermetropia, which is two foci, this one has two different foci. But why? Myopes to have only one, happens only once. You see, the reason here is different. The myopia hypermetropia, I told you the basic reason. Hypermetropia have a smaller eyeball. Myopics have a larger axis length. Okay? But this has got nothing to do with axis length. Here it's the corneal curvature. Remember, astigmatism is a problem not of the axis length, but of the corneal curvature. And what happens is that, you see, our corneas, human corneas, are not really perfectly uniformly curved. Okay? Human corneas, remember, are not perfectly curved. What we have corneas are called as prolate spheroid corneas. Okay? In human beings, we have prolate spheroid. If you want to know the actual correct term for the shape of the cornea is called a prolate spheroid. Okay, what is that? It means it is like a sphere. Spheroid means like a sphere, and it's more curved in the center. It's more curved in the center, called prolate spheroid. So if you look at the human cornea, most of us we have corneas like where it is more curved in the center. Okay, like this. So see what happens if you have a curved center, more in the curve in the center and not in the periphery. So some of the rays which are coming from the center like this, it passes through the curved cornea, so it bends more. It focuses in front of retina like that. But why? Because it's bending more. Why is it bending more? Because passing through a curved cornea, more curved. But some other rays, they will pass through the flatter periphery. No? Periphery is flat. Because flat, so it will not bend well. Flatter surfaces don't bend light very much. And because it doesn't bend well, so it will focus behind the retina like this, because it does not bend enough. So you see what happens? Some rays are focusing in front, some rays are focusing behind. Okay, there is no single point. The rays focus in an area. Look at that. If you take this area, and this area, see all the rays focus in this particular area. Remember, it's an area, a surface diffuse area. It's not a point. That's called astigma. And this area, if you look at the shape of this area, look at that. This area is the shape of a cone, no? And that is why this is a new MCQ which you should know. It's called a conoid of Sturm. Sturm's conoid or conoid of Sturm, it's called, is like a cone, no? Like an ice cream cone. You can see this shape, the ice cream cone. So the rays of light focus in this particular area between the two principal meridians, the principal two meridians, and this space is called the conoid of Sturm. So you see some of the rays, they will focus here like this, the rays will focus like this, some will focus like this, some will focus like this. So all the rays will occupy this particular cone, which is called conoid of Sturm, which is a new question. Remember, they often ask you this: where do you find the conoid of Sturm? Remember, you find astigmatism, which is the name conoid of Sturm given to the area between the two meridians where all the rays focus. They can focus anywhere between this. Okay, and there's another one, the circle of least confusion. Look at that. The circle of least confusion often asked in PG MCQs, but I'm telling you because you never know what they can ask now. And this often, it is a circle of least confusion, but is a concept of most confusion also for students. Okay, so I want you to listen to me carefully. Now see, what is this least circle of least confusion? Remember, it is a particular circle. You see, I've drawn the circles here in the conoid of Sturm, and this is the smallest blur circle. This is the circle, the smallest circle where the rays of light focus, and this gives the clearest vision. Okay, so remember that circle of least confusion. Remember, we do not say circle of maximum clarity. Okay, we don't say that because these are circles, because they are not single points. In astigmatism, rays never focus on a single point like that, which will give us maximum clarity. They always focus on circles, and the smaller the blur circle, we call them the blur circle. The smaller the blur circle, the greater the clarity. So a blur circle like this will have, because all the rays of light will be focusing like in the circle, it is not very clear. But it's a small blur circle like this. So this approximates to a point, and this gives the clearest vision. So remember, the circle of least confusion is a circle of the least diameter, which is on the right on the retina, and we have to place glasses so that the circle of least confusion forms on the retina. Remember, circle of least confusion is the smallest, 2 points to remember. It is the vision at a point where the vision is the clearest, because it is the circle of least confusion and the smallest diameter, and it's the smallest diameter circle, and it approximates to a point. Okay? So that is enough for you. Two important new concepts: the conoid of Sturm, which is this area, and the circle of least confusion, CLC, is the smallest area here with the smallest diameter, which provides the best clarity vision in astigmatism. Okay? And these people have the highest astigmatism. Remember, astigmats, because they have two different foci, none of them which are on the retina. Remember, they have the highest asthenopia, much more than compared to hypermetropia. Okay? Remember, these are very unhappy patients because they can not see very clearly, and I mean they do see clearly with a lot of effort because of accommodation, but in the effort of accommodation they get a lot of headaches and eye aches. So remember, these are the most unhappy patients in the ophthalmic OPD. Okay? They are often the most unhappy patients in the ophthalmic OPD, and they suffer from maximum asthenopia. Remember, of the three conditions, myopia is the one with loss of vision. Hypermetropia, astigmatism, both of them do not have problems of vision. They have asthenopia or headaches and eye aches, eye strain. But the maximum is suffered by the astigmat. Okay? I hope this is clear. And because there are two different foci, so remember, we have to correct them not with convex lenses, but with cylindrical lenses. Okay? So these are glasses which look like a cylinder here. Okay? Look at that. This is like a cylinder. Okay? This is the cylinder, and this is the also called a toric lens. We call it a toric or cylindrical lens. You see, in myopia hypermetropia, we use spherical lens. We call them spherical lens. Why? Because they are manufactured from a glass sphere. Okay, so if you look at the sphere here, you make cut a sphere like this, and you cut a sphere like this. See what has happened? You got one convex lens, you got a second convex lens, you get a third concave lens. So myopia hypermetropia are called spherical errors of refraction. Spherical errors of refraction because the lenses are manufactured from a glass sphere. But these are lenses from a cylinder or a toric lens. Okay, and this is that these are called cylindrical errors. So astigmats are not spherical errors. Astigmats are cylindrical errors, or they are corrected only by cylinders. And how will you know them? Well, because in myopia you will write the prescription -2 diopter S. Okay, minus is for concave, 2 is the power, D is the diopter, S for sphere. Okay, because these are spherical errors. Similarly, hypermetropes you will write +2 diopter S. Plus is for the convex lens, 2 is the power of magnitude, D is the unit, and S for sphere. But in astigmatism, there is no sphere because it's not a spherical. We write the word C. So you will find there's a 3 numbers in astigmatism. Often you have 2 or 3, 1 for the sphere, 1 for the cylinder, and 1 for the axis. Okay, so 1 part of sphere, 1 for cylinder, and 1 for the axis. Okay, what is the axis? Axis, remember, is this angle between the two cylinder axis. Look at that. This is one axis of cylinder. You can see this is cylinder. So this angle has to mention, but this angle can be anything from 1 to 180 degree. Okay, remember, you can have, this is also cylinder, but this is also cylinder, is not. See, this is not 90, this is about 120, and this is also cylinder, and this is about 170, is not. Therefore, the cylinders you can vary right from 1 to 10 to 20 to 30 to 90, 95, 100, 110 to 180. So the angles can vary anything 1 to 180 degree between the two axes. So when we write an astigmatic prescription, remember, we have to write the power of sphere, which is written first, then the cylinder, which is written second, and third is the axis. Okay? You have to mention the axis because the power depends on the axis. Remember, spheres, the power is the same in all the axes. Okay? So in myopia hypermetropia, because the spherical lens, the power is the same in all axes. But astigmats, the power depends on the axis. Okay? So if you place a -2 at 20 degree, the effect is different if you place it on 30 degree or 40 degree or 50 degree. The power depends on the axis. Okay? This is what is for you. It might sound a little complicated, but it's not really. And if you are finding it difficult, you have to go through my ophthalmology lectures in full and not just the revision. So now let's look at them. Before we come to this, we'll just go back one last look at that. What we define is regular and irregular. Astigmatism can divide regular and irregular. Regular is much more common. About 85% of astigmatism is regular, and irregular is less common. About 15% are irregular astigmats. Let me talk. The irregular are more commonly MCQ. So irregular surface, so irregular occurs in a corneal surface which is not regular. Okay, so suppose you have a cornea which has a corneal scar or a corneal opacity, or some irregular surface. It has got some irregular. It is not a smooth cornea. So because it is not a smooth cornea, so rays of light will focus here and there, anywhere, then focus without obeying any laws. So these are irregular surface corneas, like what? Like keratoconus, like pterygiums, like Salzmann degeneration, like post-traumatic scarring. Okay, so these are many conditions. Regular is not irregular. So remember, we can only correct them with contact lens. That is the MCQ. Why? Because you see, if you place a contact lens like this contact lens substitutes the irregular surface of the cornea by its own smooth surface. By placing the contact lens close to the cornea, you are replacing the irregular surface by a smooth surface of the contact lenses, and this smooth surface of the contact lenses will cause the rays to behave properly and obey laws of refraction. If you give glasses, remember glasses are worn too far in front. Glasses are worn simply too far in front, about 17 millimeters away in front, and the rays will enter the glasses, will enter the cornea, again get refracted here and there. So that is why glasses cannot correct irregular astigmatism. Remember, only corrected by contact lenses. So if we get MCQ like that, patient has 6/18 vision, which is not improving with glasses, but it is improving with contact lenses. What is the diagnosis? You will say it is irregular astigmatism. Okay, because irregular astigmats do not improve unless you put a contact lens. Okay. So that's about irregular astigmatism. Remember, it occurs in irregular surfaces, particularly post-traumatic corneal scarring, keratoconus, Salzmann degeneration, and keratoconus. Okay, pterygiums also. This is irregular. And irregular astigmatism is corrected with glasses. It is corrected with glasses, and there are 5 different types of. We have 5 different types of regular astigmatism, which I'll just talk about. And this is the 5 types. Let's look at that. What is this 5 types? The first one is a condition which looks like this. Look at this condition. See, I'm drawing this how? So this is emetropia, and supposing a condition, this is one condition like that. Now look, now there are 2 different foci. So by definition, this is astigmatism. By definition, astigmatism, but one is myopic, one is on the retina. So we call this as simple myopic astigmatism. Why? Because myopic also is astigmatic also. And an example would be -2 diopter cylinder at 90. Okay, why is that? Why -2? Because myopic. Why cylinder? Because astigmatic. Why 90? Because you have to have some axis. You can write anything between 1 to 180 degrees. No? So many of you are wearing prescription like this. You have one cylinder, any cylinder placed at 90 or any axis. This is an example of simple myopic astigmatism. Okay? But supposing, now let's go to the next type. What happens supposing the rays of light, now they are like this. Okay? Now see what has happened. One on the retina, one behind the retina. This is hypermetropia. This is 2 different foci astigmatism. So this is called as simple hypermetropic astigmatism. No? Because the hypermetropia also and astigmatism also. And the example given is +3 diopter cylinder. This is an example of simple hypermetropia. Why +3? Because there is hypermetropia, so it has to be plus. Why cylinder? Because there is astigmatism. Why 180? You can take any axis, as I said, between 1 to 180. So if you have a plus sign, cylinder sign at 180 degree or any degree, it is an example of simple hypermetropia. Now things start getting more complicated. Look at that. What happens if you have a condition like this? What happens if you have a condition like this? Some rays are focusing here, some rays are focusing here. Okay, now see, by definition, they are astigmatic because they are 2 different foci. And they are both myopic, as you can see there. But you see, they are not simple myopic. Why? Simple means that one of the rays should be focused on the retina. Here, none of them are focusing on the retina, so they are not simple. It's called compound myopic astigmatism. Compound. Whenever both the rays are not focused on the retina, we call it compound, and this is an example of compound myopic astigmatism. Example, -2 diopter sphere with a -3 cylinder 24. Now see, this is more complicated to understand because there are 2 myopics here, so I need 2 concave lenses. You know, there are 2 myopics, one this one that one. So, but remember that we cannot combine 2 spheres. You know, spheres 2 spheres cannot be combined in a single glasses. Neither can combine 2 cylinders like this. So we can combine 1 sphere and 1 cylinder. One of them will correct this focus, and the other will correct that focus. Remember, we always have a common, we call them sphere or cylinders. Always a common sphere and cylinder. That's the only one that can correct them. And by sign convention, we always write the sphere first and cylinder later. Okay? Sign convention states sphere should be written first, cylinder later. So look at that. This is minus 2 diopter sphere with a minus 3 cylinder at 25. You can take any action. So the first sphere corrects this one, the second minus corrects this one, and there's an axis has to be built. Okay? But by sign convention, always write the sphere first and the cylinder later. Both have to be minus because they're compound myopic. Then what happens, supposing the condition becomes like this. Now you have a condition where the rays of light are both behind the retina. Look, they are both behind the retina. So if they are both behind the retina, so what, these are both hypermetropics, remember, they're both hypermetropics. And again, it's compound because there is not single on the retina, none on the retina, both behind. This is called compound hypermetropic astigmatism. Okay, and because there are two convex, because remember both of them are, we need 2 plus powers. And again, because we need 2 plus powers, one has to be sphere and one cylinder. Okay, and by sign convention, write the sphere first. So I write plus 3 diopter sphere plus 2 diopter cylinder at 170. So there are 2 plus signs, and we will correct one for this, one for that. Sphere written first, cylinder later, and axis, whatever axis you write, between 1 to 180. So this is an example of compound hypermetropic. And the one that I was telling you, last one, which I was telling you most commonly we did examples of that, is if you have a condition where the rays of light focus one in front and one behind. Okay? Now this is myopia, this is hypermetropia. This is called as mixed astigmatism because it's all mixed up. It's called mixed astigmatism. One needs to be corrected, minus lens will require to be corrected for the myopia, a plus lens required to be corrected for the hypermetropia. Okay? So in mixed you will find that they are of opposite sign. It will be, as you see, plus 4 diopter sphere with a minus 5 cylinder at 90 degrees. Okay? Remember, plus 4 with the minus, again the sphere is written first, cylinder is written later. Okay? So remember, it can be anything. It can be minus 5 here, it can be plus 4 here also, doesn't matter. But they should be opposite sides. Okay? But the sphere should always be written first. So can you remember the 5 different types of astigmatism that you see? This you will find out how examples will be given to you. If you have 1 minus sign, this is simple myopic. If you have 1 plus sign, it's simple hypermetropic. If you have 2 minus signs, it's compound myopic. 2 plus signs, compound hypermetropic. 1 plus, 1 minus, mixed astigmatism. Okay? These are the examples of mixed astigmatism that you see here. And here, at this picture you see, I have shown you of the conoid of sternum. This is the conoid of sternum. So this is the conical area where the 2 rays focus here, conoid of sternum. And here, as you can see, the circle of least confusion, but for students it comes on, becomes circle of maximum confusion also, concept of maximum confusion also, but I hope it become better now. Okay? This is, you can see the smallest possible diameter, which gives the clearest possible vision, but it's not a point. It's just a circle with a very small diameter. So it approximates to clear vision, but it's not perfectly clear. So we've done astigmatism, 5 different types, irregular astigmatism. We've done this. Then another type of astigmatism is which you talk, these are 2 types of regular astigmatism. So regular, remember, these are 5 types. Okay, so if we have the 5 types, we've done what? We've done simple myopic, compound myopic, simple hypermetropic, compound hypermetropic, and mixed astigmatism. And you know how to recognize them by the number of signs. Now, of this regular astigmats, we have another classification. We divide into with the rule and against the rule. Look at that. With the rule, we call this WTR and ATR. Now, this is more a question for NEET PG, but as I said, it is impossible to distinguish between now NEET PG and the FMGE MCQs, so we are almost doing the same stuff. So look at that. With the rule is a condition, what is happening is a condition where the cornea vertical curvature is more than horizontal. You see, if you look at the curved surface, you have curved surface like this, you have a vertical curvature like this, and you have a horizontal curvature like this. Okay? Now, they have to be different, and if the vertical is more than the horizontal is flatter and the vertical is more, we call the with the rule. Okay? But against the rule is the horizontal curvature is more and the vertical is flatter. Okay? So you see with the rule, vertical axis steeper is more curved than horizontal, we call it with the rule. And this is in a younger people, and it's also called with the rule because it is more common. It's more common. So it's called with the rule, and it's in younger people up till 50 years of age. So all of you and me also, we are all suffering from with the rule, mostly because the vertical curvature is more curved than the horizontal, like this. Okay, it looks like this. Okay, look at this. It looks like this American football here with the rule where the vertical meridian is more steep or more curved than horizontal. As you can see, the horizontal is flatter, vertical is more curved. And against the rule, as I told you, the horizontal curvature is more compared to the vertical curvature, which is flatter. This is more shaped like an egg. Look at that. Here, the horizontal curve is more and the vertical is flatter. Okay, so I mentioned vertical is flatter, but the horizontal curvature is more, which looks more like an egg-shaped figure. Okay, so you have these two types. You can either have with the rule, against the rule. So against the rule is usually less common, which is why it's called against. It's seen in more older people, which is about 50. Okay, so with the rule is more common in young people. Against the rule is more common in older people. Now, how to recognize the prescription? Remember, and that is, you have to remember this, and we have to remember this because I can't go into the concept right now, because remember, this is it's a rapid revision. It's rapid. So remember, anytime you have a plus cylinder at 90 degree, or reverse this, minus at 180 degree, this is how a prescription for with the rule astigmatism looks like. With the rule, because the horizontal is more curved, the bigger part, the vertical is more curved than the horizontal, so we have to place either a plus cylinder at 90 or a minus at 180. You just reverse this. So with the rule, as you can see, look at that. So what does it mean? Plus at 90 means, look at that. Suppose this is an example, plus 3 diopter sphere with a plus 2 at 90. Look at that. The cylinder is 90. It's a plus cylinder at 90. Is it not? Which I said plus at 90. So this is an example of with the rule astigmatism. Or it can be minus at 180 degree. Similarly, against the rule is exactly the opposite. So if you place a minus at 90, because the horizontal is more curved in against, if you place a minus at 90 or reverse this plus at 180, then this is how we correct a against the rule astigmatism. So please remember that. This is all I would remember it. If a question comes like this, which I doubt, but if it does, you have to remember cylinders placed plus at 90 or minus at 180 are examples of with the rule. And if you reverse that, minus at 90 or plus at 180 is against the rule. Okay. So now if you look at this question, let me give an example here. For instance, look at this one. This is a mixed. See, this is written plus 4 with a minus 5 at 90. Now look at this. This is a minus 5 at 90. Minus at 90. This is an example of against the rule astigmatism. Because I said minus at 90 is against the rule. Look at that. This is minus at 90, is it not? Or if you look at the other one, example, compound hypertrophy, this is example of plus 3 with a plus 2 at 170. Okay, so 170 means close to 180, so we'll take 180. So it is a what? It's a plus at 180. Plus at 180 again, remember, means it is an example of against the rule. See, plus at 180 is against the rule. Okay, so please remember, with the rule can be either plus at 90 or minus at 180, like this, as I said, and against the rule it will be exactly opposite, minus 90 and plus 180. Okay. If you can remember this a little bit, this will be wonderful. So let me give one example for final, and let me make it absolutely clear to all of you. If not, please ask me, I'll explain later. Let's take an example of minus 2 diopter sphere with a minus 3 cylinder at 180. Now, see the entire description. We have two minus signs here. So this is a compound myopic astigmatism. Then look at the plus and minus sign. See, this is minus at 180, and what did I tell you? Plus at 90 or minus at 180 is with the rule. So look at the full definition, the full description of the astigmatism. It is a compound myopic with the rule astigmatism, because with the rule is corrected by either plus at 90 or minus at 180. See, plus at 90 minus 180. So the whole thing is compound myopic with the rule astigmatism. Okay, you have to start practicing a little bit if you want to get the questions right. It's a little complicated, but then somebody did ask me yesterday if we could do some numerical problems, and I'm doing that just now. So now we've got the three important refractive errors. We got the ametropia under our belt. It's time to talk about presbyopia. Let's talk about presbyopia. Presbyopia is what? Now it's not a refractive error. What is that? It is not a refractive error. It is a physiological change. All of us will become presbyopic. Remember, this is loss of accommodation with it. See, as you grow older, we lose accommodation, and it starts at around age 40. Please remember, at 40, we all become presbyopics. It starts around 40. Okay? The life starts at 40 according to Shah Rukh Khan, but so does presbyopia. Okay, and what is that? You see, we slowly lose accommodation at Age is slowly. Why do we look at with age? Because with age, the lens becomes harder and the capsule becomes more fibrous and the ciliary muscles become weaker. So the lens, which was originally, this was the original lens, which was 19 diopters. For a young patient, it can become almost spherical like that. This is accommodation. A young patient has almost 16 diopters accommodation. Okay? But as you grow older, because the lens becomes hard and the capsule becomes fibrous and the ciliary muscles become weaker, so after some time, the lens cannot become like this, it stays like that only. Okay? It cannot become like this. So the lens becomes more stiff, it cannot bend, it cannot increase its power, it loses accommodation. This starts around 40 years of age, approximately when the amplitude around 4 diopters. Remember, as a child of 2 or 3, we start with 16 diopters, but by the age of 40, we are left only with 4 diopters of accommodation. So this causes what problem? Because there is no accommodation now, so it causes blurring of vision at normal reading distance. So at normal, which is about 25 to 35 centimeters, you will find because of the divergence of the rays, there is not enough presbyopia, there is not enough accommodation, and we can't read like this. So presbyopics, they tend to read like this. They tend to hold the objects further away from the eyes like this, because the closer the object, more the divergence, more the accommodation required. We tend to move the object slightly further away in order to read. Yeah. So that is the problem. So obviously after 40, and it is progressive. So as we grow more and more older, 50, 60, 70, 80, we become almost impossible to read, write, stitch, sew, knit and cook. Okay, it becomes almost impossible to do that. And so we need to give glasses. And what kind of glasses? With convex lenses. Let me draw the diagram of presbyopia. Look at that. For distance rays of light are fine, they are focusing. So remember, presbyopes will have 6 by 6. But for near rays are divergent, correct? So I told you they become parallel later and they become focused later also. So initially what was happening, we were having accommodation, so we could accommodate the rays could come here. But now there's presbyopia, loss of accommodation. So the rays can't focus here, but we still need to read and write and stitch and sew. In fact, quite the opposite. As we grow older, we find our reading habits increase and we need to read to study more. So what happens is we need to give them glasses which will place the rays on the retina, which means place them forward in the retina. So what we do, again we have to give them convex lenses, just like hypermetropes, okay? Because that will focus the rays on the retina, because remember they are convergent lenses, they were focused earlier, okay? Remember, both hypermetropes and presbyopes, they have to wear convex lenses. Then how will I know the difference? First, of course, you look at the age. Remember, presbyopes are older people, 40 plus. Hypermetropes can be any age. The hypermetrope is not associated with any age. The younger people usually have hypermetropes. The kids are, I told you that, it's not. But age is not a very good idea because a lot of patients don't want to tell you the age. They will not tell you their age. Then you observe when are they wearing. Remember, in hypermetropia, the glasses are worn all the time. The convex lenses will be worn for near also, for distance also, because we tell them to wear it all the time to prevent accommodation for distance. Okay. For presbyopes, only problem is of near vision. No? Distance is fine. So presbyopes don't have a problem for distance vision. So normally they won't wear glasses, but when they're reading, immediately the glasses will come on. Okay. So kindly remember, presbyopes will only wear glasses for near vision because that is their problem. Hypermetropes are advised to wear it both for distance and for near. Okay, that is the way to find out, apart from the age, of course. And remember, presbyopia is a physiological phenomenon. We will all develop presbyopia. There's no way escape from this. No, you will all become presbyopic, and I, of course, myself have already become presbyopic. So, therefore, and a good idea is to have some idea of how much presbyopia is required correction. It starts around 40, we will give +1. At 45, we give 1.5, 50, we give 2, 55, 2.5. So, you see, every 5 years, around 0.5 diopter is increasing. You don't have to memorize this table, except they did ask once that 50 years of age, which you should remember, I think, because 50 is a landmark age, it's half a century. So approximately remember, we need close to +2 at 50. So it starts at 40 with +1. Okay, so every 5 years, approximately remember, it increased by 0.5. So this is presbyopia, and remember, it is always a physiological thing. All of us have to develop presbyopia. You cannot not have presbyopia. The only way to avoid presbyopia is stop aging, which cannot be done. So presbyopia, so we categorize as a convex lenses, but this is, remember, for people who are emetropic. What about people who are myopic, have metropics? Myopics are already wearing glasses for distance, So when they become presbyopic at 40, they have to wear vernier also. So then they have to wear bifocals like this. You can see the bifocal lens where the bottom segment is the convex lens for reading, because remember we read like this, and the distance segment, the top segment will look like this for distances. This is, if you are myopic, it will be minus. And if you are hypermetrop, it will become plus. Okay. Those who are wearing glasses, my friends, at 40-45 years of age, all of you will be saddled, burdened with this thick, ugly, fat bifocal lenses, okay, where the top segment is for distance, where the myopia, hypermetropia will be minus and plus, and the bottom segment is always plus for reading. But help is at hand, don't worry. Nowadays we have new lenses called progressive lenses, okay, they are most recent. And progressive lens is actually a trifocal. You know, what happens that? If this is a trifocal matlab, there is a 3 different zones here. There is a top zone, which is for distance while driving, let's say driving or watching TV. The middle zone is for intermediate vision, like laptops, like looking at GPS, window shopping, and the bottom segment is for near. So reading, writing, stitching, sewing, knitting, cooking, but there is no cut. Remember, in presbyopia, there are 3 zones, beg your pardon, in progressive, there are 3 zones, but there is not a single cut. The lens smoothly progresses from top to bottom, without any cut, unlike a bifocal, and you can see it here. See, the top distance, you can see the ocean and the skies, the intermediate is the boats, and the inferior half is for the reading. So this is a typical progressive, and this is the most recent advance, but really expensive. But nowadays, the latest advance is this particular drug which has just reached our shores. This is pilocarpine 0.125%. Not, sorry, 1.2, not 0.1. We have to remember the percentage. Pilocarpine, this is the old wine in new bottle. Remember pilocarpine discussed yesterday in glaucoma. In the last 2 years, pilocarpine introduced as a new drug for presbyopia also. Can you remember, it's a recent question. What is the latest drug for presbyopia? You will say pilocarpine. Remember the percentage, 1.25. Because glaucoma percentage is higher, that is 2%, 3%, 4%. These are 1.25%. It's a lower concentration pilocarpine, which causes pupillary constriction and it causes some ciliary muscle contraction. So it addresses 2 of the 3 things that you require accommodation. So accommodation, convergence, and constriction. Remember, so it causes a little bit of constriction and it causes a little bit of ciliary muscle contraction, leading to zonal relaxation and the lens becoming more convex. Okay, so this is the latest drug for presbyopia. Then we talk about DRP, darkroom procedures. Darkroom procedures, remember, are 4 procedures which we do in a dark room. Remember, ophthalmologists, we like dark rooms, not because of any other reason which might occur to you, not because of that, but because in the darkness the pupils dilate, right? So we get more details of the retina. We can see more details of the retina. And second, if there's less light, then there's less reflection from the cornea. So that is why you will find all ophthalmologists, we switch off the lights when we examine you. This is called DRPs, and there are 4 procedures here. One is a retinoscopy, distant direct ophthalmoscopy, direct ophthalmoscopy, and indirect ophthalmoscopy. So there are 4 techniques and 3 instruments. Remember, these 3 techniques are used with an instrument called direct ophthalmoscope, and this is with an indirect ophthalmoscope, okay, and this is with a retinoscope. So the retinoscope, we use retinoscopy, direct ophthalmoscopy, use distant direct and direct ophthalmoscopy, and indirect ophthalmoscopy we use for indirect ophthalmoscopy. So 3 instruments and 4 techniques, okay. Let's look at the DRPs. What is a retinoscopy? The first thing is retinoscopy. The first thing you have to remember is the word retinoscopy is a completely misnomer. Complete misnomer. It's got nothing to do with the retina. Don't get fooled by that. So retinoscopy, also called skioscopy, is a technique for measurement of the refractive error. Remember, I've talked about refractive error so much. Some of your myopes, hypermetropes, and astigmats. But how do we calculate that? Is it -1? Is it +1? Is it +5? Is it -5 cylinder? How do I calculate that? This is calculated by retinoscopy. Remember, retinoscopy calculates the refractive error. Okay? So the term retinoscopy is a little misleading. It's got nothing to do with the retina. Okay? So what you do, retinoscopy is performed first of all at 1 meter distance. So you take an instrument, retinoscope, it looks like this, and you stand at 1 meter away from the patient. And so what you do, first of all, remember, when we do retinoscopy, first of all, remember, when a patient comes to us, suppose the vision is 6/60, let's say, okay, called blurring of vision. So blurring of vision we divide into 2 types. Either it can be optical error, okay. Optical error means that it's a refractive error which can be carried with glasses like myopia, hypermetropia, and astigmatism, or it can be organic error. Organic error means that it is cataract or glaucoma or squint or anything, okay? So basically, loss of vision is divided into two major clauses of optical and organic. Optical requires glasses, organic does not require glasses. How do I know which is which? Remember, for this we require a very simple and elegant test called the pinhole test, which I mentioned today. Remember the half pinhole effect for myopics? So we have this pinhole, which is a plastic disc like this, completely opaque, with a central hole in the middle, the size of a pin. The size of a pin, that's why it's called a pinhole. Remember, the diameter of the pinhole is 1 millimeter. You have to memorize this diameter, it's 1 millimeter. And the diameter is 1. So we give this plastic disc completely opaque and ask the patient to see through that, okay? So he closes one eye, and through the eye, which is 660, I ask him to read the Snellen's chart again. Now there are three possibilities. It can either improve from 660, it can improve to 66, or generally improve to some vision, may generally improve, or it may remain 6 by 60. If it improves to 6 by 6 or improves anyhow, then it's an optical error. That means it is myopia, hypermetropia, or astigmatism, any of the three. Okay? All three improve with optical pinholes, remember. Okay? But if it does not improve, then it is cataract or glaucoma or detachment. So very simple. Ask the patient to wear a pinhole and read the chart again. If the vision improves, he has a refractive error, give him glasses. If it does not improve, there's no need to check for refractive error because he has cataract or glaucoma or detachment. Okay? This is a pinhole, and then remember, if he improves with pinhole, it just tells us this, that he has a refractive error. It doesn't tell us what refractive error it is, okay? It doesn't tell us that. It doesn't tell us myopia, hypermetropia, or astigmatism because all of them improve. So how to distinguish with this myopia, hypermetropia, astigmatism? Well, that is where retinoscopy comes in. So we take the retinoscope, and this is an instrument with a bulb here, so we stand 1 meter away from the patient. Remember, that's important, 1 meter away from the patient. And then we move the retinoscope from left to right like this, okay? Look at that. The retinoscope has a very powerful bulb here. And this bulb emits light, and the shape of the bulb is like a streak. So it emits a light, which is like a bar of light, and we stand 1 meter from the patient, and this light travels through the air into the patient's eye and gets reflected back from the retina, and this reflected area is visible to me through the retinoscope in the center of his pupil. It looks something like this. Look at that. Can you see this area? So this is the central pupil through which I can see the reflected light coming from his retina, and the top area and the bottom area is the light coming from my retinoscope. So see what happens. I move my retinoscope first to and fro like this, as I mentioned here. You move it side to side first and then up and down. So one side to side like this, one, and second up and down like this. When you move it side to side like this, see what happens. Remember, we are watching the reflected light from the patient's eye. So since you are moving the retinoscope and the light is coming from the retinoscope, the light that is coming from the eye, as this light moves, so the light from the reflect from the patient eye will also move, is it not? So what happens? Supposing I move my retinoscope like this, suppose the light moves in this direction, and I move it like this, it goes like this. Look what is happening. This is how the light moves. It is moving what? In the opposite direction, or in the against direction of my retinoscope. And so we remember this mnemonic called SPAM. Okay? SPAM refers to same plus against minus. A good mnemonic given by the American Academy. Same plus against minus. So remember what is moving? It's against moving like this. So this means it is minus. Look at that. You can see the movement in the against motion. See what's happening? I'm moving my retinoscope here, but the light is moving there, is it not? The reflected light from the pupil of the patient, which represents the light from the retina, okay? And so I move it here, you can see this movement going there, but that light is going. It's against movement, okay? So SPAM, against movement means AM, it means I need a minus lens. So from my box of lenses, and you draw the power cross, okay? I draw this power cross, okay? And you watch the light reflects in the pupil, which is with or against, okay? So as it was against, it places minus. You keep on placing minus in front of the patient's eye till it neutralizes. Neutralizes means it stops moving like that, okay? You say -1, -2, -3, and as you place -4, supposing it neutralizes. Yeah, how do you know it neutralizes? Because this light disappears and the entire pupil fills up with light. Normally the pupil is dark, okay, in retinoscopy. But when it neutralizes, it fills up with light. Look at this picture. So it means when I place -4, suppose when I place -4 like this, so what happens? It neutralizes. So neutralize means I have placed the correct power in the patient's eye. So I write -4. And then I do the second step, which is from move it up and down. Okay, so I was moving like this, then move it up and down. Again, I watch for the reflection, and suppose again it's going against like this. Okay, as I move it down, it goes up like this. Okay, against means remember spam. So again, I take a minus lens and I keep on doing this till I balance this power. Suppose this is also -4. Okay, so -1, -2, -3, it goes on, and -4, the dark pupil disappears and fills up with light. So this is -4 and -4. So this, remember, the same power in both the meridians. So this means it is -4 diopter sphere. This is the power of the patient. But remember, this is not the final power. Why? Because you are standing at 1 meter away from the patient. So this is the power at 1 meter. So this is not the correct power. Why? Because you introduced some extra power by standing at this 1 meter and causing him accommodation. We have introduced some extra power into his eye, which I must subtract. What is that extra power? That is due to this 1 meter. So how do I calculate the power? See, by this class 12 formula, power is 1 by focal length. Okay, so look at this. Very important. Power 1. What is the focal length? You are standing at 1 meter. So focal length is 1. 1 by 1 is 1 diopter. So this is the power we introduced into the patient's eye by standing at 1 meter. Patient's power is -4. So I have to subtract this -4 -1, and this is the final power, -5 diopter sphere. This is the final. You give this -5 to the patient, he says, wow, I can see everything very clearly. And this takes just 10 minutes. Okay, this is how retinoscope is performed. So kindly remember again. So just to do this again, see what happens. First of all, what you do, you have to draw a power cross. Okay, a cross, because it calculates the power like this, and then you start retinoscopy and watch it. Let's do this again for more practice. So again, see, I draw the power cross, and this time, supposing as I move retinoscope, look at this, it moves in the same direction. Remember, they are not all the same patients. So same direction. Now I move a retinoscope here, but I see the light reflected from the patient's pupil also moves similar. It moves like this. Okay, you can see this movement in this picture. This is called with movement because it's moving with my retinoscope. If I move it here, the reflection moves there. I move it here, it moves like this. So this is with movement, and with movement, remember, same is with, and spam says same plus. So same movement means he requires plus power. So from my box of lenses, I pick up +1, place it in his eye. Again suppose it's moving in. So it's not neutralizing. So +2, +3, +4, +5. We keep on doing it. Say +7. It neutralizes. How do I know neutralizes? Because this disappears, the dark pupil, and fills up with light. So I don't need it. So suppose it comes at +7, so I add +7. Okay, and then I do it again with the vertical movement like this, and I move it again. I see it's moving in the same direction. So +1, +2, +3. Supposing it comes at +7. Now again, +7, +7 is the same. It means it has to be a sphere because the sphere has the same power in all meridians. So +7, but remember it's at 1 meter. So again, you have to subtract the power due to 1 meter. Power is 1 by focal length. 1 by 1 is 1. So +7 -1 is +6 diopter sphere, and this is your final power. And this is your final power. So remember, the trick is in retinoscopy, first you have to stand 1 meter, and finally you have to subtract the 1 diopter from retinoscope. And if you use cyclopedia, supposing as I said for hypermetropes, you use atropine, homotropine, cyclopine, tropicamide. If you are using those drugs, you have to subtract according to the drugs also. Here you must know only the subtraction for atropine is 1. It is a powerful drug. If using atropine, you have to subtract 1. The rest we don't have to know because they don't ask you. So if you give the question, say +4 at 1 meter with atropine. So you'll get +4 -1 for the distance, -1 for atropine, you get +2. Okay. So if we use cyclopedia, then you have to add, if atropine, we subtract 1. But if there's no cyclopedia, don't subtract. You have to subtract for the distance, that is fine, because that's the distance. But every case you don't cyclopedia, so only when cyclopedia is used, then we have to subtract for that. That was our retinoscopy. So kindly remember, retinoscopy, important things to memorize is the same plus against minus, with against movement. Remember, at 1 meter, subtract 1 diopter, power is 1 by focal, and measure refractive error. So this is what the question about retinoscopy, this is how check it. Then what about distant direct ophthalmoscopy? And distant direct ophthalmoscopy, you see, you take an instrument, this is called the direct ophthalmoscope. Direct ophthalmoscopy, I told you, used for 2 different techniques. One is distant direct ophthalmoscopy, and one is direct ophthalmoscopy. You have to use this for two different investigations. In distant diet, you have to stand a certain distance away, as you can see in this picture. You stand a certain distance. So how much is the distance? Approximately 20 to 25 centimeters we have to use this system. And the quality of the image is real and inverted on the same size. Remember, real and inverted, that means the real image is inverted. Inverted means that you are seeing superior, inferior, inferior, superior, and nasal as temporal. But it's the same size, there is no magnification DDO. And you normally should see a red glow. This is an important sign. In all of you who have normal retinas, when I do a distant diet, I should get a red glow, which you see here. Okay? This eye. This means normal. But suppose you get look at this eye, you're getting a grayish glow on doing DDO. This is a sign of retinal detachment. Remember, this is a sign of retinal detachment. If you get a grayish glow, it means you've had retinal detachment. Okay? That's important. And if you have vitreous hemorrhage, there will be no glow. So remember, when you see, there will be no red glow, there will be no gray, there will be nothing. It will be just complete blackness, complete darkness. So no glow means retinal detachment, and grayish glow means, no glow means vitreous hemorrhage, I'm so sorry, and gray glow means retinal detachment, and red glow is normal. Okay? So this is the three interpretations. What else can you interpret in DDO? What you can interpret here is that if the lens dislocates, so remember, if the lens dislocates, you will be able to see a dark crescent like that. The dislocated lenses are often very difficult to diagnose, It's difficult to find also with slit lamp. So the ideal instrument for detection of a lens which is dislocated downwards, or a cataract which is dislocated downwards, is to see with a distant direct ophthalmoscope. When you do it like that, you'll see a darkish crescent like that. And you can see keratoconus, this famous Charlot's oil droplet. Look at that. This is the oil droplet sign. You stand a certain distance away, you will see the oil drop sign here. Okay? Please do not confuse this oil drop sign with the oil droplet cataract of galactosemia. That was different. Okay? Oil drop cataract is seen with a slit lamp, and it looks like a drop of oil. This looks like a drop of oil. Distant direct ophthalmoscopy done at 22 centimeters in keratoconus. Okay? And if the depth of the opacity is also estimated by the parallax displays, you see, you have three planes. You have the pupil, in front of is the cornea, and back is the retina. So if you look at that, so sometimes we see a black opacity like this, and we're not able to make out which it is. You ask the patient, look up and down. Okay, look up and down, and you look at it with DEO. Okay, if the moves in the same direction, as the patient looks up and down. Okay, he looks up and down. So watch the opacity, the black opacity. If the patient looks up and the black spot also moves up, it means it's cornea, because it's like this. But if look at the eyeball rotate like this. Suppose this is my cornea, this is my eye. When I look down, the cornea goes down, but the posterior segment is going up. It's opposite back. Similarly, if I look up like this, if I look up, the cornea goes up, but the lens goes down. So that is what we do. We look at the black shadow, and we ask them to look up and down. If the shadow moves in the same direction, it means it's a corneal opacity. Okay? If it's the opacity in front of it's in the same direction, which is in front of the pupil, which is cornea. But if it goes in the opposite, when a patient looks up, the black spot goes down. Patient looks down, black spot moves up. It means it's in the posterior segment behind the pupil, which could be a cataract most. Okay, so this we don't have to do so much. We don't have to worry about it. But what I want to know for DDO is the distance. You should know the normal red glow, and you should know the yellow glows for retinal detachment. Okay, and then the same instrument, direct ophthalmoscope, is used now, but now it comes closer. We call it distant direct ophthalmoscopy. It comes closer, and so this from distant direct, it now moves to direct ophthalmoscopy, because now we are close to the eye. Okay, so it's very close to the eye. You can see here, and what happens here? Now this is very close to face. Our nose almost touching each other, and its image, you have to remember, quality is VEM, virtual, erect, and magnified. Sometimes we like to ask this, particularly NEET PG. It's a virtual, erect, and magnified. And remember, the most important, how much is the magnification? Is 15 times. It's 15 times. So it's a very magnified image. That's why we see direct ophthalmoscope is used for visualizing the structure of the central retina, disc, fovea, and macula. Okay, so we see the disc, the fovea, and the macula. So this is the structure that you see, which is very close to the eye like this, and the field of view is very small, about 5 to 10 degrees. You don't have to memorize this, because you can see only the disc, fovea, and macula. Because the magnification is so high, the area is restricted very 5 to 10 degrees only. But remember, the most important question in direct ophthalmoscopy is the quality of the image, VEM, and the magnification, which is 15 times. And then the last of the investigations is the indirect ophthalmoscopy. Okay? Here the patient needs to lie down, because you can see the lying down patient, and you wear a headband like this. Can you see the indirect ophthalmoscope here? You're wearing this headband, and this indirect ophthalmoscope head mounted, and you have a lens. We are holding in my hand, you can see that with mirrors, and this is called the condensing lens. So the patient lies down, and the light comes from the head, from this bulb, powerful bulb here, and you focus on the lens here, and it goes into the eye. And what do I see? You see an image which is RIM, real inverted magnified. Remember, unlike the direct ophthalmoscope, it's totally opposite. That was virtually erected magnified. This is real inverted magnified, and you have to remember the magnification is not very high, it's only 3 to 5 times. But the range is very high because it can give you up to ora serrata. See, right from the center, which is the fovea, to the ora serrata, you can see this entire thing. You can see right from the fovea to the ora serrata. So remember, indirect ophthalmoscopy, it gives us a very bird's eye. It feels like you're standing on top of a mountain and looking down, and what you see, the entire village spread out at the bottom of the mountain. That gives a very bird's eye kind of view. So you can see all the structures from fovea, but the magnification is not very good, because that is obvious. You have a trade-off. You can't have magnification and a wide range. So you didn't have a wide range in direct ophthalmoscope, but you have it here indirect, but you have less magnification. So kindly remember, if you want to see the central retina, use a direct ophthalmoscope. If you want to see the entire retina, peripheral as well as the center, you indirect ophthalmoscopy. Okay? And if you want to check your power, then we do retinoscopy. Check your power, we do retinoscopy. And distant direct ophthalmoscopy is just a screening test, just to look at whether your retina is normal or not. There's a screening test for that, and you can pick up the oil droplet sign of Carlos and keratoconus, and this is DDO. So this is the summary of the 4. So I'll just summarize one thing. Refraction nowadays there are a lot of questions are being asked to refraction, because as I told you, you have the same amount of questions as in. Remember, retinoscopy what we've talked about, most important is that you have to subtract for the distance. Distance hota hai 1 meter normally, but supposing they want to fool you, they can change the distance to say half a meter. Kai baar, to make things more difficult, suppose the refraction is say, so what I was saying is, supposing aapko sum hai is -3 retinoscopy at 50 centimeters diya jaye, right? Sometimes you'll have to confuse it. So you have to subtract the distance not to 1 meter, but at 50 centimeters. So koi baat nahi, no problem. So first you convert centimeters into meters. Remember, same maths or physics, you have to convert into one single unit. 50 centimeters means half a meter, is not. So we have to now subtract, the power is 1 by focal length. So 1 by half it becomes. So 1 by half becomes 2 by 1, which is 2. So you will subtract 2, not 1 but 2. So at 50 centimeters, you'll have to subtract 2. So if you have -3 and you have -2, this is -5. This is your final power. Okay? So इस तरह से आपको पूछा जा सकता है, and you must not get fooled. What you have to remember is we have to subtract according to whatever the distance we have to subtract. Was 50 or 25 or 1 meter, whatever it is. And remember the formula, convert the units into same SI system and 1 by focal length, right? So now one more question. We talked about this in retinoscopy. This is an important one. I said that if it is myopia, spam, no? So same plus against minus. So agar minus power hai, so it will be opposite, myopia, and plus same. So if it is hypermetropia, it will be same sided. So myopia, remember, will be moving opposite, and hypermetropia moving same side. But tell me something. What if I am the patient, I am emmetropic, or many of you emmetropic? In emmetropia, when the power is 0, where will the reflection move? Same or against? Okay? Will it move in the same side, like I showed you, or will it be against? Okay, so, or will it not move at all? The third option, which is the best one, is that whenever you, an emmetropic patient, as soon as you switch on the retinoscope, you will get a direct neutralization. कौन सा आएगा तीनों में से? Against, same, or direct neutralization, that the people will fill up with light, there will be no dark area at all. Most of you, if I ask this question, would answer this one. Okay? It will directly fill up because emmetropic hai, so there is no, already neutralized, there is no power, so it neutralizes at 0 only. You'll be quite wrong. You'll be quite wrong. it will move in the same direction. In emetropia, remember, but why? Q. Because you see, let me tell you why. Suppose I'm emetro, retinoscope me, you will get in the same direction, okay? This one, you will get this movement with move. Remember, same means plus. You will pick up the lowest possible plus power, okay? Plus 1. You put plus 1 and then start retinoscoping. And the minute you start retinoscoping plus 1, I will utilize. I will utilize plus 1, so you will get this thing. So you will get plus 1 for my retinoscopy. But remember, you have doing at 1 meter, so I have to subtract 1 meter, and this is how I get 0. So emetropia, remember, this question last year पूछा गया था, and you have to remember emetropia, the movement of the retinoscopic is same-sided. It's same-sided, okay? Not against and not definitely not at 0. So this is how we try to fool you. To be careful, retinoscopy बहुत से questions आते हैं. Okay? So now we've done this thing, optics and refraction. Remember, once you've done optics and refraction, you've become half an ophthalmologist. More than half, actually. Refraction, if you know about glasses and lenses, then you know half an ophthalmologist. So you all become half ophthalmologist. But we need to make you full ophthalmologist. So we'll go to the next topic, which is retina vitreous. Retina vitreous. Retina vitreous is an important topic, lamba topic, bada topic. Let's look at that. The first thing on the retina you have to remember is that it's composed of 10 layers. 10 layers. But the good news is you don't have to memorize all 10 layers. Life is too short for that. So we divide these layers into 9 layers, which is called neurosensory, NSL, and 10th is called RP, retinal pigment epithelium. Okay, so in the cross section, it will look like this. If this is the lens, this is the retina, okay, then this would be the choroid, and the next would be sclera, okay, like this. You know the basic, this thing is, we call it the RCS complex, and retina, choroid and sclera, they're all together. And in front, there's the vitreous hair. The vitreous humor is here like this. So, ये है topographic arrangement of the entire eye. So, RCS is a complex. Now, this retina is composed, we divide to 10 layers. Of this 10 layers, remember, the first 9 layers, that is, first means close to the vitreous. The first 9 layers are called neurosensory layers, NSI. And the 10th layer, which is closer to the choroid, that's called the retinal pigment epithelial RP. That is all we need to know. We don't have to memorize all 10 layers. Okay? We don't have to memorize all 10 layers. NSL plus 1/10 layer. The next important anatomical question of the retina is that it has a dual blood supply. इसमें दो blood supply होते हैं. And dual blood supply. The inner 2/3 of the retina is supplied by the central retinal artery. This is the more important one. Inner मतलब from the vitreous onwards. And outer 1/3 is supplied by the posterior ciliary artery, which also supplies the choroid. Okay, so look at that. What does it mean? It means that inner 2/3 means from the vitreous side. So vitreous की तरफ से, if you see, from the inner 2/3 would be something like this. Okay, like this. The inner 2/3. This is supplied by the central retinal artery, and outer 1/3 by the posterior ciliary artery, बाहर वाला position. And this also, choroid is also supplied a little by the posterior ciliary artery. So this is the distribution, remember, because retina is so important. If one artery is destroyed, the other artery will keep it up. So this is a very important part of evolution, that any structure which is critical for survival has got a dual blood supply. So one is lagging behind, the other will compensate for the lack of nutrition with the other blood vessel. Okay? So dual blood supply of the retina. And also remember, one layer after many of the 10 layers, we have 10 layers, I just told you, one layer is important, we call the watershed layer. You have to remember this by the OPL, outer plexiform layer, OPL. Why? Outer watershed layer is the layer which divides the layer, this 2/3, 1/3, I told you, 2/3 by central artery, 1/3 by this. So what it states is, what is that boundary between the 2/3 and 1/3? So this boundary is called the outer plexiform layer. So inner to this is supplied by the central retinal artery, and outer to this is supplied by the posterior ciliary artery. Okay, so this is called watershed. That means a border or a boundary. So the question states, when they ask watershed layer, which of the 10 layers forms as the separating or the dividing boundary between the zones of the retina supplied by the central retinal artery and the zones of the retina supplied by the posterior ciliary artery. So it is the OPL, not the IPL, OPL, outer plexiform layer. Very good. These are some basic anatomical questions. And remember, all retinal conditions are painless. Retina को दर्द नहीं होता है. The retinal conditions are always painless. Okay. And so let's talk about retinal detachment, which we call as RD. Retinal detachment means separation of the two retinas between neurosensory and RP. And remember, it has to be all 9 layers from the 10th layer. If you have first layer separating from the second or second from the third, this is not detachment. You have to have all 9 layers from the 10th layer. This is called detachment. If there is separation of the first layer from the second, or the second from the third, or third from the fourth, that's a different diagnosis. It's called retinoschisis. What are the symptoms of retinal detachment? The first are the floaters. Okay? You get these black dots floating in front of the eye, which you know are basically means that these floaters are non-specific signs of vitreoretinal disorders. Many of you have black dots also. आपको कुछ इनको floaters बोलते हैं. Many of you have these black spots in front of retina, which you can see when you look at the sun or you look at the whitewashed wall. ये normal होता है, and कुछ cases में it's a sign of vitreal disorder. Second are flashes. Flashes is very typical, and you're looking straight ahead. From the corner of the eye, you'll see a bright bluish white spark like that, like a spark of lightning. This is very obvious, and immediately you have to watch out because it means that you may be developing damage. Floaters can be neglected. Flashes, no. You must check the retina. And third is a ominous curtain-like sensation. Typically, patient complains that, look, doctor, like a parda gir gaya, aankh ke samne bilkul parda gir gaya hai, like a curtain falling in front of the eye with total loss of vision. Remember, floaters, flashes, and curtains, retinal detachment, confirm. Diagnosis, you will see a grayish glow. Remember, I told you that normally you say red glow. All of you should normally, on doing ophthalmoscopy, I should be able to see a red glow like this. It's not this red glow, but you can see there's a grayish glow here. Remember, this grayish glow is a typical sign of retinal detachment. So we diagnose retinal detachment immediately. We get a grayish glow. That's your retinal detachment diagnosis. Now, we classify them into three types. Rhegmatogenous, which is the most important. Almost 60% detachments are because of this is what we pay attention maximum. Second is tractional, which is not very common. And third and the least common is exudative. Okay? So regma, look at the word rhegmatogenous. The word regma, not rajma, regma means a break in the retina. Anytime the retina displays some break or cracks or defects, this is called a regma, and this leads to detachment called rhegmatogenous. This is the single most common. And remember, the retinal detachment, the most common causes rhegmatogenous. And you can see the grayish glow. You can see the grayish glow here. All the retina is detached. It's a total retinal detachment. And causes of retinal rhegmatogenous, first and foremost, is myopia. Many of you are myopics. Why are you myopics? Remember, why myopic? Why should myopic? Remember, because myopia may, you have, what's the main cause? The eyeball is longer. When the eyeball is longer, the retina is getting stretched, no? Retina is a thin curtain at the back of the eye. So, the retina is getting stretched like this. So, what will happen? As the retina gets stretched, it gets thinner and thinner and thinner. So, all myopics have thin retinas because the retina expands to cover up the stretching of the eyeball, and myopics have thin retina that can crack anytime. You know? That is why all myopics are at risk, and those of you who are more than -6 diopters, we call them high myopia, and these are at very high risk of retinal detachment. Okay? So, आप लोगों के पास जो -6, -7, -8, -10, and the higher the myopia, the thinner the retina, remember you are at very great risk. So, myopics are at risk because they have thin retinas, and typically what are the breaks in the retina? These are called as holes. One of the common breaks are called small holes in the retina. So, through this hole, the vitreous goes in and separates the two layers. Another very important thing and more dangerous than holes are lattices. Look at that, you can see the lattices here. The word lattice means lines, or these thin lines. These are because of the thinning of the retina, develops cracks in the retina. Again, the vitreous can go in between and separate the two layers. Okay? So, lattices are more dangerous, they cause more detachments. And the third are the most dangerous, called the horseshoe tears. Horseshoe tears are tears shaped like a horseshoe. You know, horses wear shoes like that. So, the horseshoe tear is the most dreadful. सबसे खतरनाक ये है because it means the horseshoe tears can lead to detachments in 48 hours also. Okay? So, the three lesions are holes, lattices, horseshoe tears, and some other tears also, but horseshoes are the most dangerous. Okay? So, these once, if myopes you have this, then you are in big trouble. What will have? You have sudden painless loss of vision, apart from the floaters, flashes, and curves, you have sudden loss of vision. Remember, the most common site of retinal detachment, any retinal detachment, MCQ mark kariye, supratemporal quadrant. That means superior and temporal. Okay? This is superior, this is nasal, supratemporal. So, this has the highest amount of detachment. 40% detachments takes place here. MCQ mark kariye. This is highest detachment takes in supratemporal quadrant, 40%. And then another possible sign is a powerful Schaeffer's sign. Schaeffer's sign क्या होता है? You see it in the vitreous. Okay, on the vitreous, can you see? Look at this picture. Can you see this black dots? These are black dots. They are floating about in the vitreous, and we call them tobacco dusting. They look like dusts of tobacco. Okay? Those of you smoke, you know, tobacco dusts होते हैं. and these black dots will be floating about in the vitreous cavity, and this is a sign that you have developed detachments. So Schaeffer's sign is a very powerful sign of retinal detachment. Okay, so please remember myopia being the number one cause. What about the other cause? Why cataract surgery? Why does cataract cause surgery cause detachment? Well, not all cataract surgery, but remember, if after cataract surgery, if you leave the patient aphakic, remember aphakia means absence of the lens. So supposing you have done the cataract surgery, but you have not put an intraocular lens, okay? Then it creates aphakia, no? Then it creates aphakia. So look at that. So supposing we have aphakia, you have not placed a lens. This pen is not behaving very well, but it is here. Look at that. So why does this create it? See, the vitreous is here. Okay. Now if you see what's happening, lens जो करता है vitreous को support करता है. The lens supports the vitreous like this. You see lens and vitreous almost touching each other. So when you do a cataract surgery, but you do not place an IOL, intraocular lens, you have done a cataract surgery like this. You've taken the cataract out, but you've not placed an intraocular lens, and so there's no lens that punishes aphakic. Look at the vitreous. Now vitreous के पास कोई support नहीं है. There's no support for the vitreous here because the lens is moving. So when you move that up, down, left, right, the vitreous moves excessively. Why? Because there's no tamponade. There's nothing supporting the vitreous. The lens is out. The excessively moving vitreous may pull the retina off, and this may cause retinal detachment. So please remember that patients who have aphakia after cataract surgery, this may cause detachments, and myopics also cause retinal detachments. And trauma. If you get hit in the eye, as you get some trauma, this trauma causes a break in the retina, which is called a dialysis. We call it retinal dialysis. Okay, remember, the word dialysis means is not the same dialysis as in medicine. The word dialysis in ophthalmology means any structure separating from the root. Any structure separating from the root is called dialysis. So when you get hit in the eye, trauma causes the retina to tear from the ora serrata. This is called a retinal dialysis. Okay, this is called retinal dialysis. And when you have retinal dialysis, so this creates another break or a regma through which the vitreous goes in and separates the two layers. Okay, so these are the multiple causes of detachment. So remember, myopics are the highest risk. Cataract surgery, trauma, they all may lead to regmatous retinal detachments. What are the next time? Exudative detachments. Exudative detachments are not very common, and here again there is separation, but remember there is some fluid. Look at the word exudation. Exudation मतलब कुछ निकल रहा है. क्या निकल रहा है? Some fluid is being produced for various reasons, and this fluid separates the two layers like that, and by neurosensory layer and RP separate, so this is called retinal detachment. And there will be no breaks, no cracks, no regmas, no holes, no lattice. Remember, the minute you get cracks or holes or lattice that becomes regmatous. So इसमें कोई ऐसा lesion नहीं होगा. And what are the causes? The causes of the fluid being produced, the most common cause usually is a malignant melanoma of the choroid. Yeah, that is what this is. Remember, malignant melanoma of the choroid has two important MCQs. First, it is the most common cause of exudative detachment. Second, it is also the most common tumor of the eye in adults. Remember, tumor of the eye. Orbit nahi hai. Orbit mein I told you cavernous hemangioma of the eyeball. The commonest tumor of the eyeball in adults is a malignant melanoma of the choroid. Primary tumor jo hota hai. Okay? This causes a lot of fluid. It will separate the two layers and cause detachment. It could be choroiditis, inflammation of the choroid also. When the choroid gets inflamed, it produces a lot of fluid. This must have the two layers. And you have PIH, pregnancy-induced hypertension. Okay? You know, PIH defined as blood pressure rising above 140/90 after 20 weeks of pregnancy. Is it not? You know, pregnancy-induced hypertension defined. Remember your obs and gynae. Definitions याद करने चाहिए, important हैं. Whenever you're in trouble, the definition bails you out. Okay? So, blood pressure rising more than 140/90 after 20 weeks of pregnancy, this is called as PIH. Okay? And the three main causes of exudative detachment, where a lot of fluid is produced, separates the two layers. Remember, इसका characteristic होता है, it's called shifting fluid, because there's a lot of fluid, no? It shifts. So supposing you're sitting up like that, because of the gravity, the fluid will come down the eye like this, and the area of detached retina will be in the inferior half of the retina, क्योंकि पूरा fluid नीचे आके will separate the retina. When you're lying down like that, the fluid shifts backward, shift पीछे हो जाएगा, so gravity, and this shifting fluid will separate another different area of the retina. Remember, the shifting fluid, इसको MCQ याद रखना है, is an important characteristic of exudative retinal detachment. This does not occur in either fractional or regmatous retinal detachment. Then we come to the tractional layer. Traction, if you look at the word traction means something is pulling the retina off. It's not traction. The word traction means there is some band or some membrane or some fiber which is pulling the retina of the neurosensory layer, and you can see this band here, this yellowish thing. And so you will usually see some band or fiber or membrane which will on the present the surface of the retina and is pulling the retina off the RP. And the most common cause is, remember, diabetics. Diabetics are famous for their traction detachments, and it causes membrane which starts contracting after many years and it pulls the retina off. So diabetic are the most common cause of traction retinal. Yaad rakhiyega MCQ. You can have retinopathy of prematurity. These are kids who are born, remember, by definition, anybody who's born before 37 weeks. Aapko malum hai, 37 weeks and beyond is maturity. When the baby spends 37 weeks and beyond in utero, is mature. But less than 37 is prematurity, and when it's premature, if it's very premature, particularly if it's less than 32 weeks, if it's a 32 weeker, then the chances of development of a condition called ROP, retinopathy of prematurity, becomes very high. Particularly higher the prematurity and smaller the birth weight, the higher the chance of developing ROP. And when you develop ROP, again remember, some membranes are produced. These membranes will contract and pull the retina off. So ROP, you can get a question like that. What is the most common cause of blindness in a premature baby? You can answer tractional retinal detachment or ROP, jo bhi choice ho. The commonest cause of a blindness in a premature baby is tractional retinal detachment or ROP. Sickle cell anemia. This may also cause tractional detachment by pulling the membranes and causing the traction. Remember, iska question, ek jo MCQ hai, this is important. This is called as slow painless. Remember, other two detachments, that is exudative and tractional, are sudden painless loss of vision. This is the only detachment which is slow. MCQ yaad rakhiyega. Always we like to answer, I ask you exceptions. Okay? And the exception of the only detachment which is slow is this one. It takes some time. Okay? The other two are sudden. Just like in cataracts, I told you, cataracts, all cataracts are slow except the snowflake cataract, which is sudden loss of vision. Okay? Which is snowflake cataract of diabetes, which was sudden loss of vision. And these are the only slow one. The other detachments are sudden. So we have done the three detachments on the causes. What is the aim? Aim in attachment, this is a detached area, we have to attach them together. Why? Because if they don't attach them together, you see, the neurosensory layer, this is the neurosensory layer, and this is the RP, okay? Remember, retinal pigment epithelium also provides nutrition to the RP. A lot of oxygen, glucose, electrolytes come from the RP to the neurosensory layer. If they're detached, then the oxygen and the glucose cannot come to the RP, and the rods in the cone start dying out very fast. So you should get them back as early as possible. It's a bit of an emergency. So, attaching the retinals together is a bit of an emergency. We do it as fast as possible. Otherwise, within 40 to 72 hours, the rods and cones start dying out. Okay? So we have to do it fast. A bit of an emergency. And how do we do that? We put them with various things. Rhegmatogenous mein, we do something called buckling. Buckling is like a belt. That's why it's called a buckle. It's silicon buckle like a belt which you place all around the sclera, and we tie it around the sclera, so it puts the two retinas together, close together. Buckling is an important surgery. Or we do laser photocoagulation, take a laser beam, close the holes so that no more fluid can get out through there. In exudative retinal detachment, remember, treat the underlying condition, okay? Because exudative is basically fluid is produced. So you treat the underlying condition, whatever has caused the fluid, and as you treat the underlying condition, the fluid will absorb. As it absorbs, the retina falls back together. You don't need any surgical procedure for exudative detachment. So treat the malignant melanoma of the choroid, okay? So the fluid will absorb, the retina will come back together. Treat the pregnancy hypertension. Treat the pregnancy, for God's sake, don't treat the pregnancy. Treat the hypertension, and the fluid will come back. They'll get absorbed and it will come back. So basically treat the underlying condition. Tractional may, this is the most dangerous, because you see, traction may, you have to remove the membranes. Because even if I buckle the two retinas together, the traction is there. They will again contract and pull the retina off. You know? इसलिए traction को हटाना जरूरी है. You have to do a surgery called vitrectomy. So we go inside the vitreous cavity and gently remove all the membranes slowly. Very painstaking procedure. Vitrectomy बोलते हैं. Go inside and you peel the membranes off so that it cannot cause contraction of the membranes anymore. Okay? These are the three ways of attaching the retina, but basically the detachment is to treat this with, we have to attach them again. No, so that's the main thing. Now, that's about enough of this thing, retinal detachment. A lot of MCQs here. So what are the MCQs to summarize? Remember, you have to know the principle, which is to get the retinas back again, Remember the main causes of diabetes. Here the main cause is melanoma and PIH. Remember the Schaeffer sign, the supratemporal quadrant, and rhegmatogenous is the most common. Okay? So multiple questions, detachments are serious, and many of my students have had retinal detachment, particularly because they're high myopes. Okay? So the high myopes, on your guard, because आपकी eyeball लंबी है, it's longer, the retina has stretched to cover up the back of the eye, and in stretching it's become thinner and may crack or break anytime. So you have to take care of retina. How do you do that? Take care of retina. Get a retina checkup done once every year. Wherever you are in India or abroad, remember retina specialists are everywhere. Once every year, please go to the nearest retina specialist, get your retina checked. What we do? We check for holes, lattices and tears, we close them down. Laser energy लेके उसको हम close कर देते हैं. So we take a laser and we seal the lesion. So there's no hole, lattices left anymore. Does not allow the vitreous to pass through, and that is how it prevents detachments. Okay? So be careful, and the higher the myopia, greater the risk. Diabetic retinopathy. Let's talk about diabetic retinopathy. In diabetic retinopathy, let's talk about that. Here, retinopathy means damage to the retina caused by any systemic disorder. So hypertensive retinopathy, diabetic retinopathy. So these are systemic conditions which damage the retina. We call them retinopathy. And it is, remember, happens to be the most common vascular disorder of the retina. Remember, that means blood vessel ka disorder jo hai, is the most common disorder of the retina. Diabetic retinopathy, India has a lot of diabetics, and we are sometimes called the world's diabetic capital because you have so many diabetes here, and all these diabetics invariably land up with retinal detachment, with diabetic retinopathy. So let's look at the factors it depends on. First is a glycemic control. That means your HbA1c should be less than 7. Okay, ideally it should be less than 7 HbA1c. That is your aim to keep it. Once you've got 6.5, it means you're diabetic. But try to keep it within 7 if you're a diabetic. Okay, and that is a good glycemic control. Duration of diabetes is very important. The longer the duration, worse is the retinopathy. Remember, it's been seen that after 30 years of diabetes, almost all the diabetics have diabetes. So सारे diabetics को diabetic retinopathy हो जाता है after 30 years. So longer the duration, worse the prognosis. So 10 years diabetes, no problem. 20 years, definitely a problem. 25, much more. 30, invariably you will have retinopathy. So longer the duration of diabetes, you have worse the prognosis. On top of that, if you have associated blood pressure and cholesterolemia also, diabetes bad enough, लेकिन साथ में cholesterol भी है और BP भी है, तो दिन तो सोने पे सुहागा. That means there is no point in doing anything anymore. Okay, so all these three, they hammer the retina into major problems. Okay, so diabetes bad enough, but the combination of diabetes, blood pressure, and cholesterol is really bad. उसके बाद pregnancy. If you are pregnant also, remember, then the retinopathy worsens very, very fast. So that's why we tell all the patients who are planning a pregnancy, if they're diabetic, to postpone their pregnancy till the diabetes is under good control. Okay? Because if you are a diabetic and you become pregnant without having good control, then the retinopathy will spread like wildfire and cause blindness. Okay? Many women get blind during pregnancy because they don't listen to us. So when you're planning a pregnancy, if you're already diabetic, be very good control. Okay? So these are some associated conditions along with diabetes which damage the retina and further worsens the retinopathy. You will have blood pressure, cholesterol, and pregnancy. And what is a typical retinopathy? You'll have blurring of vision. Remember, diabetics will have blurring vision, of course. But a very important sign for diabetic retinopathy is called fluctuating vision. Matlab, it is different in the morning and in the evening different. So 6 by 6 in the morning maybe, evening it becomes 6 by 9 or 6 by 12 or vice versa. Remember, this vision fluctuation is very specific for diabetes, and sometimes we diagnose diabetes just by taking the history of fluctuating vision. Okay? Then remember the screening guidelines. What does WHO say? That if you are a type 1 diabetic, then you screen the diabetes when? After 5 years. On the 5th year of diabetes, you start screening for retinopathy. Why not before that? Because usse pehle, type 1, they are insulin dependent. So they have to take insulin, otherwise they will die. So they're very careful about the insulin. Okay, insulin ke lete rehte hain, and because they take insulin, so the sugar is under control. So retinopathy occurs later. 5 साल में से पहले नहीं आता है. Not for 5 years. But if you are type 2 diabetic, then you should examine the retina on the day your diabetes is diagnosed. Why? Because type 2 are non-insulin dependent, they are non-insulin dependent diabetics, and it's very difficult to diagnose diabetes. So I may have detected diabetes today, but you may have it for the last 10 years. In these last 10 years, you would already have developed the retinopathy, isn't it? So type 2 diabetics, we check on the day your diabetes is diagnosed, and then once every year. So please remember the guidelines: type 1, 5th year onwards, and then once every year; type 2, on the day of diagnosis, and then once every year, okay, to screen for diabetic damage. The earliest ocular manifestation, remember important MCQ, the earliest ocular manifestation is microaneurysm. That means that सबसे पहला जो दिखेगा आंख में finding diabetes is a small aneurysm. We call it a microaneurysm. There's a new term for you, MA. We call it MA. And microaneurysms are the earliest signs of ocular signs of this thing. Okay, diabetes. Remember somebody questions was asking this, but that is pericyte necrosis. No, but that is pathological sign. No? Pericyte necrosis or even occlusion is a pathological manifestation, diabetic early. I am talking about ocular manifestation, and that is going to be this microaneurysms. Let's look at the two-stage retinopathy. One is called NPDR, which stands for non-proliferative diabetic retinopathy. What proliferative means? It is not multiplying, non-proliferative. What is not multiplying? The new blood vessels are not multiplying. Okay? So remember, this is a condition where there are new blood vessels. Why should we have new blood vessels in diabetes? That's important. Remember the same thing, because remember the retina causes hypoxia, hypoxia causes VEGF, VEGF causes neovascularization. You see, the retina is becomes high. Why? Because of hypoxia? Because of diabetes. Diabetics cause a major hypoxia, stimulus, insult to the retina. So it produces VEGF, produces neovascularization. So that's why you have a lot of new blood vessels in the retina. But remember, in the first stage, there is no new blood vessels. There is no new blood vessels. NPDR, non-proliferative diabetic retinopathy. Okay. So what are the findings of NPDR? You will have microaneurysms, you will have cotton wool spots, hard exudates, and IRMA. IRMA stands for intraretinal microvascular abnormality. Okay, what are these? They're basically shunt vessels between the arteries and the veins. Okay, these are called shunt vessels. They are not neovascularization. Suppose this is the vein like this, and this is the artery like this. So the shunting vessels connecting between the two is called IRMA, intraretinal microvascular abnormality. Okay? Then we divide NPDR into 4 stages: mild, moderate, severe NPDR. 3. Mild, moderate, and severe. And this is because, you see, severe NPDR and severe NPDR we need to know, because it means that next stage is right across the cornea, and the next stage is the most dangerous one. Remember the PDR. Okay, the second stage, NPDR and PDR. NPDR is non-proliferative diabetinopathy, so there are new blood vessels, no new blood vessels. PDR is proliferative diabetinopathy. Proliferative diabetinopathy means that the blood vessels have started. Okay, so why we need to know severe NPDR is because shortly following severe NPDR, PDR occurs. So if we detect severe NPDR, it means that your PDR is about to come within a couple of months. Okay, so that's why sometimes we like to ask, this question came last year, how to diagnose severe NPDR. Remember, we use the rule 4-2-1 rule. 4-2. What is that? It states that 4-2-1 rule states that if you have a condition where that you have in all 4 quadrants, 4 quadrants we divide the retina, so you can divide into quadrants like this, 1, 2, 3, 4. If you have either microaneurysms in all 4 quadrants, or if you have 2 quadrants, any two quadrants of venous beading. Okay, venous beading. What does venous beading mean? The blood vessels, the veins appear start looking like this. Look at this, beads. इसको beading बोलते हैं, because they look like beads that some of the ladies wear here, on your ankles or on your hand. Beads, jewelry. So the blood vessels look like beads. They look like beads, दाने की तरह. So these are called beads. So if you have any 2 quadrants of beading or 1 quadrant of IRMA, that means any 1 quadrant has an IRMA, which is a shunt vessel, then this condition is diagnosed as severe NPDR. And it's important because it means that your PDR is on the way. Okay, so 4-2-1. Again, remember, this has been asked recently. It's a recent question. पहले नहीं पूछा गया था, but 1 साल पहले पूछा था. So any of these 3, not all, any 3. Either all 4 quadrants of microaneurysms, or 2 quadrants of venous beading, or 1 quadrant of IRMA. Okay? This is the 4-2-1 rule, easy to memorize. I don't say you have to memorize this, but remember at least that the 4-2-1 rule, it tells you that PDR has started, severe NPDR has started, not PDR, severe NPDR. And MCQ, what is the most common cause of loss of vision in NPDR? Remember, it is macular edema. Very important MCQ. The commonest cause of loss of vision in diabetes is macular edema, and the commonest cause of loss of vision in NPDR is macular edema. Okay. So next, it steps to PDR. So remember, NPDR usually shifts into PDR within 15-20 years. Okay, if you have good control. If you have poor control, that will shift in 10 years also. So you have NPDR, and this lasts for almost 15 years, and then you go to PDR. PDR is much more dangerous than NPDR because a lot of complications of diabetes take place in PDR, which stands for proliferative diabetic retinopathy. Okay? Now the blood will start proliferating. These blood vessels can be first on the optic disc, which you call as NVD, neovascularization of the disc, or they can be anywhere else. We call NVE, neovascularization elsewhere. Elsewhere means neovascularization anywhere on the retina apart from the optic disc. Okay? Remember, there are two stages of neovascularization. First occurs on the disc, which is called NVD, and second is what occurs elsewhere, anywhere else, is called NVE. Okay, so this is NVD, NVE. So as soon as you see any of them, it means that you are in PDR. And PDR is a much more dangerous cause of loss of vision because you can have from vitreous hemorrhage also, you can have loss of vision. You could have neovascular glaucoma, which we discussed today. Remember, the most common cause of neovascular is diabetes, I told you, or traction retinal detachment, I just told you, because the blood vessels start contracting and pull the retina off. So please remember, this is a very important slide. It states that NPDR, there are no new blood vessels, and the most common cause of loss of vision in NPDR is macular edema. PDR, there are new blood vessels, and the most common cause of loss of vision in PDR is vitreous hemorrhage. Overall, the most common cause of loss of vision, remember, overall the most common cause of loss of vision in diabetes is macular edema. This is the single most common cause, can you remember? And a lot of our patients become blind because of macular edema. Very well. So now, what has happened? So if you look at the pathology of diabetes, it starts and as it starts, within 15 years of starting, you develop NPDR. NPDR lasts for 15 years, then go into PDR. So it requires almost 30 years of diabetes before you develop PDR if you are in good control. Okay, this is not a hard and fast rule. If you are in poor control, then it may come in 20 years also. Okay, so much faster. Treatment first, what is the first? You treat the main condition, which is control the diabetes, treat the blood pressure, treat the cholesterol, and keep the diabetes under 7. The HbA1c should be less than 7. Okay? Treatment of macular edema. Remember, macular edema is the single most common cause of loss of vision in diabetes. So because we have the same pathway, retina causes hypoxia versus VEGF and neovascularization. So the best treatment of macular edema, remember, is to inject anti-VEGF drugs, which could be any one of these three: bevacizumab or ranibizumab or aflibercept. It could be any of these, right? So this is the typical best treatment of anti-VEGF of the amyloid. What about the second condition? Remember, second condition, you have PDR. In PDR, proliferative retinopathy, what happens is, why is this proliferation occurring? Remember, the new proliferation occurring so much because of the stress, the hypoxic stress that it has. Okay, so retina causes hypoxia, causes VEGF, causes neovascularization. That's why neovascularization is occurring. So how do we treat neovascularization? By reducing the hypoxia, is it not? Because the main cause of the VEGF is the hypoxia. So how do I treat retinal hypoxia in diabetics? We do something called pan-retinal photocoagulation. I mentioned this today, where we take a laser beam and coagulate the entire retina full of laser marks like this. Yes, full of laser marks like this. This is the PRP. It is a very extensive photocoagulation, takes 3 weeks to perform, almost 3,000 spots are placed, but the macula is spared. The macula, we do not do it. That's called pan-retinal photocoagulation. So it's pan, but the macula is not damaged. And how does that help? Remember, it treats hypoxia because what it does, it destroys that ischemic tissue, the hypoxic tissue of the retina, which is consuming a lot of oxygen. It destroys that non-viable tissue, which is consuming oxygen, and keeps only that little bit of tissue which is still alive. So the demand for oxygen becomes less. If the demand for oxygen becomes less because it destroyed the non-viable tissue, so it treats the hypoxia. It sounds paradoxical, but works very well. Okay? And then how do you treat vitreous hemorrhage? Vitreous hemorrhage, remember, is the most common cause of loss of vision, I told you, in PDR, which stands for proliferative diabetic retinopathy. Okay? And the most common cause is PDR, as this thing. So remember, the minute you think of where you think of vitreous hemorrhage, you have to think of diabetes, number one cause. But in younger patients, you have to think of trauma, particularly if it's young males, trauma. And because why young males can't have diabetes? Well, they can have, but remember it takes 30 years for the PDR to develop, and then you have vitreous hemorrhage. So obviously, by the time you become 30 years of diabetes, you're no longer very young. So young patients is mostly ocular head trauma, and another is Eales disease. Eales disease is a disease where there's new blood vessel formation due to tuberculosis. This tuberculosis, Eales is in India, and this causes occlusion of the blood vessels, which cause hypoxia, and hypoxia causes VEGF. So again, new blood vessels arise, and they cause bleeding inside the vitreous cavity. This is called Eales disease, found very commonly in young males. Remember the hallmark of Eales, and you have to diagnose it by three things. They're always young males. Females do not have Eales. Always young males between 20 to 30. Second, they have spontaneous vitreous hemorrhage. Okay, the reason for that we do not know. Spontaneous. And third is recurrent. Again and again it occurs. Okay, so recurrent means so you cured him, it comes back in a year again with the same thing. So recurrent, spontaneous vitreous hemorrhage in a young male is classically called Eales. Very common in India. So trauma and Eales disease are two common causes of vitreous hemorrhage in a young patient. How does vitreous hemorrhage present? Sudden painless loss of vision, the floaters, and the reddish tint to vision. Remember, because there's blood there, the patient will see everything red color tint. Everything in the world will be seen with reddish tint. This tells us that there's blood in the vitreous cavity. And what is the treatment of vitreous? How do you treat this? This is algorithm. Is simplest. Is first you give them bed rest. You know why? Because there's so much blood here. What happens is this blood, we give them bed rest so that it absorbs. There's nothing else we can do with this blood. We have to wait for it to absorb. It's been seen that if you make them lie down with the head end elevated, 2-3 pillows here, so they lie like this. This is head, this is foot. So if they lie with the head end elevated for 3 months, then it seems to absorb the blood faster. Blood seems to absorb faster. So ask them to have bed rest for 3 months. Not go to office, go to the hospital or anything, just take bed rest. And during this time where we're waiting for the vitreous hemorrhage to absorb, we treat the underlying cause. For these 3 months while he's resting, we treat the underlying cause. If it's diabetes, treat the diabetes. If it's trauma, treat the trauma. Eales, treat with ATT. Basically, treat the underlying cause. And after 3 months, if it does not work, if the vitreous hemorrhage does not absorb, then we can't wait anymore, because after 3 months, it won't absorb. So we go ahead and remove the blood and the vitreous together, or vitrectomy. Okay. Remember the three principal algorithms. First, ask them to take bed rest, wait for 3 months. Meanwhile, treat the underlying condition. If it absorbs, fine. If it doesn't absorb, then after 3 months, stop absorbing, and now we treat the treatment. We do vitrectomy, because after 3 months, it won't absorb anymore. Let's go. So this is the retinal vitreous hemorrhage done. So now we go to CRVO, central retinal venous occlusion. Remember, we just talked about this. CRVO is the second commonest cause of neovascular glaucoma after diabetes. Remember, so this is central retinal vein occlusion. Without warning, the central retinal vein occludes the most important vein of the eye. And if you see, this is what is the most common site of occlusion? It is the central vein behind the lamina cribrosa optic nerve. See, if this is the eyeball, and this is the optic nerve, okay, which enters the optic nerve, and this is the optic disc, correct? So optic disc में एक structure होता है जिसको हम बोलते हैं lamina cribrosa, LC, lamina cribrosa, and this is cribrosa, no, it has small holes like this. इसको lamina cribrosa बोलते हैं. So this is the structure, and just behind this is the site of the central retinal vein. यहाँ पे this is the optic nerve. So central vein, it enters the optic nerve somewhere here. So यहाँ पर somewhere it gets blocked like this. This is CRVO, and without warning, it suddenly gets blocked. So what are the causes? Remember, the most common causes are increased age. So these are older people, usually above 65. On top of that, they have uncontrolled diabetes, blood pressure, and cholesterol. Usually all three, but at least two, and they're uncontrolled, and they may have glaucoma also. So if the open-angle glaucoma or intraocular raised pressure, that's also causing occlusion of the vein. So without warning, the central vein gets occluded, and all the blood stops draining. All the blood stops draining, no? Vein se jata hai blood. And there are two types of CRVO. One is called ischemic, which is the much more dangerous. Ischemia matlab lack of blood flow. That is called non-ischemic. The ischemic is much more dangerous than non-ischemic, and luckily for us, ischemic is less common. Okay, remember, non-ischemic CRVO is 75%, which means about 3/4 of the CRVO, and ischemic CRVO is 25%, only 1/4 of cases, which is lucky for us, because this is very dangerous. And इसमें क्या होगा? So typically there will be sudden blurring of vision as the painless loss of vision. I remember I told you in retina there's no pain, so there's a sudden painless loss of vision. And what you will see when they come to you is the famous hemorrhages. You'll full of the entire retina will be full of hemorrhages. Such a bloody retina you will never see. Okay, it's full of hemorrhages, and retinal hemorrhages present in all four quadrants will be there. Disc edema, will be soft cotton exudates, things like this you will have. And the most common component of non-ischemic CRVO will be macular edema. Can you remember? Non-ischemic CRVO is not very serious. It is serious, but it's not that compared to ischemic CRVO. Most common cause loss of vision. But it's the ischemic CRVO which contributes to 25% or 1/4 of the CRVOs that is dangerous. And how do you call it ischemic? It means that more than 10 disc diameters of capillary non-fusion. Remember, I told you on the first yesterday when we talked about this, one disc diameter is 1.5 millimeter. Remember? That was it, 1.5 millimeters. So when you have 10 disc diameter, that means into 10 is almost 15 millimeters of the retinal surface is without blood vessels. Okay. So in ischemic CRVO, what happens is that almost 15 millimeters or more than 10 disc diameters of the retina is not having blood vessels. This is called ischemic CRVO, more than 10 disc diameters. Okay, because remember it's a CRVO, vein is not occluding. So this is more than 10 diameters, that's the definition, and this is far more dangerous than ischemic CRVO. And immediately if the same symptoms are same, sudden painless loss of vision, both ischemic and non-ischemic, both loss of vision. But on examination, look at the hemorrhages I was telling you. The hemorrhages that are seen here, the retina is full of hemorrhages. You cannot see a more bloody retina than that, and this is called blood and thunder fundus. Okay? Because it's a very unique description, blood and thunder. It's a very angry looking retina. Blood and thunder, also called a splash tomato fundus, because it looks like you have splashed tomato all over the retina. Look at the hemorrhages, all kinds of hemorrhages. You can have dot and blots, you can have flame shaped hemorrhage, everything there. So you have dilated tortuous veins. The veins will become like this. This is tortuous. Dilated tortuous veins like this. Disc edema, extensive hemorrhages, dot and dot, and cotton ball spots. So this is a very angry retina, which is very, very easy to diagnose. And this also leads to the famous neovascular glaucoma, which you call as 90-day glaucoma. Because remember, it is the same thing. Retina causes hypoxia, produces VEGF causes neovascularization. And if neovascularization, remember, after neovascular will happen, it will cause neovascularization of the iris. And you can see it here, neovascularization of the iris here, you can see in this particular area. And so it leads to neovascular glaucoma. The neovascular glaucoma, remember, it is called typically 90-day glaucoma because this glaucoma is seen within 3 months of the CRVO. Okay, it's very peculiar. It comes within 3 months of CRVO, and that's why it's called 90 days, sometimes 100-day glaucoma also. Remember, you can have neovascular glaucoma in any other condition, but it's only called 90-day when it occurs after CRVO. And if you remember, CRVO, I told you, is the second commonest cause of neovascular glaucoma after diabetes. Okay, so this is, you find this thing. And what is the treatment? The treatment of CRVO is that macular edema. First, you treat the underlying cause, which is the diabetes, the blood pressure, the cholesterol, the glaucoma. You treat that because you don't want CRVO to occur in the other eye also. So you treat that first. Second, to treat the macular edema, we have to treat with anti-VEGF drugs. Okay, the best treatment again is the same thing. Retina causes hypoxia and VEGF. So we can give anti-VEGF drugs like ranibizumab, bevacizumab, or aflibercept. Any of the 3 anti-VEGF drugs we can give. And remember, so this is the treatment of CRVO. Treat the underlying cause, treat the macular edema, which is the most common cause. In non-ischemic CRVO, this is not so important because the loss of vision is not very much. But ischemic CRVO, the loss of vision is tremendous. It becomes hand movement or finger counting. Okay, this is CRVO. Then we come to an even more dangerous thing, which is called a CRAO, Central Retinal Artery Occlusion. CRAO and central retinal artery occlusion is even more dangerous because the risk factors are the same. The risk factors are the same, which is the diabetes, the blood pressure, the cholesterol, and you can have one more extra cause. This one is giant cell arteritis, very dangerous condition, giant cell arteritis. But the most common are diabetes, blood pressure, and cholesterolemia. Okay, remember, these causes are the same of CRVO or a CRAO. It's just a question of bad luck. Okay, if you are unlucky, you get CRVO. If you are very unlucky, you get CRAO. तो अगर आपकी किस्मत खराब है तो CRVO होगा, और आपकी किस्मत फूट गई है तो CRAO होगा. Okay, and it's treated as a major ocular emergency. Remember, this is just like a cerebral stroke. Okay, like a cerebral stroke. And because irreversible loss of vision hota hai, so you have to do it. We taught the major. Remember, there are 2 major emergencies of ophthalmology where we have to take action in seconds. One is CRAO, second is chemical injuries. Okay, So these are called emergencies because we have to act in seconds and minutes. Okay? So these are the, remember again, CRO and chemical injuries. So what is the cause of occlusion? क्यों हो रहा है occlusion? This is a typically primarily it's a cholesterol embolus. Okay, this is a clot which is mostly cholesterol, and this cholesterol embolus is the most common embolus. Though we have other common ones like also fibrin, and we can also have a clot which is made up of fibrin clots, or you can have any other clots also, calcium clots also. But the most common clot is cholesterol, which is called this by name Hollenhorst plaque. Okay, remember this name? Hollenhorst plaque refers to a cholesterol clot, which is the most common cause of occlusion of the central retinal artery. And the most common site, what's the most common location where the CRO will take place? Remember, it's the narrowest part of the CRO, where the central retinal artery enters the optic nerve. See, remember, this is the eyeball, and this is the optic nerve which enters the. So, and the central retinal artery is somewhere here. So, approximately about 1 centimeter behind the optic disc, the central retinal artery enters the optic nerve here, and this, because as it pierces into the optic nerve, this is the narrowest part of the artery, and this is where the arterial occlusion takes most common. Okay, this is the entry of the central artery into the dural sheath of the optic nerve, and immediately the sudden painless loss of vision. Since like CRO, there is also CRAO, the sudden painless loss of vision. The difference being CRO is a total loss of vision, is hand movement and finger counting loss of vision. In CRVO, you can have 618 or 612. It's not particularly when it's non-ischemic. But here is total loss of vision, hand movement, finger counting, and the patient gets to know immediately sudden painless loss of vision. And when it comes to us, we have the famous cherry red spot. Remember the most common MCQ that is asked usually in ophthalmology. This is possibly the most common MCQ in entire ophthalmology. Okay, used in ever since your exam was started in 2003. You remember the MCQ exam started approximately 2003. In these 22 years, every year, year after year, this question has been asked. Okay. It is in ophthalmology, which is the cherry red spot. It's a diagnostic hallmark of CRA. And the famous cattle tracking box. What is that? Cattle track box of car appearance is a unique thing. It may occur either in the artery or in the vein. Okay, you can see either in the central artery, you see it in the central vein. See, what is this? Normally, when you look at the vein or artery like this, you see the blood flows like this, no? Smoothly and sluggishly like this, smoothly and sluggishly, and continuously. But what happens in CRO? Look at the vein. It appears to break up into small segments. It appears to break up into small segments, and the way they move is not smooth and sluggish, but in jerks like this. See, this blood column, you'll see it moving either in the vein artery in jerks like malgadi ke dabbe, like wagons of a goods train, jerks like this, which is called the cattle trucking or boxcar appearance. It's the Western terminology, where cattle was loaded across US in trains. They were loaded in wagons and trains. It's called cattle truck or boxcar appearance because of the discontinuity of the blood vessel here. And you have only 90 minutes. Remember, we have the retina being the highest consumer of oxygen. You have only 90 minutes to save the retina. If you do not save the retina within 90 minutes, patient will become blind. Okay, so this is our aim, to start treatment and start circulation within 90 minutes. It's called the retinal ischemic time, RIT. Okay, and is there any grace period? Well, yes, if you cannot start within 90 minutes, then at least do it in 4 hours. At least try to get the circulation working by 4 hours. 4 ghante tak, you will have some damage, but it will have some vision. But if you get it after 4 hours, which is 240 minutes, this is irreversible damage. So 4 ghante ke baad kalaane koi fayda nahi hai, because vision will not come back. Okay, so you can ideally for 90 minutes, if not 90, within 4 hours with some damage but some vision, and after 4 hours irreversible, no vision at all. Treatment of CRO is how your ocular massage. So you take 2 fingers and press it like this, called ocular massage. Okay? It doesn't work most of the time, but it's very safe, so we always try it, and this may dislodge the clot. Okay? Then if it doesn't work, go to lowering intraocular pressure as fast as possible. The fastest anti-glaucoma drugs are mannitol, acetazolamide. Inject them. Remember, I told you the only intravenous drugs that are given IV anti-glaucoma drugs are these ones, mannitol and acetazolamide. Particularly mannitol, which in India may available hai. Acetazolamide is not available in India. Inject this, the pressure comes around 30 minutes, and this may start the blood flow also. Okay, by lowering the intraocular pressure, it allows more ocular perfusion, so it may wash the clot out. If that doesn't work, then the highest successful rate, when you go to the next one, which is a little dangerous, called paracentesis, where we take a needle and go through the limbus and into the anterior chamber. Okay, so go to the anterior chamber and we aspirate the aqueous. Bahar nikalte hain. So as we aspirate the aqueous, again the pressure plunges down. So treatment in दोनों का principle same ही है. Lowering the pressure suddenly to allow the blood to flow more, blood to flow into the eye and wash the clot out, okay? Because this is very sudden, so this is more successful, but it's also very dangerous for the patient. इससे भी नहीं होता है, so then you give carbon inhalation. Carbon, as you can make out, is an injection of two gases, is an inhalation of two gases, carbon dioxide 5% and 95% oxygen. You ask, there's a mixture, you ask people to inhale them, and this is good, but it has its own side effects because this carbon dioxide can cause hypercapnia. Okay, and hyperbaric oxygen is an expensive proposition where you flood the patient with hyperbaric oxygen under 2-3 atmospheres, and this works, but is expensive option. Most of the places in the small towns of India does not have hyperbaric oxygen, the facility available. And of course, if it's the giant cell artery, remember giant cell artery causes arthritis, causes bilateral CRO. Okay, so if one eye, mostly we cannot say one eye, we have to start systemic steroids to protect the other eye, because giant cell arthritis is one cause which will cause CRO in one eye, and within 3 to 4 months it may cause CRO of the other eye also. You might land up being bilaterally blind. So CRO is so scary because we have to start systemic treatment immediately. Okay, so if it's giant cell artery, giant cell artery is not a very common cause of CRO, I must tell you, but though we have to be careful. Then we have cystoid. I hope the speed is better now. So CME, cystoid macular edema. What is that? Over the macula, remember, there is swelling. That's why it's called edema. And the small cysts. It's a small cyst. छोटे cysts होते हैं. That's why it's called cystoid macular edema. And what is that? In cystoid macular edema, the first question is, in what layer of the retina will it occur? It occurs in the outer flexiform layer. Okay? This is one of the, remember the OPL which I was telling you? The OPL which I was telling you is the watershed layer, wahi wala. That is the layer where the edema occurs, that one. So this is the typical thing that you have, the layer that collects the fluid. So remember, sometimes we like to ask you, what is the layer where we do that? It is the outer plexiform layer, okay? And that is the swelling. But why does it occur? It occurs because of the, look at the most common causes. First is diabetes. Remember diabetes, we had talked about macular edema, and after cataract surgery it also comes. So the second most common cause is Irvin-Gass syndrome. Remember I told you yesterday, whenever you have cataract surgery followed by cystoid macular edema, this is called as Irvin-Gass syndrome. So kindly remember these two important causes, diabetes and Irvin-Gass syndrome, are the single two common causes of cystoid macular edema. Okay? And because there's a macular edema, so again there will be loss of vision, painless loss of vision, as you see this here. So blurring of vision will be there. But also remember that I told you yesterday that the hallmark of macular disorder is metamorphopsia, the distortion of shape. See, everything occurs to be irregular like this, okay? And look at that, you can see the irregular haziness. So every time as you wake up in the morning, you find the buildings, the walls, the pillars, everything are wavy and circular and irregular like that. This is typical metamorphopsia, which is a sign of any macular disorder. And loss of contrast sensitivity sometimes occurs in same also. On examination, you can see here the yellowish spot that you can see here. This is the type, this is the macular looks like slightly yellowish the macula looks, and the loss of foveal contours. You will not be able to see the pit, the slight depression that is seen in the fovea, that will be missing, foveal contours lost, and a yellowish color that will be seen. Okay, this is the typical examination. Kindly remember the yellowish spot, that is important. You've diagnosed your CME, and then we confirm the findings by doing some investigations. One of them, which is called fluorescein angiography. Fluorescein angiography, remember, we inject the dye. You have to remember the name of the dye is called sodium fluorescein. That is why it is called fluorescein angiography. And this is injected where exactly? Remember the vein, you have to remember the vein injected here is the antecubital vein, okay? So you inject in this particular vein called the antecubital vein. As you inject the dye moves from the vein and it passes through the arm and into the eye in about 12 seconds. In about 10 to 12 seconds, it reaches the eye. This is called the ART, arm retina circulation time. Arm retina circulation time. In a normal circulation, it takes about 12 seconds till it reaches the eye. And then we take photographs of this dye as it moves into the retinal circulation. Okay? And as we take photographs, this black and white photograph that occurs to us is called a fluorescein angiogram. And typically, you will find in cystoid macular edema, over the macula, the dye accumulates like this. It looks like a flower petal. It looks like a flower petal. So we call it a petaloid appearance or a flower petal. Remember, that confirms you have CME. Okay, so and once you've done CME, so the treatment would depend on the cause actually. For instance, we give topical steroids followed by injectable, followed by topical NSAIDs and injection triamcinolone in the Irvin gas syndrome. I'm talking about Irvin gas syndrome here. So following cataract surgery, if you have CME, then we can first start topical steroids, we'll absorb the edema. If that doesn't work, we go to topical NSAIDs, and if that doesn't work, we inject triamcinolone with steroid under the Tenel's capsule. Okay? That is last because injection is dangerous. They will all cause the edema to resolve. So this is for Irvin gas syndrome, which is following cataract surgery. But supposing the CME is seen in diabetics, then remember diabetic treatment is different. We have anti-VEGF drugs, we talked about that just now, like bevacizumab and ranibizumab, and distorted macular edema occurs in retinitis pigmentosa, which is another condition may cause CME. Then the treatment is drug of choice would be astazolamide. Okay, so the treatment of CME depends upon the cause of CME also. Okay, because there are multiple causes, and the most commonly we like to ask about after Irvin gas syndrome. Okay, Irvin gas syndrome, we like to ask that. This is the one that we like to ask you. CME done. The next condition is CSR, another important number, central seizure retinopathy. What is that? Central seizure retinopathy means there is fluid over the macula. Again, central area is the macula. So then what is the difference between CME and CSR? Remember, both of them fluid on the macula, but there's a difference between in the layers. You see, in this case, look at that. This is the neurosensory layer, okay? And there's a retinal pigment epithelium. Remember, 9 neurosensory layers, 1 RP. And among the 9 layers of neurosensory layer, there's one particular layer called the outer plexiform layer. So when you have fluid in that particular layer, in the outer plexiform layer like this, when you have fluid here in the outer plexiform layer, and this is under the macula, remember the macula is here. So this is called as CME. But if you have fluid under the macula, but the level is different, it lies between the neurosensory and the RP, remember this is called as CSR. So if the fluid lies in the CME, if the fluid lies in the under the macula in the neurosensory layer, we call it cystoid macular edema. But if the fluid lies under the macula in between the neurosensory and the RP, this is called CSR. Okay, so the difference is the level of the fluid which accumulates. So remember, CSR is a type of localized exudative retinal detachment. Remember, exudative retinal detachment also causes fluid to separate the neurosensory and RP. So CSR is a type of localized, exudative retinal detachment, except that it occurs under the macula. Causes are typically type A personalities, stress, and so you remember these three, they are most important. Stress. So if there's one thing that describes CSR, it's that stress. Like, remember, many of you are under tremendous stress before the exams. These are often young people, you're under stress, exams, stress. Anybody under any stress, CSR can precipitate it. We're using steroids for some reason, whatever it is, for bronchial asthma, for anything else, for facial palsy, it may cause CSR. And the most important, apart from stress, is the type personality. It's a type A personality, they're highly anxious, ambitious, aggressive personalities. Type A can memorize by 3 A's. They are very anxious, they're aggressive often, and they are anxious and aggressive, and sometimes also they get very, very aggressive on dealing with you. So these are young patients, and these are usually males, right from 25 to 45 years. The highly strung people get easily excited, get easily upset. These are typical type A personalities, and they may land up with a CSR. So suddenly, without warning, there's a sudden loss of vision, which is painless loss of vision with metamorphosis. Remember, again, distortion of shape. Anytime the macula is damaged, you will have distortion. With a central scotoma, localized area in front of the eye, patient has a central scotoma, which means that he has a coin-shaped dark spot in front of the eye, which he cannot see through, and he complains to the doctor, what is this black spot in front? The central scotoma. And slight hyperopic shift, because the fluid here, so it pushes the retina back, it pushes the retina, so because of that, of the retina, the rays of light focus behind the retina, okay? So this is the it pushes the retina forward, I beg your pardon. There's a fluid shift the retina forward, so the rays focus back. This is called slight shift of hyperopia, say about 1.5 diopters hypermetropia they become. So these are typical presentations, and the look is also very different. It's called a halo. Can you see? Along this, I have shown arrows there. If you look at this, this looks like a blister of fluid. It looks like exactly like some blister of fluid, or some drop of fluid is present there. It's very clear cut. It looks totally different from CME, because CME you have a yellowish look. Here you have a fluid-filled blister, which looks as if right on top of the macula, and this is called the halo light reflex. This is in CSR. We have diagnosed CSR. To confirm, we do fluorescein angiography. Remember, fluorescein angiography is an important staple investigation in retina. Again, we inject the dye in here in the cavern, in the antecubital vein. Again, 12 things goes there to the retina, and then you take photograph. This is the black and white photograph you see, and So they take two patterns, typically ink blots. Ink blots means the dye leaks out slowly like a blot of ink like that. This is approximately about 70 to 80% landed with ink blots. And second called smokestack, where the dye leaks out from a small point, suddenly spreads, look at that, like smoke rising out of a chimney. It's not, it's called smokestack. So anytime, remember these terms. Remember in CME it was flower petal. In CSR it's smokestacks and it is ink blots. Okay, so any of these two, it means your CSR and your diagnosed CSR. The most important is, remember these are self-limited. Okay, these are self-limited. There was fluid there, no? These are self-limited. So basically you reassure them, because these are, remember, high-strung patients, very highly ambitious and type A, very anxious, over-ambitious, so they are worried about the exams, they're worried about the future, they're worried about the future prospects. So just reassure them, say that everything will be fine, take some rest, get some sleep, give them anxiolytics, reduce the anxiety, give them some rest, sometimes we give them also a hypnotic agent so they can sleep better. So we essentially reduce the anxiety levels and ask them to take reassure that it will automatically self-limited within 3 months the fluid absorbs, the retina comes back. Okay? So spontaneous absorption of fluid is there. So CSR usually does not require any treatment except some small counseling and just that to start relaxing and stop worrying so much. So many of you guys stop worrying about the exams, and whether this thing covers the entire FMGE or not. Just relax, do your best. Okay? Stop getting agitated and worried about whether you'll pass it. Don't worry about the exam pass. You'll all pass the exam. Worry about your strategy, that's all. Don't worry about the result. Okay? So this is your CSR, very different from CME. And the next thing is called the age-related macular degeneration. Okay? Another macular. So all three macular conditions are put together: CME, CSR, and ARMD. What is that? So older people, they develop this macular degeneration after many, many years. Typically, remember, is 50 is the cutoff age. So after 50, anybody can develop ARMD, but it is seen usually older people like 75 and 80. So usually we see very old patients, 75, 80, 85, 90. The cutoff is 50 by definition wise. So cutoff is 50. So it's a deviation condition of the macula with age. As you go older, remember, we have to go age. We cannot stop the aging. There's no way you can stop the shortening of the telomeres, is it not? So we cannot stop that. So as we go older, there is the single most important modifiable. Remember, modifiable. Age is not modifiable. You can't modify the age, is it not? So single most important risk which is modifiable is smoking. All you smokers, watch out. Okay, macula, it is damaged very fast by smokers, and smoking is the single most important risk factor for ARMD, which can be modified. These are mostly chain smokers, chronic smokers over 50 years. Remember, they are 75 now, but they started smoking at 25 when they were in college. So 50 years of relentless smoking, 1 pack, 2 pack, 3 packs. And I had a student who smoked almost 3 packs a day. Okay, and so these are cigarettes or pipes or whatever they can cause the ARMD. Then there are other things, disease of lifestyle, like they are usually highly obese, they are hyperlipidemic, they are hypertensive, and they are more seen in the white races. So Orientals not so much, the whites more often. So the damage is to the Brooks membrane. Remember, Brooks membrane, you have to remember the exact pathology. The Brooks membrane is a membrane of the choroid. Okay, it's not a layer of the retina. Remember, retina we have 10 layers, but under the retina lies the choroid. So if this is the retina and this is the choroid, in the choroid there are 5 layers. One of the most important layer is the Brooks layer, which I mentioned, and the damage occurs to the Brooks membrane. Okay? The Brooks membrane damage occurs. Why? Because of aging and smoking. And there are 2 different types of ARMD we need to talk about. The more common is the dry ARMD, which is 90%, and wet ARMD is the more dangerous is the wet ARMD, which is less common, only 10%. Dry is more benign, which is luckily for us more common. So dry ARMDs are benign, wet ARMDs are dangerous, they cause blindness. Okay, and both of them have the similar loss of vision. It's a gradual loss of vision over months and years, slowly with metamorphopsia, again distortion of shape. And hallmark of dry ARMD you can see here is the famous drusen. Drusen, basically you can see these white dots around the macula here, this is macular degeneration. But remember, the level pathology is at the choroid level, that's the Brooks membrane. So these are these whitish dots which look like hard X-rays a little bit surrounding the macula. This is called as dry ARMD. Also, you can have geographic atrophy around the macula. You can see some geographical areas like the map of a country called geographical atrophy. Okay, so this is a typical dry ARMD. This is much more common and more benign. Wet ARMD, remember the hallmark is different. It's called a choroidal neovascular membrane, CNVM, also called a subretinal neovascular membrane, SRNVM. Okay, so either choroidal neovascular membrane or SRVM is the same thing. So you develop a new blood vessel under the retina, because remember it's in the choroid, and this suddenly ruptures. As it ruptures, it floods the macula and the vision drops. Okay. So ARMD, remember there are two different things, wet and dry. Wet AMD, there is hemorrhage, there is bleeding over the macula because the CRMD ruptures and causes bleeding. Okay. Dry RMD is more benign. There are only soft these drusen hair, they do not cause any bleeding. And the treatment of RMD would be dry RMD first. First, you have to quit smoking. Remember the modifiable risk factor, you cannot modify your age. So quit smoking and use green leafy vegetables, lots of them. You have to start eating green leafy vegetables and foods rich in omega-3 fatty acids. Okay, this replenishes the retina and the choroid. So antioxidants, we have to give you antioxidants, and the most common antioxidant is devised by this very famous study called the AREDS-2 study. Okay, look at the study. AREDS, it stands for Age-Related Eye Disease Study. Age-Related Eye Disease Study. This is AREDS study, very famous, and it formulated certain vitamin tablets, medications which these patients has to take all their lives. They are the richest combination of antioxidants which they will prevent damage to the dry RMD patients. So this consists of lutein and zeaxanthin, two important pigments which are there in the macula. Lutein, zeaxanthin, then zinc, copper, and all the powerful antioxidants are there. Okay, so daily you have to take them all your life till you're alive. Okay, this is for dry RMD. Remember, dry RMD is very benign. I mean, it doesn't cause blindness. It may cause loss of vision, which is irreversible. You may have 618 or 612 or something, but you will not lose further. But wet RMD can cause blindness because this CRNVM, it ruptures, it bleeds and causes disciform scarring. So the treatment is anti-VEGF drugs, again bevacizumab, ranibizumab, or aflibercept. Okay, but if it doesn't work, then wet RMD has a very poor prognosis, usually become blind because of a scar that forms with the macula. So please remember, ARMD is an important CQ because remember, older people, smokers, white races, okay? Obese, diabetics, hypertensives. Then retinitis pigmentosa. Retinitis pigmentosa, then we have this condition, retinitis pigmentosa, where it is the most common inherited disorder of the retina. And remember, it's the most common inherited, that means from your parents. If they ask you most common inherited, you must remember retinitis pigmentosa, where there is apoptosis of the rods. Okay, rods, remember the rods which are responsible for night vision, night vision and peripheral vision. This one dies out automatically. It's a programmed cell death, and the most common is autosomal recessive. So these are autosomal recessive, which means that again these are children born to consanguineous parents who are married consanguineously, which means that they have relate to each other, and the closer the kinship, remember, first cousin, second cousin, so the chances of developing AR is higher. And these autosomal recessive kids, they have spontaneous destruction of the rods. Slowly the rods start dying out. So the first symptom is nyctalopia, night blindness. Remember, night blindness is the first symptom. Earliest symptom is night blindness. So this is the earliest symptom of this thing because it's the rods are getting destroyed. Along with that, then there's a ring scotoma. To add insult to injury, not only you're night blind, also the visual field collapses slowly like this until it collapses to a ring scotoma or tunnel vision. Okay, right? We had an open angle, remember? So it starts ring scotoma. See, it's a scotoma like this. Scotoma means a localized loss of vision surrounded by normal vision. If this is the field, you will find that this ring-shaped area that the patient, he cannot see through. It's a scotoma in the shape of a ring. You can see from inside the ring, you can see from outside the ring, but you cannot see from this ring. And slowly, with loss of this thing, our rods further, slowly the visual field collapses till it becomes tubular vision, very similar to open angle glaucoma. So end stage is tunnel vision or tubular vision. How do you diagnose? The classic triad of three things. We pale waxy disc. Remember, normal optic disc is reddish orange in color. This is pale waxy disc. Artery attenuation, this is the most important. Remember, attenuation means thinning of arterioles. You can see the arterioles become thin, very thin, like threads. And third is bone corpuscular pigmentation, which means you can see it here. All the pigments are there present on the retina in the shape of bone corpuscles, and these corpuscles, they look like bone corpuscles. That's why the bone corpuscle pigmentation. That's why it's called retinitis pigmentosa. So presence of these three, pale waxy disc, arterial attenuation, and bone speckle pigmentation, confirms you have RP. But the most important sign is the attenuation. Okay, and there are some ocular associations which are strongly seen with RP. The two of the most common is posterior subcapsular cataracts and keratoconus. Okay, so sometimes you have cataracts association with these, and we often have to remove the cataract to improve the field of vision. The other vision does not improve so much, central vision, because of the the RP, but because of the peripheral vision we have to improve. Sometimes we do cataracts, and the second association is also keratoconus, often seen with retinitis pigmentosa. Management, you have to do an ERG. It's not enough to just have these three clinical features. You have to have an ERG, and the ERG will be flattened out. Normally, ERG has a negative A wave and a positive B wave like this. This is how normal looks like. This is negative A wave and a positive B wave. But this is your normal ERG. But in retinitis pigmentosa, you will see it becomes completely flat, because there is no potential shifting be generated. So it becomes flat, 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 flat. Total flattening of the ERG tells us that it is retinitis pigmentosa. There is no proven therapy because it is a programmed cell death, and the only thing that we can give is 15,000 retinoids of vitamin A. It is not documented to be very effective, but sometimes it seems to work. So we give 15,000 units of vitamin A in the palmitate form every day for life till the child is alive. Okay, and you can give some sort of supplements with them, like lutein 12 milligrams per day and docosahexaenoic acid DHA around 1200 milligrams per day. So these are the, remember, the antioxidants we'd like to give them. And if you have macular edema in CSR, remember I told you talk about macular edema in CSR, the treatment of choice is dastazolamide. It's not anti-VEGF, neither is it the drugs that we use, Irvin gas syndrome. Remember, it is carbonic anhydrase. This is the sad story of retinitis pigmentosa. Then you go to retinoblastoma, big bad boy, retinoblastoma. What's that? Remember, it is the most common tumor of the eye in children. Be careful. The most common tumor of the eye in adults is choroidal melanoma. Is it not? Malignant melanoma of the choroid. But the commonest tumor of the eye in children is retinoblastoma. Very important. Okay? This occurs usually within 5 to 6 years. Maximum it will occur within 5 to 6 years. If after that it is not possible to come. And we have two different types of retinoblastoma. Please remember that. One is sporadic, one is family. Sporadic means that there is no family history. Okay? There is no family history. Anybody can get it. Okay? And that is 90%. And familial means there is usually family history. Okay? So somebody in the family has retinoblastoma. So sporadic is 90%, familial is 10%. Okay? And then unilateral, bilateral. Remember, 70% unilateral and bilateral 30%. So this percentage we like to ask you sometimes. Retinoblastomas, usually 70% of the retinoblastomas are unilateral. And when they're unilateral, remember, most of the time they are usually sporadic. And if they're bilateral, most of the time they are familial. Okay? Not always, but similar. And there are two. Remember, the sporadic and familial types of retinoblastomas are very different. The sporadic ones are more benign. Okay? They are more unilateral. And they come a little later. Okay? So they come about 3 years, 4 years. It is the familial ones which are more dangerous, which come earlier at 1.5 months, which have mostly bilateral tumors, and they have more secondary cancer. Do you understand? So there are totally different types of retinal. They behave as students. The familial one, which is only 10%, remember, this family one, which is family history usually, they are the ones that usually bilateral tumors. Okay, these ones family history are usually bilateral though, and they are more aggressive in the sense that they have more secondary cancers, and they occur earlier. They occur at 1.5 years of age. So the familial ones are all the bad boys. The sporadic ones are often good because they are 90%, but they usually do not have family history. There's usually unilateral. There's not much, secondary cancers there, and they are not so aggressive. So what is the cause? The cause of retinoblastom, remember, is the RB1 gene. Out of the almost 21,000 genes that human beings possess, this is the single most important gene called RB1. And if not responsible retinoblastoma, because it's a suppressor gene, remember, it does not cause the tumor, very much the opposite, it suppresses it. So why we don't have retinoblastomas is because the RB1 has suppressed it. But in these situations, the RB1 itself is damaged or deleted. So this gene, which prevents the tumor, it's itself deleted or damaged, and that is why it is not able to prevent the retinoblastoma and it climbs up. Okay? So RB1 is the one that is the one responsible, even though it's actually a suppressor gene. And this RB, remember, located on 13q14. You have to remember this important location very well. Remember, this famous gene is located on the 13th chromosome, the 14th band, and the exact location is the 14th band. And you have to have mutation of both the alleles. In this case, retinoblastoma gene has a mutation of both alleles. Okay? This is called the Knudson's two-hit hypothesis. And the most common cause is leukocoria. Okay, the most common presentation. How does it present? You can see the white pupil here, leukocoria. Normally the pupil is red in color. This becomes white in color. It's called leukocoria. Okay, and leukocoria, white pupil. Please do not say as leukorrhea. Leukorrhea is an obscene term. This is leukocoria. This is the single most common cause. 60% of patients land up of retinal blastoma with leukocoria. And second commonest cause is squint. Okay, the strabismus. Often you will find the child comes with a squint. That's important because many of the doctors, think that squint, it's just a squint will correct itself. Many of the parents also think so. But what if it's a squint due to underlying retinal blastoma? You kill the child. So remember, all children with squints are supposed to refer to us because you do not know where the squint is natural, normal, or is due to underlying retinal blastoma. We have to rule it out. Okay? So squint, and then you can have loss of vision also. Three important cases: white pupil, squint strabismus, and decreased in vision. Okay? So these are the three important how they present to us. And are there different angles? White pupils, are they seen only in retinal blastoma? No. There are other differentials also. The number one differential, of course, is retinoblastoma. When you see white pupil, you have to think of retinoblastoma. But the number two is a disease called as Coats disease. Coats disease, remember, is seen in young boys, often in the first 10 years of life. Okay, and Coats disease is the second commonest cause of leukocoria. Can you remember that Coats disease? You have to remember that they found in young boys. Girls don't have coats, so remember, boys wear coats. To memorize this, boys wear coats. And they usually in the first 10 years of life, as a whitish pupil will be seen, and this is called Coats disease. It's the second commonest cause of leukocoria after retinoblastoma. And then you can have toxocariasis. Remember dogs, toxocariasis, which appears as a white pupil, retinopathy of prematurity, the retinal detachment works like white pupil. So anytime leukocoria has many other differential diagnoses, but the number one is the retinoblastoma, followed by Coats disease, followed by congenital cataract. Okay? So you have white pupil. Then a very important hallmark of retinoblastoma is the famous intraocular calcification. So whenever you are in doubt about retinoblastoma, so we often do a CT scan or an X-ray, and this picks up the intraocular calcium. What is that? Remember, what is the yellow pupil? What is the whitish yellow pupil? The leukocoria, what is this? It's nothing but the calcified tumor. It's the calcified tumor that you can see, and that's why it's very famous finding to have a calcified lesion in. It is going to tell you that it is retinoblastoma. So often we like to ask you, what is the most common cause of intraocular calcification in children? Is retinoblastoma. Okay? In adults, it could be an ulcer, it could be something else, but in children, it is always retinoblastoma. Okay? It's always calcified. But I must also tell you that you should not do a CT nowadays for this. I did say CT and X-ray, but remember that's not recommended because you see, the CT and the X-rays will further cause radiation exposure and increase the secondary tumors which are already there, okay, which are already at risk. So, if you are not very sure retinoblastoma and you want to pick up the intraocular calcification, we should do an MRI as investigation choice, or you can do an ultrasound also. We don't have an MRI, but do not do CT scans or X-rays because it will worsen. It might cause increase in the frequency of the secondary cancers. And the hallmark of retinoblastoma is the famous flexner windsand rosettes. You know that when you cut open the tumor and we stain with hematoxylin and eosin, you will find this very famous. It's called rosette. It's called a rosette because it looks like the rose windows of a church, and this is called as the flexner windsand rosette. You have to remember FW rosette. This is the hallmark. The minute you see this, you know that you have retinoblastoma. Okay? And then what about the treatment? Treatment is based on the classification, which is based on the International Classification of Retinoblastoma, ICRB. This is how we do that. And ICRB, what it states is that it divides a retinoblastoma into 5 stages. Okay, from A to E. A is the smallest possible tumor with size equal to 3 mm. Okay, you don't have to memorize it, but I'm just telling you it's based on number 3. So stage A is a very small tumor less than equal to 3 mm. Then stage B is a tumor which is more than 3 mm. Anything more than 3 could be 5, 6, 7, whatever. Then C is for localized seeds. Okay, localized seeds means that retinoblastoma is now carrying seeds, but these seeds are within 3 millimeters of the main tumor. It has to be within 3 millimeters of main tumor. This is localized seeds. And then diffuse. D is for diffuse seeds. Now you have seeds again, but this can go beyond 3 millimeters also of the main tumor. It can go beyond. It's basically based on number 3. And stage E is the name given to a retinoblastoma which is massive, which covers more than 50% size of the eyeball. We call it stage E. Okay, it's not so difficult. Remember, it's based on the size and on the number 3. Okay, so stage A less than equal to 3 millimeter, stage B more than 3 millimeter, stage C with localized seeds. So already you have seeds in the tumor, in the eye, but it is within 3 millimeters of the main tumor. Stage D diffuse seeds, because it crosses that 3 millimeter barrier and goes outside more than 3 meters away from the main tumor is stage D, and finally stage E, so huge that you have to, there's no way except it fills up the entire retinal blastoma. 50% or more of the sclera is filled. This is stage E. This is stage A, and for very small tumors like stage A, what we do is do laser photocoagulation and thermotherapy. You take a laser beam and focus on the tumor. Okay? Remember, the laser beam, it focuses not in laser photocoagulation, not on the tumor per se, it destroys the blood vessels feeding it. Okay? These are all feeders. Once we destroy the heat of the laser, destroy the feeders, the retina would die out. So this is called laser photocoagulation, which is done, this thing, for very small children, because the very small tumor, less than 3 millimeter, or you can do transpupil therapy, TTT. TTT means you take through the pupil, you take a rod, which is heated, this is thermo, and you apply the rod to the very small tumor, the heat will destroy the tumor. So these are done in very small stages, stage A, which means less than 3 millimeter. Then sometimes we use EBRT, which is generally not used. It's called external beam radiotherapy. Okay? Remember, this is very, very damaging. It causes a lot of problems to the patient. So, but we can do it for recurrent disease, not respond to anything. Sometimes disease not respond to anything. So then we try EBRT, external beam radiation therapy, in a desperate attempt to treat the untreatable one. Okay? This is EBRT. Then that was the stage. What about BCD? The BCD stages, remember, they are too big for the laser photocoagulation thermotherapy. For them, we do chemotherapy. The chemotherapy is done for stage BCD, where you can do intravenous, inject intravitreally, and intraarterial. Intravenous is the most popular, where we use this therapy called VEC, 6 cycles of VEC. Okay, VEC, vincristine, etoposide, circumplatin, 6 cycles of VEC we can give, and this causes shrinkage of the tumor. The tumor shrinks in size, very useful. So we have this very useful thing called as the chemotherapy. For it can be given intravenous, is the most popular. Remember, VEC. Then intravitreal causes a lot of morbidity where you inject the vitreous cavity, but the latest one is intraarterial. Okay, intraarterial, which is injected in the artery. This is the best treatment because it goes straight to the artery, into the vein, into the lesion. It does not cause side effects like the other ones. And intraarterial, we use chemotherapy. The artery, remember, is in the ophthalmic artery, because this is, we talk about retina, we talk about the ophthalmic artery. So chemotherapy, we have 3 varieties. Intraarterial is the latest, intravenous is very good. And then, so this is the chemotherapy, and the last one, the last which I have not mentioned here, is the stage E, which is so large, which fills up more than 50% of retinal blastoma. There's nothing we can do about here except to take it out, enucleation. So take it out, because it's too big and nothing can be done. So if enucleation is advanced retinal blastoma, which occurs more than 50% of the volume, and along with that, it will sacrifice 15 millimeters of the optic nerve. You see, what it means is, suppose this is the eyeball like this, and this is the optic nerve here like this. So you don't cut the enucleation, you come here, you cut it here. You also sacrifice 15 millimeters of the optic nerve, because if I take it out here, it may already have metastasized to the optic nerve, and it will metastasize to the brain and cause death. So we play on the side of safety. We cut it not here, but here, 15 millimeters extra of the optic nerve, sacrifice it. And there are 3 main causes of retinal blastoma. Remember, it still causes a lot of deaths, particularly in India. 3 main causes: one, metastasis, invariably fatal, the child will die. The most common metastasis is via the optic nerve. Can you remember, always asked, the most common route of metastasis is via the optic nerve. Second could be intracranial tumors associated with retinal blastoma. The most common tumors with retinal blastoma happens to be the pinealoblastoma. Can you remember, with the pineal gland. This is the commonest tumor of the brain, intracranial, which is associated with retinal blastoma, is called as trilateral retinal blastoma. Shocking misuse of grammar. So when you have a bilateral retinoblastoma with a central pinealoblastoma, we call it a trilateral retinoblastoma, because bilateral. Invariably fatal, the child will die. Okay? And one more are the secondary cancers. The secondary cancers, just do retinoblastoma, this may kill the child. The most common, which is the osteosarcoma, remember, is the most common secondary tumor associated with retinoblastoma. Remember, if they are secondary tumor, do not answer the pinealoblastoma. Pinealoblastoma is not a part of the secondary tumor. Okay, pinealoblastoma is a part of the primary complex itself. So you are not to answer pinealoblastoma if they are secondary cancers. Secondary cancers are osteosarcomas most commonly, and that is why I said that we should not. I said we should not do the X-ray or CT scan in this one, because they will induce further secondary cancers. So now we come to this neuro-ophthalmology. Remember, neuro-ophthalmology is the interface of neurology with medicine. A lot of questions can be asked, which is from medicine and neuro-ophthalmology both. Let's talk about this. And the first thing we talk about, remember, the neuro-ophthalmology is neurology or ophthalmology. So optic nerve is involved. Okay? So optic nerve jab involved hoga, so the inflammation ho sakta hai, The optic inflammation of the optic nerve we divide into two types. One is called optic neuritis. Second is called retrobulbar neuritis. These are two different varieties. What's the difference? See, this is, look at me, and this is my eyeball, and this is my optic nerve, isn't it, like this? Remember that this watch is the optic disc, and optic nerve enters like this. So when the optic nerve is inflamed in front of the optic disc or in front of the disc is called as optic neuritis. But inflammation, if it is behind the optic disc, this is called the retrobulbar. From is behind, तो पीछे inflammation होगा तो retrobulbar, आगे होगा disc के तो optic neuritis. So the only difference between these two diseases, remember, is the part of the optic nerve which is inflamed. If it's inflamed behind the disc, we call retrobulbar. If it's in front, it's called optic neuritis. Okay, that's all. Otherwise, they are all the same pathology, same treatment, same clinical features. सब कुछ same है, except the difference of inflammation. That is the area of inflamed area. Let's talk about retrobulbar neuritis, and this is the most common cause. Remember, is multiple sclerosis, which means MS or multiple sclerosis is most commonly seen in 20 to 45-year-old women, so about young ladies. And I must tell you that so many of my young ladies sitting here in my audience today, they have chance of developing multiple sclerosis. And I still remember one of my own students from Bulgaria. She had MS long time back. When I saw her first time, she was in very bad shape. Okay, so remember, most of the optic neuritis occurs to young ladies only who suffer from multiple sclerosis. And so this can be asked as MCQ. Look at that. How will we ask this? We ask this MCQ as, what is the commonest ocular manifestation of multiple sclerosis? The commonest ocular manifestation of multiple sclerosis is optic neuritis or retrobulbar neuritis. Okay? And how does it present itself? It's called a sudden painful loss of vision, which worsens the ocular. Typically, remember, when you look straight ahead, this is not very painful. When you look up, down, left, and right, this is very painful, particularly the upward movement and the inward movement. Why particularly that? Because the upward movement is controlled by the superior rectus, and the inward movement is done by the medial rectus. Now, these two muscles are attached very close to the optic nerve sheath. So, when they contract and they pull on the inflamed optic nerve and cause pain. Typically, look up the pain there. Okay, so this is sudden painful loss of vision, worsens in ocular movements, very specific sign of optic neuritis or retrobulbar neuritis. And another very powerful sign is the famous color vision desaturation. What is that? All the bright colors, particularly red and green, they become desaturated, means they appear lighter colored. Okay, so you can see this here begins with bright red and green, and slowly at the end of the first week it becomes desaturated. Typically, patients say, doctor, it appears to be washed in water. ऐसे लगता है जैसे पानी में धुला हुआ है. Okay, colors are washed in water. ऐसे लगता है जैसे पानी में धुला हुआ है. So this is typically, we call this as color vision desaturation. And another famous important thing is, remember, the famous abnormal pupil, because the optic nerve, it controls the pupil reaction. What is the most famous pupil reaction? That when you flash a light, pupil constricts, and take it away, it dilates. Not. This is the most famous pupil. So this particular reaction is not followed in optic neuritis, because it is controlled by the optic nerve, and the optic nerve is damaged in optic neuritis. So this particular reaction, that the pupil constricts on flashing a light and dilates on darkness, is not obeyed anymore. It's called abnormal pupil reaction, which we also call as a Marcus gun pupil, and better known as RAPD, relative afferent pupillary defect. RAPD stands for relative afferent pupillary defect, is the same thing. Okay, do you remember Marcus gun pupil? All of you, Marcus gun ptosis we talked about yesterday when we talked about the connection between the LPS and the lateral pterygoids. That was the jaw winking ptosis. Okay, the same Marcus gun pupil, the same fellow, the Marcus gun, is named after Robert Marcus Gunn, ophthalmologist from the US. So Marcus gun pupil we call it, which will explain what is the Marcus gun pupil or RAPD. I'll just explain. It's an abnormal pupil reaction. And however, the hallmark, remember, the hallmark of the retrobulbar optic neuritis is the disc edema. Optic neuritis, sorry, not retrobulbar. The hallmark is disc edema, because disc edema is an inflamed optic nerve. You will see swelling of the optic disc. This is the hallmark of optic neuritis, without which you cannot diagnose optic neuritis. And this is very important. But remember, this disc edema, the hallmark, is missing in retrobulbar. Why? Because remember, retro means the inflammation behind the disc, okay? So retrobulbar neuritis, the inflammation is here. It's not affecting the disc remains normal. So remember, in retrobulbar, there will be no disc edema. In fact, that is the only difference between the optimal, that is how to diagnose retrobulbar, is the absence of disc edema in retrobulbar neuritis, okay? That's the absence, and that is why this is a very famous MC which has asked many times, is that which condition is described as a condition where the patient sees nothing and the doctor sees nothing. Patient sees nothing and the doctor sees nothing. Remember, this is a wonderful description of retrobulbar neuritis, because patient sees nothing because of loss of vision because of retrobulbar, and doctor sees nothing because there is no disc edema. This is absolutely normal. See, this is the disc edema that you can see in optic neuritis, but you can see the blurring of disc margins. See, I am drawing this out, blurring of disc margins here. But in retrobulbar, the disc absolutely normal, clear-cut margins, okay? The patient sees nothing, doctor sees nothing, because doctor kuch dikhta nahi hai, the disc looks normal absolutely, okay? Wonderful description. This is a description of retrobulbar neuritis. And then remember, again, visual field. Remember, I told you anytime the optic nerve is damaged, okay, you'll have visual fields because the optic nerve controls the visual field. So since the optic nerve is, you'll have visual field defect just like in glaucoma, but these are different visual defects from glaucoma. And let's look at this important field. There are two of them. One is called central scotoma, one is called centrocecal scotoma. Central scotoma means right in the center of the field of vision, you can't see anything, okay? And centrocecal, look, centrocecal. The word cecum refers to blind. Remember, the word cecum in Latin means blind. That's why this is called cecum. You know, it ends blind. You know, this loop of intestine, it ends blindly. So that's why it's called cecum. The word cecum means blind. So centrocecal means the center as well as the blind spot is covered by the scotoma. So remember, you can either have a central scotoma which covers the central area, or you may have a centrocecal scotoma which covers the blind spot as well as the center. Okay, so any of these two you can have. Remember not to get confused. In glaucoma, you had paracentral, which means close to the center. This is central. That was paracentral. This is centrocecal. That was paracentral. Don't get confused. They are different terms. Okay. So these are the difficult field effects in optic neuritis, retinal neuritis, and the treatment is, you remember this, IVMP, intravenous methylprednisolone. Remember, I have made you write IVMP because oral steroids are contraindicated. Okay? We do not give oral steroids here because it will cause recurrence of the optic neuritis. Okay, so remember IVMP, intravenous, has to be intravenous methylprednisolone. This is the treatment of choice, though it has no long-term recovery. I mean, it does not really change the visual. It just makes it faster. That's all. If you don't give steroid also, the vision will also recover, but it will be much slower. So for faster recovery, they increase the visual faster. That's all. But oral steroids should be absolutely contraindicated. Now we come to the PLR, the pupillary light reflex, which is the light reflection. Remember the famous reaction. The most important single reaction which the pupil always should obey is that when you flash a light, pupil constricts. We take it away, it dilates. Why? To prevent damage to the retina. It's not because the light can damage the retina. So whenever there's a bright light, immediately constricts to protect the retina, and when there's darkness, pupil dilates, okay, to able to retina to see. Now this is the famous PLR, we call it pupil light reflex, and it constricts pupil in response to light into retina. And so it has two components. Remember, it has two components. One is called the direct response, this PLR, and second is called the consensual. Direct and consensual. The direct means when you flash a light to one eye, whatever happens to that pupil, this is direct. It constricts or dilates. But when you flash to one eye, remember the reaction also takes place in the other eye also. This is called consensual. So whatever happens to the light, to the pupil under the light, it's called direct. What happens to the other pupil is called consensual. They always act together. You know why? Because remember the two eyes, they're connected together at the chiasma, isn't that? So this connected to the chiasma. So when you flash a light here, this also gets affected because they connect to the chiasma. So see what happens. When I flash a light, constriction, constriction. When I take it away, dilation, dilation. Okay? This is direct, this is consensual. So what happens to the pupil under the torch is direct. What happens to the pupil away from the torch is consensual. So again, this is constriction, constriction. You take it away, dilation, dilation. This is the direct, this is consensual. Okay? So this is a normal pupil. Any pupil, this is a very specific reaction, and any pupil which does not follow this is abnormal. Which does not is abnormal. There is a normal balance between, as I said, sympathetic and parasympathetic. So look at this beautiful picture. We're flashing a light to this pupil. It is constricting, but you can see this is also constricting. isn't it? Right? And they're constricting equally. It's not as if this is constricting more and this is constricting less, is it not? So this is a very powerful reaction. Remember, any pupil that does not behave, that is constriction on exposure to light and dilation in darkness, is abnormal. Very well. Now therefore, the next thing is, now we know the normal reaction called the pupillary light reflex, or the PLR. So now let's do the abnormal pupillary reaction, conditions where the pupil does not behave like this, which I've just told you. So what is that? One of the most famous is the Argyll-Robertson pupil. The Argyll-Robertson pupil, remember, is seen in neurosyphilis. You know neurosyphilis. Neurosyphilis is the third stage, the tertiary stage of syphilis. Syphilis has first stage, second stage, and finally it attacks the nerves, which is called late or tertiary syphilis or third stage syphilis, where it attacks the central nervous system, and that is why how the eye is also affected. What happens in neurosyphilis to the eyes? Remember, bilaterally posterior. So both the pupils, when you look at the eye, you will find both the pupils are constricted and irregular. So they will not be round, irregular, and you can see this picture: constricted, irregular, and bilateral pupil. This is the typical sign of neurosyphilis. But remember, there's one more reaction, which is, you see, because there are other pupils which are also constricted. You might confuse them with neurosyphilis if you didn't know the other reaction. For instance, like festoon pupil. You know, festoon pupil is in anti-uveitis. This is also the pupil is constricted also like this. This is also irregular. This is also irregular. How would you know which is neurosyphilis and which is festoon pupil? So this Argyll-Robertson pupil is a very important rule. We call it, when you flash a light, remember, it does not constrict. You take it away, it doesn't dilate. Remember, light is negative. Okay, light is negative, but accommodation positive. That means, you see, so when you flash a light, the pupil will not react. Why it will not react? It will not constrict or it will dilate. Why not? Because the neurosyphilis has damaged the light center. The light center, which controls the light reaction, is located at the dorsal midbrain, okay? And that is being damaged by the neurosyphilis, so that's why the pupil does not constrict to light. The second reaction, another way to test the pupil, is to ask the patient to look at a close object. Remember, three things happen: accommodation, convergence, and constriction. No? The pupil, it accommodates, it converges and constricts. So in this case, this is maintained. When you ask me to look inside a closed object, the pupil does constrict because the accommodation and constriction, that center is intact. That is not yet touched by the neurosyphilis. So therefore, it's a very famous thing. We remember this as light negative and accommodation positive. So flashing a light, the pupil does not constrict or dilate, but accommodate, ask him to look at near object, it constricts. Okay, so it does not constrict to light but to near vision, and this condition is often called as LND, which stands for light near dissociation. Light near dissociation means the light reaction and the near reaction, they are dissociated. That means light is not active, the near is. Okay, and this you can memorize by a very famous one called ARP, which stands for Argyll-Robertson pupil. Argyll-Robertson pupil, and it also for accommodation reflex present. That means it accommodates, but the light is negative. So this is called accommodation reflex positive. ARP, very famous, and remember, that's why very famous it is called a prostitute's pupil. You know, prostitute's pupil. Why prostitute's pupil? Because the pupil behaves like a prostitute. Why? Because like a prostitute, it accommodates. See, remember what is this? Light negative or positive, is not. So light negative or positive. So that's why it's so possible sometimes, because you might think it's because of neurosyphilis, and you know, prostitutes do have neurosyphilis. That's why sometimes we call it the prostitute pupil. But the better reason is it behaves just like a prostitute. How? Because just like a prostitute, it accommodates but does not react. Okay? So that is how it's proven. So please remember prostitute's pupil, Argyll-Robertson pupil. Then the second important pupil is the AD's pupil. AD's pupil is found in ladies. Easy to memorize. AD's is found in ladies. What sort of ladies? Young ladies. Remember, older women don't have AD's, and men also have less AD's. And typically, AD's pupil is found in young ladies. And what happens following a viral fever? Sometimes can be idiopathic also. It could be idiopathic also, could be trauma also, but most times following a viral fever, one of the pupil dilates. One pupil dilates and the other remains normal. You can see that here, pupil is dilated here, and this is normal here, isn't it? So one pupil dilates, the other remains normal. And why does this occur? Because you see, it's the viral reaction. So the virus attacked the eye, and just behind the eyeball, there is a structure called the ciliary ganglion. You know that there is a structure just behind the orbit. It's called the ciliary ganglion, and it causes inflammation of the ciliary ganglion, which is called as ganglionitis. Okay? Ciliary ganglionitis. And so these nerves get inflamed, and amongst this nerve is the third nerve. The third nerve passes through many of these nerves, and third nerve carries the parasympathetic fibers, isn't it? So what happens is that when you have the viral fever, it causes ganglionitis, it damages the third nerve, which damages the parasympathetic fibers because the parasympathetic fibers pass through the third nerve. Okay? So the parasympathetic fibers are damaged and they are not able to constrict. They're not able to constrict the sympathetic fiber, which is unbalanced now, it dilates that. You understand? This is the reason why this pupil is dilated, because the sympathetics are fine, the parasympathetics are damaged. The intact sympathetic dilates the pupil. Okay? So this is why in this case pupil is dilated, that's the reason. And again remember, just like Argyll-Robertson pupil, they also don't react to light. Again, there is a light negative and accommodation positive, but remember the reasons are different. In Argyll-Robertson also similar, they react light negative, accommodation positive. That means you flash a light, does not constrict, you take it away, it does not dilate, light is negative. But when you ask them to look at near object like this, the accommodation, they constrict immediately. Okay? This also happens in Argyll-Robertson, is also in ADs, but the reasons are different. Okay? The reasons are different, we don't have to go into them right now. This also obeys light negative, accommodation positive. But then tell me something, if both Argyll-Robertson as well as ADs obey light negative, accommodation positive, then how will I know which is which? Well, remember, simple, when you see light negative, accommodation positive in both occurs, that's true. But remember, AD's pupil is dilated and unilateral, but Argyll-Robertson pupil is constricted and bilateral. So watch out for that. If you have a light negative, accommodation positive, look at the pupil. Is it constricted? It's Argyll-Robertson. Is it dilated? It is ADs. Is it bilateral? It's Argyll-Robertson. Unilateral? It's ADs. Yes, that's how we differentiate. But as you kindly remember, the reasons are different for behaving like that. And then this, how do I diagnose this? How do I confirm this? I think that it could be ADs because a young lady whose pupil is not dilating, is dilated. Well, confirmation is by the famous pilocarpine 0.1 to 5%. Okay. So this is pilocarpine. What you do, you take a drop of pilocarpine. You all remember pilocarpine is a very powerful constrictor, isn't it? You take a very dilute solution, 0.1 to 5. Look at that. This is 0.1 to 5. Some of you who are following me, you might remember that we use the same concentration in a higher concentration, pilocarpine, 1.25% in testing for presbyopia. Remember, presbyopia new treatments I told you, pilocarpine 1.25%. This is 1/10 of that also. This is 0.125, this is essentially 1/8. So you take a very dilute solution of pilocarpine and put it on both eyes. You put it on both eyes, you will find that the normal eye will not constrict, but the abnormal eye will constrict. And if the abnormal eye constricts, it means it is the AD's pupil. Okay, so normal pupil does not constrict, but the AD's pupil does. But what is the reason? It's a constrictor, it should not constrict. So why does the normal pupil not constrict? Because you see, it's too diluted. Look at that. It's 0.1 to 5, it's 1/8. The pilo is simply too dilute to be able to constrict a normal pupil. But then why is it able to constrict the AD's pupil? It's able to constrict AD's pupil because of a concept called denervation supersensitivity. It's a physiology concept. When it says that any tissue in the body which is denerved means deprived of innervation, becomes supersensitive to acetylcholine. So because here the nerve is damaged, this is supersensitive to acetylcholine. So even very dilute amounts of pilocarpine, 0.1 to 5, they stimulate a little acetylcholine. That little acetylcholine is enough to cause constriction of this pupil because it is supersensitive. That same amount of acetylcholine is not enough to constrict the normal eye because it is not supersensitive. Okay, it is supersensitive in a damaged eye only. So this is the reason. So remember, in the exams they will just give you simple that a patient comes to you with a fixed dilated eye. No hints, no young ladies, no wild fevers, no nothing. There is a patient comes with fixed dilated pupil. What is the test? You will say it is the pilocarpine 1.25, 0.125%, beg pardon. Then the next abnormal pupil is what I mentioned before, RAPD, which stands for relative afferent pupillary defect. It's also called as Marcus Gunn pupil, remember, named after Marcus Gunn ptosis also. And this RAPD Marcus Gunn pupil is a highly abnormal pupil which occurs for any damage to the optic nerve or retina. Remember, asymmetric, look at this word, asymmetric. Asymmetric defect means that it has to be either one eye, okay, not both. Not both, because that's why it's called relative afferent, because relative means relative to the other. So if only one optic nerve is damaged, then you will have this. If both optic nerves are damaged, then you cannot see this direction. Asymmetric means that, or it means if both are damaged, then one should be damaged more than the other. Do you understand? That's called asymmetric. So either you have unilateral damage to the optic nerve or retina, or you have asymmetric, means one eye is damaged more than the other. That's called asymmetric. Only then will you have this pupil reaction, which is called as RAPD. or called as the Marcus gun ptosis. So that could be any damage to the non-specific damage to the optic nerve. It could be optic neuritis, it could be retinal neuritis, it could be optic nerve glioma, it could be CRAO, CRVO. So multiple causes. These are basically showing you damage to the optic nerve and associated retina, asymmetric and unilateral. What happens? You test so what you do the same test, remember the pupil light reflex, you do the same test, you just modify it, we call it the swinging torchlight test. We swing it from one eye to the other. Okay, so if the eyes are normal, see what will happen? As I swing the torch to my normal eye, it will constrict, and then I go to the other eye, this will also constrict. Again I come here, constrict and constriction like this. This will happen. No? This is called swinging torchlight. You swing it from one eye to the other, 2 seconds, 2 seconds, 2 seconds, 2 seconds. But what happens here is, suppose this eye is optic neuritis, this damage optic neuritis. So what will happen? When I go to normal eye, it will constrict. But as I move to the opposite eye, it will dilate. Now that is abnormal. You know that whenever light falls on an eye, it should constrict, but it dilates. Again, when I come back here, it constricts, and go there, it dilates. But why does it dilate? Because this is the abnormal reaction. It dilates because the optic nerve is damaged. It cannot come and conduct the impulse to the brain because it's damaged, and the brain thinks it's dark and tells the people. You understand? So again, I come to normal, constriction, come here, dilation. Again, I come here, constriction, and come here, dilation. This abnormally dilating pupil, when it should have constricted on exposure to light, is the Marcus gun pupil, or RAPD, so abnormal dilation of the pupil on exposure to light is the Marcus gun or RAPD, which is the hallmark of optic nerve damage of any cause, be it optic neuritis or retinal neuritis or optic nerve glioma or whatever. Okay? So normal pupil should constitute stimulation, and disease pupil dilates abnormally like this, we know. But in this case, when the disease pupil, rather than constriction, it dilates abnormally. This is what you see here. We have pupil is dilated here. Okay, so we have seen here, what we see here is actually on flashing light is dilating, and this is the famous RAPD, which is also called the RAP Marcus gun, which is a sign of abnormal optic nerve or retinas. Okay, so this is how it is. Very important thing to have. And therefore, the next thing is coming to be Horner. So the next pupil, important pupil is Horner's pupil. Horner's pupil, Horner syndrome pupil, जो है उसमें क्या होता है? Remember, you have to memorize this by OSP. So oculosympathetic paralysis. That means the sympathetic, like the parasystem of the eyes are paralyzed. So for multiple reasons, बहुत सी reasons होते हैं. For multiple reasons, the sympathetic plexus of the eyes is damaged. Okay, and that's called oculosympathetic paralysis. That leads to Horner syndrome. And the famous triad of Olmers, the ptosis, meiosis, and anhydrosis. Okay, please remember PMA, not PMS, from which we have suffered enough, but PMA stands for ptosis, meiosis, anhydrosis. Anhydrosis means absence of sweating. Absence of sweating, classic triad. These are the three things you require. Okay, we don't need more than that. There are many other things that occur in Horner's. You need only this. So this is ptosis, and you can see here in this picture, you can see the ptosis here and the meiosis here compared to this is the Horner syndrome. But why look at the ptosis, why this is so small? Why the ptosis is not the entire ptosis? Because remember, the ptosis is due to the Mueller's muscle. Remember that we have 3 muscles to open the eyelid. The most important is the LPS, which opens widely. The second muscle to open the lid is the Mueller's muscle, which opens the eyelid only 2 millimeters. And this is supplied by the sympathetic system. So when you have damage to the sympathetic plexus, is the Mueller's muscle which gets paralyzed. So it is not able to open the lid, and the ptosis only very little, because that is the little action of Mueller's, only it is able to open only 2 millimeters. So it's closed only 2 millimeters only. Okay, so remember, this is often asked, which muscle is responsible for the ptosis in Horner syndrome? Can you remember? It's the Mueller's. It's not the LPS. LPS would have severe ptosis. Okay, and anhydrosis, PMA, anhydrosis, absence of sweating. Remember, this is congenital Horner's. So we have this Horner syndrome, and we have 2 types. We have one called congenital Horner's, we have acquired Horner's. Yeah, acquired Horner's is the one that I've just told you, ptosis, meiosis, anhydrosis. In congenital Horner's, which is from birth onwards, remember, there's one extra feature. That extra feature is called as heterochromia. Okay, so remember, if you have extra feature of heterochromia, then this comes in congenital Horner's. What is heterochromia? Hetero means different, chroma means color. So remember, the 2 iris are of the different colors. That's called heterochromia. If you have heterochromia, that means you have congenital Horner's. But you can see here, they are the same color. They are the same color, no? So this is not This is not a congenital hornus, it's acquired hornus. Acquired hornus has the same iris color. So if you have different colors, then it becomes heterochromia. And so why do we need to know whether it's congenital hornus or acquired hornus? Remember the different causes. Acquired hornus, the most common cause, can you remember, is Pancoast tumor, the tumor of the lung apex. If we have a tumor of the apex of the lung, how does it have hornus? Because remember, it damages the sympathetic part of the brachial plexus. Remember, the sympathetic component of the brachial plexus looping from the apex of the lung like this, and the tumor, it damages the sympathetic part of the brachial plexus, and that's why it leads to Horner syndrome. Okay, so Pancoast tumor is a very important, one of the most common cause of Horner syndrome. So remember, we can diagnose a life-threatening condition by looking at the iris. Internal carotid artery dissection. Remember, this is a very painful Horners. When you have painful Horners, typically there is an internal carotid artery dissection. That means it ruptures. And you know that around the internal carotid artery, there is a sympathetic plexus, no? If the artery ruptures, so the sympathetic plexus is damaged, so it leads to a painful Horners. So remember, normally Horners is not painful, but if it's painful Horners, that means it is caused by internal carotid artery dissection. Okay, so two important causes of acquired Horners. In congenital Horners, there is extra heterochromia I just mentioned, and the reason is due to birth trauma. Okay, birth trauma. So what is that? During delivery of the child, birth trauma suffered by the child, not to the gynecologist, who also suffer from birth trauma sometimes. So in birth trauma, when you are, suppose there is an obstructed labor, and you are using forceps to deliver the child. As you put the clamp, on this, sometimes the clamp clamps the shoulder, and the pressure of the clamp, which is very powerful, it damages again the sympathetic component of the brachial plexus. So again, the child has oculosympathetic paralysis, leads to Horner syndrome. You might want to ask why you have heterochromia. Heterochromia is because there is no, when in child what happens, why does the iris look brown in color to us? Because of the deposition of the pigmentation on the iris by melanocytes. So shortly after birth, remember, the melanocytes, they migrate to the iris and deposit pigment, melanin, which causes the brown colored iris. But this, remember, this migration of the melanocytes to the iris is controlled by the sympathetic plexus. Now this poor baby, from birth onwards, because of the oculosympathetic paralysis, what has happened? The sympathetic plexus is damaged, so there is no migration of the melanin to the iris. The melanocytes to because they are controlled by the sympathetic. So sympathetic is damaged, so it stops the migration of the melanocytes to the iris, and that is why there is no deposition of melanin onto the iris. It remains lighter colored, it becomes heterochromia. Okay, so that's the reason. And the confirmatory test, the powerful cocaine test. Remember, cocaine is one of the most powerful mydriatics on the Earth's surface. Okay, it dilates all pupils, but the one pupil it does not dilate, it cannot dilate, is the Horner syndrome. This is the only pupil it cannot dilate. Suppose you suspecting Horner syndrome, you take one drop of cocaine. You take one drop of cocaine and put it on both eyes. Okay, put it on both eyes. You will see the normal eye will dilate within 1 hour 10 millimeters. 1 घंटे में pupil dilate हो जाएगा 10 millimeters. Okay, but this is the Horner's pupil. It will not dilate. Okay, this is the only pupil which is not dilate with cocaine syndrome, cocaine, and that is the test that tells us that this is a Horner syndrome. The only problem is that obtaining cocaine, because cocaine is highly addictive in its potential. And even we as doctors are sometimes, not able to get cocaine because the pharmacist just refuses to give us unless he is convinced of the fact that I'm a doctor. So many times it's happened that I have been asked for cocaine and the pharmacist looks me up and down like this. And he says, "You're a doctor, I'm a doctor." And I said, "No, मैं गुब्बारे बेचता हूँ." So he sees me every day and yet he behaves like this. Can't blame him because cocaine is so highly addictive. Okay. Right, so we have got 4 important pupils, can you remember, to summarize. Now these are very important pupils. You will encounter these questions not only in medicine and ophthalmology but many others. So can you remember, Argyll Robertson seen in neurosyphilis. मैं summarize कर रहा हूँ, I'm summarizing. Argyll Robertson pupil in neurosyphilis, and both bilateral irregular pupil, light negative, accommodation positive, prostitutes pupil. Okay, and ADS pupil, young ladies after viral fever, one pupil dilates, the other remains normal. Post viral fever damages the parasympathetic plexus of the third nerve, so it cannot constrict. So the sympathetic, which is undamaged, will dilate the pupil. And for young ladies are viral fever, and they are diagnosed by the powerful test, which is pilocarpine 1.25%, where the normal pupil constricts. Normal pupil does not constrict, beg your pardon, but the abnormal pupil constricts immediately. So this is ADS pupil. Marcus gun or RAPD is seen in one of the optic nerves is damaged, or even if both are damaged, they should be asymmetric. That is, one is damaged more than the other, or the optic nerve. So any optic nerve damage, be it optic neuritis, optic nerve gliomas, optic nerve tumors, meningiomas, whatever it is, if the damage are one optic more than the other or the retina, lead to RAPD, or called the Marcus gun, where when you flash a light, pupil dilates. Rather than constricting, it dilates. This is RAPD. It's a non-specific sign of optic nerve damage. And then the Horner syndrome is oculosympathetic paralysis of the eye. It could be any causes, could be congenital, could be acquired. If it's diagnosed by ptosis, meiosis, and hydrosis, and if it's congenital, you have extra additional feature of the heterochromia. The most common causes of acquired are usually Pancoast tumor and internal carotid artery dissection, and for congenital Horner's, it is usually birth trauma. Okay? And to confirm your Horner syndrome, you have to do the cocaine test, which the Horner's pupil is not able to dilate. The Horner syndrome pupil will not dilate with the cocaine. The other normal pupil, every other pupil dilates with cocaine. Okay? So this is what 4 important pupils we have, and therefore this is what is going to be. Now we are going to a quick one on papilledema. So papilledema, look at this word called papilledema. Papille means disc, edema is swelling. So this is disc swelling. Okay, it's a very short topic. So there is disc swelling, but what is the difference between disc swelling of papilledema and disc swelling of optic neuritis? Remember, there is swelling of disc in both. Remember, papilledema is very specific because it means disc edema with raised intracranial tension. Remember, not intraocular pressure, intracranial pressure. Okay. So whenever the cranial pressure increases, if it leads to a disc edema, that is what called as papilledema. Kindly remember, the normal ICT is 50 to 180 millimeters. What is the range of normality? 50 to 180 millimeters of water. Remember, we measured millimeters of water, not mercury. Okay? And so, if it is more than that, so in adults, if it is more than 200 in children and more than 250 in adults, 180 is cut off. If it is more than 200 in children and more than 250 in adults, this leads to raised ICT, and this causes disc edema, which is called papilledema. So remember, papilledema, you can only use the term when it's raised ICT for whatever reason. So one of the most common causes are the traumatic brain injuries, TBIs. That means you get hit in the head in an accident, as it often happens after a bike accident. Okay, so you get hit in the head, and post-traumatic, this bleeding occurs. So this bleeding occurs, and they will increase the pressure of the cranium. So pressure will rise, and this increased pressure will be transmitted to the disc, will become edematous. Okay. So traumatic brain injuries, or ICSOLs, which stands for intracranial space occupying lesions. Okay, intracranial space. That means this is a better term for brain tumors. Brain tumors scare the patients when you say intracranial spinal lesion. These are brain tumors. Again, raise the pressure, and subarachnoid hemorrhage, where there is bleeding inside the brain. Subarachnoid hemorrhage takes place, and again raises the ICT. So these are multiple causes. There are many causes. In all these causes, because the pressure rises, they are transmitted via the optic nerve to the disc, and you have disc edema. So this is called, remember, the most important thing here, how to differentiate from disc edema optic neuritis, is that is bilateral disc edema. You can see the disc edema here, because it's a raised ICT, it will be transmitted to both the discs. So papilledema is always bilateral, except in very rare cases, and optic neuritis is always unilateral. Okay? That is how it differentiates. That's the best way. Another thing that happens in papilledema is because raised ICT, it often compresses the sixth nerve. So sixth nerve is a very long nerve. Okay, it's one of the longest under the arachnoid mater, and because it transmits a long way, so the raised ICT, what it does, it pushes the brainstem down. As it pushes the brainstem down, the herniating brainstem, it pulls on the sixth nerve. The sixth nerve is trapped in the Doyle's canal, and as the brainstem goes down a little bit, it pulls on the sixth nerve like a plucked guitar string, and the sixth nerve gets paralyzed. Remember, sixth nerve is supplied lateral rectus, so immediately the eye will develop a squint like this when the medial rectus forces the eyeball inwards like this. Okay, lateral rectus gone, the medial rectus will force the eyeball inwards like this, eye becomes like this. This often happens. So remember, sixth nerve pulse is an important sign, can you remember, of papilledema. Okay, because you might think it just looks like a squint. It could be squint, but it's not squint here. It's because of the sixth nerve paralysis caused by papilledema. And the earliest sign, remember, it can be either blurring of nasal disc margin. Okay, so of what happens, suppose this is the nasal area, this is the temporal area. So usually it is the nasal disc margin which occurs blurred first. Okay, in papilledema, this is the first sign. But an even earlier sign than that is the loss of spontaneous venous pulsation. Okay, Remember that on the optic disc, the veins are pulsating. I told you this, or if not, let me tell you, there are only two veins in the body which pulsate. Okay? Normally, the veins don't pulsate. No, the arteries pulsate. But there are two veins in the body which pulsate. One is the jugular pulse. Here, you can feel the jugular pulse here because the internal carotid artery pulsations are being transmitted. The second pulse is the spontaneous venous pulse on the disc. Okay? It is also pulsating. It is the second vein which pulsates in the body. But the reason is not because of transmitted pulse. Okay? That's a different reason. What happens in papilledema is you stop, the pulsations stop. Okay? So normal venous pulse should be pulsating, but if there is no pulsations, then this is the even earlier sign of papilledema. So you can have any one of them. This is actually the first one, loss of SVP, spontaneous venous pulsations. But sometimes we don't give you this choice. Then if you remember, blurring of the disc margin. Then what about the field effect? Remember, every time there is optic nerve damage, you have to have a field effect. Here, the important field effect called enlargement of the blind spot. All of us have a normal optic disc. Remember, the optic size is 1.5 millimeter. The size of the blind spot is also normal. Normal spiral blind spot about 7.5 by 5.5 degrees. Okay, you measure in degrees, 7.5 to 5.5 degrees. But here it becomes enlarged. Enlargement of the blind spot, the typical sign of papilledema, where there is enlargement of the blind spot. This is the most common visual field effect of papilledema. Okay, so then this is a raised, so please remember, papilledema is raised disc edema, raised ICT causing disc edema. The treatment we are not covering here because treatment comes more on neurosurgery. Basically, you have to lower the ICT, we have to control the ICT. It's not a lower ICT, which is not ophthalmic measurement. So we do the neurosurgeons, we give it to them, so they will have to reduce the intracranial pressure, and then only then you can have ICT going. So I can tell you for the drug of choice, sometimes we like to ask drug of choice. So drug of choice papilledema typically is astazolamide. Okay, astazolamide, you all heard of drug. This also causes CSF production to reduce. It also causes the not only the intraocular pressure to come down, it causes the CSF pressure to come down. So it reduces the CSF, and it may sometimes treat the papilloma. There are many other treatments which we'll not go into right now. And then we have neuroophthalmology. The last thing and the most important probably in this case is the visual field effects that we like to ask you. Visual field effects of this thing. Let's talk about this. The visual field effects are probably the most important questions in your often asked. It's a little complicated. But before we do that, we need to go to visual pathways. Okay, visual pathways. There are 7 systems of as the light flashes to the eye. Suppose you flash a light to the eye. It takes 7 pathways before it reaches the brain. Is it not? Which is that last stage is the occipital lobe, which is the smallest lobe of the 4 lobes, where on the occipital lobe lies the primary visual cortex, which is the last thing. But how does it reach the primary visual cortex? Well, it passes through 7 steps, which you have to remember right now. And the first is when you flash a light to the fovea. Remember, the light falls on the fovea. That is not a part of the system. So from the fovea, it goes to the optic disc. You can see this is the optic disc here. This is the first of the 7. From the disc is to the optic nerve. This is the optic nerve. Then it crosses over at the chiasma. This is the optic chiasma. Then it becomes the optic tract. This is the optic tract. The optic tract then goes into the lateral geniculate body, the small pyramidal body here. From the lateral geniculate body, the 2 vast fibers run called the optic radiations, and finally they go to the primary visual cortex, which lies in area 17. Where exactly the primary visual cortex? Remember, anatomical knowledge you should know. It lies on the calcarine sulcus. Okay, there is on the brain, there is the occipital lobe, there is a small sulcus which is called the calcarine sulcus. On the wall of the medial wall of the calcarine sulcus lies the primary visual cortex. Okay, these are the 7 stations of light traveling before it reaches the brain. So what is that again? It starts with optic disc, becomes optic nerve, becomes chiasma, optic tract, lateral geniculate body, optic radiations, and primary visual cortex, which lies on the occipital lobe. Okay, so these are 7 stations, and this is the 7 stations, and therefore any damage anywhere, this particular area of the brain is extraordinarily susceptible to strokes because it's very densely packed and the blood vessels are not so well developed. So often you have ischemic strokes or thrombotic strokes, and when you have strokes, so this brain tissue is damaged and it leads to other field effects. Now these field effects, by way of anatomy, we can diagnose by just the field effects where the lesion is. Okay, because of a knowledge of anatomy, we can diagnose. We don't have to do a CT scan to find out where the lesion is. Look at these important field effects. and you have to memorize them quickly. Remember, the field first one is, suppose you have a field defect in the, we call it as prechiasmal. You can remember any thing that is before the chiasm called prechiasmal. So remember, if you have optic chiasm, let me talk about optic chiasmal lesions, or the chiasma here. Okay, so when you have optic chiasmal lesions, you have this condition called as bitemporal hemianopia, which you can see here, both the temporal halves. So this is the temporal of my left half, temporal right eye, both the halves get damaged. This is called as bitemporal hemianopia. So if you have a chiasmal lesion, remember you'll end up with bitemporal. Why? Because only at the chiasma do the nasal fibers cross each other and they can get damaged easily. Then crossing, if it's pre-chiasm, that is before the chiasma, before it comes to chiasm, therefore, the lesion will be one-sided only. Remember, monocular blindness. So if you have a problem in only one eye, field defect in one eye, monocular, that means the lesion has to be in front of the chiasma, which is pre-chiasma. Anything at chiasma and behind the chiasma will be bilateral. Remember, pre-chiasmal lesion is always unilateral and same-sided. Monocular blindness is same-sided and uniocular. Then optic tract. The optic tract lesions, as it damages the optic tract, it causes homonymous hemianopia. Okay? Occipital lobe lesion leads to macular sparing. You can see the macular sparing here, where what is happening is that you can see it's a left-sided incomplete homonymous hemianopia. Look at that. It's incomplete because this particular area is not damaged. So it's called left-sided incomplete homonymous hemianopia with macular sparing. For short form, we call this just macular sparing. And macular sparing occurs due to occipital lobe lesions due to anatomical fact which is called as dual blood supply. Okay, so to remember, for this is the main important field defects that I'd like to ask you. I haven't explained this because this too involve a long explanation. For those who want to know the explanation, you have to attend my classes and see how we explain this beautifully. This is a very conceptual topic. So again, to summarize, remember, you have a pre-chiasmal lesion which is before, somewhere here, before the chiasm. The damage is here. Then you have a same-sided blindness, monocular, same-sided, and it is always unilateral. Okay? If you have a chiasm lesion like this, then you have bitemporal hemianopia. If you have a optic tract lesion like this, you have an opposite-sided homonymous hemianopia. What about genital body lesions? Genital body lesions, remember, are very rare. They are vascular and they're very rare, so they don't work, so we don't ask you. Optic tract lesions, you have a pie in the sky or pie on the floor, and occipital lobe lesions, finally, we just talked about, is the sparing, the macular sparing field defect. Okay, so these are the most important field defects that we need to know. Most commonly asked questions are usually bitemporal hemianopia, and now there's macular sparing also. With that, we finished our neuroophthalmology, and now we go to the squint. And we go to one of the most difficult subjects in ophthalmology called squint strabismus. And let's look at that. Squint strabismus is patient. But before that, we need a quick hurricane summary of all the ocular movements here. Where see the extraocular muscles. Remember, I told you there are 6 ocular muscles, including the LPS, it becomes 7. So superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. Very simple. Positional wise, we mentioned on this position, superior, inferior, medial, lateral. And whether it is straight or oblique. If it's attached straight, called rectus. If it's attached obliquely, it's called oblique. So you see it here. So each eye has 6 muscles, and including the LPS, it becomes 7. And what are the actions? Remember the actions of this thing, each of muscles, you have to memorize them. The lateral rectus and the medial rectus, remember the simplest. Lateral rectus and the medial rectus are the simplest muscles because they have only one action each. So laterally, to take the eyeball out, it's called abduction, and it is medial will take the eyeball in, it's called adduction. It's not. So medial rectus does only adduction, which moves the eye towards the nose, and lateral rectus does only abduction, which moves it away from the nose. Okay, so it's like this. That's simple. What about the other 4? The other 4, superior rectus, inferior rectus, and superior oblique, inferior oblique, all 4, they have 3 actions each because of their oblique angle of origin and this thing attachment. So they give you not only one but 3 different actions, and that we have to sometimes remember the 3 actions. Remember this by the famous SYNRAD mnemonic. Okay, this is a mnemonic provided by the American Academy. Let's look at the first half. SYN and second half is RAD. Okay, so this is the SYN. It refers to superior muscles cause intorsion. Okay, S for superior, in for intorsion. So whatever muscles are superior, remember they'll cause intorsion, rotate inwards. So what is that? Look at that. This is superior rectus and this is superior oblique. They are superior muscles, so they will have intorsion. So whatever superior muscles, they cause intorsion. Okay, so this is what SYN is. Now if the superiors are intorting, What will the inferiors do? Remember, they will be extorting naturally. No? What are the inferiors? We have the inferior rectus, which is extortion, and inferior oblique, which is extortion. So you see that's how. So superior is intort, inferior is extort. And then we have the second half, rad. This stands for rectus causes adduction. The rectus must cause adduction, R-A-D, add for adduction. The rectus will all occur. Let's look at the two rectus, superior rectus, inferior rectus. Both of them cause adduction, okay, because it is R-A-D. Now, if the rectus adduct, what will the obliques do? If the rectus is straight, oblique is like this. Obliques cause abduction. So both of them, superior oblique, inferior oblique, they cause abduction. Okay, so that's simple. And now we need just the names for elevation, depression. Remember, look at the name, superior rectus. It's a superior muscle, so it will elevate the eye, the elevation. Superior rectus cause elevation. Inferior rectus, remember, inferior looks down, inferior means down. Inferior rectus is called depression. But the obliques, one is superior oblique, inferior, they do not obey the simple rules. They do exactly the opposite. If it's a superior oblique, rather than going superiorly, it goes exactly opposite. It causes depression, superior oblique. And inferior oblique, which it should have gone depression, it goes exactly opposite. It does elevation. Okay, that's it. This is syndrome mnemonic, simple to mnemonics. Superior is intort, rectus adduct. That's what it is. Superior is intort, rectus adduct. So superior is intort, inferior is extort. Rectus adduct and the obliques abduct. Okay, so this is how you must remember the actions of the muscles. And then terminology, various terminology you should be careful about. First is tropia. Tropia means obvious, manifest squint that is visible to us. The squint is like this or like this, visible to us. Phoria means latent squint. That means the squint is present, you can't see it. Look at this lady from Hyderabad, and she looks perfectly normal, but she came to us for squint, and she did have squint, but it's not obvious, it's latent. Okay? So then what is the condition named to? The eyes which are parallel, the eyes which are parallel, these are called orthophoria. Ortho means straight. When the two eyes are parallel, then we call it orthophoria. Okay? Whenever straight eyes. And if the eyes are not parallel, one is in or one is out like that, this is a squinting eye, this is called as heterophoria. So ortho straight eye, heterophoria squinting eye. Who has orthophoria? Remember, nobody has orthophoria. All of us have squints. The only person with absolute ortho eyes is he himself, because he has absolute paralysis. All of us, we have some squint or the other, so none of us are really actually orthophoric. Okay? So heterophoria is the name for squint. Then the four terms which are self-explanatory. Remember, exotropia means it has gone out, exo. Ezo means one eye has come in, ezo. Hyper means one eye goes above the other. And hypo, one eye goes below the other. Okay? So please remember these four. It is easy to memorize. Exotropia means one eye is out. Esotropia, one eye is in. Hypertropia, one eye is above the other eye. And hypo means one eye is below the other eye. Okay? So this is how we develop this. It's quite simple. The terminology should be clear. If there's a manifest squint means that you can see the squint. This is called as tropia. And phoria is squint, which you cannot see. But tell me something, why can't you see the squint? Squint? You can't see the squint. See, the squint can't be seen because the two eyes are balanced by two muscles. So if one eye is like that, the other will also become like that and try to copy this. So it becomes normal. It looks normal. If the other eye is out like this eye will also go out like this, and again they will become parallel. You see, the two muscles, they tend to keep the two eyes under parallel when the muscles have strength. So most of us, we don't have squints. But once you get tired or exhausted or irritated or upset or frustrated, immediately you will find the two eyes are not able to contract well, and so one eye goes out, the other eye cannot go out, and you will clearly see the squint manifest. So remember, phorias are not seen simply because the two eyes balance each other. Okay? One eye goes out, the other goes out. The other goes out, it goes in like this. Okay? The phorias are not visible because the two eyes balance each other. To see phorias, we have to disrupt the barrier, to disrupt the fusion, or make the muscles so tired that they cannot hold up to tropia. Okay? So please remember that phorias cannot be seen unless we break the fusion. Because we break the fusion by closing one eye or making the patient feel so tired or exhausted that the muscles don't contract. So you can see here, this is what you can clearly, this is what you can see obviously, is the hypertropia. One eye is above, and this is esotropia. You see this clearly. Okay? This is what happens. And then some other terminology. Phorias, let's look at that. Latent squint is visible during exhaustion. Let's look at the phorias now. So remember phoria we just talked about, what is that? The phorias are not visible. They are the ones that are not visible to us. They are parallel. They help. Why they are parallel? Because the two eyes are being balanced each other. So when the muscles are not, they are not very active, when the muscles are not exhausted, when they are fresh, then they will hold the two eyes parallel. But when the eyes are tired, exhausted, irritated, frustrated, then they cannot hold the eyes together, and one eye will go out, the other will not. It will become tropic. Forea becomes tropic. So when retinal vision is visible during exhaustion, remember whenever you are tired and exhausted, which is happening to most of you, if you look at your own eyes, you will be drifting off to sleep, or you will have to squint also. Or fusion disrupted. Fusion, which means the two eyes fuse each other, that is disrupted when you're exhausted. Symptoms of phoreas, what are they? How do you know? Eye strain, okay? And asthenopia, because the two eyes are not parallel, no? So the effort of trying to maintain them, the effort of trying to maintain the parallelism creates eye strain, headaches, and eye fatigue, which was the basic strain of phorea. So often patients come to us and say, Doctor, I am feeling exhausted and tired and headachy and all. What is the reason? This is because of the poor fusion that they have. Okay, they have the poor fusion they have. So this we have to know about. Then this is the cover test. We have these cover tests we have to know. For the cover test, you have to know called the two important tests I want to tell you called the cover tests. One called the cover. What do? You cover one eye and look at the other. Okay, see what happens. So suppose one eye is, this is called cover test. When you cover one eye, look at the other eye. Okay, and then you cover this eye, look at this eye. This is called the cover test. What does it do? It detects the tropias. Okay, it detects the tropias. Okay, so what happens? Supposing I have a squint like this. Okay, one eye say goes out like this. Now you want to take the squint. When you cover this eye, what will happen when you cover this eye? This is squinting out, no? This, and you ask the patient to look at a torch like this. So the torch, when the patient flashes, when you look at the torch, the patient looking at the torch, the normal eye, the right eye, looking at it, but this eye has squint, let's say. It's a tropia, no? Because it's manifest. So while looking at torch, suppose you cover this eye of the patient. When you cover this eye, immediately this eye moves in, okay, to look at the torch. Okay, because you have to instruct the patient to look at the light. So normally it's squint, because this is squinting outward, but when you close one eye and he has to look at the light, this eye moves in to look at the light. So this movement is detected, and this movement tells us that he has a tropia or a manifest squint. So you close one eye, look at the opposite eye, is the test called the cover test. Okay, this is for tropia. Now how to detect phoreas? For phoreas, which are the ones that are not visible, remember, we do a cover-uncover test. Okay, what is that? You cover one eye and uncover other. Okay? You cover and uncover and look at the same eye. Okay, remember cover test, the first one. I cover this eye, look at the opposite eye. In the cover-uncover, I cover and uncover this and you look at the same eye, which was under the cover. Okay? So this will detect phoreas. If you have movement of the eye under the cover, it means it is a phorea. If you have movement of the opposite eye, that means it is tropia. Okay? So cover test specifically tests for tropias, cover one for detection of phoreas. Okay? And then the next thing is how to calculate the amount of squint that the patient has, which is in tropia. We do the powerful Hirschberg test. So what we do, we take a torch and flash it on the forehead like this. Okay, ask the patient to look at the torch. Look at the torch like this. Okay. Now, if the two eyes are parallel, what will happen? The light will reflect off the cornea. Then remember, the two corneas behave like highly polished convex mirrors, you know. So when you flash a light, the light bounces off the cornea, and you can see the reflection of the light exactly in the center of the pupil if the two eyes are parallel. Look at that. Okay, you can see the two eyes are parallel, and you can see the reflection of light in the center. So this is a trope. There's no squint here, okay, because eyes are parallel. But however, if suppose eyes are squinting, one eye going out or coming in like this, then the reflection will be showing in the center of one eye, but not in the center because the eye is out or in like this. So that is what. So what happens? We detect the tropia by, look at that. So this is the, suppose the cornea, and in the right eye, suppose the patient is normal, the reflection will be seen here. For the left eye, suppose there's a squint, reflection will be seen somewhere here, okay, because the eye is moved out or in. So what you do, you know the center of the pupil is here, and this is where the reflection should have been, like this. But the reflection is here. So you measure this distance from the center of the pupil where the reflection should have been and where it is now. Where should have been center and where it is now. This amount of displacement or decentration away from the center. Okay? जितना amount of decentration है, you have to measure by the scale or a ruler, normal scale or a ruler. And what you do is you measure this, you find that each 1 millimeter of decentration away from the center is equal to 7 degrees also. Remember, very important question. Squint is measured in degrees. Okay, 1 unit is degrees, and each 1 millimeter of displacement is equal to 7 degrees. So अगर 2 millimeter है तो 14 degrees, 3 millimeter है तो 21 degrees. Okay, and there's another unit which is called prism diopters, and each 1 degree is equal to 2 prism diopters. Okay, each one is 2 prism diopters. So you can either calculate in degrees or prism diopters. So I prefer prism diopters. A lot of my friends prefer degrees. So you can convert them. So remember, 1 millimeter is 7 degree, and each degree is equal to 2 prism diopters. So supposing I have a displacement of only 1 millimeter, that means 7 degree squint, which is equal to 14 prism diopter squint, is not. So you can calculate 1 degree is equal to 2 prism diopters. So you have to calculate this and this thing. So supposing I give you the sum, that supposing I say that the deflection or away from the center, supposing I say is about 3 millimeters from the pupil center, somewhere over here. Okay, so 3 millimeter away from the center, displacement or decentration. So how to calculate the squint? Let us do that. 1 millimeter 7 degree, so 3 millimeter would be 3 into 7, which is 21 degrees, right? And if you want to convert in prism diopters, remember each degree is 2 prism diopters, so 21 degrees will be 42 prism diopters. Remember, that's how we calculate. So each millimeter is 7 degree, 1 degree to 2 prism diopters. Okay, this is 40 prism diopter. Also remember, you have calculated this correctly, 42 prism diopters, but you have not told me where is the squint. Is it exo, is it eso, is it hyper, or is it hypo? Okay, remember the reflection has gone out, so you would think exo, but it will be quite wrong. It is eso. Why? Because why has it gone out? Because the eyeball has moved in, is it not? If it has only gone out, that is because the eyeball has moved in. Suppose this is my eye, center of the eye, and this is the reflection here, the center. So if my eye goes inward like this, the reflection will fall out, no? This is exactly opposite. So this falls out, so this is actually esotropia. So the answer for this question is 42 prism diopter esotropia. Remember, the squint is in the opposite direction of the light. This is moved out, so the squint is eso. When moved up, it will have been hypo. When moved down, it will have been hyper. It's exactly the opposite. So this is the way to calculate for squint for tropias. Okay. Then tropias, let's collect that. Tropias means obvious squint. We divide into 2 types of comitant and incomitant. We divide that. So comitant, incomitant. So let's talk about comitant squint of tropia. So tropia means, suppose, what is this comitant? The word comitant means together. The word comitant means together. And as you can see, I've divided into comitant into 2 types of comitant and paralytic. Okay. Comitant squints can be divided. This thing, the tropias can be divided into comitant and paralytic squints. Okay. See, phorias we don't discuss too much, because you see, phorias we don't have to treat them. Most of the time the eyes are normal. We don't have to treat phorias because we just tell them to relax. We just tell them to relax, reduce the eye strain, and not get irritated. So it relieves the eye strain. So phorias we don't have to treat, but tropias we have to treat because they're obvious squints. And tropias we divide, as you can see, into 2 types of comitant and paralytic. So the word comitant means together. Remember, the word comitant means together. It's a squint that the patient is born with most of the time. It's inborn. And here, the angle of deviation remains normal, constant in all guys. You see, what happens? Supposing I am born with the comitant squint. Okay, so I am born with the comitant squint. Looks what happens to me. Suppose when I look at you, one eye is right is exo. Okay, so this is a comitant squint. So remember, we have 9 different gazes. Eyes can move in 9 gazes. What is that? 1 gaze, head straight, eye straight. 1 primary gaze. Then 4 secondary gazes. Up, down, left, and right. 4 secondary gazes. Okay, and 4 tertiary gazes. Up and left, down and left, up and right, and down and right. Okay, have you got that? So we have 9 gazes. 1 eye is straight, head straight, eye straight. This is primary, and 4 secondaries. Okay, what is that? Up, down, left, right. 4 secondaries, and 4 tertiaries. Up and left, down and left, up and right, and down and right. Okay, so 9 gazes. So what happens when I look in the primary gaze? Suppose I am born with a 5-degree exo. So when I look straight ahead at the camera, and my right eye is like this. Okay, so let's say 5 degrees. See what happens when I try to look ahead. This is the 2 eyes, no? So the eye moves together. Remember, the eyes always move together, and there is no paralysis, there is no restriction. So the eyes move equally. So whatever is 5 degree here, it will be 5 degree here also, it will be here also, there also, there also, there also, there also. No, because the 2 eyes moving together, there is no restriction, no paralysis, nothing at all. So that is why comitant squint is defined as a type of squint in which the angle remains the same in all 9 gazes. 5 degree, 5 degree, 5 degree, 5 degree, 5 degree, okay? And that's the definition. Remember, it remains constant, these patients. Okay? So this is what the word complement means together. The word complement means together, and that is why, because there is no deviation, because the angle remains the same in all 9 gazes. So these patients, they do not have any problem. Most of these patients are absolutely fine. They don't have any double vision, and they don't have any problems. They may have a cosmetic problem, but that's about all. They don't really complain of anything else. Okay, so this is the typical primary. And also here, also remember in Compton squints, remember the primary deviation is always equal to secondary deviation. Now this is another important niche PMCU which you should know, I think. And what is that? What is this primary deviation? Well, primary deviation is the angle. Remember that my squint is like this. Okay, look straight, right out. The primary is the angle between the two eyes with the normal eye looking straight. Okay, remember, normal eye looking straight. Look at that. So this is my normal eye, this is my abnormal. So when I look straight at you, this is 5 degree I told you. So my primary deviation is 5 degree because the normal eye is looking straight ahead. Okay, and what is secondary deviation? Secondary deviation is the angle between the two eyes with the abnormal eye looking, or the squinting eye looking at the straight eye. You see, this was the squinting eye. So primary deviation was 5 degree. So I push my eye, the squinting eye like this. I shift my squinting eye towards the normal, and as I shift my squinting eye, see what happens. This eye also moves away. This is also 5 degree because they're moving together. Remember? So all 5 degree for primary deviation, 5 degree for secondary deviation. Remember, in Compton squints, the primary is always equal to secondary. That's an important MCQ in the NEET PE question, but not yours, I might add. And once you've done so, Compton squints, remember what have we talked about? They are born with it. The angle is the same in all directions. They have no problems. There's no diplopia, no abnormal aspera, no problem coming at all. Only have a cosmetic problem, and the primary is equal to secondary deviation. There are 2 different types of Compton squints. 2 different types. One is called accommodative. The other is called non-accommodative. Called accommodative and non-accommodative. Let's look at that. Accommodative, non-accommodative squints. What's the difference? Accommodative means it is due to uncorrected refractive. Remember, I told you uncorrected refractive error. So this today only we talked about this, that if you don't wear glasses and have metropia, I told you, you develop a convergent squint. Remember? So when you have refractive error which is not corrected, which means you're not wearing glasses, so this will cause a accommodative squint, where excessive accommodation causes excessive convergence, and it causes a convergent squint. And uncorrected myopics will have a divergent squint. We talked about this. So if you don't wear glasses, it will go to divergent squint. So this is the type of 2 squints called accommodative because they are due to uncorrected refractive error. So treatment has to be 1 glass. You have to give them glasses like this. You see there, this is a typical convergent squint here, and look at the minute we put on the glasses, the squint corrects itself because the main cause is the refractive error, and as soon as you give them glasses, the patient stops accommodating excessive convergence stops, and the patient becomes normal. This is accommodative squint, and this is the typical accommodative squint that we are corrected by wearing glasses. Okay, so remember, accommodative squint, 2 important points. 1, they are to uncorrected refractive error. 2, they are treated by wearing glasses. You see, but all of these squints are not accommodative squints. Okay, so these are not squints due to corrected refractive. They are not squints due to refractive error. So there are other ways also where squint can take place. We call them non-accommodative squint. So there is no refractive error. So it could be what? It could be post-traumatic squint. Child has fallen from a crib, develops a squint. It could be, parents, congenital parents have squints, the child also squint. There is no refractive error. Since no refractive error, we don't give glasses. Obviously, we can't give glasses. So here, for non-accommodative, we do surgery. What is the surgery? Surgery, we make 1 muscle weak and 1 muscle strong. Okay, this is the treatment of this thing, that we make 1 muscle strong and the opposite weak. You understand that what it means is, it means like this. You can see the picture here. See, this is a patient who is non-accommodative squint because we've given him glasses, and yet he does not improve. Obviously, he won't improve because he doesn't have a refractive error, is it not? So he has not improved. So with this we give them glasses for about a month, and we see if they improve. If they do not improve, it means it's a non-accommodative squint, because we are just trying to force glasses. He doesn't really have a refractive error. So what we do surgery. What kind of surgery? 1 muscle is weakening, the other is, see how what it means. Suppose I have a squint like this. Okay? If a squint like this, then how do I make it straight? What I could do is a right exo like this. No? So what I could do is to make the right medial rectus stronger, so it will pull the eyeball in, it's corrected the squint. Or I could make the right lateral rectus weaker, so that it stops pulling the eye outside. If it weakens the lateral rectus, then only the eye will come in. No? So this, what we do both. What I do, not only do I make the right medial rectus stronger to pull the eye in, I also make the right lateral rectus weaker, so it stops pulling it out. In both cases, the eye becomes straight. So we do a combination of weakening one muscle and strengthening the opposite muscle. Similarly, suppose I have an EZO like this, okay, right? This EZO, what I'll do to make it straight, I would make the right lateral rectus stronger, so it pulls it out like this. Or I could make the right medial rectus weaker, so stops pulling it in. In both cases, the eye will become this, not. So in this case, see what happens? I strengthen the lateral rectus and weaken the medial rectus, eye goes out and becomes balanced. So this is a combination of weakening and strengthening muscles, which needs to be done for surgery as non-accommodative squints. You can remember to summarize: accommodative squints are uncorrected refractive error, non-accommodative squints, no refractive error. Accommodative squints need glasses, non-accommodative means surgery. What surgery? Recession one muscle, resect one muscle, but remember to be careful to treat the correct muscle. Do the wrong muscles, the squint might worsen. This was about, so we did about tropias. And remember, tropias we divide into two types. What are the two types? Is comitant and comitant we have just done, which means that we have done. Now it's due to the paralytic squints. Paralytic squints. So paralytic squints, it means that there is paralysis of the eye. Okay, the paralysis of the eye. And this paralytic squints, remember, so the eye can be like this or like this, is some paralysis. And these are not congenital, they are acquired squints. That means they come after birth. And the most common cause of paralytic squints are uncorrected, the systemic disorders like diabetes, blood pressure, and cholesterol. So these are patients who are suffering from typically very high blood pressure, high cholesterol, or high diabetes, and they have no idea. We call them vasculopathic causes. This leads to paralysis of any of the muscles, superior rectus, inferior rectus, medial rectus, lateral rectus, and lead to paralytic squint. Okay, it's called paralysis. In this case, see, the definition of paralytic squint is that the angle changes in every gaze. In every, depending on the direction of gaze. Look at that. What does that mean? Supposing I say that my right sixth nerve is damaged. Okay, remember, paralytic squint means it can be, paralytic squints are either damage to the nerve or the neuromuscular junction. Any of the nerves, what nerves? Could be third nerve, fourth nerve, sixth nerve, any of them could be damaged. Okay, any of them could be damaged. And neuromuscular junction could be anything of the neuromuscular junction. So this is how paralytic squint occurs. Paralysis of the third, fourth, sixth nerve or neuromuscular junction could be myasthenia gravis. Why should paralysis occur? I told you paralysis occurs because of uncontrolled diabetes, blood pressure, or cholesterol, which we call as vasculopathic causes. Okay, and let me show you. Suppose I have a sixth nerve pulse. Okay, suppose I have diabetes, and I hope not. And sixth nerve suppose is damaged. Okay, so look what happens. Suppose my right sixth nerve is damaged. So that means lateral rectus is gone. So lateral rectus is gone. What will happen? The medial rectus will pull the eye inwards. No, so this is paralyzed. The medial rectus unopposed will pull the eye like this, and my eye will become in this condition. When I look at you in the camera, eye is like this. Okay? And you can see it here. This looks at the right sixth nerve. This lady also suffers from the same thing. Right sixth nerve paralysis. The lateral rectus is gone, so medial rectus forces the eyeball in. Now see what happens. So it likes it. So when I want to look that side, see what happens. I can take this eye like this. Suppose this is 5 degrees. Okay. So when I look here, this eye moves fully, right? Because it's free, but this can't move. There's no space. Remember, it's hitting against the nose. So this eye is already like this. This eye moves 5 degrees. This is not moving at all. So the angle changes. Okay? The angle would remain the same only if the two eyes are moving equally. It's not. Both are moving equally, then the angle will remain the same as in comitant squint. But here, because one eye is paralyzed, the other is free. So sometimes this is moving more and this is moving less, obviously. So when I look like this will not move, lateral is gone. When I look here, medial rectus, there's no space because it's hitting the nose. So because these two eyes are not moving equally, like in comitant squints, so in paralytic squints, the angle changes in every gaze. Okay, will become 5 here, 10 here, 15 there, 20 there, 25 there. Why? Because this is not moving. It's very little. The angle between the two keeps changing because this eye is moving very little and this eye is moving all the time. Okay, so this is the definition of the squint, that it changes in every gaze. Okay, and it depends upon the direction of gaze. And then what about, remember in comitant squints I told you that we have secondary and the primary deviation are equal, but here in the paralytic squint the secondary deviation is more than the primary. What is that? Look at that. Suppose I have a squint like this, we took 6 nerve, no, like this. So when I look at the primary development, primary means when the normal eye is looking here and this like this. Remember this angle say is 5 degree, okay, when the normal eye looking. But what is second division? Second division means that the angle of two eyes with the paralyzed eye looking, the squinting eye looking. So see, since the eye is paralyzed, I have to make a huge effort to move the eye like this. Okay? This huge effort has to make the eye to move the eye look straight, and this effort by Hering's law will be transferred to the other eye. No? So as I make this huge effort to take the eye out to look at the prime, this eye will also move and this angle changes. Okay, it will move like this. Okay, so it will move like this, and now the angle will be much more. This is only 5 degree, but because the effort is so much to move it out, this effort will convey to the other eye. It will become 10 degree. So the secondary deviation, remember, is always more than the primary deviation because the effort required to push the paralyzed eye into fixation is too much, and it creates movement of the other eye because the movements are distributed both, and this angle is always more than the primary deviation. So remember, secondary deviation is more than primary deviation in common, not in common with parallax squint. Okay, so that's another difference. And because in parallax squint, the angle changes in every gaze, so they'll end up with 4 major problems, which none of them are seen in competence squints. None of the competence squints, which is what? Diplopia, double vision. Immediately patient will have double vision. This is a very distressing thing. Abnormal head posture, they hold the head abnormally like this. Vertigo, they will have dizziness, चक्कर आ रहे होंगे इनको, जैसे बाप लोगों को, बहुत लोगों को चक्कर आ रहे हैं बैठ के मेरे को देख के कि क्या हो रहा है, no? So many of you are having disorientation and vertigo, चक्कर आ रहे हैं, and this disorientation, many of you disoriented, you have no idea what is going on, what time is, what year it is, and what subject is it. So these 4 things appear in squint also. But these two, vertigo and disorientation, is not specific for squint. It occurs, as I said, most of you also. The vertigo, diplopia and abnormal head posture are pure squint manifestations. Vertigo disorientation can occur in other conditions also. Okay, and remember this diplopia, this double vision, has one particular characteristic. It is with both eyes open. Okay, so if you have both eyes open, you have double vision there. If you close the squinting eye, suppose this eye is squinting like this, no? This eye you can see, this is the squinting. If I close this eye, then there will be no diplopia. Okay, so remember this is called binocular diplopia. Diplopia is seen with both eyes open. If it is with one eye open, then this is the cause is not squint. Okay, so this is binocular diplopia is required with both eyes open, and this is about diplopia. And the second is abnormal head posture. What is abnormal head posture? Remember, the abnormal head posture, as in this case, you see the eyes like this. No? So because the patient is having double vision of like this, so often the patient moves the eye like this or like this, trying to avoid double vision. And you can see here, this child is holding the head tilted like this. It's called head tilt, which is seen in parallax squint. Remember, there are 3 kinds of abnormal head posture. You can have a face turn. Okay? The face turns to one side like this or like this to avoid diplopia. Second, you can have a chin lift or a chin depression. The chin lift or the chin lift up like this or chin depression like this. Okay, again to avoid diplopia. Or third, you can have a head tilt. Head tilt, the head tilts over one shoulder like this or like this. Remember, they have different interpretations. The face turns like this, the face turn like this is when any of the horizontal muscles are paralyzed, like the lateral rectus and the medial rectus. That's why they move the head like this to avoid diplopia. The chin lift like this or like this, it is due to any of the vertical muscles get paralyzed, which could be the superior rectus or the inferior rectus. Okay? Again, trying to maintain in diplopia, trying to suppress diplopia. And head tilt, the third one, like this or like this, which you see here, it tells us one of the oblique muscles are paralyzed, either supraoblique or inferior oblique. Okay? So remember, the head tilts tell us you have to watch out these tilts very carefully and decide. Face turns means horizontal rectus muscle paralysis. Chin lift, chin depression means superior rectus or inferior rectus, and head tilt means it is superior oblique or inferior oblique paralysis. Then parallax squints, remember this I just mentioned, face turn, the horizontal rectus muscles are paralyzed. This is the interpretation, it's like this or like this. And chin lift or chin depression is vertical muscle paralysis, either superior rectus or inferior rectus. And head tilts means oblique muscle paralysis, or superior oblique or inferior oblique. And the abnormal head posture depends on which plane of the muscle is paralyzed. So that's a very important thing. You can see this diplopia, horrible double vision. Look at the time, वक्त को देखिए. अगर मेरे को time ऐसे दिखा तो मेरे को लगेगा कि मेरा time आ चुका है. Okay? Isn't it? So diplopia is terrible to have. Everything is double. It's a very scary thing for a patient to have diplopia. Okay? So this we did now, tropias. And to come back to paralytic squints again. Paralytic squints mein, remember the basic thing is what? Paralysis is occurring. So the most important is double vision. And remember, double vision is seen with both eyes open. If you close one eye, you will have no diplopia. If you close the other eye, there will be no diplopia. With both eyes, you will have double vision. So binocular diplopia, remember, the most common cause is squint. अगर दोनों आँख खोल के आपको double दिख रहा है, the most common cause is squint. Okay? And also remember basic principles of squint in the underaction of the muscle in the field of action. That means what? Muscle underact karega. See, lateral rectus paralyzed. Lateral rectus, what is that? It takes the eye out, no? So it will not, if it's paralyzed, so it cannot take the eye out. It's called underaction. And overaction, opposite muscle ka hoga, opposite muscle. Because lateral rectus kaam nahi kar raha hai, the medial rectus will force the eyeball in. Okay. So please remember, the paralyzed muscle is underacting because it's paralyzed, and the opposite muscle is overacting because it is now unbalanced. Okay? It is not paired with the other eye. And how do I manage the double vision? Is remember of in paralytic that you see here, what is this? The first important thing is to patch the eye. Okay? To close one eye. Okay? Because binocular, I said you have to see both eyes, no? So just close the squinting eye. Okay? Just close the patch here. You just close the one that is squinting. With the other eye, she'll be very happy. You know, the other eye should be very happy. So this is the squinting eye is patch closed temporarily. So with the one eye should be normal. Or you can give prisms. Prisms are optical prisms are like, you know, you may have seen in class 12. The optical prisms are prisms which split the light towards the base. Okay, prisms, they all cause the ray of light that enters to divert towards the base. So if we give them glasses, you know, then what will happen? It will cause the rays which made of prisms like this. These are prismatic glasses. So a series of prisms are like this. So they will divert the rays towards the base, and we make the glass such that the rays focus on the fovea. So if the rays focus on the fovea, these diverging rays, then the fusion will take place. There will be no diplopia. So remember I told you that you have to have bifoveal fixation. So prisms glasses can also help in diplopia. And third is botulinum toxin, is that you inject botulinum which paralyzes the muscle. It inject this thing which paralyzes the muscle in the opposite muscle. You understand? So what happens? Supposing that I have a lateral rectus palsy like this. My eye is turned in by medial rectus like this. Like you can see in this diagram. One eye is the light like this. Okay? What happens? This is already eye like this. So what you do, the lateral rectus paralyzed. So now you inject the medial rectus. So lateral is already paralyzed, the medial you paralyzed, but you inject botulinum, the eye becomes straight. You got this? So original eye is suppose like this, lateral is paralyzed and the medial rectus is overacting, pulls like this. So in Botox, what you do, you inject botulinum toxin, which is a very powerful toxin, into the opposite muscle. So lateral is already paralyzed, you inject in the medial, lateral is already paralyzed, medial you paralyze, the eye becomes straight. Okay? So these are temporary ways of managing diplopia, and the three ways. Patching is done. The older people, they don't mind being patched. The younger people, they don't like being patched because they have cosmetic reasons. Prisms and botulinum toxin can be used for temporary correction of diplopia while we wait and watch for the nerve muscle too. So remember, paralytic squints, to summarize what we've done so far, if you don't get confused, look at that. What I said in comitant squints, what happens is that the two eyes are parallel. The angle is same. And patient has no diplopia, no nothing. We don't have to treat comitant squints most of the time because they have no problem. But paralytic squint require treatment. And how do we treat paralytic squint? Is remember the most common cause are the vascular disorders like uncorrected diabetes and blood pressure. No? They're the most common causes. Paralytic squint, because they have so many problems like diplopia and other things. So first we treat the underlying cause, which is diabetes and blood pressure. Okay? So you treat them. What is the diabetes blood pressure result? And this takes time. And once you correct the sugar and the blood pressure, what will happen is the nerve muscle recovers. They will recover naturally because the sugar and blood pressure control. This recovery takes time. It takes 3 to 6 months. So while we are waiting, we have to wait for the recovery of 3 to 6 months. But while we are waiting, we have to correct the diplopia. Because remember, patient cannot tolerate diplopia for 3 to 6 months. This, I told you how to correct the diplopia by patching or prisms to botulinum toxin. Okay? So this is the principle of paralytic squints. First, correct the underlying disorder, wait and watch for 3 to 6 months. Meanwhile, correct the diplopia with prisms, with patching, or with Botox. Okay? And within 3 to 6 months, the patient will be absolutely okay. Okay? Because the diabetes and blood pressure is now treated. So therefore, next look at the paralytic squint, the third nerve. Now we talk to paralytic squints. Let's look at specifically एक specific देखते third nerve palsy. Remember, third nerve palsy में you know that third nerve supplies all muscles except two, the LR6, SO4 and R3. Remember the formula that the third nerve supplies the rest of the muscles R3 except the sixth nerve supplies lateral rectus and superior oblique supplies the fourth nerve. So if the third nerve is paralyzed, all muscles are paralyzed except these two, the lateral rectus which takes the eyeball out and superior oblique which pushes the eyeball down. Okay, so look at that. Typically the eyeball has gone out and down and out. So this is a very famous appearance. We call this down and out because it has gone downwards and outwards. The down because of the superior oblique and out because of lateral rectus, which are the only two muscles still active. Rest are all paralyzed. And they are why ptosis? Because even ptosis also because the LPS is also paralyzed. Remember, third nerve also supplies the LPS. So remember, third nerve is diagnosed by the famous triad of three conditions of down and out and ptosis. You can see it here. The eyeball is down and out, and the ptosis will lift it up by lifting it up with a cotton tip applicator. So ptosis is corrected so that we can take a photo here. And there are two different types of third nerve. Remember, one is called pupil sparing. Just the pupil size is normal. And the other is pupil involving, the pupil is dilated like this. Okay? The pupil sparing, the size is pupil normal, is called medical third nerve because the causes are medical, which are sugar and blood pressure. Remember, I told you all paralytic squints are because of that. So if the pupil is normal, it tells us you take a blood pressure and a blood sugar, you will find the cause there enough. If the pupil is dilated, it's called a surgical third nerve because the causes are surgical. Why? The causes are a tumor or an aneurysm. Okay? Tumors, intracranial tumors or aneurysm, they can cause third nerve palsy and they can be life-threatening. See, the aneurysm may rupture any time, no? So where this aneurysm may rupture any time and may cause death. Remember, it's a very dangerous thing. Once you diagnose third nerve palsy by down and out ptosis, look at the pupil. If the pupil is normal, which is sparing, it means it's a medical third nerve. We are not to panic. We just take a blood pressure and blood sugar and everything will be fine. We find the cause. But if the pupil is dilated of the third nerve down and out ptosis, if the pupil is dilated, it means it's a surgical third nerve and the cause is either an aneurysm or a tumor, and the aneurysm or tumor may rupture any time and cause death. So it's a bit of an emergency, third nerve palsy, a bit of an emergency because you treat very rapidly. Remember, the most common aneurysm is at the junction of the PCA-IC junction, MCQ. That's an important MCQ. PG-MCQ, the most common aneurysm to cause third nerve palsy lies at the PCA-IC junction. You used to memorize PCA-IC stands for posterior communicating artery and internal carotid artery. Okay, PCA-IC, posterior communicating artery with the internal carotid artery. This junction is the most common, which causes third nerve. So please be careful. And in this case, as you can look at this, remember this pupil is dilated. Appears to be dilated, no? And it's dilated, so it's a third nerve palsy due to a aneurysm or a tumor. You have to do a CT scan or MRI immediately, detect the tumor aneurysm before the patient ruptures and dies. Okay, so it's a bit of an emergency. And remember, but why should the pupil dilate in surgical cause? Because remember, the third nerve carries the parasympathetic fibers. They are also damaged. When they are damaged, so the sympathetic will dilate the pupil. Okay, very important. Look at the pupil. If it's normal, do a blood pressure and blood sugar. They will find the cause. If the pupil is dilated, immediately order CT MRI. It will pick up the aneurysm or the tumor before it ruptures and kills the patient. So what we do, once we do this, treat the underlying cause, which is whatever it is, aneurysm or tumor or sugar or blood pressure. Correct diplopia how? By patching, prisms or Botox for 3 to 6 months. And during 3 to 6 months, it will wait, we watch and wait. And he makes a full recovery in 6 months. If it's a younger patient, in 3 months also they can make a full recovery. So this is the how we treat it like this. And then we do the fourth nerve. The fourth nerve palsy, fourth nerve has a lot of MCQs because it's anatomically very peculiar. You know, it supplies the superior oblique, SO4, and it is the longest intracranial nerve. Remember, At 75 millimeters long, the fourth nerve is the longest intracranial nerve. Remember, it's not the overall longest because the overall longest is the vagus. You know, the vagabond nerve, it goes all around the body. Overall longest cranial nerve is the vagus or the vagabond, but the overall longest intracranial nerve is the trochlea, which is about 75 millimeters long. It is the thinnest cranial nerve. It is the first, that is why it is the first to be damaged in trauma and the only one to cross over from one side. Remember, the fourth cranial nerve supplies the left superior, unique. Left fourth nerve supplies the right superior, okay? So it crosses over like this. So it is not ipsilateral, it's contralateral. The right superior oblique, the right cranial nerve, fourth cranial nerve supplies the left superior oblique, the left intracranial nerve supplies the right superior oblique. It's like this. It's the only one to do that. So remember, because of his trauma, so the most common causes of fourth nerve palsies are not usually sugar and blood pressure, but traumatic. So whenever you get a palsy of this one of the fourth nerve, you have to first take history of trauma. That's very easy. Trivial traumas to the head can damage the fourth nerve. First take history of trauma. Then, because the fourth nerve is a very powerful depressor, so what happens is pupil, it goes up, and typically it causes diplopia in this particular one. When you look down inward, so downward inward like this, you will see diplopia. So when you read a book, look at this. When you read a book, the letters will appear, because this is the down and inward gaze, the letters will appear vertical diplopia or oblique diplopia, superior oblique, because it's called vertical or oblique diplopia like this. So you'll have vertical or oblique diplopia in downward or inward movement like this. While, and what is the most common? In reading, because reading is what gives us this downward inward. Also, the other one is walking downstairs. Remember, a typical MC was asked last year that patient comes with diplopia while walking downstairs. What is the nerve damage? Is the fourth nerve damage, okay? And typically, because the fourth nerve is the very powerful depressor, the superior oblique, the very powerful depressor, so the eye moves upward like this. So typically, in down and out and ptosis, you had third nerve here, the eyeball moves upward like this, and there's a head tilt on the opposite shoulder like this. Okay? Why? Because you can see it here, look at the upward, eye movement has gone up like this, because it's a depressor is paralyzed, so the opposite muscle pulls it up like this. So one eye moves upward and the head tilt on the opposite shoulder. Why head tilt? Because remember, it's a superior oblique, so head tilt. And why opposite? Because they cross over, the fourth nerve crosses over. So therefore, kindly remember, the fourth nerve palsy, we've all got a lot of MCQs. First, remember, it's the longest, the thinnest cranial nerve, it is the first to be affected in trauma, and is the only nerve to cross over. Second, you'll have vertical diplopia or oblique diplopia in palsy, particularly in reading and walking downstairs, because the gaze affected is the downward and inward. And on examination, eye goes upward and head tilt on the opposite shoulder. And in this, you can see it here. Usually, in children, if it is, it's most probably congenital. Congenital is from birth onwards. Adults is most commonly traumatic. Remember, I told you trauma causes. And you treat the underlying cause, whatever it is, the trauma, the sugar, the congenital cause, treat it, and treat the diplopia by Botox, patching, and the prisms. And within 3 to 6 months, they recover. Children will recover even faster in 3 months. Last of the sixth nerve palsy. And sixth nerve palsy, we have, remember, the sixth nerve is the supplies lateral rectus, and this we've already done. It is the most common cranial nerve palsy. Sixth nerve is often seen in a lot of studies with the most commonly damaged nerve. It damages the lateral rectus and is also the longest subarachnoid. Because kindly remember, fourth nerve is the longest intracranial. This is the longest subarachnoid. Okay, subarachnoid. So it is, I have told you this before while discussing papilledema. It travels the maximum distance under the arachnoid mater, and that's why a lot of cranial pathologies damage the sixth nerve. So sixth nerve means lateral rectus is gone, so eyeball is moved in like this. You can see here, the eyeball is moved in, medial rectus force the eyeball inwards. So you have horizontal diplopia, double vision like this, esotropia you can see, and the face moves out. Remember, it is the face in, face out I was telling you. So you have the face turn here. So trying to eradicate diplopia, eliminate diplopia, the face turns out because the eyeball cannot turn out. So typical position, they'll have horizontal diplopia like this, one pen showing them, they will appear like this, two pens, and one eye is moved in, so the face will move out. Eye in, face out, we call it. Children in sixth nerve is most common. It could be serious sixth nerve, it could be pontine gliomas, because these are tumors of the pons. I told you, because of the fourth nerve, sixth nerve's long propensity of running around under the arachnoid mater, a lot of cranial nerve pathologies can cause it. In adults, it is mostly again vasculopathy causes like typically you see as in diabetes blood pressure. And LPs also, remember, lumbar puncture is well known to cause 6 nerve damage. Very famous question. You see what happens as you put lumbar puncture, when you put an LP, the CSF leaks out, the leaves out, and because of loss of CSF, the brainstem sags a little bit, because of loss of CSF. So there is sudden descent of the brainstem like that. Again, it pulls on the 6th nerve. Remember, the 6th nerve is very long and it's trapped in the Doyle's canal, so it pulls on the 6th nerve and the 6th nerve gets paralyzed. So this is a very common MCQ that will ask in NEET PG, that following lumbar puncture, patients present with diplopia within a few days. What is the most common cause? You will remember 6th nerve palsy caused by LP. Leakage of the CSF causes sudden descent of the brainstem, pulling on the 6th nerve line. So these are multiple causes. You can have vasculopathies like sugar and blood pressure, lumbar punctures, particularly children will have serious causes like pontine gliomas. So treat the underlying cause, whatever it is. Again, wait and watch for 6 months. Correct the diplopia with botulinum, with patching, and with prisms, and they'll be fine. The treatment is essentially the same for all. And finally, myasthenia gravis. And we are about to finish squint now. Let's look at the neuromuscular junction, which is the most common disorder, is myasthenia gravis. Okay, myasthenia gravis, remember, is a great mimic. It mimics a lot of disorders, so you have to rule out a lot of things. It's the most common disorder of the neuromuscular junction. Okay, remember, that's why myasthenia is important. And what happens is antibodies, it's autoimmune disorder, so occurs the autoimmune disorder. The antibodies are formed against acetylcholine receptors. It is seen most commonly in young ladies between 20 to 40 and old men between 60 to 80 years of age. Okay, so typical, remember, the population involved is young ladies 20 to 40 and old men between 60 to 80. Okay, that's why I said yesterday that there are often young ladies in my class, and if you look too exhausted, it means that you might be having myasthenia. After all, remember, it is the most common muscular disorder, isn't it? So acetylcholine receptors are blocked because of the antibodies. So there is no transmission of impulse neuromuscular junction because acetylcholine travels to the receptors but is blocked by the antibodies. So it cannot cause muscle contraction. And the muscle contraction cannot cause, so the first muscle damaged in the eye is the LPS. You remember, that's why they come to us with ptosis, severe ptosis. Okay, but in the body, all muscles are weak and they cannot contract. That is why this patient is constantly fatigued, always tired. He looks always tired. He feels always tired because the muscles are not able to contract because of the blockage of the acetylcholine receptors. That's why it's called myasthenia gravis. Myasthenia, muscle weakness, serious muscle weakness. Myasthenia gravis is a serial muscle weakness. Okay, serious muscle weakness. So you have the first thing to appear in myasthenia is the ptosis. Is the ptosis where the LP is affected, and you have ptosis, and then this ptosis, remember, is worse in the evening. It's called fluctuating ptosis because that is the myasthenic fatigue, that with the daytime, as the day falls into afternoon and evening, the tiredness increases, the fatigue increases, because more and more the nerve is firing, more and more the receptors are blocked, and less the muscles are contracting. So the fatigue increases with the day. Remember, entire body fatigue increases, and that is a hallmark of myasthenia, that the patient becomes very tired but recovers after a bit of rest. Typically, give him half an hour's rest, he'll be fine. Okay, because then by that the blockage is redundant. So therefore, the ptosis increases in the night. That's called fluctuating ptosis. The second is diplopia. The doubling vision increases in the evening also, because remember, the superior rectus, inferior rectus, they also cannot contract and they cannot keep the eye straight, so they have diplopia. So remember, fluctuating ptosis and diplopia worsening in the evening is the sign of myasthenia, and typically tiredness, which improves with it worsens with the daytime, but as you get him a little bit of rest, then his tiredness reduces, he feels better, improving with rest. Then here, this is it. Remember, the myasthenia only attacks typically the skeletal nerves, the muscles. So it does not, the involuntary muscles it does not attack. So pupils, which are controlled by the sphincter and dilator, there are involuntary muscles it cannot touch, and ciliary muscle is also involuntary, so it cannot touch. It only attacks the skeletal muscles. So remember, in myasthenia, there will be the pupils will be normal and the accommodation will be normal. Okay, but third nerve will have both pupils and accommodations will be lost in third nerve. That's how we represent this. It's a mimic, no? That's how in myasthenia, the pupils in the accommodation will be spared. Third nerve, it won't be. And the test is tensilon typically, where we inject edrophonium, reverse the blockade, and immediately the patient becomes better. You know that, very dramatic test, inject tensilon, and the muscle rises, immediately ptosis improves. So drug of choice here is pyridostigmine. We use pyridostigmine and steroids also, because autoimmune disorders, it means steroids also. With that, we fill up a very important topic called squint, and I hope you understood this. And with that, and now we go to the last important topic, conjunctiva and cornea and sclera. So last topics. So conjunctiva, look at the word. Conjunctiva क्या होता है? It's a transparent membrane on the cornea, on the conjunctiva, sorry, and the sclera. See, look at the word conjunctiva. What it does, it conjoins, or that means joins the eyelid to the eyeball. Okay. So conjunctiva is the only tissue which connects the eyelids with the eyeball, and it connects this on, reflects on the sclera, and then reflects from the back surface of the eyelids also. So once it covers the sclera, see what does it goes back and reflects from the under surface of the upper eyelid, and it goes like this, and it reflects from the lower side from the of the lower lid also. ना? ऐसे करके जाता है this way, and other it goes like this. So it must be very important tissue which is able to cover not only the eyelids but the eyeball also, and that's correct. It's conjunctiva. It's called conjoins, and it covers lubrication of the eye and protection against foreign bodies, immune surveillance also. And the most important function of the conjunctiva is that conjunctiva produces goblets. It has this cells called goblet cells, and these goblet cells produce mucin, which are very important for tear film stabilization. So now we'll talk about the tears. आँख के आंसू जो एग्जाम के दिन आने नहीं चाहिए, दिखने नहीं चाहिए मुझे, because you have read all this, so you should have no tears in your eyes on the day of the exams. Okay, let's look at the tear film and what are the levels of the tear film. The tear film has 3 layers. Remember, it's called the tear film because it is so thin, and it has 3 layers like this. Okay, it looks like this. Schematic diagram mein. And the topmost layer, this is the topmost layer. The topmost layer is the outer layer called meibomian glands. Called meibomian glands, and what it does, it produces meibum. It produces meibum. This is the oily layer which causes prevention of evaporation, because the lipid, so it prevents evaporation of the tear film, because it's so hot that you go out within a few minutes the tear film would evaporate. The second layer is the most important, called the aqueous layer, and this is produced by the lacrimal glands. Look at that, lacrimal. The word lacrimal means tears. I told you that lacrimal means tears, and these are 2 huge glands. We talked about this when drainage, and lacrimal glands are present on the outer surface of the lipid hair, supratemporal area, and it produces the main tears of the eye, and it contains all the things that we require. What is that? This lacrimal fluid, okay, contains the oxygen, the glucose, the electrolytes, and a very powerful enzyme called the lysozyme, which is required to fight bacterial organisms. Okay, and the inner layer, the innermost layer, is the mucin layer, which I said is produced by the goblet cells, which is for stabilizing the tear. Stabilize karna ka matlab kya? That it does not allow the tear film to drain down the eyelids. Have you ever wondered why the tear film does not drain out of the eyes? Because of gravity. Well, it should, no? It doesn't, because the mucin keeps it tightly adhered to the conjunctiva. If there's lack of mucin layer, all the tears would keep flowing down all the time. A very irritating condition down the lower lids. Okay, so absence of any of these layers, or all of these layers, produces a condition called as dry eyes, also called as keratoconjunctivitis sicca, KCS. It's called the same, keratoconjunctivitis sicca, dry eyes. And what are the common causes of dry eyes? Why should they not produce these tears? Well, remember, advanced age. As we go older, above 60, particularly the female patients, they develop more dryness. Okay, remember, why the females only? Why not the males? Because after 50, the females get hit by a thunderstorm, which is called as menopause. Okay, as called menopause, and menopause does not allow, so there's no estrogen, so there's no further tear secretion. So females suffer from dry eyes quite a lot. Males also, but not so much, because males have testosterone which compensates for that. So elderly females, that is our mothers and grandmothers, all have dry eyes. Then what about young people? Young people also have dry eyes for prolonged contact. If you wear contact lens for a long time, more than 10 hours a day, then you develop dry eyes. Though some of you do that, you mustn't do that. Maximum allowed use is 8 to 10 hours. That's it. Then you can have Sjogren's. One of the most dangerous causes of dry eyes is this Sjogren's. It was a classic triad. Remember the classic triad of 3 things: dry eyes, dry mouth, and rheumatoid arthritis. This is very severe and very difficult to treat, and it's incredibly difficult. I can't tell you how difficult, unhappy these patients are. Severely, the dry mouth is the worst. Okay? They can't eat biscuits and toast because they're so dry mouth that without saliva they can't eat it unless they swallow it with some tea or coffee or something. Uske bagair they cannot have these dry things. Okay? Drug-induced dry ho sakta hai. You can have certain drug-induced, certain drugs, particularly the anticholinergic drugs. Remember, anticholinergic drugs, they will reduce the secretion of the body, and tears are a secretion, so anticholinergics will cause dryness. Antihistaminics also. So many of you who keep popping a pill for levocetirizine or Allegra or this should avoid it because they will cause prolonged dry eyes after a long time. Okay, and another very powerful drug called antidepressant. Antidepressants cause a lot of dryness. Okay, so to some of you are using antidepressants, be careful about that. They cause a lot of dryness of eyes. So certain drug induced, so multiple causes of dryness. Then the three causes of trachoma and vitamin A deficiency. These cause mostly mucin cell deficiency and cause dryness. MGD stands for meibomian gland disease. Remember these glands we said, meibomian glands. So when you have disease of the meibomian glands, we call this MGD. It stands for meibomian gland disorder, and this is one of the rare causes of dry eye due to lipid deficiency. So you can have lipid deficiency, aqueous deficiency, mucin deficiency. All of them cause dry eyes, KCS. And remember, the most common signs of dryness of eyes is a foreign body. Aankh mein aisa lagta hai just something, there is some foreign body in the eye. Okay, remember, typically they feel patients, the doctor, there's some sand in the eye, some foreign body, some stones, some mud. Typically it's always burning. Okay, remember the burning sensation, which is worse in the evening. Why in the evening? Because the whole day the eye is open and the evaporation takes place maximum in the evening. By the evening, the eyes are totally dry. So eyes are burning all the time, and aankh mein mirchi lag rahi. Some patients will say, Doctor Sahab, mere aankh mein mirchi lag rahi. It is burning so much. And the eyes become red very quickly, blurring of vision. Why blurring? Because when there's no tear film, the cornea gets exposed, and the cornea is actually not very smooth. Okay, there are some microvascular. Typically you have hills and valleys here. Is the tear film normally which coats the surface of the cornea, makes it smooth. In the absence of the tear film, all these microscopic irregularities are exposed, and the patient develops blurring of vision also. Okay? Ocular fatigue, he feels always tired, and the tear meniscus height reduces. Tear ka height hota hai, it reduces. All these are some findings of dry eyes. Remember, tears are a very important thing, so don't waste your tears. Okay, don't try necessarily you are wasting your tears. Tears are simply too important to be wasted. Okay? So KCS, also called dryness, dry eyes. This is to do certain diagnostic. How do you diagnose them? We use a couple of dyes here which you should know. One dye is called rose Bengal. This detects conjunctival dryness. So you take a rose Bengal dye, it's on a filter paper strip, and you just touch the eye like that. If eyes are dry, it will pick up the pink stain. It means you are conjunctival dry. Or another dye is called the lissamine green dye. Lissamine green is again you touch the conjunctival surface with it, it's green in color, and if you are dry, the conjunctival will pick up the green dye and it will show green color. So this, if you're rose Bengal or lissamine positive, it means conjunctival is dryness. For picking up corneal dryness, we have the corneal dryness is more advanced than conjunctival dryness. This means other problem hogi. So we use another dye called the fluorescein stain. Okay, it's a fluorescein dye only. And again, we touch it to the eye like that, it will pick up the green dots. So you can see the green dots, and if the stains were positive, it's called corneal. Be careful. The rose Bengal and lissamine green pick up the conjunctival dryness. The fluorescein dye pick up the corneal dryness. This is more advanced dryness, corneal dryness is. Okay. Then you can have the Schirmer's test. Okay, Schirmer's test, you quantify the amount of tears which are being produced. You put a filter paper strip on the patient's eye like this, and this has a millimeter markings like this. You place this for about 5 minutes, then you take out the paper strip like this, and when you take out the strip, you will measure how much of it is wet. How much of it is wet? Remember, if in 5 minutes, if it's less than 10 millimeters of wetting, okay, if it's 10 minutes of wetting, then you are dry. Normally, within 5 minutes, it should be more than 10. If it's less than 10 millimeters of wetting, it means that you are dry. And the tear T-but is called the tear breakup time. The tear breakup time. See the tear, normally the tears that you blink like this, the tears are from the eye. It slowly, see what happens. The tears slowly spread like that. Okay? As you blink, watch me. As you blink, as the lid blinks like this, and the eyelid opens. As the eyelid opens, as the eyelid falls, it coats the tears lid with the cornea with tears, and as the lid opens, these tears it starts spreading, okay, across the corneal surface like that, okay. And as it spreads, it becomes thinner and thinner, and it breaks. It breaks means a small dry spot is developed. It breaks, And this time, we start timing it as soon as the lid opens, we start timing it. So the first dry spot should not appear before 10 seconds, okay? 10 seconds is called the tear breakup time. And if it breaks up earlier, 5 seconds or 6 seconds or 7 seconds, it means your tear film is not very stable. So we measure the tear breakup time less than 10 seconds, it means you have unstable tear film and you're developing dry eyes, okay? The treatment would be, we give tear film supplements. Supplements means that we have these drops called methyl cellulose, which do not replace. We cannot replace. Remember, the tears are simply too unique for us to replace them. So we supplement them, means that we try to make it something different. Close to that, but not exactly tears. We also call those artificial tears because they're not real tears. And artificial tears are lubricants or tear film supplements. So anything extra in trying to replace the tears, but it's not the real tears. So it's called methyl cellulose. And sometimes we keep this putting, we have to put all this time, all the time, 5, 10 times, 15 times, whatever required, you have to keep putting all your life. And cyclosporin, eye drops, cyclosporin is the second. Suppose the tear methyl cellulose does not work, then you have to put cyclosporin. This is anti-inflammatory drug, which can treat the inflammatory component of the dry eye, and it helps, okay? So this is the two-step treatment of dryness. Then xerophthalmia. Xerophthalmia, remember, ophthalmia means eye, xerosis means dryness. So this means dryness, but actually it is not really dry. Xerophthalmia basically refers to the vitamin A deficiency changes in the eye. Whatever changes are seen due to vitamin deficiency in the eye, we lump it under xerophthalmia. So it is actually a misnomer because you think it's going to talk about dryness, but it's not only dryness. There are many other things that occur if the eye becomes vitamin deficient. So let's look at this. WHO classifies this as 8 different. There are 8 classes of classification of vitamin deficiency. And let's start with the XN. Remember, XN means night blindness. This is the earliest symptom of vitamin deficiency. Kindly remember, always asked, the earliest symptom of vitamin deficiency is night blindness. This is also the most common cause of night blindness in the whole world. So if you have look at night blind people, and there are many other causes like retinitis pigmentosa, like cortical cataracts, night myopia, but the most common cause of night blindness in the world is vitamin A deficiency. This is the earliest symptom called XN. Then a few more months of vitamin deficiency, it goes to X1A. This is conjunctival cirrhosis. The conjunctiva becomes dry, wrinkled, and it develops these folds. A few more months, X1B called Bitot spots. Now you develop these foamy white spots on the conjunctiva, which looks very, look like soap bubbles. This is called Bitot spots, and this is due to remember, you have to remember this is Bitot spots, X1B. Then still no vitamin A deficiency, still no vitamin A, and your X2 now goes from conjunctival dryness to corneal dryness. I told you corneal dryness is more advanced. Now the cornea develops dryness and your vision starts blurring. And then it goes to X3A. From corneal blurring, corneal dryness, it goes into more severe conditions where you develop small corneal ulcers. These ulcers develop like this, so oval, shallow ulcers like this. This is because the collagen is melting away. Remember, collagen requires vitamin A, and vitamin A is missing, so collagen is not formed, it starts melting away, so develops small ulcers, and disastrous condition occurs called keratomalacia. Cornea melts away. The entire cornea melts away due to absence of vitamin A, and X3A is less than 1/3 of the cornea melts away. X3B is more than half. So this, where the cornea just literally melts away, it liquefies, and everything comes out, all the contents of the eye. That means the iris, the lens, the retina, the vitreous, everything comes out, the eyeball is lost. It's over, the game is over, entire eyeball is lost, because remember, cornea sclera is the basic layer of protection. Everything comes out. X3B, keratomalacia, patient becomes blind, okay, more than half. But, and then sometimes, miraculously, most of the time the game is over, but sometimes miraculously, even without the vitamin A, the cornea starts healing, okay. It's an amazing condition of the human body that everything heals ultimately. It takes some time, everything heals ultimately, and sometimes even the cornea starts healing, it forms a corn scar, XS, and finally we go to XF, the 8th stage, where it's been now almost 2 years of vitamin A deficiency, xerophthalmic fundus develops, okay, XF, where you get golden white spots, golden brown spots on the retina, patient becomes blind, okay. So this is the 8 stages of vitamin deficiency. So remember, starting with XN, night blindness, X1A, conjunctival cirrhosis, X1B, Bitot spots, X2, corneal cirrhosis, then X3A, oval ulcers, and joining together from keratomalacia, corneal melting. Less than 1/3 is X3A, more than half is X3B, excess corneal scarring, and excess xerophthalmic fundus. And the treatment is vitamin A. We have to give vitamin A. The dosage, remember, we have this dose, entire dosage, but I would be happy if you remember this particular dosage for people, for children more than anybody more than 12 months, okay? Particularly children, we have to give them 3 doses of 0, 1 and 14. What does that mean? 0, 1 and 14 means that on the first day, day 0, when they first present to us, we give them 200,000 international units of vitamin A. 200,000, 2 lakh in line, 2 lakh rupees nahi. We don't have so much money, you know, ophthalmologists are very poor people, you know. We don't have 2 lakh rupees to give them, but 2 lakhs, 2 lakhs, 2 lakh international units we give them. On day 1, we give it. Second day, the mother has been taught how to give it, and the 14th day, the second week, they again come, we give it first. So 2 lakhs, 2 lakhs, 2 lakh international units are given by mouth for children above 12 months of age. I've given other doses also, it just becomes half. From 6 to 12, it becomes 100,000, less than 6 months, it becomes 50,000. So 200,000 ka half karo, 100, 100 ka half karo, that's 500, 50,000. So this is the dosage you have to remember, we have to give, because serum levels require to be at least more than 20 micrograms per deciliter. 20 micrograms per deciliter is the dose required in vitamin deficiency. So this is usually asked, some questions will be there, remember, because vitamin deficiency is very common in the world, particularly in our country. We need to know about vitamin deficiency. The ophthalmos managed. Then what about conjunctival degeneration? Conjunctival degeneration occurs to patients who are exposed. There are many kinds of degenerations. The first one, the one we need to talk about most, is pterygium. Pterygium kya hota? Pterygium is very important, very commonly seen by us, because it causes the word pterygium means a wing-like growth. You know? So over the cornea like this, you will see this is the pupil. The conjunctiva climbs up in the time of a triangle like this. Okay, it looks like a triangle. It climbs up, and it's like the bird's wing. That's why it's called pterygium. The word pterygium means like the wings of a bird, and it climbs with the cornea like that. Why it does? Because this is exposure to sunlight. So these are patients who are exposed to UV light. Most important, from the ultraviolet light that's exposed. So people who are not wearing sunglasses and they're exposed to the hot, dry, dusty climates. So typically, degenerations of these pterygiums are seen in the hot, dry, dusty climates where there are no sunlight, whereas there's not much sunlight. There's a lot of sunlight, lot of sunlight. No rain, I'm so sorry. So typically seen in Rajasthan, in Gujarat, Uttar Pradesh, parts of Delhi, where there are very dry areas and lack of rain. This is typically the farmers that are exposed to the sunlight and the UV light, the hot flying sand, dry dusty climates. They are the ones who develop pterygiums. It goes up like this. There's a very important MC called the Stalker's line. Stalker's line is a line which is seen at the advancing edge. यहाँ पे एक yellowish line आपको दिखेगी. This is the yellow line in front, and this is called the Stalker's line. Very important. I always ask the question, what is the Stalker's line in front of a pterygium? Multiple symptoms of redness, photophobia, watering, lacrimation, unable to wear contact lenses, you know, but there are no pain. It's not a painful thing, but it looks pretty bad. It looks horrible. And remember that it causes loss of vision also. 2 reasons. One, which is the more common, is astigmatism, because it pulls in the cornea and creates flattening, so it causes astigmatism. This is a more invisible cause of loss of vision. And second, it may cause typically it causes blocks the pupil. So pupillary blockage occurs, and that also causes loss of vision. So 2 causes loss of blocking of the pupil, but the more important is the astigmatism it causes by pulling the cornea flatter. So this is a more invisible and more common loss of vision. The treatment has to be excision. It has to be excised, taken off, because it's a membrane. The problem is it has a very high rate of recurrence. So because it recurs so fast, it has a 70% higher rate of recurrence. Within 6 months, they come back to us again. And we are fed up of doing it again and again and again. The more times you take it off, the more it comes back. Okay. So what we do with the surgery, which you have to know the name, it's called conjunctival autograft. You take it off and borrow conjunctiva from the opposite eye of the same patient. That's why it's called autograft. Autograft does not mean कि आपने nearest auto वाला से उसका conjunctiva लिया. Not that. You borrow the conjunctiva from the opposite eye of the same patient, and where you have taken it out, excised, you stitch it back again. This kind of little bit of strip of conjunctiva stitched back with either stitches or glue, and this does not allow the pterygium to go back again. So remember, the surgery is often asked, what is the best surgery to prevent recurrence? The best way to prevent recurrence is to do excision with conjunctival autograft. Okay? This is the pterygium we need to know, and then we need to know about conjunctiva, the inflammation of the conjunctiva, and because conjunctivitis, the conjunctiva gets inflamed, and it is typically, there are 2 different types of conjunctivitis. Remember, one can be infective, or which means it can spreads, can be non-infective. If it's infective, it can be the most common cause of viral condition. Remember, the most common conjunctivitis cause of viral conjunctivitis, and the most common virus is the famous adenovirus. Okay? Please remember, these are infective, so they can spread, and the most common is viral, and the viral most common is adenovirus. The non-infective ones are mostly allergic, so they cannot spread. So they are allergic conjunctivitis. How to diagnose conjunctivitis? You have the bright red color. Remember, it's bright red color, very scary, and it is painless. There is no pain, and there is usually some discharge. Okay? What is the discharge? Discharge is the inflamed conjunctiva producing some exudate or transudate. Okay? There are three different types of exudates or transudates. You can have a purulent discharge which looks like pus. It's greenish color, yellowish color, so it means bacterial conjunctivitis. Or you can have a serous discharge. Serous is clear water, this is a viral conjunctivitis. Or you can have mucoid discharge, this is mucinous. Okay? It looks white and elastic. It means it's allergic conjunctivitis. That's how we can tell you what kind of conjunctivitis you have. If it's purulent, pus-like, we know it's bacterial. If it's clear water, we know it's serous, which is viral. And if it's mucinous, which is white and stringy and elastic, you know it's allergic. It is allergic conjunctivitis. Okay? Most common, I told you, is viral conjunctivitis, and amongst the virus, the most common is adenovirus. Now, this adenovirus can cause a conjunctivitis, where a lot of this, but you have to remember one particular one, which is the famous EKC, epidemic keratoconjunctivitis. Okay? We call it epidemic because attacks in epidemics, it typically occurs in the monsoon season of India. So it starts from any time from July, it goes into August, September, October. These are the months of acute monsoon. And this virus attacks is called adenovirus. It's also called pink eye. It's also called Madras eye. It has nothing to do with Madras. Also called as shipyard eye, old name. It occurs often to sailors on ships. Okay? So multiple names, pink eye, Madras eye, shipyard eye, the multiple names for this. And this is called the EKC. And what will you see? His eyes will be absolutely red and discharging, but there will be no pain. And here an important sign is the preauricular adenopathy. You will see in front of the auricles of the ear, you will see this adenopathy. So you can touch them, there will be inflamed lymph glands here, and they're often tender also. So preauricular lymphadenopathy, eyes are discharging and red, and there will follicles will be found. Follicles are collections of lymphocytes which are seen in infective conditions, particularly virus and chlamydia. And sometimes you get the subepithelial infiltrates which cause a lot of blurring of vision. We call them SEIs, subepithelial infiltrates, which cause blurring of vision. So these are the important findings of adenoviral EKC. Remember, the most important finding here is that it occurs in the same community. Community means wherever same group of people are working, a lot of people are working together, same house, living together, working together, same house, same colony, same citizen, same city, same office, same hostel, same medical college, same dormitory. So these are people working together, sitting together, living together, and they develop this. So one by one, it's highly communicable. I saw in a classroom, it began with one guy, and by the end of the class, the entire classroom had developed. All 70, 80 students had developed conjunctivitis. Okay? So it's highly communicable. That's why it's called EKC. Remember, anytime people from the same house, the same medical college, from the same hostel, the same dormitory, they develop is EKC. Then the second kind of conjunctivitis you have to know is the acute AHC, acute hemorrhagic conjunctivitis, because there is a subconjunctival hemorrhage here, and it looks a little frightening, but it's not as dangerous as EKC, which is more dangerous. It looks frightening because of the hemorrhage here, and this is caused by enterovirus 70. You have to remember EV70, the name and the number you have to memorize. This is not a adenovirus, okay? It's an enterovirus, EV70. It's also called Apollo virus or Apollo 11 virus because it was discovered during the Apollo 11 moon landings. That man has landed on the moon. So it was discovered during that time, which was in August 1969. So, and at the same time as the Apollo 11 landed on the moon, around the same few days, this virus was discovered on the Earth. So that's why we call it Apollo 11 virus or the Apollo disease, which is AHC. Treatment for both of them, these are viral conjunctivitis. There's no treatment. We just have to wait it out for immunity, kick it out. Meanwhile, give you some cold compresses, give you some antihistaminics, trying to stop the discharge and make the patient a little more comfortable. But there's no pain per se, and within 1 week to 10 days, it usually goes off. Then about the chlamydia trachomatis. Chlamydia trachomatis causes conjunctivitis. It's called chlamydia, and it's caused by A, B, BA, and C. Okay, remember trachoma, it has 3 conjunctivitis syndromes, of which the most important is trachoma. Okay, the trachoma is caused by chlamydia trachomatis. A, B, B, and C. ABAC, we call the ABAC serovas. They all cause trachoma. But from D till K, D, E, F, G, H, I, J, K cause another conjunctivitis called adult inclusion conjunctivitis. Okay? This is by D till K, and from L1, L2, L3 causes lymphogranular venereum, of which the most important is the trachoma, which is A, B, B, A, C. Okay? Let's quickly do trachoma, because trachoma is very commonly asked questions. It is caused, as we know, by chlamydia trachomatis A, B, B, and C. ABAC, remember that. Okay? This is caused by this. And this is the most infectious cause of blindness. If you remember, I told you that yesterday the commonest cause of blindness is cataract, followed by glaucoma, but the most common infectious cause of blindness is trachoma. It's the only infection that causes blindness. I mean, there are others, but this is the most common. And what are the risks? Why would you develop conjunctivitis? Trachoma, because of endemic areas which you have, lack of hygiene, overcrowding, poor water supply, poverty. Remember, it's a disease of poverty. So wherever there are a lot of slums, okay, a lot of people living together in a two-room flat, there are 10 people staying, okay, the lack of water, lack of sanitation, lack of toilets. So people, they are basically the disease of poverty, and you have endemic areas of trachoma. So anybody living in those areas bound to develop trachoma. Remember, in the world, the most common trachomas are found in the area that is South Asia, the Middle East, and North Africa. So these are the areas. North Africa, which means the countries around, you have typically have Algeria, Somalia, you have Tunisia, you have some Morocco, around the Mediterranean Sea. You have North Africa, Middle East, all the Middle East, Saudi Arabia, Iraq, Iran, Bahrain, you have UAE, whatever it is, full of trachoma. South Asia are our favorite countries because they are the maximum population. India, Pakistan, Bangladesh, Sri Lanka, everything is full of trachoma. Okay, they are the most crowded. Why particularly these areas? Because they're very crowded, overcrowded, lack of opportunities for poor people staying in overcrowded areas. Okay? Their typical symptoms: redness, photophobia, and watering. The same symptoms as any other conjunctivitis. Trachoma symptoms are no different from any other conjunctivitis like EKC or AHC. But it is the victims which are very typical. First, the children, and second, the women. The children are the most affected by trachoma, followed by women, because women are surrounding the children. Children and women in contact with children, but the number one victims are children. And the hallmark is the segograin follicles. Remember, I told you the follicles which are lymphocytes, and we call them segograin, which is called sabudana. You know what sabudana is? They look whitish, sabudana. They look like sabudana. Follicles are a hallmark of trachoma. You have Herbert's pits, which are depressions on the upper limbus like this. Okay, you ask me to look down, and you will find that there are dots, depressions on the upper limbus. These are the typical Herbert's pits which you found. Herbert's pits are not found in any other condition apart from trachoma. Also famous Arld's line. Remember, Arld's line are the fibrotic scar on the upper papillary conjunctiva. If you evert the eyelid, you will find this white line, which is a scar on the upper papillary conjunctiva. This is called Arld's line. Please do not confuse with Arld's triangle, which is seen in keratic precipitous. Remember, keratic precipitous has Arld's triangle. This is Arld's line. Be careful, they are different. That was uveitis, this is trachoma. And there's some late sequelae. These are early findings. These are late sequelae, which are the ones that cause maximum problems in these patients. Trichiasis, which means change in the direction of eyelashes. Remember, the eyelashes, their upper lashes come down and go out like that. The lower lashes come up and go up. Because the eyelashes normally go out like that, their function is to trap the foreign bodies. No. But in this case, they turn inwards. The upper lashes turn inwards, rub against the cornea. The inner lashes turn inwards and rub against the cornea. This is called trichiasis, change in the direction of eyelashes. Extremely irritating foreign body symptom, causes corneal scarring and may cause blindness. Tylosis means thickening of the lid margin. Madrosis means loss of eyelashes. Entropion is inward rolling of the lid margin. Entropion, inward rolling of lid margin, again causing the eyelashes to rub against the cornea. And because of this constant rubbing of eyelashes due to entropion and trichiasis, you have three kinds of corneal opacities, which is the main cause of blindness in trachoma. The three causes of blindness are nebula is a very superficial opacity, macula is a half thickness of corneal opacity, glaucoma is a full thickness corneal opacity. Okay, so grades hote teen. The lightest grade is nebula, the second is macula, half thickness, and glaucoma is full thickness. Okay, so you have these typical grades of corneal scarring which cause blindness. This is the most common cause of blindness, and they may lead to dry eyes also because they damage the goblet cells of the conjunctiva and cause dryness. Okay. So here you need to know the WHO class, Fisto class. We call the Fisto classification of trachoma. Grade 1 is follicles, which on the upper tarsus. So if you have more than 5 follicles, you have to sit and count these follicles. more than 5 follicles which measure more than 0.5 millimeter in diameter, we call them as grade 1, okay, in the upper tarsal or the upper palpebral conjunctiva. Grade 2 eye for intense inflammation. There's a lot of inflammation here, and this is diagnosed if we have inflammation sufficient to obscure 50% of the tarsal vessels. Normally, the blood vessels are visible in the tarsal conjunctiva or the palpebral conjunctiva, but it is so inflamed, the conjunctiva is so inflamed that is sufficient to obscure 50%. You cannot see the blood vessels at all of the conjunctiva. We call it grade 2. This is the most dangerous thing because it causes a lot of symptoms for the patient. Grade 3 as for scarring. Now you have Arl's line, which means it started healing. You get the Arl's line, which is the S for scarring. Grade T is T for trichiasis, which means even if one eyelash turns inwards, it is called a grade T or grade 4. This is, remember, the most blinding stage. The trichiatic cilia rub against the cornea, causes corneal scarring. The most blinding stage is the grade 4 trichiasis. The most unpleasant stage is grade 2 intense inflammation. And finally, a corneal opacity involvement is a nebula macular on the cornea. If it affects the pupillary margin, we are in grade 5, which is the last stage which causes blindness. So, fifth to classify: follicles, inflammation, scarring, trichiasis, and opacity. Okay, so this is extremely important for us. We'll have to ask questions on this. Then trachoma. So, fistula, once we have trachoma, remember, it's also called Egyptian ophthalmia, named after the country. Rare, used to be named after a country. And this is the drug of choice is azithromycin. Can you remember, you have to give just one dose of azithromycin. 1 gram oral doses is enough to bind trachoma. And topical treatment, if you want to give, you have to give topical 1% tetracycline ointment twice a day for 6 weeks. Okay, this is older treatment. When there was no azithromycin, we used to give topical azithromycin, or beg your pardon, tetracycline, 1% ointment twice a day for 6 weeks. Has to be full treatment. The safe strategy, we remember the safe strategy famous name, S for, which is, this is a strategy developed by WHO to prevent trachoma. S for surgery, okay, surgery of what? Trichiasis. Remember, S for surgery for the trichiasis. You pull the trichiatic cilia out, or you destroy the eyelashes by giving electrolysis. That's the surgery. A for antibiotics, drug of choice azithromycin. F for face washing. You keep washing your face with water, keep it clean, because if you don't wash your face, that spreads trachoma. E for environmental improvement and sanitation. Keep environments clean, keep your areas clean, and you will not have no trachoma. Okay. Finally, the blanket therapy. Blanket therapy, we don't give you a blanket which you can wrap around yourself. It's not that. It's a blanket of antibiotic. We give a blanket of antibiotic, which is 1% tetracycline ointment to be given once a day for 10 days or twice a day for 5 days. Okay. Remember, you can either give it 1% once a day for 10 days in a month, or twice a day for 5 days in a month. It's the same thing. But remember, only for 10 days in a month for 6 months. That means that it's interrupted therapy. So, let's say you give it from January 1st to 10th, okay? And then you don't give it from 10th to 30th, 20 days, no treatment. Again, February 1st to 10th, March 1st to 10th, April 1st to 10th. Only 5 or 10 days in a month. If it's 5 days twice a day, if it's 10 days once a day. Okay? The rest of the month we don't put. For 6 months at a time, Jan, Feb, March, April, it's interrupted therapy. This breaks the cycle. This is called the blanket therapy or the mask therapy of trachoma. Okay? Seems to work very well. This is a treatment of trachoma. Then we go to next conjunctivitis called the spring catarrh. This is the only conjunctivitis which I'm going to talk about, which is not infective. This is allergic conjunctivitis. It's called spring catarrh, also called vernal catarrh. Word catarrh means inflammation, and it occurs in spring. Vernal also means spring. It's means, but remember, it's a total misnomer. It's not inflammation of the conjunctiva in the spring. It takes place in the hot summers of India. So this is a misnomer because it tells you of a spring. That is because the British thought it was spring when it was actually summer. Okay. So in the hot summer months, we have allergic conjunctivitis. Okay. Highly allergic conjunctivitis. In the hot summer months, it's seasonal. It occurs from the hottest months of the year, from April to October. So 6 months of the year, it's recurrent. Every year it comes again and again. And in the hot summer months of Indian subcontinent, Africa, Mediterranean region, it's the same thing. It comes again and again. It's allergic conjunctivitis occurring to children. Remember, it occurs to children, particularly boys. Many of you have had allergic conjunctivitis as kids, and it's highly allergic. The most important sign is the itching. Okay, symptom is the itching. The constant itching that they do, they literally scratch their eyes out. Eyes becomes red, and the loss of tearing, watering, photophobia. This is the critical symptom. It's highly unpleasant symptom. They're constantly rubbing their eyes. The famous hallmark is the cobblestone papilla. Remember, papillae are flat-topped elevations of the conjunctiva. They are flat, they are redder, they are smaller, they are more velvety, but they are flat. okay, and this is the sign of, this is the typical sign, we call them papillae. In any allergy, we'll have papillae, but here we have cobblestone papillae because they look like giant flat stones. These are cobblestone papillae, which are hallmark of spring catarrh hair, right? Then another important find is the famous Horner-Tranter spot. Remember, these are these white dots that you see on the limbus. As you look down, these are collections of eosinophils, so white dots, because this is allergy, so you'll have eosinophils. These are called Horner-Tranter spots, and a very famous ulcer called the shield ulcer. The ulcer looks like a dhal or a shield, okay? A dhal or a shield like that, and very important is a shield ulcer are not seen anywhere else apart from spring catarrh, okay? So these three findings. Treatment is mast cell stabilizers, which contains allergy, so we keep them from January to, from April to October. It controls the itching, and next season again it comes back again. But mostly we have to resort to topical steroids because it's not enough. Mast cell stabilizers, sodium chromoglycate are not usually enough. It controls the itching, but most of the times we have to resort to topical steroids for a couple of weeks because these children are scratching their eyes out, okay? So sodium chromoglycate is the first line of treatment followed by topical steroids if it doesn't work. But remember, steroids are only to be given for a week or two because it may cause cataracts or glaucoma. So watch out for cataract and glaucoma in young patients. It means that they have had prolonged treatment with steroids, which has caused the cataract or glaucoma. Remember, very commonly asked, spring catarrh is always asked in your MCQs. Be careful about that. Okay. What about Vision 2020? This Vision 2020 is a program which is, you might say it's 25, so why talk about Vision 20? Well, it's over, but it is still not over. This is a program which was run by the WHO. It ran for 20 years from 2000 to 2020, okay? And the aim was to eradicate blindness all over. The very famous aim was actually called everybody should be 20/20 by 2020. So by 2020, everybody should be 20/20, which means 6/6. Okay. How? By eliminating all the major kinds of blindness, but alas, it couldn't be, though they tried valiantly. How to eliminate cataracts? Look at the diseases included in this Vision 2020 program. Cataract, how? To operate it. So by operating cataracts, would cure blindness. Trachoma, by safe strategy. Okay. For safe strategy, surgery, antibiotics, face washing, environmental sanitation. And the aim was to get 20, which means global eradication of trachoma. Get 2020 stands for global eradication of trachoma by 2020. Aim was to eradicate trachoma by 2020. Not possible. Even now, 50 countries are still having trachoma. 50 countries. I'm glad to tell you, India is one of them. India has just attained this last year, October, in 2024 October, we eliminated trachoma. Childhood blindness. Why? How? By giving vitamin A. How to eliminate refractive error? Start wearing glasses. Many of you don't wear it still. Onchocerciasis, not found, merciful India. It's found West Africa. It's river blindness, very dangerous. Okay, you have to. They try to eliminate this by giving the drug of choice of onchocerciasis, river blindness. You have to tell me which it is. And Indian scenario, no, India. Okay, Indian scenario is what? Because Indians we don't have river blindness, so Indians we have other things to eliminate in Vision 20: corneal blindness, glaucoma, and diabetic retinopathy. So these are the three diseases that is in India, but not in the rest of the countries: corneal blindness, glaucoma, and diabetic retinopathy. This is the typical Vision 2020 programs here. Okay? And now we come to the cornea. The last few topics, the cornea and the sclera, and those of you are looking tired, and remember it's just got to over, say around 15-20 minutes only. So the cornea has 5 layers. Let's look at them. Each layer has a possible question. The outermost layer is cornea. First of all, it's a principal refractive element because remember it has 43 diopters. And it is a protective layer, so it causes for the vision also, the protection also. And the thinnest central cornea is in the CCD, central cornea, which is approximately 540 microns. I told you, average corneal thickness is 540 microns, but you may have thicker corneas, you may have thinner corneas. And the 43 diopters is the main power, it's the main optical element. Look at the 5 layers. The outermost layer is the epithelium, this black layer, which is the basically, which watches against, is the guard dog, is the watchman. So anytime the epithelium is damaged, the bacteria fungi will move in. The epithelium is very important, used by stem cells. Remember, stem cells of the cornea, they lie in the limbus. Please remember, in the limbus of the cornea, they lie the stem cells, and the stem cells are ones which regenerate the epithelium. Every time the epithelium is damaged, it regenerates by the stem cells, and the exact location of the limbus is called the limbus is the palisades of Vogt. Okay, so you will have these limbus cells like this. We call them palisades because they're parallel and they are longitudinal like this. We call the palisades of Vogt. This is the exact location of the stem cells of the cornea. Every time epithelium gets damaged, the stem cells produce new cells and replenishes the corneal epithelium. Remember, it's very important. The minute epithelium is damaged, will cause corneal cyst. Second layer is a layer called the Bowman's layer, this yellow layer, Bowman's layer. Bowman's layer is the layer which cannot repair itself if damaged. So it forms corneal scar. Remember, MCQ often asks, it cannot repair itself and leads to corneal scar or opacity. So this is always asked, which layer of the cornea does not repair itself and cause a corneal scarring or corneal opacity. Okay. Third is the stroma. Stroma is the main element of the infrastructure. 90% of the common cornea thickness is the stroma, so it provides the infrastructure of the corneal on which the endothelium and exothelium are mount. Fourth layer is the Descemet's membrane. Descemet's membrane is the red line here, which is a very powerful layer. It stops all the layers, all the organism from entry except fungus. Okay? Only fungus it cannot stop. This is a very powerful layer and only fungus can penetrate the intact epithelium. And finally, you have the endothelium layer, endothelium. The endothelium, which is the most important layer of the cornea. Why? Because the endothelium is a single layer of cells which has these metabolic pumps. And when we talk about corneal edema, I told you that normally the aqueous humor rushes into the cornea like this, and it is the endothelial pumps which has sodium, potassium, ATPase pumps, okay? And these pumps, they pump the aqueous out and keep the cornea clear. These pumps, they pump the aqueous out, keep the cornea clear. This is called the endothelial pumps, and they keep the cornea clear very importantly. So that's why the single most important layer of the cornea is the endothelium. It maintains the most important function, which is corneal transparency. Okay, this is the endothelium, and endothelial pumps, sodium, potassium, ATPase pumps. So once the endothelium is damaged, remember, they cannot regenerate again. So another layer which cannot regenerate is the endothelium. So the cornea has two important layers which cannot regenerate. One is the Bowman's, which forms corneal scarring. And if the endothelial pump can regenerate, what will happen? The pump cannot throw the aqueous out. Immediately you have irreversible corneal edema. Be careful. You have two irreversible layers. One is the endothelium, which causes edema. The other is the Bowman's membrane, which forms scar. So be careful. And then about 10 years back, a new layer was discovered to lie in between the descemet's and the stroma. Okay, between the stroma and the descemet's. So this layer, this was found. This is the sixth layer. It was usually called the PDL. It will stand for the pre-descemet's layer. But now we talk about this is the Dua's layer, okay, descemet's membrane and stroma. So now we just call it after its discoverer called Dr. Harminder Singh Dua. The sixth layer of the cornea is called the Dua's layer. So now we have 6 layers. So from outwards to inward, it works like this: epithelium, the Bowman's, the stroma, the Dua's, the descemet's, and the endothelium. Okay, so two irreversible. One, the Bowman's membrane forms a corneal scar, and the endothelium, which causes edema. Be careful, there are 2 layers which are irreparable. And you have to remember the endothelial count, the number of cells that are there, 3000 cells per approximately 3000 cells per square millimeter. You have to remember this. Why? Because the number of cells, endothelium sodium pumps, the sodium potassium pumps, they depend on the cells. So more the number of cells, more the number of pumps. So 3000 cells per square millimeter is the average count of normal adults, between 2500 to 3000 cells. Okay, and you have to remember that each year we lose a certain number of cells due to aging. So this one important cell count we have to memorize this, called 500 cells per square millimeter, which is called critical density. So if the number of cells keep on reducing from 3000, slowly it comes down. So if the number of cells required as in now are less than 500 cells per square millimeter, by less than 500 cells per millimeter, this is called as critical density. Why? Because less than 500 cells, the aqueous cannot be pumped out. Less than that, it cannot be pumped out immediately. You will have corneal edema, irreversible corneal edema. So this we can ask you, what is the minimum number of cells required to keep the cornea clear? Remember, it's at least 500. We need at least 500 cells to keep the cornea clear. That's called critical density. And for corneal donation, remember that we need at least 2000 cells per square millimeter. If you want to donate your corneas and you have less than 2000 cells, we cannot accept your corneas. Okay, so be careful. For donation, we need at least 2000 cells per square millimeter. So 3 important counts to memorize: normal count 3000 cells per square millimeter, normal count, critical density 500 cells per square millimeter, and corneal donation at least 2000 cells per square millimeter. Okay, then now the next condition is what happens if number of cells keep falling less than 500. Then what will happen? Then the aqueous humor would immediately rush into the cornea because they cannot be pumped out anymore, and irreversible corneal edema will occur. So the cornea will become hazy, you can't see anything. So since the endothelium cannot be repaired, the only way to manage irreversible corneal edema due to endothelial damage is to do a corneal transplant. So we do corneal transplant, which is called keratoplasty. There are two types of keratoplasty. One we call penetrating keratoplasty, which is called PK, which means full thickness, all 6 layers are transplanted. Second is called LK, lamellar keratoplasty, which is partial thickness keratoplasty. Partial thickness, which means that the innermost 3 layers of the cornea of the patient is maintained, the outermost 3 layers are donated. So it means you donate your epithelium, your Bowman's and your stroma, but the patient has her own endothelium, her duas, her desmids and her duas there. It's called partial thickness. And remember that out of all the transplant rejections in the body, out of all organ transplants, the most successful are corneal transplants. These are most successful. Almost 90 to 95% of corneal transplants are successful. Why? Because cornea is avascular, cornea does not have any blood vessels or any lymphatics, so the chance of rejection are very few. Of the two, remember the LK is more, PK and LK, kindly remember, there are rejections in between also, but the most successful is LK. Why? Because LK, you have only given the outermost 3 layers and the maximum rejection takes place against the endothelium. Can you remember MCQ? There are rejections sometimes. Of the 6 layers, the maximum rejections take place against the endothelium. Very important questions. So since in PK, you have also donated your endothelium, so PKs can still reject. But LK, there is no endothelium donation, so there is no rejection. A patient cannot possibly reject against his own endothelium. No? The endothelium is the patient's own. So LKs are most successful, but PKs can reject. And the most common indication of keratoplasty, what is that? Is a condition called as PBK, pseudophakic bullous keratoplasty. That means while implanting an IOL for cataract surgery, suppose you damage the cornea, pseudophakic, okay? Remember, you have to slide the IOL like this, and while implanting the IOL, suppose it damages the corneal endothelium, which is the innermost side, then tomorrow morning, there will be no pumping of action, the endothelium is lost, and all that goes to Russian, causing corneal edema. This is called a pseudophakic bullous keratopathy because the edema takes place shape of small bullae of vesicles of fluid, okay? This is bullous keratopathy, or it is the world's most common cause. In India, we have corneal scarring and non-healing ulcers, okay? So India, non-healing ulcers, which just don't heal, the perforate, we have to do them, or could be corneal scarring as in trachoma. Okay? So these are the other indications of keratoplasty in India. And there's another keratoplasty called therapeutic keratoplasty. What is that? It is not to give you vision. Remember, cornea has 2 functions. First, it protects the internal structures, and second, it gives you vision. If you do the keratoplasty for vision, we call it optical keratoplasty. If you do to protect the internal components so that they don't come out, the cornea ruptures and everything comes out. So if you want to do that for protection of the internal organs or the internal structures of the eye, then it's called therapeutic keratoplasty for treatment. And this is done for active infection or repair struggle. Sometimes it is active infection. You know, the corneal ulcers you cannot repair them, and the entire cornea perforates, everything comes out, you've lost that. So we do keratoplasty to remove that infection and repair the structural defect. This is called therapeutics. Therapeutics are not meant for vision. We're trying to save that. The most common indication of therapeutic is a microbial keratitis, where the infection, the ulcers are just not able to healing, and everything perforates, everything comes out. So this is the most common indication for keratoplasty, a non-healing ulcer, which is microbial keratitis. So then what about corneal donation? Remember, corneal, anybody can donate. There is no age limit for donation. So even children can donate. But corneas less than older people, we have a limit of less than 75. We can take corneas for 90 years away also, but the is not so healthy. The endothelium is damaged usually. But less than 75 is the best. But remember, there is no contraindication. We can take any corneas. Age is not a contraindication. That's to be taken within 6 hours of death. Okay, because after 6 hours of the death, the endothelium starts getting damaged. So there's no point taking an endothelium which is damaged. Endothelial count has to be at least more than 2,000 cells per millimeter square, beg your pardon, because I told you less than that, we cannot take corneas. Why do you preserve them? You preserve them in a media which is called the MK media. This is the most common in India. It's called Macquarie-Kaufman media, which preserves it for maximum of 4 days. But if you want a longer media, which is more expensive, we call it Optisol GS, which can preserve the eyeball for 7 to 14 days. So India mostly we use MK media. Worldwide we often use Optisol GS or Cornisol. This is a better media which will preserve the eyeball for almost 2 weeks. Okay? And are there any corneal donation? Yes, there are. If you cannot donate corneas, if you are suffering from highly active infectious disease which may transmit to the recipient, or if you have some tumors which may cause metastasis or seeding of the eye. Remember, if you suffer from HIV, hepatitis B, rabies, septicemia, Creutzfeldt-Jakob disease, retinoblastoma, head and neck cancers, some lymphomas, leukemias, and particularly death of unknown cause, then we cannot take your corneas. Okay, highly infectious diseases, certain tumors like retinoblastoma, lymphoma, leukemia, head and neck cancers, and remember one more, death of unknown cause. If you don't know what the cause of death is, we cannot take your corneas. Okay? Then a quick word about keratitis, bacterial keratitis, ulcers. Remember ulcers, anytime you have a damage to the cornea. So suppose there's a damage to the cornea, and as there is damage to the cornea, what happens? The epithelium sloughs off. The epithelium is damaged, so a little bit of the epithelium goes away like this. So as the epithelium as the epithelium gets damaged, so it allows all the bacteria from surrounding bacteria fungus to enter like this, and the bacteria enters because of epithelial damage. So first you have to history of trauma and see how the cornea ulcer penetrates. So it goes from epithelium, it goes to the Bowman's, it goes to the stroma, then it goes to the duas, and finally the descemet stops it like this. So the ulcer penetrates like this. Finally, the descemets, which is just before the endothelium, I told you that no other organism can penetrate the descemet except fungus. It stops it. So our aim is to stop the ulcer penetrating deeper, because the deeper the ulcer penetrates, the more difficult is the treatment. Okay, so you have to treat ulcers earlier. So what are the risks of bacterial keratitis? Trauma if you get hit something, contact lens, prolonged contact lens wear, loose stitches, suppose there are some stitches for cornea surgery which are not taken out, dry eyes, and exposure to keratopathy. The most common bacteria worldwide is Staph aureus and Pseudomonas, but in India it's mostly Streptococcus. Remember, so sometimes like India specific with Streptococcus pneumoniae, and this is also called Ulcus serpens. The Streptococcus is called serpens because why? Because it moves like an ulcer like this, like a snake. Like a snake, the ulcer moves like a snake like this, like a side-winding action. This is called Ulcus serpens, also called a hypopyon corneal ulcer, because these ulcers are well known to produce a lot of hypopyons. Pneumococcal ulcers produce a lot of hypopyons called hypopyon corneal ulcer. Remember, hypopyon corneal ulcer is not any ulcer with hypopyon, it is specifically a pneumococcal ulcer. Then the most common contact lesion ulcer, remember, is caused by Pseudomonas, very important MCQ, and the only bacteria which can penetrate intact epithelium are Corynebacteria and the Neisseria. Okay, they can penetrate intact epithelium. Remember that no other, not even Pseudomonas can penetrate intact epithelium. Okay, so and the drug of choice is the 4th generation fluoroquinolones, which is the moxifloxacin and gatifloxacin. Then acanthamoeba keratitis caused by acanthamoeba, history of contact lens wearing, okay, which is washed in tap water. Remember, if you wash your lens in tap water, you're bound to have acanthamoeba. Or corneal trauma, exposure to contaminated water. Suppose you take a bath in contaminated water, like where the animals have also waded in. Okay, and history of suspected HSV keratitis not responding to contact lenses. Remember, suppose you are wearing a contact lens and you think it's herpes simplex virus, but it's not healing. Okay, it looks like herpes, but it's just not healing. Then it is most likely acanthamoeba, because I told you acanthamoeba attacks contact lens wearers. But overall, remember, Pseudomonas is number 1, attacking contact lens wearers. Number 2 is acanthamoeba. So all dendritic looking ulcers in contact lens wearers you have to suspect, because they look very much like dendritic, which means it is most likely viral, but actually it is acanthamoeba. Remember, in a contact lens wearer, a dendritic looking ulcer, you should always suspect acanthamoeba. And the pain out of proportion, very severe pain. Patient literally has the highest amount of pain in acanthamoeba. No other ulcer is as painful as acanthamoeba. Ring shaped ulcer, typically it is shaped like a ring. Okay, so it's a very painful ring. So many of you might think it's a wedding ring, but it's not. It's much more painful than a wedding ring also. And it's a ring shaped ulcer, and this reason is why it's so painful, radial keratinosis, because the nerves of the cornea, they get infiltrated with acanthamoeba. We call radial keratoneuritis. The nerves of the cornea, they get damaged because radial keratinitis, and that's why it's so painful. And you call pseudodendrites visible. So you have dendrites which look like pseudodendrites. They are not true dendrites. True dendrites are only found in herpes simplex. So when you get the pseudodendrites, you have other conditions like acanthamoeba, herpes zoster, you can have trauma, but only true dendrites are found in herpes simplex. Okay? Drug of choice is PHMB, polyhexamethylene biguanide. You want to memorize this, you have to make it in the laboratory, polyhexamethyl biguanide, or you can have chlorhexidine or propionate. Okay? Remember, the most dangerous ulcers are acanthamoeba. So watch out for contact lens washing in water. Watch out for suspected herpes simplex in a contact lens wearer who's not healing at all. The fungal keratitis is the fungus, and the most common fungus is Fusarium keratinum. Remember, Fusarium and Aspergillus are the 2 most common fungal which cause fungal ulcers. they're both filamentous fungi. The predisposing causes are injury with organic matter. You get, a scratch with a leaf, a bark of a tree, the branch of a tree. Typically, these are agricultural injuries or prolonged topical steroids. You've been wearing topical steroids for 2 months, 1 month, you will get a fungal ulcer. Okay? So typically organic vegetable matter. So you get scratched, or you're cutting onions, an onion comes and hits the eye, shelling peas. So typically organic vegetable matter, a farmer working his field is the one who is the most common to have a fungal ulcer. And signs more than symptoms we call it, because there is no pain, no redness, no watering. It's a very quiet ulcer. It kills you by its quietness, but the doctor can see the signs. The doctor can say that here you have ulcer because you have infiltration. So remember, here the doctor points out to the patient that you have an ulcer. The patient has no symptoms. It's a very quiet ulcer. Fungal ulcers are deceptively quiet, and that's why they are more dangerous, because the patient doesn't come to us till late. So how to diagnose? Finger-like projections. Typically you will see the finger-like projections like this with feathery margins and the famous satellite lesions, which are small nodules of ulcer surrounding the main ulcer. Okay? This is satellite lesions. Drug of choice is natamycin. Stop all steroids. Remember, the steroids cause it, so stop all steroids. Drug of choice is natamycin. The last ulcer is the viral keratitis, where the virus attacks. Typically, it is the herpes simplex virus which attacks you, and these are type 1 herpes, which is the most common. It can be primary or reactive. Reactivate means you already had herpes sometime before. It's reactivated due to lack of immunity, due to sunlight exposure, contact lens wearers, stress, particularly stress and trauma and contact lens, particularly stress. When you have a lot of stress, it may precipitate your secondary reactivation of the herpes. And herpes are epithelial. It can attack the epithelium of the cornea, or stromal, or endothelium. They are totally different. Okay? It's the epithelial keratitis, which are most commonly asked because we call them dendritic ulcers. This is the true dendritic ulcer I was telling you, and the shape is very typical. They look like the branches of a tree. Okay, this is the typical. It's called true dendrites. Remember, only HSV has true dendrites. The rest of them has pseudodendrites. So that's seen in herpes zoster, in acanthamoeba, and many other things. So this is the only true dendrites, shaped like branches of a tree. Remember, that is that. And loss of consciousness is a very important sensation. It's called loss of conscious sensation. This is the only ulcer which damages the nerves, which is the typically trigeminal nerves, and they cannot feel sensation. So sometimes when you cannot pick up the herpes because of the shape, we test the sensation, we touch the cornea, compare the sensation with the two eyes with the corneal pledget. If he says he can't feel one eye, but he can feel the other eye, then that is usually herpes simplex. Okay? And treatment is topical acyclovir. Remember that shapes are important of all viruses. So her virus, HSV, is dendritic shaped, fungus is satellite lesions with finger-like projections, bacteria is, you have bacterial ulcers, you have the typical ulcus serpens, and acanthamoeba, you have the ring-shaped ulcer. Okay? These are the 4 types of ulcers we have done, and then the other type of herpes which we like to ask you, the other type of herpes that we like to ask you is the famous herpes zoster ophthalmicus, a cousin of the herpes. But remember, it's not the same herpes. It is caused by the virus which causes the chicken pox, okay, which is the varicella zoster. Varicella zoster, chicken pox. Remember, so it occurs only to those people who had chicken pox. Remember, so some of you had chicken pox, you can have zoster. Those who have not had chicken pox, you cannot have it, because it's a chicken pox virus which is reactivated again. Okay, it is healed. Chicken pox is healed, but it is resting in your dorsal root ganglia. It's resting in dorsal root ganglia and resting in it, and again it rises like Kumbhakarna after many years when you're immunocompromised. It gets reactivated. Okay, so Kumbhakarna is sleeping peacefully for 20-30 years, and as you become immunocompromised, it rises again to attack you as herpes zoster. Usually the older patients, because you become immunocompromised when you become old. And young patient, remember, is a very important sign of HIV. Be careful. Young means less than 50 here. And anybody of you who develops a zoster, we need to test for HIV, because HIV is the most common immunocompromised condition in the younger patients nowadays. Okay? And you typically have the painful vesicles along the dermatome of the 5th cranial nerve. It will never cross the midline. It's always one-sided. And the famous Hutchinson sign, which means if the tip of the nose is affected, the eye will also be affected. Okay? So this is very important. Watch out the tip of the nose, because both of them are supplied by the same branch of the nasociliary nerve. And treatment has to be started within 72 hours, otherwise the risk of PHN, post-herpetic neuralgia, is very high. This is a very, very severe pain after surgery. That's why post-herpetic neuralgia. Okay? The treatment is a massive dosage of almost 4 grams of acyclovir. 800 milligrams 5 times a day means 4 grams of acyclovir per day for at least 10 days we have to give them, because it's a very severe problem, herpes. Then I know, ladies and gentlemen, we are about to finish now, about another 10 minutes I think, and we're all done. Keratoconus, what is that? A condition where the cornea is conical and thin. Remember, keratoconus has two things. Not only it has to be like a cone, it has to be also very thin. Okay? If only it is conical, it's not keratoconus, it has to be thin also. So it's a non-inflammatory, it's not inflammation, bilateral, both as usually, progressive corneal ectasia with central. Ectasia means thinning. Okay? It becomes protrudent more and more with central thinning of the cornea. The main risk is that you keep rubbing your eyes. Okay? So many of you are allergic and you keep rubbing your eyes. That is the main cause of keratoconus. If you rub your eyes, it has to very gently with the palm of the hand, not with the knuckle, not like this. You have to palm it very gently. Okay? And it occurs early adolescence, so it starts say around 15-16 years of age and it keeps on thinning and thinning and thinning till the mid-30s. Mid-30s, from 15 to go to 35, it keeps progressive thinning of the cornea keeps on taking place and cause blurring of vision because of the corneal curvature. The cornea is conical, no? So you have curvature myopia, so it jumps by 6 diopters. So frequent change of glasses. So these are often young ladies, anytime from 15-20 years of age till your age group 30. They come in a frequent change of glasses. Every 6 months they need to change their glasses, which is surprising because normally change glasses once a year, but these ladies or the young people, they change their glasses very frequently. So any of you who's changing your glasses very frequently, 3 or 4 times a single year, I would advise you to watch out if you're developing keratoconus. Okay? You have a highly irregular astigmatism. You have irregular astigmatism because it's conical, so that means it can be cut by contact lenses but not by glasses. With scission of reflex. Remember retinoscopy, remember we do retinoscopy today, so it goes either against a movement like this or it goes with the movement like this. In this case, it goes against, like this. This is how it goes like this. It goes like this, like the blades of a scissor. So this is one of the earliest signs of keratoconus, scissoring of retinoscopic reflex. And typically you have the Munson sign. Munson sign means you ask the patient to look down, you hold it like this, look down, see what's happening. This is the Munson sign. If the cone, it causes indentation or notching of the lower lid on looking down. The normal lower lid looks like this, but as the cone hits it like this, the lid becomes like this. This notching of the lower lid, which occurs in advanced keratoconus, is called Munson sign or Munson sign. Vogue stripe is the vertical folds on the corneal stroma, like this vertical folds called Vogue stripe. Now there are 2 striae in ophthalmology. One was the Hab striae, which is in ophthalmos. One is the Vogue striae, which is vertical for keratoconus. There are only 2 striaes. Okay? And Fleisch's ring is a ring-shaped circle like this, which surrounds the base of the cone. So the base of the cone like this, and it's called Fleisch's ring. Do not confuse with case of Fleisch's ring, we see in Wilson's disease. This is Fleisch's. So this is an epithelial ring on the base of the cone. It's made of iron, whereas Fleisch's case of Fleisch's ring is copper, and it is on the descemet membrane. This is on the epithelium. So these are multiple signs of keratoconus. To diagnose what is the management, give glasses. Initially, because the power is changing every 6 months, 3 months, so keep changing glasses. But soon we have to go to contact lenses because as it becomes more conical, glasses cannot correct a cone like this. So we have to give contact lenses. But these are lenses, remember, which are not your soft lenses, the which ones you wear. You wear soft contact lenses because they're very soft, and we cannot give them to keratoconus because they would take the shape of the cone. So we want to give a lens which has its own shape. We have to give them this lens is called RGP, which is rigid gas permeable, which will take its own shape. It will not take the shape of the cornea. RGP lenses. And finally, we can do keratoplasty. Remember keratoplasty, because of the cornea. Suppose it ruptures, it's a very severe. Suppose it's a very progressive cone like this. One day it will rupture. As it ruptures, the cornea, the stroma becomes edematous because the aqueous flows out. It's caused corneal scarring or corneedema. So then you cannot place a contact lens because there is central scarring here, so we have to do keratoplasty. And nowadays the latest treatment is called C3R or called as corneal CXL, corneal cross-linking. So what we do, we radiate ultraviolet light. Remember, it's UV light. Yeah, don't confuse infrared. UV light on the cornea along with riboflavin drops. Yeah, riboflavin drops. This combination of UV light with riboflavin, it creates extra collagen bonding. It creates bonds in the collagen, so the cornea becomes very stiff. It cannot cause further coning. So it will not flatten the cone, but it will stop the cone from progressing further because very stiff cornea. So this stops the progression, which is also pretty good. Okay, so this is the latest treatment for keratoconus. Now, the last topic is sclera, and inflammation of the sclera is the scleritis. Okay, so scleritis is a very painful sclera, often associated with systemic disorder. Remember, it is often associated with systemic disorders like autoimmune disorders, particularly most common is rheumatoid arthritis. It's rheumatoid arthritis, but you can have SLE, you can have Sjogren syndrome, you can have other things, which is vaginous granulomatosis. Okay, but the most common association, remember MCQ, of scleritis is with rheumatoid arthritis, mostly in women in their older age, 50s, 60s, 70s, or 80s. Look at the typical deep, boring pain. Scleritis is very painful. Okay, it looks like somebody is taking a nail and is boring into you, digging the nail into you. It's a very deep-seated pain and worsen with the ocular movement. You move your eyes, it worsen. And typical, look at the color. It's a bluish color. Okay, it comes typically bluish because very deep vessels. It's not a bright red color. It's a violet bluish color, and you'll have scleral. So you see the color, it looks bluish, isn't it? Because of the deeper swelling of the cornea, of the sclera, and you have very painful and this characteristic bluish violet color, which is best seen in a torch, not in torchlight, but sunlight. Okay, with edema, you have anterior posterior scleritis. We divide the anterior sclera or posterior. If it is posterior to the insertion of the recti, superior rectus, inferior rectus, middle rectus, if the sclera is inflamed, posterior to that is called posterior scleritis. Okay, which is rare but difficult to treat. And anterior is anterior to the insertion of the rectus. And anterior scleritis is more important. If you can ask a question, we have 4 different types: diffuse and nodular nucleus scleritis with inflammation, scleritis without inflammation. These last 2 are very dangerous, and without inflammation is called scleromalacia perforans, because it perforates very easily. Because without inflammation, the patient doesn't come to us, there's no pain, so it perforates very easily. The diffuse and nodular are more simple to treat, where we need, these are the 2 most common. Diffuse scleritis is usually the most common, where again there's pain and redness, bluish violet, but they can be treated. We usually treat them with systemic steroids. Remember, topicals don't work here. Systemic steroids, we start treatment then. And the one that we want to talk about mostly is the one which is the rarest one, necrotizing scleritis with inflammation. Remember, this is the least common but the most dangerous, but the most destructive. Not only it may cause of the loss of the eye, it can loss of life also. Okay, because of rheumatoid arthritis, it may cause death also. Okay, so be the most dangerous one, but thankfully it's rare. So associations are rheumatoid arthritis and vaginous granulomatosis. Okay, remember now the new name for vaginous granulomatosis is GPA. Granulomatous polyangiitis is the new name of vaginous granulomatosis, GPA. These are the 2 most common associations of necrotizing scleritis. Intense pain, and see the white area surrounded by thing. You see the intense pain and the white area. Look at the white area here. So this is what tells us that it is white avascular surrounded by inflamed sclera is the intense pain. This is the most dangerous thing of all scleritis. It may cause death also. You have systemic steroids and immunotherapy, because you cannot give steroids for more than 3 months. Remember, the side effects are so much. Immunotherapy means you can give some drugs like cyclosporin, or you can give methotrexate, azathioprine, which are immunomodulating drugs. And the last one of the inflammation is the scleromalacia perforans, which is basically scleritis without inflammation. Okay? So these are elderly women who have rheumatoid arthritis, chronic rheumatoid arthritis. Remember, it's called perforans because absolutely painless, no redness, and minimal signs of inflammation. The patient will have no signs of inflammation, but you will see this darkish area as the sclera thins and the uvea becomes visible. Okay, this is very dangerous looking thin because there's no inflammation. They often don't come to us. We discover automatically. The dark sclera becomes thin, dark uveal tissue is visible, becomes visible like this you see here, and it ruptures very easily with mild trauma or may form a staphyloma, raised intraocular pressure, rupture very easily. Again, the treatment for systemic steroids and cyclophosphamide, methotrexate, etc. This can be treated. Remember, there are the 2 dangerous forms of scleritis: is necrotizing scleritis with inflammation, far more dangerous, but without inflammation is also dangerous, which is called scleromalacia perforans. And with that, ladies and gentlemen, is the end of a very long, very boring, and very, very long lecture. Thank you very much, and all the best.